Okay. A very good morning, everyone. It's a bright Sunday morning, but a polluted morning in Delhi. I'm sure things will be better in other cities and across the globe. We have people logging in from Cairo, from the Gulf, from the Middle East. And as the day passes, I'm sure we'll get more and more logins. A lot of people interested. Yesterday, for people who were not there yesterday, we had a great scientific feast yesterday also. Delegates and faculties from all across the world. We had towards 9 o'clock. As we were ending, we still had around 850 plus logins, which speaks volumes about the science that was delivered, excellent scientific sessions delivered by the best of faculties from across the globe, from India, from everywhere else. We had great discussions and active participation from everywhere. So I think that is what science is all about. So, friends, welcome to the 9th Virtual International Symposium in Diabetes organized by CMRE, Consortium for Medical Research and Education. As all of you know, CMRE is a platform jointly envisioned by Dr. Rajiv Chawla, my senior colleague, and me, kind of to propagate science, because we always feel there is a need to keep updating ourselves, be it through medical education, be it through symposia, workshops. So we've been conducting this symposium. This is our 9th annual symposium, 9 years. We've done it in partnership with our partners from Cardiff University, UK. We've done it with the South Wales people. We also, last 3 years, we've been collaborating also with AASD, the Arabic Association for Study of Diabetes and Endocrinology, so headed by Professor Inas Shaltout from Cairo. And our partner in this entire journey has been Dr. Mohammad Hasnain from UAE, Dubai, along with Professor Colin Dyan from the UK. So this time we are collaborating with DIPSI and AASD for this virtual symposium. And I promise you a grand scientific feast as always, and I'm sure everybody will go home satisfied and richer with the scientific exchanges that are to follow in the entire day. So with that welcome note, let's kickstart the sessions for today. Bang on time, 11 a.m. And we already have our young, dynamic mobile chairs logging in from the road for the session. And I welcome Dr. Rutul Gokulani and Dr. Dharmendra Panchal. Can I have their intro slides, please? RX. So I think these are young, dynamic men. All of us know, very active in the field of diabetology and propagation of medical science. Dharmendra, we know, consultant physician, diabetes, obesity, endocrine from Diacare, Sabarmati, Ahmedabad, a very, very humble yet intelligent and go-to person when it comes to any help that you need, and I can vouch for that. And Rutul, my younger brother, Managing Director, AHC Diabetes Center, somebody who's really working hard, especially in the field of diabetes and pregnancy and type 1 diabetes. So happy to have both of you here. Welcome, Rutul. Welcome, Dharmendra. And let's kickstart the session.
Thank you, ma'am, for kind introduction. It was really great to have to be here, and congratulations to you and Rajiv Chawla sir for wonderful program in collaboration with AASD and DIPSI. And for the first session to kickstart, we have Dr. Meena Chabra, ma'am. May I have the introduction slide, please? So Meena Chabra ma'am is senior visiting consultant and diabetologist at Sir Gangaram Hospital, New Delhi. Presently she is affiliated with RSSDI Delhi chapter. She is chairman there and chairman of Innovative Physician Forum, and she is part of the committee of Joint Consensus Guidelines on Management of Diabetes by RSSDI and ESI. In 2019, she is RSSDI Women Diabetologist of the Year in 2022-23. Just recently, she was awarded in Chennai, and she has been awarded with Distinguished Services Award in 2018 DMA. She received Dr. B.D. Kumar Oration Award in 2019 for excellence in the field of cardiology at IMA 2019, and RSSDI Award for excellence in diabetes care 2019. So with this, I'll hand over the session to Meena Chhabra ma'am for her talk on biosimilars. Over to you, ma'am.
We can't hear you, Dr. Meena.
Is my screen visible and am I
Yes, it
audible
is.
now?
Yes.
So good morning, doctors, and a very warm welcome. I'm going to talk about interchangeable biosimilar insulins. I'm going to talk about the evidence and the benefits. And the world's first and only US FDA approved biosimilar interchangeable insulin glargine. And this is the topic today, and it's a sponsored talk. But I'm going to discuss the science of it. So 1 minute, my slides are not moving. Just give me 1 minute. Yeah. So this insulin glargine has got approval in major markets now. You can see that it has got a US FDA approval in 2020. It's got an EMA approval in 2018. The India approval came, of course, in 2009. It's also approved in various other Asian countries. Now, how do you prove that this is interchangeable? Obviously, you need studies. You need PK/PD studies where you want to compare it with the international or the gold standard U100 glargine or Lantus. Now, this is a very interesting study. It was a global PK/PD phase 1 study where Basalog, which is the Biocon's insulin, was compared with the Lantus that is sold in the European Union versus the Lantus that is sold in the United States. So I'll be talking about 3 trials. InStride 1 was a phase 3 trial. InStride 2 was again a phase 3 trial, and so was InStride 3. So these are interesting trials, and these were global trials which happened several places. Now, the global phase 1 PK/PD in type 1 diabetes. So comparative pharmacokinetics and pharmacodynamics of a proposed biosimilar insulin glargine and reference insulin in patients with type 1 diabetes. This was presented at San Diego. Now, in this phase 1 study, what was the objective? The objective was to compare the PK/PD of biosimilar glargine with the reference glargine, both of them. So the glargine from US and the glargine from Europe. The population of patients was 114 type 1 diabetic patients. What was the study design? It was a single center study. The patients were the randomized and double blind. So neither the doctor nor the patients knew which glargine they were receiving. A single dose was given, and it was a 3-way study. And patients received a single subcutaneous injection of 0.4 units per kg of each trial drug. So now they were randomized. So it was a single center, double blind, single dose, 3-way crossover, euglycemic clamp. Now a little word about the euglycemic clamp. What you do in a hyperinsulinemic euglycemic clamp is that you inject insulin and you want to maintain the sugar as euglycemia or normal in a particular range. So if the patient is insulin resistant, when you give insulin, the blood sugar will not fall. Therefore, the injectable insulin required would be less. And opposite happens if the patient is insulin sensitive, like most type 1 diabetic patients are. When you inject insulin, the blood sugar will fall and you will need glucose to be injected to maintain euglycemia. This is the concept of a hyperinsulinemic euglycemic clamp. So the patients were randomized within 20 days to either the it's called MYL, either the glargine from Biocon or the US glargine or the European glargine. And at visit 2, the first clamp, after 28 days at visit 3, the second clamp, and at visit 4, the third clamp. And within 10 days of the fourth visit was visit 5 or the follow-up visit. It was found that the serum insulin profiles and the mean serum insulin concentration of the 3 insulin glargine preparations were absolutely similar, right? So the profiles were nearly superimposable. You can see the 3 graphs that the insulin from Biocon, insulin from US, and the insulin glargine from Europe had superimposable graphs as far as 3 things are concerned. So what are these 3 things which are important with any insulin, particularly with basal insulins? Number 1, the onset of action. Number 2, the peak action. And we assume that U100 glargine is practically peakless, but it still does have a small peak, and the total duration of action. And also we can see for inter-individual and intra-individual variability. That means variability in 2 different patients with the same dose, and variability in the same patient at different times in the same day. So these are 2 different terms: inter-individual, 2 different, and intra-individual in the same patient. So if you see the 3 graphs with the 3 different insulins, you see that the graphs are superimposable, which means that the PK/PD is almost similar. So the bioequivalence of the biosimilar insulin, glargine, biosimilar US and EU was demonstrated in patients with type 1 for the PK/PD endpoints. Now we come to the INSTRIDE 1. This was a non-inferiority study. We were trying to compare the efficacy and safety of Biocon's insulin glargine with the reference insulin glargine in type 1 diabetes patient. It was a global phase 3 study. In a phase 3 study, you've already in phase 1 done the safety studies, the efficacy studies. So in a phase 3 study here in type 1 diabetes, it's basically the phase 3 study is a study comparing the efficacy of the various drugs that are being studied. So what we were trying to do here is the efficacy and safety of glargine by Biocon as compared to the reference insulin or the gold standard insulin, Lantus, the INSTRIDE 1. This was a multicentric trial, unlike the previous study. There were several centers, open label, which means the observer and the patients knew which insulin they were getting. Patients were then randomized. A parallel group, which means that the different groups received different insulins and not the same. And it was comparison between the groups. So there were 558 type 1 diabetic patients. The HbA1c was less than or equal to 9.5 at the time of screening. These were type 1s between the ages of 18 and 65. They were treated with once daily insulin glargine for at least 3 months. Now, how was this done? Screening the patient happened for 4 weeks. There was a run-in period of six weeks. And then there were 2 parallel groups. So one group received Biocon's insulin and the other group received the reference insulin. And these patients would receive these insulins for 52 weeks, and then they were called for follow-up at 4 weeks. What was the primary endpoint? Change in HbA1c from baseline to week 24. What was the non-inferiority margin? The upper limit of the 2-sided 95% confidence interval for difference in mean change from baseline to endpoint for HbA1c should not be greater than 0.4% at week 24. And if this happens, that means that Biocon's insulin glargine is non-inferior. And of course, this in the INSTRIDE 1, Biocon's U100 glargine met the primary endpoint. What were the secondary endpoints? Of course, efficacy. So the HbA1c change from initial administration to week 52, the change in fasting plasma glucose, change in insulin dose, and the self-monitored blood glucose values. The safety endpoints were hypoglycemia, other adverse events and adverse reactions, and immunogenicity, which means development of anti-drug antibodies. Now, if you see the result, again, HbA1c stabilized at all time points from baseline. So you can see that the HbA1c, the lines are really actually superimposed. Fasting plasma glucose by visit and treatment superimposed, which means in both the parallel arms, that means both the parallel study groups, where you are giving insulin glargine biosimilar to one by Biocon and the other group giving the international glargine, both of them had similar PK/PD. No statistically significant difference in HbA1c profiles. Both basal and bolus insulin doses did not differ between groups. Why bolus? Because these patients in INSTRIDE 1 were type 1 diabetic. And apart from being in the parallel group where they were receiving either biosimilar glargine or the U100 standard glargine, they were also receiving boluses before meals of Lispro. So even the boluses remained the same, rate of hypoglycemia remained the same, other adverse events were also comparable. So again, we come to the conclusion that Biocon's insulin glargine has similar efficacy, safety, and immunogenicity as the reference insulin glargine. This is INSTRIDE 2. This is the non-inferiority study to compare the efficacy and safety of Biocon's insulin glargine with reference glargine in type 2 diabetes mellitus patients. So it's interesting, INSTRIDE 1 is type 1, INSTRIDE 2 is type 2 patients. So again, the objective was the same, to determine whether biosimilar insulin is non-inferior to the reference insulin. Again, this was similar trial, multicentric, open label, randomized, 2 groups, one group receiving the biosimilar, the other group receiving the gold standard glargine. There were 560 type 2 diabetic patients, sample size little bigger than INSTRIDE 1. And the population studied had to have type 2 diabetes for at least 1 year before screening, and stable dose of oral anti-diabetic drugs for 3 months before screening. Again, similar, screen for 4 weeks. Then when you had all the patients you had screened whom you wanted to put in the trial, there were 560 such patients. They were divided into 2 groups, 1:1, 2 parallel groups. One received insulin glargine by Biocon and the other received the reference insulin glargine. They were followed up. And again, we saw that the primary endpoint was similar, change in HbA1c similar, and secondary endpoints, both efficacy and safety, were similar in both of them. So again, you see that the reference insulin and the Biocon's glargine, similar PKPD, similar safety, similar efficacy. So this is very interesting. So coming to biosimilar, yeah, you can actually see that the standard deviation in the doses was not statistically significant. Now coming to the results, mean change in HbA1c was similar. And again, rates of hypoglycemia, which means adverse events, and change in fasting plasma levels, again, similar. So safety-wise, efficacy-wise, the Biocon's insulin was similar to the parent insulin. Now, there's another trial called the INSTRIDE 3. In this, we assess the efficacy, the insulin dose, and safety and immunogenicity when people with type 1 switched. This is very interesting. In this, patients who were already on the standard U100 glargine was switched to Biocon's glargine. So this is very interesting. See the study, type 1 patients who had completed INSTRIDE 1. So you had patients in the INSTRIDE trial who had completed being on Biocon's insulin, right? Or on reference insulin. Because remember, in INSTRIDE 1, we had 2 parallel groups, one on Biocon's insulin and the other on standard U100. So type 1 diabetic who completed INSTRIDE 1 and were on the reference insulin glargine, they were now given Biocon's insulin glargine, right? So it's clear. So this was the first switch that happened. And they were randomized 1:1. And then what happened is, after this switch, again, there was another switch at 12 weeks where the reference insulin, of course, the patient continued to receive Lispro. Another switch happened in this in the 12 weeks period, where now the patient who were already on the reference glargine was switched to the biosimilar glargine, right? So again, at the end of 12 weeks, it was seen. And what happened? So there were 3 periods, period 1, 2, and 3. So this was 12 weeks each. So 36 weeks, patient continued to take the doses of Lispro or Humalog for control of as boluses, right? At the end of the trial, which is week 36, and then there was a follow-up at week 40. So these were the 3 switches that had happened. And again, change in HbA1c from baseline to week 36 with Biocon's insulin glargine was equivalent to reference insulin glargine. So even if you switch the patient who was on Biocon's insulin and, who was on reference insulin, and you switch them to Biocon, the efficacy remains the same. So overall incidence of hypoglycemia, again, safety, similar, no severe hypoglycemia occurred at any point. And this is interesting, cross-reactive insulin antibodies binding over time by treatments were similar. So equivalent efficacy, equivalent safety and immunogenicity was demonstrated between the two groups of patients receiving either the Biocon's glargine or the U100 reference glargine. So I think I'll skip because these are similar. No statistically significant change from baseline to cross-reactive anti-drug antibodies. So they had checked this, and proportion of patients who met the criteria for a cross-reactive ADA positive response, very few people developed anti-insulin antibodies, and they were similar in both the groups. So to conclude, comparable immunogenicity profiles in the two groups and proportion of patients who tested positive for anti-HCP antibodies was similar between the treatment groups. Therefore, availability of insulin products, which are cheaper, which are biosimilar, will help increase access and potentially lower the cost of insulin for people with diabetes. And US FDA has, for the first time, approved the interchangeable biosimilar glargine. It is indicated to improve glycemic control in adults as well as in type 1 diabetic patients who are receiving insulin. So approval of this interchangeable glargine can provide patients with safe, high quality and low cost option for treating diabetes, right? And now the FDA and US Congress says that biological products may be substituted for the reference even without the intervention of the healthcare provider. But I don't like to reiterate this in India. I don't want the patients to change their insulin without talking to their healthcare provider because the pens are different, the devices are different. And sometimes when you just tell them to change the insulin or they do it themselves, they may be using a Lantus pen. And when they use another cartridge from Biocon, sometimes the cartridge may break and they may not be injecting the right doses. Even WHO says that interchangeability should be based on appropriate clinical data and safety issues should be considered, which we have already done because the 3 INSTRIDE trials, particularly because they were phase 3 trials and they did address safety in the phase 3 along with efficacy and immunogenicity. So in India, again, doctors, I would like to reiterate, if you want to choose a cheaper glargine, U100 glargine, because U100 glargine has been the gold standard as a basal insulin for several years, you should be talking to the patient who cannot afford. You should be changing the device as well, because otherwise there'll be wrong dosing. So I think in diabetes UK, of course, they say people with diabetes choose to switch. They should be encouraged. This is the position statement from Diabetes UK. And they can, because of course, NHS pays for their insulin, so they can change. So, but the challenges we faced, yes, the patients who cannot afford glargine. So sometimes because of affordability, there may be late insulinization. And because of late insulinization and a high HbA1c, there may be complications and there may be a rising economic burden because 80% of patients in India pay out of their pockets. So I think biosimilars are here and we should use them judiciously. And the 3 INSTRIDE studies have showed that U100 glargine by Biocon and is not inferior to the reference glargine, which is being sold in United States and America. And therefore, we can save cost by. So per unit cost, you can compare. Biosimilar insulin glargine vials are 48% more affordable than the reference product. And biosimilar insulin glargine cartridges are 23% more affordable than the reference. So I think I conclude my talk by saying that our Prime Minister is talking about Atmanirbhar Bharat. So we are going towards that direction, self-reliant, and we are also providing insulin to the whole world. So it's a matter of great pride for us that Biocon is now. So Kiran Majumdar-Shaw, she's providing insulin to the whole world, and there is no harm because we've actually done the PKPD studies. Some of us were part of the trials which were done in India, and we've seen that you can change from U100 reference glargine to U100 glargine biosimilar. Normally, I discourage changing from one to another unless the patient is non-affording. But all newer patients that we want to start on basal insulin, we are actually comfortable starting with the U100 glargine, which is a biosimilar. Thank you. So I stop sharing, Shalini.
Yes, please.
Yeah.
So that was really a wonderful talk, ma'am. And you clearly explained that when to use biosimilar, and it's not always that you have to change as it is Indian product, but when to change, that you have beautifully explained. And we'll have the discussion further later, and I'll hand over the session to Dr. Dharmendra Panchal for next proceeding.
Thank you, and we are proceeding to the next session or next lecture, and that's going to be delivered by none other than our own Dr. Shalini Jaggi ma'am. She is going to talk on regarding second generation basal insulin options in context with its consideration regarding some glycemic metrics and personal patient centered approach. We all know she is consultant, director of Life Care Diabetes Center, New Delhi, fellow of Royal College Physician, London, Edinburgh,
Dharmendra, we can
Glasgow,
just start.
fellow Pace, and uh, over to you, ma'am. Yeah.
Thank you so much, Dr. Dharmendra. So, since this is Insulin Symposium, the idea of putting these two topics was essentially because, we all have been using insulin for a long time, but somehow, in spite of the best of our efforts, there are challenges. And a biosimilar insulin, and then a generation 2 insulin, both of them have their own place in therapy when it comes to overcoming these challenges. So when it comes to a biosimilar, the quality of insulin delivery at a reasonable affordable price is the USP of using a biosimilar insulin. But when we move on, when it comes to the gen 2 basal insulins, this is where we may feel that it is expensive, but if you look at the benefits that these offer, then the cost does justify when it comes to the benefits that you get with these designer insulins. So again, my confession, this is a sponsored talk. So when it comes to glycemic control with insulin, we all know patients with type 2 diabetes at some point in their progression of disease will eventually need insulin treatment, which means initiation of insulin and then intensification of treatment. Because the whole idea is not only to achieve good glycemic control, but to prevent complications and give them a good quality of life. So therapeutic inertia is something that kind of, in spite of initiation, prevents the patient from reaching targets. Now, this could be physician driven or this could be patient driven. So even if we at times initiate insulin, we do not intensify, and that is why patient is not able to achieve good glycemic control. And a very important reason why we are scared of intensification is because of the fear of hypoglycemia. So the moment you start thinking of insulin, besides the point that it's an injectable, hypoglycemia becomes a major concern, because we know that hypoglycemia is associated with significant morbidity and mortality. And the risk increases multifold when it comes to a frail elderly patient or patients who have comorbidities, for example, somebody who's got renal impairment, etc. This is where the second generation basal insulin analog, Glargine 300, provides comparable glycemic control with a lower risk of hypoglycemia compared to the other basal insulin analogs that are available. Now, this is something that I just talked about. Various studies clearly showing that hypoglycemia is a major barrier when it comes to achieving optimal type 2 diabetes management, because it is common, though underreported, in a lot of patients with type 2 diabetes. Mild to moderate hypoglycemia increases the risk of injury from falls or accidents at times, and recurrent hypoglycemia, especially severe episodes, can increase cardiovascular events as well. Again, when it comes to the elderly and the frail, we know hypoglycemia risk has to be kept in mind whenever we're thinking of any particular therapy for them, especially those with renal impairment or multiple comorbidities. So that is where the choice of insulin and the dosing has to be very, very proper. Now, this is where the second generation basal insulin analog scores over the conventional or the first generation basal insulin analogs, as you can see here on your screens. All the guidelines now clearly recommend that basal insulin analogs are much better, far superior when it comes to reducing the risk of hypoglycemia as compared to the conventional NPH insulin that all of us used decades back. The improved PK/PD profiles of the second generation basal insulin analog, Glargine 300, are associated with lower risk of hypoglycemia when you even compare it to the first generation analog, which is the U100 Glargine insulin. And this ideal PK/PD profile of a basal second generation, as you can see here, a much flatter and a much longer duration of action with much less glycemic variability and a longer duration of action. So I'll not bore you with all the theory, because I'm sure all of us have been using the second generation basal insulins. What I'll do is I'll run you through a few clinical cases that we commonly encounter in our OPDs and see how the generation 2 basal insulin comes to the rescue for these patients where we have those challenges. So my first case is patient A, who is uncontrolled on multiple oral agents. Now, this is a 52-year-old gentleman, diabetes duration of 6 years. He's a delivery driver, so drives around a lot, has got irregular working hours. Now, his BMI is 32. You can see a renal function pretty all right. 90 is his GFR. He is currently on all the OADs that you can think of. So he's already on an optimized dose of metformin, 1 gram twice a day. He's on glimepiride, 2 milligrams twice a day. He's already on an SGLT2 inhibitor and a gliptin optimized dose. And for his hypertension, he's already on an ARB, and for dyslipidemia, he's already on a statin. He's got hypertension. There's no established CVD in the family. His father did have type 2 diabetes and died of an MI. So the patient is worried about potential weight gain with insulin when you talk of insulin. He was given the option of a GLP-1, but he could not tolerate. So that's why GLP-1 is not on board. Now his current A1C is 8.2%, and it's been almost in the similar range almost the entire year. But again, whenever the topic of insulin comes in, he's reluctant because of the inconvenience of taking insulin, because he's got irregular working hours. If he has a delivery in the morning or in the evening or late night, so taking insulin at that particular time becomes a difficult problem. And like I said, he's a driver. So, with sulfonylurea and then adding an insulin, hypoglycemia concerns are something very, very important here. Now, let's take a step back and see what is the evidence when it comes to choosing an insulin with this patient in mind. Well, first is the flexibility of taking the insulin. So compared to a U100, which has to be taken at the same time every day, Glargine 300 can be injected in a 3-hour period. So you have a window of taking it 3 hours prior or 3 hours after the usual time of this once daily efficacy administration without any effect or change in its efficacy or safety. Then you have these 4 studies which actually bring you back to why you can choose this insulin for this particular patient. The take control study, which clearly says that compared to a physician-led titration, if you empower your patient and you educate him on self-titration, Glargine 300 resulted in superior HbA1c reduction without an increase in the risk of hypoglycemia. So that means if you can initiate and teach him how to titrate the dose, the risk of hypoglycemia becomes much less. Again, we have the Edition 3 and the Bright trials. Both of them clearly showing that Glargine 300, when compared to Glargine 100 and IDEG insulin also, did show comparable glycemic control with much less hypoglycemia, especially in the initial titration period, because during titration, if a patient goes into a severe hypoglycemia, sometimes the compliance becomes difficult and he'll completely go off insulin. So that is one good advantage here. And furthermore, when it comes to the weight gain concern, again, you see that over 6 months of Glargine 300 use, weight increase was negligible, hardly 1.4, 1.6%. Then even in insulin naive patients, the real world evidence through the Deliver naive clearly shows initiation of Glargine 300 in comparison to Glargine 100 was associated with significantly improved glycemic control without an increase in hypoglycemia. So empowered with all this knowledge, I think we can be convinced that we can add a U300 for this patient and maybe reduce the sulfonylurea dose and eventually later on maybe discontinue the sulfonylurea, because the second generation analog offers relatively low hypoglycemia risk, good efficacy and dosing flexibility for this patient. Of course, it's important, immaterial of whatever therapy we give, whenever we are intensifying therapy, don't forget the role of lifestyle and diet modification, which need to be reiterated at every visit. Again, like I said, it's important to guide and train the patient on regular SMPG, which has to be performed essentially on a daily basis if possible, so as to titrate the insulin doses, especially in this case because he's a delivery driver. So hypoglycemia has to be avoided. So that's very important. And now we all have SMPG and AGP CGM technologies available, which can largely help these patients to achieve good glycemic control. And like I said, revision of his HbA1c target. So he's already uncontrolled. You have to tell him that his target has to be less than 7%, of course, without hypoglycemia, to ensure a tight glycemic control, because this man is young, does not have established CVD, but his father did have a MI. So with that, let me move on to the second case. This is a female, 61 years old, diabetes duration of 10 years, BMI 31. Currently, she's already on a U100 Glargine, the first generation basal insulin analog, 28 units HS. She's also on an optimized dose of linagliptin, empagliflozin, and metformin. She did try a GLP-1 receptor agonist, but eventually discontinued due to the high cost, and we all encounter such patients on and off. Her HbA1c is 7.5, and she seems to be pretty satisfied with it at her age. She has no CVDs. She does have confirmed nocturnal hypoglycemia with maybe 1 to 2 episodes every 2 to 3 weeks, which result in maybe fatigue in the day. She's concerned about hypoglycemia, scared of a severe hypoglycemia because she lives alone and drives to work and has a good social life. She thinks that she's on HbA1c target. 7.5 at her age seems to be reasonable to her. And she thinks that, since she's already on target, can she stop insulin? So now let's go back and look at some research evidence here. Now, Deliver 2 was a real-world evidence which showed that patients with type 2 diabetes, if they were switched from U100 to U300, the incidence of hypoglycemia became much less, and this was exactly the same benefit was achieved whether the patient was on a degludec insulin or a detamar insulin or even a glargine 100. So any switch from first generation basal to a second generation basal, hypoglycemias became much less. Now, addition 2 was an RCT, again in people with type 2 diabetes and controlled on basal insulin and OADs, where compared to glargine 100, glargine 300 arm, patients showed less nocturnal and anytime hypoglycemia. And the lightning real-world evidence, which clearly shows that treatment with glargine 300 was associated with lower rates of severe hypoglycemia in comparison to glargine 100 or detamar in patients who were switched from another basal insulin. So for this patient, what do you need to keep in mind? You need to tell her that type 2 diabetes is progressive. She does need insulin, and glycemic control does not mean that she's in remission and she can stop insulin, because obviously if she stops insulin, there is definitely a huge probability that her glycemic control is going to worsen again. Furthermore, since she's confident she's already on a basal insulin, all you need to do is switch her to a generation 2 where the hypoglycemia concern can be addressed, giving her a good efficacy, and tell her that for her, even a target of 7% is equally good. She need not stay at 7.5. She does not have any comorbidity. So you can probably aim for a better intensification. This is where second generation basal insulin analog will help, because it reduces the risk of nocturnal hypoglycemia as well. And of course, she needs to adjust the dose based on her glycemic control, based on the SMBG values. And sometimes if she's scared of, a nocturnal hypoglycemia, maybe switching from an evening to a morning administration can be considered. You need to educate her on hypoglycemia self-management and recognizing situations when hypoglycemia may occur, which means telling her to eat on time and small frequent meals along with regular SMBG. So with that, let me move to the third case. This is case patient C, an 80-year-old elderly gentleman, BMI 27, who's had diabetes for 16 years. Of course, you can see he's got mild renal impairment, GFR is 64. He's also got peripheral neuropathy, pre-proliferative retinopathy. So the microvascular complication gamut is already there. There is a slight beginning of dementia for this patient. He's got hypertension and lipids, which are well managed with treatment. Now, this patient is on a DPP-4 inhibitor, metformin, and SGLT2 optimized doses. Now, his caregivers are unsure on whether his glycemic control is adequate or inadequate because they are scared of hypoglycemia impact. They are concerned for his safety, worried about the complexity of starting insulin, and are therefore reluctant to start insulin injections. Now, this is where we need to go back and look at the data that is present in the senior age group. So you have the senior RCT, where glargine 300 demonstrated good efficacy and safety in people who were more than 75 years of age with type 2 diabetes. And there was documented less symptomatic hypoglycemia and documented less severe hypoglycemia in glargine 300 arm versus the glargine 100 arm. Again, the addition 1, 2, and 3 RCTs clearly showed similar glycemic control to glargine 100, again with a lower incidence of nocturnal hypoglycemia irrespective of age. So even if it was less than 65 or more than 65, you see the same results. The bright RCT again showed that glargine 300 in comparison to the degludec 100 showed good greater HbA1c reduction without an increase in hypoglycemia in people with type 2 diabetes who were more than 70 years of age and starting a basal insulin analog. So this patient, of course, needs better glycemic control because his blood glucose levels, are high. He's already got neuropathy and retinopathy, and these could be detrimental to his complication profile. Furthermore, he's got an onset of dementia, and we know that hypoglycemia also can worsen his dementia. So you need to start a basal insulin analog, but you need to give him something that does not give too much of a hypoglycemia. Start with a simple titration algorithm as is recommended by the ADA. This is where glargine 300 gives you a relatively simple regimen to improve glycemic control with a risk of hypoglycemia that is lower than the first generation basal insulin and the other second generation basal insulin analogs. So for this patient, educate this patient and his caregivers to enable them to manage his diabetes using a pragmatic A1C target of at least less than 8% and home glucose monitoring, which is very, very pertinent in this case. My last case, this is patient D. 68-year-old gentleman, 20 years of diabetes, BMI 30. Again, you see a compromised renal function. He's at a stage 3A CKD with 40 GFR. He's got background diabetic retinopathy. He's already on metformin, empalina. He's on a statin and an ARB and a calcium channel blocker for his hypertension. GLP-1 was not tried due to a pre-existing gastritis on and off. His A1C, as you can see on your screen, is 8.8. Now, of course, this lady is worried about her glycemic control. She's never been on her target ever since she was diagnosed. So she's been on pretty uncontrolled diabetes. And no doubt she's landed up with CKD and background retinopathy. She's particularly worried about her complications now, and she's worried for her eyes and for her kidneys. Now, what does the research evidence say for such patients? This is a post hoc analysis of edition 1 to 3 randomized controlled trials, which clearly showed glycemic control with glargine 300 was comparable to that with glargine 100, but with lower rates of hypoglycemia in patients with type 2 diabetes who had mild to moderate renal impairment. So again, you see a safety data here. The DELIVER high-risk study found that in people with type 2 diabetes and mild to moderate renal impairment, switching from another basal insulin to a glargine 300 resulted in similar A1C reduction and less hypoglycemia compared to a switch to the first generation basal insulin. And again, a post-hoc analysis of the BRIGHT randomized control trial found that glargine 300 use was associated with greater reductions in A1C compared to degludec, without increasing hypoglycemia in people who had type 2 diabetes and impaired renal function. So what do you need to keep in mind when you are looking at this patient? Of course, you need to intensify her glycemic control because you need to stop the CKD progression. Since she is already on a metformin and SGLT and may not tolerate a GLP, next step, of course, would be offering a generation 2 basal insulin, the glargine 300 insulin. She should be educated on diabetes self-management, managing hypoglycemia risk, and dealing with hypoglycemic events if at all it does occur. You should review the recommendation for medication use on days when she is unwell. So if the basal insulin is initiated, she may benefit from continued treatment on such days with increased blood glucose monitoring and adjustment of doses as required. And for her, a pragmatic target would definitely be anything around 7 to 7.5%, which may be more appropriate compared to where she is today. So friends, to sum up, there is a strong evidence for glargine 300 use. You have the PKPD studies versus glargine 100. You have the addition program. You have the DELIVER and the ATOS real world studies. So you have RCTs, you have real world evidence. You have a combination of each, both on comparison to the first generation or the other basal insulins. You have the patient experience studies. You have studies clearly showing much less hypoglycemia risk with the U300 insulin when you compare it both to glargine 100 and both to insulin degludec. The one case study clearly showing you the real world evidence in type 1 as well, the BRIGHT study in type 2, and the real randomized control trial in range, which clearly talks of less glycemic variability with glargine 300 in comparison to degludec. So to summarize, patients with type 2 diabetes will eventually require a basal insulin to achieve or maintain glycemic control, and we should definitely not delay this. Second generation basal insulin analog, such as a glargine 300, represents a suitable basal insulin option for people who need insulin initiation and then intensification of their anti-hyperglycemic regimes. And improved communication is the key. So you need to empower your patient, educate your patient, along with appropriate tools and support, which increases the patient's confidence when it comes to starting insulin and titrating insulin doses to achieve optimal glycemic goals. With that, I think I'll end and stop sharing and we can take up some discussion. Thank you.
Thank you. Thank you, Dr. Shalini. So I like to add one thing here, Shalini, that now we should bring out the, very warm welcome, our dear friend, Dr. Bhavitarani. It's nice to see you. So Shalini, what we should now do is that we should talk to the audience that where is the place for U100, whether the reference glargine or the biosimilar glargine, and where is the place for the generation 2, whether U300 glargine or degludec. So let me just set the ball rolling by saying that it's not just the cost. If my patient is a type 2 diabetic, is on U100 glargine, takes food at the same time day after day, and has a very good lifestyle, and is ready to inject at the same time, say 10 p.m. or 11 p.m. at bedtime, has a regulated life, I don't mind giving a U100 glargine. Because if he's only on basal insulin and I'm controlling his postprandials with either oral drugs or a combination of oral drugs, or if I'm using an oral semaglutide or an injectable GLP-1, I'm happy. So these are patients, other than cost, who are well controlled, do not have evidence of nocturnal hypoglycemia, can be continued on U100 glargine, whether biosimilar or the reference glargine. Now, coming to the advantages of generation 2 U300 glargine that you discussed, let's take our audience back to, every time we should take them back to the basics. So any insulin, remember the onset of action, the peak or is it peakless, and the duration and the variability. So the inter-individual and the intra-individual variability. Now, I agree with you wholeheartedly that the inter-individual and the intra-individual variability with U300 glargine is much less. So obviously we have a more stable profile. All said and done. Dr. Bhavitarani, if you don't agree, you can unmute. If we are using low doses of U100 glargine, say less than 12 to 14 units, it may not act for 24 hours.
Yes.
So the duration becomes shorter when you're using a smaller dose. So in your type 1 diabetic patients, you may be struggling in the last 1 to 2 hours because the 10 or 12 units in a type 1 whose weight is say anything between 35 to 55,
Yes.
50, you are struggling in that last 1 hour. Also, they may not be able to take the insulin day after day at the same time. So they have tuitions, they go out, they come back, have a late dinner, and they delay the bedtime glargine. And that is where the window of U300 becomes important, and we can use U300. So again, my message is very clear. If your patient is non-affording, don't not give him insulin. Give him a biosimilar U100 glargine. Give him Biocon's insulin. We have PK/PD studies, comparable studies. But yes, if your patient has nocturnal hypoglycemia, two more things: can have nocturnal hypoglycemia and post-hypoglycemic hyperglycemia, Samogai phenomena. Now, Shalini and me will be able to pick it up more and more because we are using sensors. So you'll actually see the sugar drop, say 3 a.m., and then you'll see a very high fasting sugar. And if you don't do a flash glucose, or if you miss that hypoglycemia, you end up increasing the dose of basal. So even this nocturnal hypo followed by hyper can be taken care of by the U300 or the degludec. So that's my take. They are different. So don't get us wrong when we talk about two different insulins. They have their own place. One size doesn't fit all. So my take is if your patient needs insulin, please start insulin. 3 drugs or maybe 4 now because we have oral semaglutide. If they fail, it's better to start with insulin, start with basal insulin. If the patient is non-affording, you can start with the biosimilar U100. If the patient is affording, you could start with the U100 glargine, or, if you want additional advantages, like Shalini said, you could start with the generation 2. Now to you, Shalini, what's your take?
One more addition and indication where we have been using glargine 300 is pregnant patients, pre-gestational diabetic, somebody who's already got type 1 or type 2 diabetes and is already on a basal bolus regime and needs high doses of insulin. Earlier we did have concerns of glargine use in pregnancy, but now there's sufficient data, and actually about 2-3 years back, we did publish a kind of a review article where we actually looked at all the studies that were available. I mean, the audience can understand, in a pregnant patient, you cannot conduct an RCT. All you can do is just look at the case studies, collaborate all the data, the literature evidence that's available. And we did a thorough literature search of all the global evidence that we had on use of glargine. And just like all the guidelines, even the NICE UK guidelines And most of the global guidelines today accept that if your patient is already having diabetes prior to planning the pregnancy and is doing well, maintained well on a glargine insulin, there is no need to change the glargine insulin a preconception, so that the glycemic control can be optimized all through pregnancy, because we have a pregnancy symposium coming up after this session. In pregnancy, we all need preconception very tight glycemic control, and there's data which shows that using glargine insulin in pregnancy is also safe, and there were no major adverse events. And this is where Dr. Rutul is also here chairing this session. Rutul, me, a lot of us did combine our data on U300 use in such women who needed high doses of insulin. The pregnancies progressed smoothly. There were no major increased adverse events when it comes to both the maternal or the fetal outcomes using glargine 300. And I think Rutul can put in his comments here. We're again collaborating a larger proportion of data on U300, and we will be probably submitting it next year for one of the presentations.
Yes, so Dr. Shalini, I want a clarification.
That's again one indication where, patient who needs a high basal. We have a lot of obese type 2 diabetics these days coming with IVF pregnancies, who need like basal insulin almost to the tune of 40 units.
Especially for pre-existing diabetes.
Pre-existing. Yeah, I'm talking only of pre-existing. I'm not talking of gestational diabetes here.
Yes.
Only the pre-existing type 1s or type 2s. There, if she is already on a basal bolus and needs a high dose of basal, although we know that detemir insulin is the safest insulin when it comes to the analog basal in pregnancy, but sometimes levemir may not be sufficient. So either you have to give 2 shots of levemir when she needs high basal. Compared to that, a U300 insulin at this point can help you achieve better glycemic control. So clearly, I'm talking of pre-gestational.
So Dr. Shalini, we clarify here that we are talking about diabetes predating pregnancy.
That's what I said, type 1 or type 2 diabetes.
So it's a
well
type
maintained.
1 or type 2. So are you saying the audience should be clear that somebody who has been type 2 diabetic predating the pregnancy now is already on basal bolus, because one of us has started basal bolus for better blood sugar control. We have
so you can continue U300 glargine. No need to stop glargine and convert her to a detemir insulin, because surely the glycemic control will deteriorate and you cannot afford that.
What about U100 glargine?
U100 is also equally good, but U300 definitely works better because of the less nocturnal hypoglycemias and all the benefits that I just discussed.
Truly, very, very stable profile.
In pregnancy, any amount of glycemic variability is associated with macrosomia and adverse neonatal events. So in pregnancy, as it is, you need very tight glycemic control, and I'm sure in the pregnancy symposium we're going to talk about this in detail. So this is again one indication. Lady with type 2 diabetes pre-existing can be continued on glargine insulin.
So I have another interesting question now.
Yes, ma'am.
You have made it clear that already on glargine can be continued. Already on.
Yes.
But it is not be started new.
New either NPH or detemir. Okay, Shalini, I have another question because our audience again will be curious.
Ma'am, I want to add something.
Please.
That we are going to present this data in IDF this time, and we have around 130 patients data for glargine U300 in pre-existing diabetes, and we are going to provide the data for safety mainly. So our idea was that glargine 100, what is difference between glargine 100 and glargine U300? It is just the concentrated insulin. There is no difference in molecule. This is why we started using it, and it has shown tremendous results. And we are seeing that it is helping a lot in pre-existing diabetic patient. So rightly said by Shalini ma'am, that we are using it, and she was also part of this study, and she gave the data. I was fortunate to have some data from her as well, and Dr. Dharmendra Panchal was also.
Yeah, your voice is cracking. If you could switch off your video.
Of this study too. So with this,
Rutul, if I am correct, that glargine. Again, what you're saying, the incidence of hypoglycemia also you'll feel very less with the 300.
300, yes, ma'am. That
true,
was one reason why we, so it's like if it is, so initiation for the first time, definitely levemir any day is better, or NPH. But if it is a pre-existing lady with type 1 or type 2 diabetes being managed already on glargine, no reason to switch to a detemir insulin. So that message should be very clear.
So, Shalini, I have another
Pre-existing
question
diabetes.
here for the audience. When we were students, we were taught that short-acting insulins become longer-acting when there's chronic kidney disease, and long-acting become increasingly long-acting. So there is a lot of confusion in the mind of the physicians whether to use an ultra-long-acting insulin in CKD. Now, my premise is that the problem with long-acting insulin is not the action that is long because it's not being excreted by the kidney, but it's also because they have a peak. So are you sure we can use U300 glargine in CKD as it advances? And please, your message to the audience that should be used basal, because we see a lot of doctors, including hospitals, where there is no basal in chronic kidney disease. They're scared of using basal and they are just following, they're just giving boluses and they're just controlling the post-meal sugars. So obviously, if you don't fix the fasting, you're groping in the dark. So again, a very clear message to our audiences, even in CKD, basal is needed on board. Yes, basal may cause hypoglycemia on the 4th or the 5th day because it may accumulate because it's not being excreted. So vis-a-vis U100 glargine and U300 or generation 2 basals, Shalini, what's your take in CKD?
In CKD patients, it's very clear if your patient is on dialysis, prior to dialysis, the dose requirement is going to be different. On the dialysis day, the dose requirement changes. And once the dialysis is done, you will immediately see a fall in the glucose levels. So the insulin requirement will majorly fall down. So these are exactly, there will be a category of CKD patients on dialysis who will not need a basal insulin. There only the bolus insulin as per his glucose levels is required. But a patient who is relatively more stable, eating well, for those patients, a basal may be started and may be indicated. Now, this is where the dose of basal, you have to be a little more careful. Maybe prior to dialysis, it's always better to reduce the dose of basal on the day prior to dialysis so that on the day of dialysis and the next day, the risk of hypoglycemia can be less. And on the non-dialysis days, you can again go up on the dose. So I think this is going to be a little tightrope walk, a tightrope walk in such patients where you need to actually do active glucose monitoring. You need to keep checking the glucose levels and accordingly decide on the dose of insulin. Yes, there will be, the cachexic patient who's not eating well, who's already not doing well. So for those patients, at times, a basal insulin is not required in these kind of patients. But relatively, a patient who's stable, going for maybe a once weekly dialysis or maybe even a twice weekly dialysis, for those patients, some amount of a basal insulin does help in getting a little more stable glycemic control.
So one more question, I think, and then we'll wind up, is to all the panelists who are listening in, does the dose of glargine bother you? Because there were studies that very high doses would act on the receptors and there was some concerns about malignancy. So yes, what is that dose? And would you like to give it then in 2 divided doses? If the dose is high and higher than what?
I have never been in favor of dividing the doses of glargine into 2 and giving. I mean, what's your take? How do you use it?
I do it. But now after I heard an international speaker talk about Detamir being better if you want to divide in your type 1s, I've been doing that with Detamir. The problem with Detamir is availability. Because Detamir is not, Novo doesn't market it so well. So Detamir is not available easily to the patient. We have to provide it. So we were happier using glargine once.
Now we have data for,
Rutul,
data for Detamir as in US it is, okay, now I'm audible?
Yeah, you switch off your video, Rutul. Your voice is cracking. Switch off your video and we listen to you.
So, as it is largely available in US market, Levemir, this is why we have the data for dividing it. Otherwise, I would say that glargine is always better, even if you divide or if you give in single dose, as we have more and more data for Levemir. This is why they are talking like this.
Dr. Meena, we
Dr.
have
Dharmendra.
It is in particularly if you are going to use in obese patient, BMI more than being 30, and if you require a daily dose of more than 40. Yes, of course, clinically we have seen some benefit of using glargine U100 twice a day. But nowadays we are switching over them to glargine 300.
U300, absolutely.
So with one shot only, we are getting that improvement. Yes.
Absolutely. Dr. Meena, are you there?
Yeah, I'm there.
So just a quick question. A lot of people, we've discussed CKDs. What about CLD? Your take on using basal insulins in CLD patients? Because that's again something that we see all spectrums.
We may not need.
We lost your signal. We
burn
can't hear
your
you.
fingers because there's hardly any hepatic. Hear me?
Yeah.
Can you hear me now?
Yeah, your
So
network.
Shalini, we may not need basal. So there are two conditions where you may not need basal. One is pregnancy, sometimes CKD, and chronic liver disease. You may be happy only giving them boluses as and when they eat. But I think that in chronic liver disease, you will have to divide the patient into child pug A, B, and C. In child pug A, I think you may need a little basal if the patient is, has good liver function. You may need basal. I prefer using U100 glargine, and in the hospital, we still use NPH because then we have a window of opportunity because I'm using the NPH twice. But we continue to use it in our hospital, Gangaram. Otherwise, U100 glargine is as good. Some of our chronic liver disease may not need basal insulin because they don't have any glucose reserves
Glycogen
in
reserves.
the liver. So I think
this is very important because hypoglycemia can be a very important challenge in patients who have severe CLD, especially the class C patients, because there's no glycogen reserve. So hypoglycemia could be a major concern in these patients. So I think the message is very loud and clear to the audience. Yes, the newer generation basal insulins do offer us the benefit of good glycemic control, good efficacy, at a lower risk of hypoglycemia. Weight gain again is not a huge concern with these generation 2 basal insulins. But what we need to understand is the importance of initiation and titration. Simply starting an insulin and sending the patient is not sufficient. You need to empower and teach your patient on SMBG. He has to do SMBG, and accordingly, he needs to titrate his doses to intensify the insulin doses to achieve a glycemic target. So simply writing 12 units HS and sending the patient home, he comes back after 2 months and he's still on 300 does not make a difference. So I think empowering the patient on dose titration, need for intensification, and how to use that knowledge he's gaining by SMBG to optimize his glycemic control and insulin doses is very important. I think with that, we'll end this session. And many thanks to our chairs, Dr. Dharmendra and Dr. Rutul, and my co-speaker, Dr. Meena, for the excellent insulin symposium. And I'm sure all the delegates would have definitely taken home some important advice when it comes to insulin, especially the basal insulins, the biosimilar U100, as well as the generation 2 U300 insulin. So many thanks, Dr. Rutul and Dharmendra and Dr. Meena.
Thank you, ma'am. Thank you for having us here.
So now it's time for the pregnancy symposium, a very, very important DIPSI symposium that we have, a joint CMRE DIPSI symposium. And to co-chair this symposium with me, we have none other than my very, very close friend, my elder sister, Dr. Bhavtarini. We all know her. Whenever it comes to pregnancy, I think we cannot do without her expertise in this area. Dr. Bhavtarini, welcome, ma'am. She's honorary professor of diabetology, state IMA. She's state coordinator of IMA diabetes course, national and state award for academic contributions, and has a huge contribution to DIPSI and the field of pregnancy. Welcome, ma'am. Good morning.
Good morning.
Good morning, everyone. Professor
Shishai, Dr. Good morning, Dr. Seshia, sir. Pranams
Dr. Balaji
to you.
And everyone.
Dr. Balaji, sir. Good morning. Welcome, sir. We have the who's who of pregnancy here.
CMRE DIPSI ASD Joint Symposium, which is scheduled for 10 to 2:20 p.m. And I can promise it is going to be a wonderful scientific feast because we have the best of the batteries, those who can speak about GDM, starting from Professor Shishai, who is not only a father of GDM in this country and mentor to all of us. And very fact that me and Dr. Shalini didn't qualify for getting a session in this speaks about the quality of science which will be delivered in this session. So we'll be just around. She'll be cheering along with you, and we'll be happy hearing Professor Shishai, Balaji, everyone, Sunil, and other people. Thank you. Over to you, Dr. Shalini.
Thank you, sir. Can we have, I know Dr. Seshia needs no introduction, but formalities have to be done. Bhavtarini, ma'am, I would like you to say a few words.
Yeah. My mentor, Professor Padmasri, Professor Dr. Seshia, has completed his MD, MRCP, DSc, DSc honors and distinct professor of Tamil Nadu, MGR Medical University lifetime, and established the first department of diabetology in the country in Government Madras Medical College in 1978. And he also started the feto-placental unit for the first time, I think second in the world, at Madras Medical College in 79. And he is the founder patron of Diabetes in Pregnancy Study Group of India, DIPSI, and he is the Vice Chair, Executive Board, International Association of Diabetes and Pregnancy Study Group, and he is the recipient of P.C. Roy National Award in 88 for the development of diabetology as a specialty for the first time, and none other till date in the country. And he has a Lifetime Achievement Award confirmed by the International Diabetes Federation in 2017, and the most prestigious Padma Shri Award in 2022. And now we are going to hear the recent, of course, we had the single DIPSI test given by Professor Seshia as the national guidelines, which everybody is following right now. Now, our professor wants to grab diabetes from its roots rather than finding out the cure or preventing the complications. Now we are going to hear about Professor Seshia's concept, what he is going to say. Over to you, sir.
Thank you. Thank you, my dear chairpersons. I thank Dr. Rajiv Chawla, Dr. Shalin Jaggi. My goodness, what a capacity they've got to organize such a big meeting like this. My God. And I thank the International Symposium on Diabetes Care, the international speakers, and I thank every one of them for. I hope they attend to this talk, which I think very rarely, recently I started talking on this particular topic. And I'm very happy to have Shalini and Bhavadani, the chairperson, and Rajiv. Good. Rajiv is I don't know what to praise him. So good. Now I am going to speak. Colleagues are there. This particular topic, I think it is like a school teaching. I will be talking on the slides here. It is where I would like to talk on the heart of the matter for 2022, because this concept which I am going to speak introduced only in the month of April of this year. So my topic will be in discussion will be on this. I am path-breaking concept for primordial prevention of diabetes. Believe me or not, I have been professor for so many years. It never occurred to me till March of this month. Prevention of diabetes, we have been always treating diabetes. The lots of drugs, I just listen to the insulin, oral drugs. But I don't know why I don't know when I thought about prevention. It occurred to me how to prevention of diabetes. So estimation and projections of the number of people with diabetes in different editions, millions. So it is a problem what you're going to face. You are how to prevent that. So 2019, the prevalence of diabetes was 463 million. In 2020, it was 536. That is 60% increase. And we are expecting 2045, 783 million, 54% increase. So it's phenomenal increase in the prevalence of diabetes. Pre-diabetes approximately 380 million, which is likely to increase to about 480 million by 2040. So it is a frightening. Diabetes is an epidemic of unprecedented magnitude, and as IDF President told, he calls it a pandemic. So we are facing it from epidemic to pandemic. Then we must take some steps to prevent this diabetes development. How we have discussed with you and then share your opinion also. Now, all of us know detection of diabetes does not mean prevention of diabetes. You have this screen like this. Of course, it's laudable. You will see here, defeat diabetes, number of people are talking on that all over the country, all over the world. If they say beat diabetes, beat pre-diabetes, let us fight diabetes, disability diabetes, demystify diabetes, and discriminate diabetes. These are all words used to say detection of diabetes. But what I am going to talk will be these methods are unmasking already existing diabetes, what we are going to concentrate here, and I'm going to share with you what we need is primordial prevention of diabetes. That means that disease should not develop. So that is my first introduction. So how to go about this primordial prevention of diabetes is that now we'll discuss. Now, number of studies we always quote abroad, what they are doing, what steps can be taken for primordial prevention of diabetes. Evidence. Now I'll share here what this is a work done in the United States Diabetes Prevention Program. What they said was in September 2001, this is very, very important slide, the Centers for Disease Control and Procedures, all of us know is very important organization, issued a press note or release stating that twin epidemics of diabetes and obesity continue to threaten the health of Americans. Genius thinking about that. And diabetes prevention program was introduced. Very good effort. But what happened? Here, surprisingly, in 2001, it was 6.1% when they introduced the diabetes program. And when they analyzed data after 10 years, 20 years, about 10.5% had Americans developed diabetes. So whatever program they made is an utter failure because this attempt they made by the CDC is almost double from 2001 to 2021. So then having come to conclusion, this study and this program is, I think it's obvious, it's a failure. Obviously, this is not a successful program. And what could be done? Then what could be the successful program? I think I'm sharing with you my opinion. You are welcome to give your suggestion. Let me see at the end what we're going to do. Now, is it possible to achieve diabetes free generation? That is what we are aiming for. As I told you initially, whom to focus? We want free generation, whom to focus? This, fortunately, this is an answer given here by Lice Kingo. He said, female gender is key for diabetes prevention. I don't know why they told only poor females. They never told about male. They key for diabetes prevention. But there must be some reason why female gender is key for diabetes prevention. Because here you will see here how we can discuss about this point. If you take a developmental origin of disease of any life, it is like this. The womb is well supplied with the mitochondria. But the sperm contains a few, and even those few do not persist in the offspring. That shows sperm plays a very little role. That is why we probably told womb is very important. In this, what happens at fertilization? It is only the nucleus of the spermatozoa that enters the womb. Thus, all the cytoplasm, mitochondria, and mitochondrial DNA are exclusively maternally oriented. So we all depend on our mother for everything. The whole thing comes from mother. What going to happen to our children, like anybody. So that is why they said female gender is more important. That laser king. Now we'll see here that part is over. Now what David Barker told in the last century, he conceptualized the body's susceptibility to lifestyle disease was programmed intrauterine. He almost supported the idea given by Les King. The intrauterine programming is very, very important. How? Now we'll look into this statement here. Gestational programming is a process whereby stimuli, maternal fuels or stresses that occur at critical or sensitive period of fetal development permanently change the structure, physiology and metabolism which predispose individuals to disease in adult life. So this is very clear. As Lice King told like that, and David Barker said fetal origin adult diseases. Now we got 2 points with us. One, female. Second thing, fetal origin adult disease. Some evidence we can get how to go for the prevention of diabetes. So with this background, now somebody may question me, what about genetic? Parents are diabetic, children may be diabetic, father diabetic, grandfather diabetic. Okay, it is there, it is true, it is not, I am not disputing it. Developmental origin of health and disease, the phenotype here, genes will be definitely plays a role for any diseases here. And then most importantly here, intrauterine environment. And again, when child is born, adult age, postnatal development, both are called epigenetic. That means for any disease, you must have basically some gene wise there and epigenetics. But what we are going to discuss now is that only gene is important or epigenetics are important. Maybe both may be important, but which one is more dominant will be epigenetics. Here you will see here, genetic loads the gun. It may be there. It's not. I'm not disputing. You may have a genetic background from parents or elders, and environment triggers stuff. That shows without environment, genetic won't produce a disease. So that is another basic information which I want to share. And then we'll proceed here. Now, friends, ladies and gentlemen, now we are going to talk about the diabetes mellitus. Here, it is inherent destiny, as I told you, it is genetic, or is it intrauterine environment? Which is more important? Genetics or intrauterine environment? Now we will discuss and come to conclusion. Now what happens here? Exposure to diabetic environment in vitro associated with the increased occurrence of impaired glucose tolerance, a defective insulin secretory response, and adult offsprings, independent of genetic predisposition to type diabetes. This statement is very, very clear, made about 2,003 years ago, that genetic predisposition to type diabetes is not very important. It's independent of that. That shows mother's womb is more important. So now we'll give an example. How can we prove this? Animal experiment has proved that in the model is Mr. rat, the low genetic risk of diabetes. When exposed to hyperglycemic media of goat or rats utero, significantly increase the risk of diabetes in adult life. So the experiment has proved that the uterus is very important, hyperglycemia is very important, animals. Now somebody may question, what about the human beings? This also proof is there here. Maternal hyperglycemia and progeny, the offspring of Pima Indians who were in utero when their mother had diabetes have a greater risk of diabetes compared to them than earlier siblings born before the mother developed diabetes. So both animal experiment and in human being it has found that maternal uterus is more important. Here that means intrauterine milieu is more important than the inherited destiny. So now we all accept this concept of intrauterine milieu. Because intrauterine milieu, what could happen here? We go to the next slide here. Hyperglycemia in pregnancy. All of us know about that. Gestational diabetes mellitus is defined as any degree of glucose tolerance with onset or first recognition during pregnancy. Now, why we are worried about that? Why we are concerned about GDM? Here, another view I want to take here. Then, if you take a pregnant mother with pregnancy, gestational diabetes mellitus may play a crucial role in the increasing prevalence of diabetes and obesity. That means you have to focus on the gestational diabetes mellitus. Here, that's what this statement says. And not only that, if you with this GDM, insulin resistance, increased atherogenic lipid profile, inflammatory markers, hypertension, endothelial dysfunction lead to increased risk of CVD. So we are almost coming to the point that GDM is a mother of non-communicable diseases. So at this third point we have accepted now. So having accepted GDM as mother of non-communicable diseases, next step will be here. I'm going to another angle here. Detection of diagnosis of GDM is possible because all of us know diagnosis, number of countries are given, number of guidelines. It is possible. What I would like to share with you will be what we are concerned is prediction of GDM. Detection is a different thing. Prediction is a different thing. What we are concerned in the prediction of GDM. How to predict the lady is going to become GDM in the future, so that we can prevent development of GDM and its consequences. This message is very, very clear. Prediction is necessary. Once you predict, then you can prevent. So now that means you have to take both prediction, when prediction can make, and when we can take the steps to prevent. So we will see here when to test to predict GDM. The next question. That is very important here. Then recently, about few years ago, year 2018, the blood test may identify gestation diabetes risk in the first trimester. This is the National Institute of Health has come out with this type of statement saying the blood test may identify gestation in the first trimester. That's all they told. And one more statement they made, they said which week they said was gestational weeks prediction of GDM. I told you in the previous slide, prediction, that is very important. Then we go for the prevention. Gestational weeks of prediction of GDM will be here. A blood test conducted as early as the 10th week of pregnancy may help identify women at risk of GDM. So it is very important message we got from this study, 10th week. So once you know that is weak, that's going to be a problem, then we can do what possible we can do to prevent that is happening here. So the glycemic level will be there. Another important information, at higher A1C levels of 5.3 or 111 milligram blood sugar compared to those without GDM, that is 5.1. That means any woman at the 10th week, when they check, happen to be having A1C 5.3 or a 2 hour postmortem blood sugar more than 111 blood sugar, probably she is at the risk of GDM. That's why prediction. Now we got at least some answer for the problem. This blood sugar value is going to predict GDM, and 10th week is the most important. Predict the weeks a week we know. Now we also know the blood sugar level at which the GDM can occur. So having known both, what steps we can take to prevent it? Here, and I told you in the previous slide, significance of 10th week pregnancy. Why 10th week is significant? Why not other weeks? Any national institute told 10th week of pregnancy, but they didn't know why, but they just mentioned 10th week of pregnancy. Now this is the answer. Now each islet cell functions as an endocrine organ. Here this slide is very, very important, which gives an answer for that question. Why 10th week? The 10th week important because here the human pancreas begins to develop 4 weeks after conception. And first insulin deposits can be found, but in weeks 7 and 8. And next sentence very, very important. Pancreatic islet cell differentiates at 10th and 11th week of gestation and recognizes and responds to glycemic at 11th week of gestation. So that is what that shows. 10th week is very important for us in the war we want to prevent GDM. And the 10th and 11th week play a major role in the prevention of GDM because now we know 10th week, now we know the answer. What being 10th week. Then also we know blood sugar level should be about 110 milligram, we will get a problem. And so prandial glycemic level that can be considered as abnormal. That is, then only you know that sugar has to be controlled. Very beautiful work done by Hermandes. He says pattern of glycemia in normal pregnancy. Many of us done it also, but anyway, this beautiful work is done in 2011, latest one. Fasting is 71 plus or minus 8 is the normal value, normal pregnancy, and 2 hours less than 110. That means he gives the target of 200 blood sugar, postprandial blood sugar, no post glucose. It is a postprandial 111. You may ask me what food they'll take, but whatever food is taken, it will produce only the same level. If you're a normal person, it won't go up, will be less than 110. So under 10 is the target value which is suggested now. Now I am going to discuss another important angle here. First time NH study in 2018 suggested A1C of 5.3, otherwise we call 2 hour PP blood sugar 110 at 10th week predict GDM. Okay, he has told like that. Then what has happened? He told, but so far no explanation has been given for prediction as well as a prevention of GDM. He stopped with the 2018, after that no progress was made. So we taken up that particular point. Now we know, but so far no explanation has been given for the prediction of GDM or for prevention of GDM. And then here, this is where it comes from us, from India. We conceptualize that maternal tour people from PPBS should not cross, having told that a particular first line, conceptualize, now we conceptualize that maternal tour PPBS should not cross more than 110 milligrams at 10th week. That's very clear. As fetal beta cell starts secreting insulin around 10th, which I showed in the previous slide, pancreas histopathology starts secreting insulin around 10th to 11th week of pregnancy. So now we have got at least half the way across. We know which week will predict, and we know which blood sugar is going to predict GDM and which week. So number of information we have got. Now we have to put everything together, how to go about prevention of diabetes. Now we'll go again here, fetal hyperinsulinemia and maternal glucose. This is very important physiology here. Fetal hyperinsulinemia. Well, we will have to come to the point in future, but I am telling you earlier itself what is the physiology here. Fetal hyperinsulinemia will favor a persistently high glucose flux even at times when maternal blood glucose is normal. That will come back out some time. But this information I would share with you now itself. So the obvious implication is that glycemic control needs to be optimized very early in pregnancy to prevent the establishment of fetal hyperinsulinemia. So the statement here is, when woman conceives, from that time itself, there should not be any high blood sugar, so that we should not develop, mother should not develop, the child, the fetus should not develop hyperinsulinemia. And how to link this maternal hyperglycemia with that of fetal hyperinsulinemia? I will come here. How to link fetal handling of maternal glucose. Fetus has more role to play the early weeks of pregnancy to handle the maternal glucose. Now you will see here example I have given so that we can follow what I am going to share with this idea. Example of fetal handling of maternal glucose, which we never thought. This has been published recently, but we never gave much importance. Now I am giving importance for this particular statement made. For example of fetal handling. Here I will give example here. Weeks postpartum blood glucose here 10th week. Example which I never knew. Happened to, for example, I only give figure example 1 to 6. What suppose when you see blood sugar 1 to 6, most of OBG obstetrician will not interfere at all, because it is not known at that time 1 to 6 is abnormal. We never knew about that. So they said, okay, this is okay, we can continue diet only. Then again 12th week, you see again 112, oh okay, nothing has happened, she is normal. So we conclude saying postpartum blood sugar comes down without any intervention. That is where the problem starts. How the 126 came to 112 without intervention? How? This is the answer for all the problem. Here what happened here, see 11th week, as I told you earlier, secretion of fetal insulin starts. This brings down maternal glucose, which is not desirable. It brought it down from 126 to 112. Who brought it down? Fetal insulin, fetal beta cell, because it secretes insulin. By 10th to 11th week it will secrete, then it brings down. So we have done nothing for the mother. Automatically the fetal beta cell starts secreting insulin and brought down. But this is not a good thing to happen. It is not desirable, because maternal blood glucose does not go up due to fetal insulin handling of the maternal glucose. It has a different physiological action. So maternal glucose does not go up due to fetal insulin, and nothing we did for the maternal glucose. And because of that, this is very important statement. When maternal PPBS more than 100 milligrams, this is recorded in the early weeks of pregnancy, it is advisable to take immediate steps to bring PPBS less than 110 milligram. Last, she will develop GDM and the consequences. So in early pregnancy, 110 milligram, if you record very, very dangerous time, you must bring it down 110 so that otherwise that lady who has 110 milligram, anywhere in the week of pregnancy, she will develop GDM. So the message will be here, your blood sugar should be less than 110 milligram before 10th week. If you more than 10th week, you can't do anything about that by the time fetal insulin starts secreting. So I'll give another answer here. Contribution to glucose gradient here. This is another interesting study. It shows, suppose we take a mother, glucose, M mother, F for fetus. Maternal glucose goes up, immediately it goes down to the fetus compartment. Maternal hyperglycemia pushes glucose into the fetal compartment. And then what happens here? Fetal hyperinsulinemia pulls glucose. So it pushes, mother's glucose pushes glucose, and fetal hyperinsulinemia pulls glucose so that insulin is secreted in the fetal compartment. Then glucose and insulin will result in the adiposity. That is what we're going to get as a macrosomic fetus. The fetal glucose steal across the placenta to the fetus. This is an important event which occurs in the fetal in the uterine compartment. Now again, we'll summing up here what I told you previously. We take like this: guidelines to screen glucose intolerance at appropriate gestational weeks. Here this message is again very, very important. Here, imagine, I'm going to give a picture here. We 10th, 11th, 12th weeks and 20th week onwards. All of us know in 20th week onwards, it's the second time is going to start. Insulin resistance starts due to hormonal changes. Turmeric factor, HPL, progesterone, all these hormones as insulin resistant. So this hormone, because of that, mother may request more insulin. Now, because this is what for many, many years, you should recommendation even now for screening 24-25. Many people still stick to 24-25 for screening for the GDM. Now, what happened to us? What is happening for us will be here. 10th week PPBS 110 milligram, as I told you earlier, and 11th week fetal beta cell secretion starts. This is a fundamental thing which many of us don't know. I'm sharing with you all this information. Now, because why I'm telling here, this particular point will be here. Here it will be here. Presently, the recommendation to test for the glucose tolerance at 10th week is not followed. If you have been following this, things would have been changed. By the time half of the diabetes in the country would have been vanished. But since we are following only the 24th week or a first trimester, never, there's important. The 10th week is important. Don't tell me your 12th week, first trimester. No, it is not important. It is finished. Still, that mother will develop GDM. So presently, the recommendation to test for the glucose tolerance at 10th week is not followed. That is the reason why we get both hyperglycemia of the mother and hyperinsulinemia of the fetus, promote fetal adiposity, and result in the offspring of developing male child obesity, IGT, diabetes, female child born will become obesity, GDM diabetes, and vicious cycle. That's what happens. The whole problem is nobody told us to screen for glucose tolerance. If I had done that earlier, as I told you, we would have almost 50 to 60% of our diabetes would have been managed. Now, this is reference is also there. Now I told you 10th week. Now, another important message I would like to share. Ideally, it is test for glucose tolerance at 8th week. I said 10th week, but I am here. I'm telling you, next step I am going here. Ideally, to test for glucose tolerance at 8th week, 2 months. Why? There should be some reason. Why I am telling 8th week? Because this is only our concept. I'm telling this. I hope I'm sharing with my friends concept. Why 8th week in pregnancy? Because we know prediction of GDM is 2 hour PP is 110 milligram at 10th week. That we are now with this particular point, all of us would have got in our ideas. Fine. Now the second point will be here. Hence, at 8th week itself, PP has to be estimated. Why? Why 10th week is a problem? Why should we do it 8th week itself? Because we need some time. Because here, this is another important statement. In case of PPBS is more than 110 milligrams at 8th week, suppose you do the 8th week test, a grace period of 2 weeks is available to attain PPBS less than 110 milligrams at 10th week. So hope this is the message I would like to share. This by 8th week we test. If you know it is more than 10 milligrams, at that time itself you can use grace for 2 weeks to bring it down less than 10 milligram at 10th week. If you do only on 10th week, you can't do anything because 10th week is a problematic week. 10th week you do is on 10, within a week's time, beta cell will start secreting insulin. So you have to start moving from earlier weeks and proceed so that by the time 10th week, which is a very awful time, you will bring some blood sugar will come down so that beta cell of the fetus will not secrete insulin. Example. Why? Because eighth week, if suppose you find out routine, the same I earlier told you, early weeks of screening is very important. 8th week, at least at 8th week, 110 milligrams. Intervention here you can use with MNT or with metformin. 10th week, it comes down to less than, but within that week, 2 weeks time, grace period from 110, which is a dangerous blood sugar value, but 10th, see 8th week nothing will happen. But 10th week it comes, it will again fetal beta cell starts as secretion. You are on grace for 2 weeks and then 11th week itself, it is not going to cross 110. So what will happen is no increase in fetal beta cell secretion. So that's what we want. We don't want fetal beta cell secretion occurs. So if we start taking earlier itself, we start taking care of the mother, pregnant woman from 8th week itself, you can prevent the 10th week is a problematic week for the mother. So this is what happens. Suppose 10th week only you do the blood sugar. Imagine 10th week I told you is important. Suppose you do 10th week at most 100 milligram, you cannot bring it down. Suppose sometimes it happens 10th or 11th week, not enough time available to achieve less than 110 milligrams, and then here fetal beta cell secretion starts increasing. Once fetal beta cells start increasing, it cannot come down. So it will slowly get increasing and mother will develop slowly gestation diabetes mellitus. This is the important message. So on 10th week should not go 110. For that you must take earlier action itself. So how early should be taken here? This is a very important slide. We take embryonic stage is about till 9th week. After 8th week, after 8th week is over, fetal stage. So you are in the, suppose you test the blood sugar 8th week, you are in embryonic stage. The moment you cross 9th, it will fetal stage. Why this very important will be here, embryonic stage. If 100 milligrams MNT and metformin 259 BD has to be started and continued. Target glycemic to be obtained is PPBS is 99 plus or minus 10. Why? Because 8th week metformin is safe. Please, this sentence, please note this. Metformin is safe as embryonic stage is over by 8th week. Suppose 8th week you don't give, none of us will recommend. So of course PCOS they give from the beginning itself. In this situation, metformin is safe as embryonic stage is over by 8th week. So you are from 8th week, end of the 8th week, you can start metformin. Again, I want to share another information here. Women with diabetes may be advised to use metformin as an adjunct. Safe to use metformin at the 8th week onwards because it is in the 8th week you don't have any problem. So now I'm going to another angle now. Prediction, tour PP more than 110 milligrams. Prevention, tour PP post-mortem blood sugar less than 110 milligrams. More and less. Now, recently I started on publication here. the importance of giving metformin at what time intervention should be done is very early should be done it. Administration of metformin after 12th week will not be effective in preventing GDM. Nobody has so far in the preventive medicine, in the prevention GDM trials, after giving the 12th week, none of them could prevent GDM. They all become GDM. So what I have been discussing now, start 8th week itself and bring it down 110 by 10th week. So after 12th week of using metformin, you will not have any beneficial effect. So now I will come to answer here. Scope for prevention of GDM. What is the scope? You got a scope here. PPBS more 100 milligrams at 10th week is the crucial time during pregnancy for prediction of GDM. That is all of us know. Now how to prevent? Here, hence intervention has to be started at 8th week itself. If PPBS more 110 milligrams. 8th week because fetal beta cell does not start insulin secretion, embryonic stage, and metformin is safe. That is why I put it in a bracket, safe. So if PPB reaches more than 110 milligrams, fetal beta cell insulin secretion starts at 10th to 11th weeks. So you can prevent, not only predict, you can also prevent by start screening by 8th week itself and bringing the blood sugar level of the mother to be less than 110 itself. No point in trying 110 at 10th week. But by the time 10th week reaches, the sugar should be less than 110. So premortem prevention, ideally peak maternal or postpartum blood sugar should be around 110 milligrams from preconception period and early peaks of pregnancy. Whatever you do, you must do this is the level you must maintain. And then else it is necessary to optimize metabolic control early in pregnancy. This is necessary pre-pregnancy planning. Now, this is what I want to share with you, the work we have done here. 11,000 people with skin gestation trimesters. We have been following only this. First trimester 140 and above, 31%, and second trimester 42, and finally 25. There are almost 60% more, 60% of the women that develop GDM in the first half of pregnancy, most importantly 31%. Now what I am saying here, I wish this study was done recently also. 2007 also we have done the study of trimester, and also in 2016 also this publication was done. I wish I didn't know at that time should have used 2 PPBS more than 100 milligram in the first trimester for prediction of GDM, not aware at that time. I feel very sorry. I wish I had known this earlier. Otherwise, I think, as I told you, by the time you would have prevented the GDM in the country and the diabetes. So now, at least now, this generation now should be think about that and start screening for GDM in the 8th week itself and bring the blood sugar less than 110 milligram at 10th week. So any value above normal, don't give grace. 110 is normal, 110 only. Then 111 is abnormal. So any value above normal is abnormal. Let's say in the period, some religions say Lakshman Rekha. Cross the Rekha, you get a problem. So any value above normal is abnormal. So friends, glycemic level for diagnosing different glucose tolerance during detection, GDM, which all of us possible, 140, all of us know about that. And we have introduced one more category, gestational glucose intolerance is more than 120 milligrams. What we are introducing now, probably in future, a classification of GDM will be like this. Early gestational glucose tolerance, EGGI, 10th week, is when you get this 100 milligrams, probably that lady, you must classify them. 100 milligram and above, 10th week and above is DGGI, 120 and above is DGI, GDM 140. So this person also prone to develop GDM and diabetes in the female, IGT in the male. So friends, aims Male, female, gender, the key to diabetes prevention start with the healthy pregnancy, low birth weight, large gestation age, and will result in the adult life, elevate risk for obesity, diabetes, hypertension, and CVD, intergeneration transfer risk occurs, and then the link to the NCD epidemic is only maternal health. That is why the answer is less key insult, female gender is key to diabetes prevention. So prevention of NCD, preventive measures against NCD should start during interactive period and continue throughout life from early childhood. Prevention of type diabetes must begin in the intro and continue throughout the life course. So friends, here the whom is more important than the whom. So we must take care of the pregnancy. It all starts in intro. That's the important thing. Henceforth, we suggest diabetes-free generation, focus on the fetus for the future. That is the only way of preventing diabetes. So I said here, this is a nice photo here. One blood test prevents transmission of diabetes. If she is going to GDM, a child, male child with diabetes, or female, that child has GDM, the transmission occurs. So one blood test during pregnancy and bring it down to less than 110, we can prevent diabetes in the world. I hope so. So, friends, ladies and gentlemen, this is my last slide. I request all of you, let us all pledge to prevent diabetes. I think everywhere in your clinic, put the board, let us all pledge to prevent diabetes. CS. Okay. Thank you very much, my friends. Thank you very much, chairpersons. Thank you.
Thank you so much, sir. That was such an enlightening talk, and I'm sure the concept is absolutely out of the box and very, very relevant. And I'm sure this great idea, we just need to conduct a few more studies, and probably we'll have the proof in our hands to actually propagate what you have actually come out with. And I'm sure we'll have a lot of questions in the discussion, sir. We'll request you to please stay back for the discussion at the end of this pregnancy symposium,
Sure.
Thank you so much, sir.
Thank you, sir. Thanks, sir.
Thank you, sir. So with that, we move on to another very, very important and relevant topic in this DIPSI Diabetes and Pregnancy Symposium. And to deliver this, we have none other than Dr. V. Balaji. Professor Balaji, we all know him as the Chairman and Managing Director, Senior Consultant Diabetologist at Dr. Balaji, Dr. Seshia Diabetes Care and Research Institute. We all know his credentials, huge credentials, FRCP, Glasgow, Edinburgh, London. We know he's the Founder Secretary General of Diabetes in Pregnancy Study Group India, DIPSI, of which all of us are foot soldiers, and a lot of prizes, orations to his credited. Lot of orations, the B.R. Sen Gupta oration, Sam G.P. Moses oration. He's part of IADPSG, a very, very active member when it comes to propagation of diabetes and pregnancy and GDM. Member expert group committee on GDM, Ministry of Health, Government of India, and the ICMR. Has more than 200 papers published in national and international journals, which talks huge about his academic credentials. So welcome, sir. And sir is going to shed light on the diagnosis and targets of control in pregnancy. Welcome, sir.
Welcome, Dr. Balaji.
Welcome, sir. Thank you. Good afternoon, everybody. Chairpersons, Professor Dr. Seshia, and colleagues. So, now let me go on from the futuristic talk of Professor Viseshaya, where he talks about prevention. So I don't want people to get confused with prevention and diagnosis and treatment. So what I'm going to talk to you now will be what we are currently following for diagnosis and treatment of gestational diabetes. The future, as was Dr. Seshia said, after many studies, maybe the diagnostic cutoffs can come down. You may treat and you may diagnose it at 8th week or 10th week. But presently, please do not confuse yourself with the present guidelines of DIPSI, which I'm going to tell you. And this is for diagnosis and treatment. And don't confuse with primordial prevention of gestational diabetes. So let me go on to the first slide. This is already alluded to that it is gestational diabetes is defined as any degree of glucose intolerance first recognized during pregnancy. So the concern already mentioned, it is a detection of chronic beta cell function, and it's also a stage in the evolution of type 2 diabetes. And as Professor Sesha mentioned, it may play a crucial role in increasing the prevalence of diabetes and obesity. So when we talk of ethnicity, we have 11-fold increased risk of developing glucose intolerance during pregnancy compared to Caucasian women. So among ethnic groups, South Indian countries, Indian women have the highest frequency of GDM. So primordial prevention plays a very major role, for especially in a high-risk group. So diagnosis is essential in all pregnant women. Universal screening, if you say now, universal testing has become mandatory with all the associations throughout the globe, as especially if you see more than 90% of cases of hyperglycemia in pregnancy are estimated to occur in the low and middle income countries. So all women should be screened for gestational diabetes, even though they have no symptoms according to the new recommendations. Early screening, we come on to early screening. Earlier for prevention of diabetes, Professor Sesha mentioned how early you have to go. Now when we take of diagnosis and treatment, you see the slide here from Japan, which they have picked up 63% in the first trimester and 36% in the second trimester. Almost the entire population screened found to have gestational diabetes within the first and second trimester. This shows the importance of GDM in the Asian countries. The implication, again, I'm going back to where Professor Sesha started. The severe macrosomia manifests as 11 to 14 weeks of gestation. Severe macrosomia manifests, yes, as early as 11 to 14 weeks of gestation. So why this happens? You see already this slide has been mentioned that each islet cell functions as an endocrine organ and is able to recognize and respond to maternal glycemia. This is exactly what the crux of the point Professor Sesha was trying to tell you. So at about the 11th week, it can recognize and respond to maternal glycemia. So when fetus is exposed to increased amniotic fluid glucose before 15th week of gestation, suggesting that metabolic alterations are underway before diagnosis, and earlier screening and intervention may be warranted. What happens at that time? Already Professor Sesha has explained to you. So GDM, let's see in an Indian data, what happens to our country, our people. This GDM manifests on all trimesters. This is a study which we did where we screened more than 4,000 on all pregnant women. When you see here, the red data is of 16th week, you have 16%. And in the 17 to 20 XLO, 22%, and greater than 24 weeks of gestation, we have about 61%. So now the most important thing here I want you to say in this slide is 38% of women were diagnosed before the recommended weeks of screening. And what happens, the World Health Organization is also recognized and said testing in the early trimester is recommended. And again, another study which we published, again, it shows the same data. If you see what are the crux here is 1/3 of all GDM cases were diagnosed during the first trimester itself. So it is very, very relevant. We are screening them early and screening them as early as possible. Some of the studies that says what the studies abroad have told us, that early glucose tolerance could avoid some diabetic-related complications as hydramnios, preterm deliveries, premature rupture, and fetal anomalies than the later screening groups. So what happens? Why they keep on going for early screening? Already Professor Sesha has mentioned few things. This is exactly what happens. Early metabolic imprinting may affect the fetal growth. The human studies have shown increase in beta cell mass and insulin secretion of early as 16 weeks. Now studies have shown even as early as about the 11th week. And that increases throughout the second trimester until 26 weeks of gestation. And this priming in mid-gestation account for the persistent of fetal hyperinsulinemia throughout pregnancy and the risk of accelerated fetal growth even when the mother enjoys good metabolic control later pregnancy. So catch them early, treat them early, prevent the maternal glucose from crossing the placenta, and you prevent the maternal insulin from secreting fetal insulin from secretion, then you are already there in prevention of diabetes in the future. So early metabolic imprinting may affect the fetal growth. So this is a study now to show whether this is proof in there or not. See, early detection and glucose intolerance and the care given outcome similar to that of non-diabetic pregnancy, where we had two groups here. You can see here one group has been picked up 0 to 23 weeks of gestation and group 2 directed beyond 24 weeks of gestation. And when the same care was given in terms of treatment and HbA1c, when we take the outcome or the birth weight of neonates, people who were picked up early, the birth weight was similar to a normal gestational women of about 3.2, whereas the people who are picked up little late and treated with the same glucose values and same control, the birth weight was much, much higher compared to the one pricked earlier. This is exactly what we say when one of maternal glucose crosses the placenta, it causes stimulation of the fetal pancreas, and this goes on continuously, even though after that, if you reduce the maternal glucose, still the fetal hyperinsulinemia persists. So now we come to repeat screening. What our studies have shown is women with normal oral glucose tolerance tests were screened in subsequent visits. 28% of women were detected to have GDM on repeat screening, repeat testing. So it doesn't mean you screen them once or at the first visit and leave them alone, especially if they have high risk family history. And if you feel they are high risk people, you definitely have to screen them at least with each trimester and based. So DIPSI criteria, now we come for the diagnosis and guidelines. And this is a single test procedure which says a 2-hour plasma glucose greater or equal to 140 with 75 gram oral glucose administered in the pregnant women in the fasting or non-fasting state without regarding to the timing of the last meal is able to identify women with gestational diabetes. Ladies and gentlemen, this is a single test which has been advocated by the DIPSI criteria for diagnosis of DIPSI, for GDM, for rationally being after a meal, a normal glucose tolerant woman will be able to maintain the normal glucose despite glucose challenge due to the good insulin response, whereas a woman in GDM who has a compromised insulin response will not be able to increase with the meal their glucose challenge, and with glycemic exertions, the glucose levels will exaggerate further. And thus what happens is performing the single test procedure in the fasting and non-fasting state, regardless of the last meal timing, is rational. As glucose concentration, the glucose tolerance test will be least affected by the timing since the last meal in a normal glucose tolerant women, but in a GDM women, definitely it will be affected. So this walk-in test is recommended by the Diabetes and Pregnancy Study Group, India. So now we talk about the DIPSI criteria. Now we know how the DIPSI criteria, the outcome data is good and all. You should know a number, the number is effective or not. So how do you know this is effective? So this is a study which we did, diagnosis of gestational diabetes in Asian Indian women. You can see here you have the green bars, the normal glucose tolerant women. And now we see the red bars. This is the red bars represent the GDM women after intervention. After intervention, you can see the blood glucose was similar and there was no, the birth weight distribution was similar between the NGT and the GDM women after intervention of the 2-hour of 140, that is the DIPSI criteria, and it was not associated with any macrosomia. So the advantages of DIPSI procedure, the procedure requires one blood sample only drawn 2 hours at 75 gram, and even if the test is repeated each trimester, the cost is 66% less than performing the IABA recommended IAD-PSG, which consists of 3 tests. And the DIPSI procedure is feasible, sustainable, cost-effective, and high impact for less resource setting. And this is exactly what the experts say. And it was worthwhile to decrease macrosomia rate, fewer emergency sections, serious perinatal mortality, may improve the women's health-related quality of life. So the State Health Society, this is what they do in Government of Tamil Nadu. First screening 12 to 6, second screening 24 to 28 weeks, and third screening 32 to 34 weeks. And the National Ministry of Health, Family Welfare, all they incorporated this one step in their procedures. And they also mentioned supply of glucometers to sub-centers. And we have also done the point of care testing where the glucometers which have been the glucometers, if you see, if they have been standardized for pressuring plasma glucose. The same values applicable even when you use glucometers in centers where you have this auto-analyzer not available. And the WHO has already said the same thing. They endorsed that often not available, so glucometer can be done. And the WHO recommendations in 2000, where we are a part of it, where they already mentioned that certain conditions, especially in low middle income countries, you can have a non-fasting test, maybe the only practical option, and the single-step procedure to diagnose GDM, all endorsed by WHO. And for the future strategies, they mentioned the DIPSI criteria to be one of the important studies for future tests. So the FIGO has already endorsed all women at booking at first trimester. The FIGO IDF joint statement also accepts the DIPSI criteria, and the technical team of the Indian, the NHS and other things. If you see the Indian, they follow the DIPSI criteria in treatment. I won't go into the detail. Now we come to the target glucose levels during pregnancy. What are the levels we want to maintain to get the cutoff? So studies here have shown that a fasting of 90 and a 2 hour of 120 milligrams, definitely multiple studies have shown to have a good pregnancy outcome. And this again, I'm retracing this slide back to you to see the 90 and 120. This is on a mixed meal. I said 140 on a GTT, which is equivalent to 120 on a mixed meal postprandial. So this again, I'm retracing the study here to show that the birth weight when treated for DIPSI criteria after intervention, you had a very good outcome data similar to a non-normal glucose tolerant women, and the intervention was maintained at 90 and 120. This shows the results of the values which we say are very effective. And the prevention diaper project which we did, you can see here the National Family Health Survey, the SGA 17% was decreased to 10.4% of about 41%, and LGA has been decreased from 19% to 7.26%. This is the place where we conducted the diaper project, and the intervention maintained target control was fasting and 120 milligram. And don't think we have used insulin on every patient. No, 95% of these patients were only manipulated on dietary control, and only 5% we are given insulin. Thus, a single initiative of achieving birth weight of infants appropriate to gestational age. We have a significant positive health on the overall health and family of the community. So this is again another study which was done using the DIPSI guidelines by Professor Jitendra Singh, who is now the national minister, and is divided into 3 groups: control and GDM, who we treated, and the GDM, which they did not allow them to be treated. And you find the people, GDM treated people, have less complications compared to people with GDM who are not willing for treatment. So this study proves advantage of adhering to DIPSI guidelines and diagnosis. So birth weight, you can see here, it's a very good slide. If you see the 3rd trimester, 2 hour post-glucose in relation to birth weight on the left, you can see the birth weight is a continuum. As the blood sugar increases from 82 to 99 and to 120, you see the birth weight, the normal birth weight in Indian children, 2.5 to 3.5, and it goes 3.5. You can see at 120, it keeps on increasing. And once the blood glucose 2 hours crosses 120, you can see the threshold is being altered, and they're going much higher than the normal average birth weight in Indian women. And this shows the importance of treating or adhering to the DIPSI criteria. So the occurrence of macrosomia was continuum as a 2 hour plasma increased from 120. So now maybe based on the newer concept of we can go down further or even check from 8 weeks and see even at 110, maybe you can get, it can go continuum right from 110. This is exactly our studies which we published in Diabetes Care, says the same thing. The occurrence of birth weight of newborn greater than 90th percentile was continuum as it increased from 80 and significant about 90. And you can see here the glycemic targets. ADA 2018 has said 95, whereas the other DIPSI and everything sticks at 90. So you must see, very important, this study, what this study says is even a glucose of less than 5 millimoles prevents macrosomia as well as other adverse outcomes such as preeclampsia, neonatal hypoglycemia in women with gestational diabetes. So even that 95 to 90 has a significant positive impact in treating gestational diabetes. And the pattern of glycemia in normal pregnancy, this Professor Sesha already explained to you. This is what happens in normal pregnancy where the fetal renal threshold is 110. That is why he said don't allow the blood sugar in the 10th week to cross 110. Otherwise, it will cross the placenta and stimulate the fetal insulin release. So if you say the fasting is about 71 plus or minus 8, 2 hours, 99 plus, or if you see the 1 hour and 2 hours, the 2 hours less than 110, this is normal. But to an epidemiology, normally they take 2 standard deviations above normal. So that is why in a normal mixed meal, we are keeping 2 hours at 120. This is mainly for detection and treatment. Please don't confuse with prevention. If you want to go prevention, you have to go much more down. As Professor Sesha had said, maybe if we go further down and prevent throughout pregnancy, the blood sugar not to cross 110, which can stimulate the fetal pancreas, then we may achieve primordial prevention of diabetes just for future generations. So target plasma glucose should be that of non-diabetic pregnancy. I told you what is that. What to be achieved right now practically is fasting of 80 to 90, 2 hours of 110 to 120, and you have a mean glucose between 95 and 105. And this is what recommended by the DIPSI, and a birth weight is obtained between 2.5 and 3.5 kgs. As you know, if you see a step to prevent offspring development diabetes, and if you see here, this is a U-shaped curve where the birth weight less than 2.5 and a birth weight more than 4.5 babies are susceptible to diabetes in the future. So make sure you have a target blood glucose levels and have a proper birth weight between 2.5 and 3.5. So the clinical classification of hyperglycemia in pregnancy, 2 hour plasma glucose in pregnancy, outside pregnancy, if you see more than 200, diabetes, outside pregnancy, diabetes, go 2 hour plasma glucose of 140, GDM, and outside pregnancy, it's IGT. And this 2 hour between 120 and 139, we call it as the gestational glucose intolerance. These are the people who need to be followed up and make sure that they don't develop GDM. So as I had mentioned to you earlier, the occurrence of macrosomia was continuum as it crossed 120. So these are the people which needs to be monitored. And less than 120, now we say it as normal. With the present Professor Sesha's concept, we may have to go further and say less than 110 may be normal to keep the blood sugars at 110. But this concept has to be now proven, and we need more data. And once we are able to prove in subsequent years that if you are able to treat below 110, then so they may not develop diabetes in the future. So right now, for all practical purposes, we are using these criteria for diagnosis and treatment. And please don't confuse yourself for the future projects, which is primordial prevention of diabetes. So the renal threshold for glucose is 110, as I mentioned to you. That is why now it is, I think, makes more sense to go further down, which may happen in the few years when we get the data. We can come out with the newer data which shows less than 110, what happens. And let me summarize the whole thing, ladies and gentlemen. Current scenario, what is happening, what is DIPSI now, what are the DIPSI current guidelines? Ethnically Indian women are prone to develop gestational diabetes. Universal screening is necessary in the Indian context. We have the customized screening, that is community 75 gram of glucose challenge test irrespective of the last meal. Timing is recommended. That's the DIPSI criteria. DDM is diagnosed if the 2 hour plasma glucose is greater or equal to 140, and single test that is cost effective and reliable. And clinics, you can do both fasting and 2 hours. It's 75 gram OGTT may be performed in clinics where all the facilities are available. And screening for the glucose intolerance at the earliest opportunity during pregnancy. Repeat screening when negative. And then if you are able to pick up people with gestational diabetes, intervention to maintain target glycemic control of 90 to 120 milligrams. So thank you very much for patient listening.
Thank you so much, sir. I think that was very, very clear. What Dr. Sesha has been talking about, the PP less than 110 is a futuristic approach where we are actually looking at primordial prevention so that the fetal programming and the fetal priming can be prevented. And what you actually talked of was the current diagnostic criteria for any woman who is pregnant and we want to screen for GDM for obvious reasons. So I'll request you to please stay back, and I'll for the question answers and discussion towards the end of this symposium. And now I hand over to Dr. Bhavtarini to introduce Dr. Sunil Gupta, past president DIPSI, and again somebody who's very, very precious to the DIPSI group.
Thank you, Shalini. After hearing clearly about the diagnosis and detection by Professor Dr. Balaji, now we'll move on to the treatment. Now we have our president, the past DIPSI president, Sunil Gupta, who is the national president, past president, and national treasurer of RSSDA headquarters. And he has got so many awards and done so many orations, and he has plenty of awards to his credit. And he has published about 206 articles and book chapters and abstract presentations. And he has conducted the total 2,705 programs in the last 28 years, 89 programs per year. And he is doing the he is the National Executive Committee member of RSSDA, President, Diabetic Association of India, Academy of Medical Sciences, Nagpur. And he is also the editor of International Journal of Diabetes in Developing Countries and Journal of Clinical Diabetology. He is the principal investigator, the second phase 2 clinical trials, more than 25 phase 3 clinical trials. Over to you, sir, for the pharmacotherapy of GDM.
Thank you very much, Bhavatarni. And I'll just take 30 seconds to, I feel, yeah. Hope my slides are visible.
Yes, sir.
And now they are full screen.
Yes, sir. Now it is slideshow.
So my today's talk is on pharmacotherapy in gestational diabetes. And before I proceed, let me humbly congratulate and thank Dr. Rajiv Chawla, Dr. Shalini Jaggi, and the whole team of International Symposium in Diabetes, which is being actually conducted from Delhi. And of course, my challenge first to Dr. Seshaya, my regards to Dr. Balaji, Dr. Hema Divakar, the current president, and Piki, and the whole team members, as including the chairperson, Dr. Bhavatarani. There is no conflict of interest for this particular session. So we have the discussion on some slides on introduction, which I don't think will be too much because our earlier two speakers, including Dr. Sheshaya and Dr. Balaji, have already covered it. I'll directly proceed to the pharmacotherapy in hyperglycemia and pregnancy. First part will be on oral drug, and then we'll be talking on insulin therapy and the carry home message. I feel this slide is also being shown earlier that we have the recent classification by FIGO, where you have HIP, hyperglycemia and pregnancy, which is an umbrella term, which has two subclasses, which is gestational diabetes. I'll just use the pen marker here. So you have gestational diabetes, which classically appears during pregnancy, and an 85 to 90% patient will disappear after delivery. And there will be another class of patient which will be diabetes in pregnancy, which could be a pre-existing type 1 or type 2 diabetes which are getting pregnant. And another group will be diagnosed for the first time during pregnancy, but actually it is an earlier unknown case, which is classically presents to you as pre-existing diabetes. Now, commonly it will be type 2 diabetes. Rarely it can be even type 1 diabetes. So when we talk about the pharmacotherapy in such individuals, the thought process and the approach changes in pure gestational diabetes versus diabetes in pregnancy or DIP category. So we'll just see this case in very, very brief. A young woman at 25 years working in Pune, and she has an ANC of 26, primary gravida, almost normal weight, negative family history of diabetes, no other significant past history, clinical examination normal. I feel we have just heard from the horse's mouth. Will you screen this case? And we have come to know from Dr. Balaji and Dr. Sheshaya that yes, every woman should be in India should be screened for diabetes, irrespective of the symptoms, irrespective of the risk factors, irrespective of the family history, irrespective of the BOH or anything, or obesity or BMI. So we have to screen each and every woman at the first given opportunity. So like we have a Government of India guidelines of DIPSI, 75 gram glucose GCT was given, and 2 hour has come to 136, which classically defined that it is not GDM, but it is certainly above 120 targets, which Dr. Balaji has told you. HbA1c normal, but the urine sugar sometimes may positive. It is renal glycosuria, which is common in pregnancy. Now, what is the diagnosis? So we have in 2006 classification published in JAPI by DIPSI that we have more than 140, it is gestational diabetes. But if it is between 120 to 140 in JCT, it is called as GGI. Different bodies across the globe speak out different terminology for this. Some of the countries, they name it as mild GDM. Some of them, they have called it as IGT in pregnancy. And some of them have said isolated abnormality in blood glucose. And DIPSI has decided to put in India as GGI. And such cases should be certainly put on the treatment and the follow-up. And many of them may become GDI in future. But the important is that such patient, if remain untreated, might create a problem because the targets are above, the blood sugars are above the targets. And in India, all women with pregnancy is being celebrated. So pregnancy is a celebration in our country. If you call it as negative, possibly these women will be subjecting themselves to GCT more often, and they will remain hyperglycemic and they may be missed out. So this patient has blood sugar, the diagnosis made as gestational glucose intolerance with renal glycosuria, and she was given the targets of 90 and 120 and mean, which was addressed by simple medical nutrition therapy and the exercise, and she could achieve her goal. Then when you talk about the targets, MNT and the lifestyle modification, which includes physical activity and exercise, if they don't do well within 2 weeks of the medical nutrition therapy and exercise, if you fail to achieve your targets in GDM, then you need to start the pharmacotherapy. So after 2 weeks of trial of MNT and LSM, this young woman could achieve good glycemic control and have proceeded, and then monitoring and everything was done. And she proceeded, the outcome was good. And she had a normal 3 kg male child without any complication to mother. But the actions were taken well in time, and she could had a good neonatal outcome with, of course, a concept of primordial prevention, which we have just learned from Dr. Seshaya. So after 2 years, the same GGI woman, ABC, and now she's 27. Now she presented with 18 weeks of second pregnancy. Weight, now she has gained around 10 kg of weight in between. And now she presented with a typical case of GDM after 75 gram GCT. Now she has 168. No associated comorbidities, the rest everything is normal. After 2 weeks of medical nutrition therapy, this young girl still has 2 hours is 150, 80 is fasting, which is classically seen in GDM, where your fasting usually is normal, and 2 hour postprandial is high, which high, and that need to be addressed. So if it is a pure gestational diabetes, classically it presents to you with postprandial hyperglycemia. That does not mean there will not be any exceptions. There will be few cases which might also present to you with associated fasting hyperglycemia. Now, what should you choose? The next drug, the oral versus the insulin therapies. So let's talk about the oral glucose lowering therapy. Whenever you use oral drug, you should know that the drug should have 2 important properties. One is, ideally, a drug should not cross the placenta. Insulin doesn't cross the placenta. All oral drugs, including metformin, sulfonylurea, glibenclamide, any drug you say, and that crosses the placenta. Insulin doesn't cross the placenta. The oral drug, which even if it crosses the placenta, it should not be causing the hypoglycemia, hyperinsulinemia in the baby, and it should not have teratogenic effect. If you have these 3 properties, we call it that this particular oral drug is safe for pregnancy. Now, we have 3 drugs which have been approved globally: metformin, glibenclamide, and acarbose. In India, we have got the approval for, the Government of India guidelines talks about only metformin. Glibenclamide is not being used in our country, though in parts might be people are using off-label. Acarbose is again not being studied in our population, as well as glibenclamide, and is not being used regularly. But glibenclamide is a drug which is quite commonly used in US population as well as South Africa population. We have some reservations which data has come from metformin. that neonatal, this is a meta-analysis which has shown that the intrauterine exposure to metformin for the treatment of GDM, the neonates were significantly smaller than the neonates whose mothers were treated with insulin. Now, despite lower birth weight, there was a catch-up growth in the early childhood, and this phenomena of low birth weight and postnatal catch-up growth has been reported to be associated with cardiometabolic outcome, adverse long-term cardiometabolic outcome. That means increased risk of obesity and cardiovascular disease. Now, this concept has raised some questions, and then there were some other papers which again hardly 3 or 4 years back, they said that the fetal concentration of metformin are equal to the maternal, and the metformin can inhibit the growth, can suppress the mitochondrial respiration, can have epigenetic modification on the gene expression, can mimic the fetal nutrient restriction, and alter the postnatal gluconeogenic response. Because both the placenta as well as fetus, they express metformin transporters and exhibit high mitochondrial activity. These properties of metformin raise an important question about the developmental programming of the metabolic disease in the offspring. But then to counter this, we had another paper, which is a clinical data, which is MITI trial, where MITI trial is a known type 2 women, already known type 2 diabetic women, and they have subjected to metformin before conception, have continued till delivery. And they have also come out with the data that metformin treated women achieved better glycemic control, required less insulin, gained less weight, and had fewer cesarean deliveries. Compared with placebo, metformin exposed infants weighed less. Metformin exposed infant had reduced adiposity measures at the time of birth, but there was high proportion of small for gestational age babies in the metformin group versus the insulin group. But on the basis of this particular trial and the earlier data from Europe, recently European organization has approved this drug to be used in pregnancy throughout. What does the government of India says? It says that metformin or insulin is the acceptable medical therapy for the pregnant woman with GDM not controlled on MNT. Now, insulin is the first drug of choice, and metformin can be considered after 20 weeks of gestation for medical management of GDM. If it is polycystic ovarian disease, everyone allows up to 12 weeks of gestation, and there is no additional benefit of continuation of the metformin in cases of polycystic ovarian disease for prevention of GDM or for prevention of abortion after 12 weeks. And that's why it has been recommended to withdraw metformin after 12 weeks. Now, Government of India approves it after 20 weeks. And recent DIPSI guidelines says from the 16 weeks also we can give it. Now, insulin can be started anytime during the pregnancy for GDM. So insulin can be given at any weeks of pregnancy. A pregnant woman with GDM before 20 weeks, the medical nutrition therapy failed, insulin should be started. So very clearly, Government of India guidelines has said that if the GDM is diagnosed before 20 weeks, better we start insulin therapy. Metformin can be started at 20 weeks if MNT has failed to control her blood glucose, and the maximum dose could be 2 grams per day. And the insulin can be added if they are not controlled on metformin alone. This is what has been shown in even MIC trial, that 50% of the women who were on metformin arm required additional insulin therapy to achieve the glycemic targets. Hypoglycemia and weight gain with metformin are less compared to insulin. If insulin is required in high dose, metformin can be added as can be an add-on treatment to counter the insulin resistance in such women. So this is the recommendation from Government of India, and this is what I was talking about. The 28th February 2022, European work-shared procedure has approved the first oral glucose medicine, that is metformin, even from the conception to the birth. And this has again actually increased, has added the confidence on this drug, which is being loved and being taken as a primary drug by most of the OBGYs across the country. What about sulfonylureas? They are known to cross the placenta and have been associated with increased risk of neonatal hypoglycemia. The concentration of this glibenclamide in umbilical cord is at almost 50 to 70% of the maternal level. Glyburide or glibenclamide was associated with higher rate of neonatal hypoglycemia and macrosomia than insulin or metformin. and glibenclamide failed to be found to non-inferior to insulin based on the composite outcome of neonatal hypoglycemia, macrosomia, and hyperbilirubinemia. So it has not shown additional advantages over insulin, and unfortunately, there is no long-term safety data available of glyburide versus even metformin. You have at least up to 11 years of age of data available for metformin. So this ABC was then put on metformin twice a day because there was no contraindication for metformin, but she could not really achieve post breakfast 126, post lunch 136, post dinner still high. So all three post meal were higher. Fasting was normal, and metformin, once the dose was increased, she could not tolerate the increased dose of metformin. So maximum tolerated dose for metformin in this woman was only 1 gram, and ultimately we have two choices. One is to add some another oral drug like glibenclamide if she doesn't want to have insulin or acarbose, or to initiate insulin. Now, let it be very, very clear, my dear delegates, that there is no recommendation globally to add another drug. So do 2 drugs in pregnancy, 2 oral drugs in pregnancy is not being recommended across. So never ever add another oral drug to metformin. If you want to encourage, it could be either glibenclamide alone or it could be metformin alone. So in such cases, insulin remains the drug of choice in addition to metformin. Insulin, there's some absolute indication if you have high HbA1c, ketonuria, renal dysfunction, hepatic dysfunction, obstetric morbidity like macrosomia, IUGR, hydromnias, or deterioration in the glycemic control. And if you are giving steroid therapy, insulin becomes a drug of choice. Though the topic is on GDM, but still I'll cover some of the important topic, which is Indian data, which might help you in your clinical practice. This is our own original data of pre-existing type 2 diabetic women, and this data of around 101 pregnancy. And we have shown that pre-GDM type 2 diabetic women are requiring around 0.5 unit per kg body weight in the first trimester. And by third trimester, it has increased to almost 0.7, and that's almost 0.8 unit per kg body weight of their pre-pregnancy weight. So all type 2 diabetic might need the doses in near to these doses, because this is the Indian data for which actually matches or which might be approved for its use in Indian population. When it comes to GGIs, it is those who are requiring insulin might require 0.1 unit, GDM might require 0.25, and pre-GDM require around 0.5 unit per kg body weight of their pre-pregnancy weight in the first trimester, which gradually increased to almost 1.5 times of their basal requirement to 0.15. Here it is 0.4 and 0.8 unit. Now, insulin regimen, best is basal bolus therapy whenever you require it. In gestational diabetes, you will require only prandial insulins. If you are using premixed insulin, one should also keep a close watch on the nocturnal hypoglycemia, because in pure gestational diabetes, your fasting usually is normal. So in such situation, better to use prandial insulin, maybe twice a day or thrice a day, depending on the requirement. In our own population in Central India, we have found the post-dinner dose of the pre-dinner dose of the insulin is highest versus the breakfast and the lunch dose. So if someone requiring say 6 units at the breakfast time, they require around 7 to 8 units in the lunch, and they might require 8 to 10 units in the dinner time. So almost 1.5 times to double dose at the dinner time versus the pre-breakfast dose of insulin, and that has to be closely monitored. But it's only self-monitoring of blood glucose which will dictate and which will actually guide you where to use which insulin and how much the dose can be taken. But unfortunately, many of the clinicians never monitor post-dinner blood glucose. They do monitor post-breakfast and sometimes post-lunch, or sometimes only one. But ideally, they should be monitoring fasting, post-breakfast, post-lunch primarily. And if you are pre-existing type 1 or type 2, you should also be monitoring pre-lunch, pre-dinner, and 3 a.m. blood glucose on a regular basis. Which insulin is safe? So we have regular insulin as well as aspart, lispro, and detamir, which is being safe. Fasting aspart, fast acting aspart controls postprandial better than the earlier aspart. So it could be also a good choice. There's one data coming from degludec. The use of degludec during pregnancy resulted in similar pregnancy outcome as that of the other long-acting insulin. But this was not a randomized controlled trial. This is observational data. Emphasis on HMBG should be given. Insulin in twin pregnancy, and we have presented this data earlier also, that insulin requiring, this is a paper from US, that they have observed in type 1 diabetic twin pregnancy, they are requiring almost double the dose as that of the singleton pregnancy in type 1 women. Unfortunately, we did not find from our database, from our center and Dr. Sanjay Gupta's center from Pune, we did not have any patient of type 1 twin pregnancy, but we certainly had GDM women with twin pregnancy, and we had tried to evaluate the treatment strategy and the pregnancy outcome in the GDM women with twin pregnancy, and they had been compared with GDM singleton pregnancy, and we concluded that GDM women in India with twin or singleton gestation differed insignificantly with their treatment strategies, whether it's insulin or diet. Insulin requirement need not be proportional to the number of fetuses, and treatment should be planned to achieve a good glycemic control. So insulin doses should be individualized, and there cannot be real mathematics what has been shown in type 1 diabetes from the Caucasian's paper.
Sunil,
this is last 2-3 slides. I'll finish up. Your targets intrapartum should be 70 to 120. Sometimes you may need to use the infusion. Postpartum follow-up should be taken aggressively, and that has been discussed. So rule of 6 days, 6 weeks, and 6 months, you should be subjecting these women for GCT. Breastfeeding should be encouraged, and during breastfeeding, which drug should be used? So glipizide and metformin. The last slide. The long-term outlook of the offspring of diabetic mother, the primordial prevention. If the glycemic control can be maximized to the extent that the fetus no longer recognizes that its mother has diabetes, then the treatment of mother during pregnancy may become the first step in prevention of obesity and diabetes in the offspring. With this, I stop here. Thank you very much for your patience listening.
Thank you, Dr. Sunil. You clearly explained elaborately about the pharmacotherapy, but you emphasize that it is very important to know various types of hypoglycemia in pregnancy to decide the pharmacotherapy. And you have made it very clear that insulin is the drug of choice. Otherwise, other drugs you have explained clearly. It was excellent. Now, we want of time, we'll move on to the next session. I call upon Dr. Piki Sakshana for the next session to talk about PCOD to GDM. Is it inevitable? She is the Director, Professor of Obstetric and Gynecology, Lady Hardinge Medical College and Associate Hospitals, New Delhi. She is a winner of 31 gold medals and awards for best research work in national and international conferences, including CS Down Award twice. And she is the editor of 4 books, published more than 230 articles. And she is the Senior Executive Editor, Indian Journal of Medical Specialties and Pan-Asian Journal of Obstetric and Gynecology. She is in charge of infertility clinic in IUI Lab, LHMC, and Nodal Officer of National Skills Lab, and member of Endometriosis and Multipurpose Committee 2018 to 20. Over to you, Madam.
Thank you so much, ma'am, for such an elaborate introduction. And I thank Dr. Rajiv Chawla, sir, and Dr. Shalini for giving me an opportunity. It is an honor for me to participate in this prestigious conference. And also my deepest regard to Dr. Sachaiya, sir, and regards to all other members of the DIPSI family. Is my slide visible, ma'am?
Visible, audible.
Okay, so I will proceed. I will be talking on a different subject today, PCOS to GDM. Is it inevitable? In our practice, we are getting so many patients with PCOS, starting right from adolescence till they are menopausal. So PCOS is the most common multi-system endocrinopathy, which is affecting the women of reproductive age group. PCOS, in this PCOS, the hypothalamus, the pituitary, the ovary, adrenals, liver, adipose tissue, and skin, all are affected. And PCOS is the forerunner and maybe the earliest manifestation of continuation of GDM, diabetes, hypertension, coronary artery disease, endometrial hyperplasia, and malignancy in later on life. So the PCOS sets in the intrauterine life itself. Because of hyperinsulinemia, hyperglycemia, and hyperandrogenemia, there is metabolic imprinting, as Dr. Balaji had just told us, and children born with less than 2.5 kgs and more than 3.5 kgs are prone to develop GDM PCOS later on in life. During adolescence or childhood, because of hyperinsulinemia, there is visceral obesity, there is adipose tissue dysfunction with premature adrenarche and pubarche with PCOS. And as the child grows, she presents with abnormal uterine bleeding, irregular cycles, and is not able to conceive. She presents with difficult to treat anovulatory infertility. And once she conceives, she has so many pregnancy-related complications. As she grows up, she is prone to develop type 2 diabetes, SAH, obesity, dyslipidemia, and in old age and now in middle age, they develop CVD, endometrial cancer, and breast cancer. So the Rotterdam criteria to diagnose PCOS includes any of these three criteria: oligomenorrhea, clinical or biochemical hyperandrogenemia, and ultrasonic picture of PCOS. So the PCOS Society has divided the PCOS manifestation into 4 phenotypes. These are, first 3 are hyperandrogenic phenotypes, and the last one is only oligomenorrhea and PCOS picture of ultrasound. So we wanted to see whether all the 4 PCOS phenotypes have endocrine and metabolic derangements. So we conducted this study in Lady Harding, and we found that all phenotypes of PCOS had deranged endocrine and metabolic profile. And to add on to this, prevalence of insulin resistance and metabolic syndrome was maximum in the complete phenotype, which had all the 3 criteria, and on oligoevolution and hyperandrogenic phenotype. Whereas the O plus P phenotype without hyperandrogenism had the least amount of metabolic derangements. Another thing which we see in the practice is, although most of the patients, about 70 to 75% of women, are obese, but we also deal with lean PCOS. So we wanted to know whether there is any clinical, hormonal, and metabolic difference in relation to BMI. We conducted another study in Lady Harding, and we found, we were very surprised to see that nearly 83% of lean PCOS had insulin resistance, although the insulin resistance was much more as expected, 93% in overweight. So among the clinical parameters, hirsutism, which we objectively measured as Ferriman-Galway scoring more than 8, irregular cycles, acanthosis, and acne, as you can see, was significantly more, maximum in overweight, followed by lean. But again, it was significantly more in both the groups as compared to the controls. In hormonal profile, FSH, TSH, and prolactin were comparable on all the 3 groups, but LH and testosterone were significantly high in both the PCOS groups. Coming to the metabolic profile, the family history of diabetes, deranged lipid profile, impaired GTT were significantly more in overweight, followed by lean, and they were negligible or minimal in the control group. Both fasting and 2-hour post-glucose were normal in all the 3 groups, and postprandial insulin, which you can see here, is 95, mean level is 95 in overweight. It was 52 in lean, and it was less than 40, which is the normal limit in the controls. So what I want to say is, this is a common pathology, pathophysiology for all the 3 conditions. The PCOS, which is also a pre-diabetic condition, which will further progress to GDM when the woman gets pregnant, and later on to diabetes. We studied the gene polymorphism, which was associated with metabolic features in PCOS, and we found the same genes to be affected in GDM also. Again, some of the novel biomarkers which are involved in energy and glucose metabolism and are implicated in pathophysiology are shared by all the 3 conditions. So we conducted this study to characterize, to find out the association of nisfatin-1 levels with metabolic and clinical parameters in PCOS. And what we found out was that nisfatin-1 levels were 10 times higher in PCOS subjects and correlated well with postprandial blood glucose levels. The same findings the Caucasians have reported in GDM and also in diabetes. Then coming to FET2NA, kispeptin, and copeptin, these three markers also we correlated with anthropometric parameters and cardiovascular risk indicators in women with and without PCOS. And we found these levels were raised in PCOS subjects with respect to both age and BMI matched controls. And they also correlated well positively with carotid intima thickness, HbA1c, waist hip ratio, LH, testosterone, and total cholesterol. Same findings have been implicated in GTM. So now the question is, how many of them are going to progress from PCOS to GTM? So this is a beautiful study. This is a systematic review and meta-analysis, which included 21 studies involving 4,841 women and with PCOS and more than 11 lakh women with as controls. They found that the odds ratio of developing GDM was 3.58 in women with PCOS. Another study to share the same thoughts, association between PCOS and the risk of pregnancy complications. They found that the woman with PCOS had a relative risk of 2.78 to develop GDM. Along with this, they also found that these women have a higher chance of, when they compared to women without taking metformin, they found that the rate of spontaneous abortions, preterm labor, GDM, pre-IH, preeclampsia, chronic hypertension, all the hypertensive disorders of pregnancy and SGA, small for gestational age, were significantly higher in women with PCOS. And this is the latest international evidence-based guidelines of PCOS, which were which came out in 2018. They say that Asians have 5 times higher risk of developing GTM. In medical complications, of course, impaired glucose tolerance, type 2 diabetes, coronary artery disease, increased LDL and triglycerides, high BP, endometrial cancer, all these things are there. So PCOS has to be a multidisciplinary approach. There is no doubt to it. And lifestyle modification is the first line, which includes behavioral changes, diet, exercise, and stress management. Besides this, we deal with menstrual irregularities, problems associated with hyperandrogenemia and infertility. And we find that metformin, which is one of the most commonly used insulin sensitizers, is effective to treat both the clinical axis, the endocrine axis, and also the metabolic axis. Morbid obesity women have to go for anti-obesity drugs like sibutramine and orlistat, or for bariatric surgery. In the behavioral strategies, we need to make them set a goal, realistic goal. Do continuous self-monitoring. Stimulus has to be controlled. They have to solve the problem. Assertiveness training. They have to be told to eat slowly and take small meals, small portions, reinforcing changes, and prevention of relapse. So the key for retention, adherence, and maintenance of healthy lifestyle is support and continuous measurement. Dietary intervention to reduce the weight and reach ideal BMI, because it has been seen that even if a weight reduction of 2 to 5% occurs, it improves the clinical and metabolic axis. Exercise intervention, it has been talked about since the beginning of the program. 150 minutes per week of moderate exercise or 75 minutes of vigorous exercise, and 2 times resistance exercise. For adolescents, 1 hour of moderate to vigorous exercise and muscle strengthening 3 times a week. Even leisure time physical activities are very important, and ideally they should cover 10,000 steps every day. Physical activity has to be tracked down and monitored by fitness tracking devices. The goals have to be SMART, which means specific, measurable, achievable, relevant, and time limited. Even bouts of 10 minutes of progressively increasing 5% every week is important. Now comes the mainstay of the treatment of PCOS. It is a bigonide. In front of the August gathering, I don't need to talk much about metformin. It acts by reducing insulin resistance, reducing hyperandrogenemia, and suppresses gluconeogenesis. It improves inflammatory markers and vascular endothelial defects. Maximum dose is 2 grams. But do we start metformin in all women with PCOS? No. We generally do a OGTT, and if the woman has impaired fasting or impaired glucose tolerance, or deranged HOMA-IR, or fasting insulin more than 24, or 2-hour insulin post 75 gram glucose more than 40, or we have surrogate markers like BMI more than 23, waist hip ratio more than 0.8, having acanthosis, family history of diabetes, previous history of GDM, macrosomia, shoulder dystocia, or sudden stillbirth, we start them on metformin. And I found that this 2-hour post-glucose insulin level was particularly useful to mark insulin resistance, because it showed a good correlation with area under the curve of glucose, insulin, and insulogenic index. Therefore, it is a very useful test to titrate the dose of insulin, of metformin. We also studied the effect of metformin after 6 months of therapy in PCOS women, and we found that there was a significant reduction in insulin resistance, LH, total testosterone, BMI reduced significantly, and many of our patients started getting regular cycles. These are the details which I'm not going to elaborate. Then comes the effect of metformin on pregnancy outcome. So here we have this very important meta-analysis where they studied the effect of metformin on pregnancy outcome in women with PCOS. This included 13 studies, out of which 5 were RCTs. What they recommend is that metformin treatment in women with PCOS throughout pregnancy, not just first trimester or second trimester, could increase the possibility of term delivery, reduce the chances of early premature labor, preterm labor, pregnancy complications like GDM and PIH with no serious side effect. Moreover, metformin was not associated with any teratogenic effects, and they recommend that metformin should be used in PCOS women throughout the pregnancy. However, ADA says that metformin in women with PCOS should be discontinued after first trimester. This is another lovely study. Can metformin reduce the incidence of GDM in pregnant women with PCOS? Again, they showed that there was a statistically significant reduction in the incidence of GDM and preeclampsia in those women where metformin was given continuously. Another very recent study, a systematic review and meta-analysis about effect of metformin on pregnancy outcome, metabolic profile, and sex hormone in PCOS women. This included 18 studies, and again, in the women who continued metformin, they had a significantly reduction rate of preterm delivery, PIH, preeclampsia, macrosomia, and HOMA-IR values. Dr. Sunil sir has already told us the good news. In February 2022, this is the first regulatory body which has recommended that glucophage may be approved as a first oral anti-diabetic medication to be used continuously during pregnancy from conception till birth on the basis of the Merck's own safety cohort study, flu study. So the evidence till date, MOHFW, the Government of India and NICE guideline recommend both insulin and metformin as first line. DIPSI also recommends both to be used in pregnancy. Australian guidelines do not recommend use of metformin in pregnancy. And ADA and ACOG both recommend that insulin is the first line, but if the woman is not ready to take insulin, metformin should be used as the second line. Although we need to tell them that the long-term safety is not well established and it crosses the placenta. The other things, molecules which we are using as insulin sensitizers are N-acetylcysteine, which is a derivative of amino acid L-cysteine and is used as a mucolytic. 600 milligram 8 hourly is the dose, and it is a very good agent as an insulin sensitizer. It has anti-apoptotic activity, antioxidant, preserves vascular integrity, and has been shown to have anti-cytokine effect. Inositol is another molecule which belongs to B-complex vitamin types, and again, it is being used in women with PCOS as an insulin sensitizer. Now, progression of GDM to diabetes, we can see as a continuum the risk of type 2 diabetes mellitus after gestational diabetes. This is a very nice study including 1,809 publications. and it includes more than 28 lakh women. What they found was that 78,893 developed type 2 diabetes at 6 weeks or later after delivery, and the unadjusted relative risk of developing diabetes was 8.92. Another study, metformin, this is a very important finding. Metformin reduced the incidence of type 2 diabetes by 31% compared to placebo after an average follow-up of 2.3 years, and by 18% over 10 to 15 years after randomization. And another study says that the subgroups which are most benefited were the subjects who had obesity, high baseline fasting glucose, or high HbA1c, or women with GTM. Of course, PCOS women will also come in this. So to conclude, the comprehensive management of PCOS requires a timely diagnosis of PCOS for initiation of appropriate treatment. A multidisciplinary approach has to be taken because these patients are going to go to physicians, dietitians, dermatologists, obs and gynae people, and physical instructors. They are going to go to the gymnasiums. So everyone has to be taken on board. It has to be a patient-centered lifestyle management as the first line, and role of metformin is now proven. It improves the clinical, endocrine, and metabolic features, and also helps in delaying, if not preventing, the progression to GDM, diabetes, and metabolic syndrome. Optimization of health of women of PCOS before conception, as Sir says, may be an important milestone in preventing disease, transmission of disease in the next generation, and reducing intergenerational transmission of disease. So we need to catch them young, and I thank you all for a very patient hearing.
Thank you, Dr. It was a very excellent lecture, and all are of the long idea that PCOS will develop only in obese, but you have made it clear that even the lean can develop PCOS and have all the consequences. It was very nice. And we'll move on to the next speaker, Dr. Hema Divakar, on the topic GDM prevention, why and how. We all know she is the president of DIPSI. She is the gynecologist and obstetrician speaker and activist above all. Currently, she holds an exhaustive list of important positions of great responsibility within the country as well as in Asia. She is an international figure. She is a speaker, activist, technical advisor to Ministry of Health and Family Welfare, chairman of FIGO, Well Women Healthcare Committee, dean of Karnataka College of Obstetricians and Gynecology, and president FOXI, vice chair Pregnancy and NCD Committee, vice president of AHPI Karnataka, and national technical leader for quality accreditation, Manyata Fox. Over to you, madam. Dr. Hema.
She has pre-recorded lecture. Please start. Darshan, are you there?
Yes, screen visible.
Namaskar. This is Dr. Hema Divakar, the chair of the FIGO, Well Women Healthcare Committee, speaking to you today on GDM prevention. And the questions that have been posed by the organizers to me is why and how. Well, a couple of years back, we campaigned for I Pledge to Defeat Diabetes by eating healthy food, exercising, striving to have a good lifestyle, and prevent the type 2 diabetes. But we as OBGYNs recognize that it all begins in utero. And if we program this little baby in the in utero environment, there is a good chance that by preventing GDM, we can prevent the future type 2 diabetes in the generation next. How do we do this? Well, that is the theme of my deliberation. We again are reflecting on the obstetric emergencies that we used to tackle yesterday. today we have a tsunami of NCDs, starting with the pregnancy, with hypertensive disorders, hyperglycemic disorders, etc., and finally landing up in cardiovascular accidents, hypertension, obesity, type 2 diabetes, which have now become the leading cause of death in women. So tomorrow we may well be left with dealing with these issues for morbidity and mortality rather than the years of obstetric emergencies. So then pregnancy is a window of opportunity to answer the question how we are going to prevent GDM. Pre-pregnancy offers the best possible window to provide maternity services and reduce the traditional maternal perinatal morbidity and mortality. But most importantly, it addresses the intergenerational prevention of NCDs transmitting from generation to generation. And that's why we said it all begins in utero. And if we take care of the complex of mother and baby, we will be doing a lot of good for future generations to come. The pregnancy-induced complication is the forerunner of non-communicable diseases, and whether it's the extreme swing of the low birth weight baby or a large for gestational baby, it sets the stage for elevated risk of obesity, diabetes, hypertension, and cardiovascular diseases in adult life. And therefore, we say that female gender is the key to diabetes prevention. When we identify the high-risk pregnancies in the preconception, interconception period without any action to reduce the risk factor, if you go on to track the pregnancy, there is a huge risk of NCD in the mother in a couple of years after she delivers, and a steeper life course trajectory risk of the NCDs in the child as well. Therefore, we urge that the composite care should be taken with sexual, reproductive, and maternal child health programs integrated for long-term care with non-communicable diseases as a reflection of continuum of care. Prevention and care of NCDs will have to be prioritized even further to improve the population health, and what better place to begin than where the life begins. NCD-related pregnancy complications, once again, I re-emphasize, it can be considered as a multiplier of the ongoing pandemic of NCDs. So it's time to act now. The best possible time to invest is the mother and infant combination, where the NCD risk in the future is likely to be really, really less, by testing every pregnant woman and taking care that she's euglycemic. If you miss the bus, then track the child in its adolescence for avoiding the childhood obesity and early onset adulthood diabetes. Tackle them in the adulthood. Even then, you will be containing the NCDs. But if you don't interfere at any of these points, then you see the y-axis of NCD going really, really high. As how you see on the cover of this Time magazine, the Barker's hypothesis and Pedersen hypothesis, whether it's low birth weight or macrosomia, stand as a testimony to what happens in utero, reflecting in later life as the NCDs. So the solution, dear friends, is the life course approach from prenatal to postnatal, the intrauterine insults of the undernutrition, placental dysfunction, hypoxia, decreased blood flow, moving on to the catch-up growth, overnutrition, inactivity, obesity, and aging, all of which increase the risk of diabetes. So you need to prevent the GDM to prevent the tsunami of diabetes in generation next. So we take small steps to make a big difference in preventing diabetes, where all the foodstuffs shown on this infographic here increases the risk of diabetes to the zone red. So this is a vicious cycle because it all begins with the female who is pregnant, uncompensated insulin resistance, pancreatic beta cell dysfunction, and an increased risk of type 2 in herself. The pre-existing maternal disease of diabetes can further complicate the pregnancy situation. So in the early pre-pregnancy stage, if preventing obesity, preventing PCOS, treating PCOS, paying attention to preeclampsia in pregnancy is the key, The controlling of hyperglycemia in pregnancy will happen if every single pregnant mother is tested early and in mid-pregnancy. These infants need to be tracked through their life course because epigenetic and genetic predisposition to obesity and diabetes in adulthood needs to be prevented. And this is how you break the cycle from the first generation infancy, early childhood, to adolescence, to young adults, to preconception and pregnancy, adult lifetime risk, and the second generation, where the children will be born with euglycemia and with least risk of diabetes if the first generation is taken care of. So normal to pre-diabetic to diabetic, that's how the graph goes. The type 1 diabetes cannot be prevented, but yes, the type 2, early in adulthood, and most importantly, in utero prevention is the key to preventing the tsunami of type 2 diabetes. The diet, exercise, doable in every country, even if it's resource poor, maternal education and awareness, so that she understands why the counseling has been done to her, not eating for two, even though she's pregnant, the fetal health evaluation, at times when needed, pharmacological therapy inclusive of oral anti-hypoglycemics, as well as the insulin therapy. One simple thing that every obstetrician should initiate is exclusive breastfeeding and prolonged breastfeeding, because this itself will decrease the chances that she becomes a type 2 diabetic by 57% and easily doable. This is a busy slide telling you that we have the opportunities pre-pregnancy, pregnancy, and long-term postpartum, where these women should never be left alone in population. Life course, lifetime tracking needs to be done. I would like to say that though this seems to be a huge, daunting task and an overwhelming situation with millions of gestational diabetes in our country, the technology is here to transform the diabetes management. We often grumble the constraints that we have with time, with non-availability of dietitians, diabetic educators, and how to train the patient herself for self-management, etc. The time is here and now with digital innovations changing the diabetes care. One must remember as an OBGYN, if it's GDM today, it may be NCD tomorrow, and post-hyperglycemia, long-term care beyond pregnancy is the key. So dear friends, it's a call to action. We have to push for caregivers and the women themselves to be made aware of the risks and the opportunities to modulate the risks, especially the cardiovascular risks. Strive for all women with risk factors such as obesity and hypertension to be offered post-pregnancy counseling. Ensure that annual follow-up at the general practitioner starting 3 months postpartum, especially for those women with previous preeclampsia and gestational diabetes, is a must, and educate the women to discuss their obstetric history at all routine checkups. By this, we will be ensuring that this year on, as a minimum, we pledge that all pregnant women attending our health facilities in every region will be tested for hyperglycemia using the single-step test. All the high-risk mother and child pair post-GDM pregnancy will be encouraged and supported for postpartum follow-up, and engagement linked to the child's vaccination program or other initiatives by encouraging our respective fraternity members to collaborate with each other and with other healthcare providers, breaking the silos and reaching the care to everybody. It's no use just talking about non-existent things. We have to generate the demand on one hand, but also strengthen the supply side. We have to build the capacity of healthcare practitioners, encourage them to follow the guidelines, both for diagnosis and management, set the protocols, and ensure that there is a robust network for the follow-up. This also is done in the present context through the digital platform, and you will see organizations like ARTIST, which is Asian Research and Training Institute for Skill Transfer, standardizing the maternal care pre-pregnancy, during pregnancy, and postpartum by digital skill transfer to thousands of frontline healthcare providers. So in conclusion, I would say that we disseminate and share the international, national, and government of India guidelines, make simple infographics so that the colleagues at every level of healthcare provision understand what we are saying and why we are saying whatever we are saying, advocate by talking to the policymakers and the governments to highlight the connect between the maternal healthcare and the NCDs, and collaborate with other professional societies. An outstanding example of how Dr. Chawla and Dr. Jaggi have put us together, the OBGYNs and diabetologists, at this brilliant meeting to ensure improved testing, diagnosis, and care for women. So let's prevent diabetes and give the gift of a life free from non-communicable diseases to the generation next. With this, I thank you all for a very patient hearing and pledge yet again that we will do our best and we will do whatever it takes to make the generations in the forthcoming years diabetes free. Namaskar.
Thank you, madam. We miss you in person. Shalini, now can we go for discussion?
Shalini ma'am is not here, but yes, we can start the discussion, ma'am.
Yeah. Now, starting with Professor Seshia, he has made clear that epigenetic plays an important role than genetic, and mother is more important than father, deciding the future of the fetus. And remember, HbA1c 5.3 and 111 blood sugar at 10 weeks of is abnormal. The importance of 10 weeks fasting and start responding to the fetus starts responding to the maternal blood sugar, and screening after 10 weeks is a waste because we miss GDM, but the fetus will have the consequences because of the fetal hyperglycemia, hyperinsulinemia, and maternal hyperglycemia. Now, sir has given the newer concept, the very latest, Professor Seshia's concept of totally stopping the development of GDM itself, which triggers diabetes. So with this, now we are very glad to know that we can make diabetes itself disappear from the universe. Wait, I'll see if there is any questions.
Sir, good afternoon, sir. Very nice to see you here, sir. And a lot of new things added in the talk, sir.
Yes, yes. Every day I'm reading, every day I'm my brain to think how to go about that. Let me see. I think you are there. I'm very happy. And you also told you and Sunil the metformin is safe drug. So people should not fear of giving metformin. It is a very safe drug. See, diabetes is much worse than few months of metformin. I am very happy that you projected the slide, and as well as Sunil. I think you are one of the member of the Primordial Prevention Diabetes Committee. Please go ahead with this work. We'll see. Very happy.
Any questions? Or now as per Professor Dr. Balaji, he has clearly emphasized again and again not to confuse with reduction and prediction. Reduction is diagnosing by 75 grams of glucose in the fasting or non-fasting state, 2-hour post glucose 140 for diagnosis, and it is whom to screen, when to screen, and how to screen. It is a universal screening for all pregnant women in the very first trimester, and now it is still early, and if it is negative, it has to be repeated in the second and third trimester. And for monitoring, it is after mixed meals. Fasting always less than 90 and 2 hours, post meal less than 120. Please don't confuse both. That this is detection and diagnosis, whereas Sir, give the latest idea of prediction. To questions to Dr. Picky, at what age we should start screening for PCOS? What is the earliest age?
Actually, there is a big dilemma because in the adolescents, at the time of menarche, the hypothalamic pituitary ovarian axis is immature. And anyway, physiologically, they are going to have irregular cycles. So how to, and also at that time, they generally gain weight and develop some hirsutism. So how to follow up these patients and screen? So this new PCOS guidelines, which was I showed in my slides, international guideline consensus in 2018, it says that if a girl 1 year after menarche is not getting periods for more than 3 months, or is getting very polymenorrhea, frequent cycles, or getting less than 3 or 4 cycles every year, then these women, along with if she has acanthosis, family history of diabetes, she's obese, and she has pubarchy, at an early age, precocious, all these girls have to be followed up. But the diagnosis of PCOS is not to be made till we follow them up for 7 years post-menarche. This is the latest consensus. And we need to keep a very strict vigilance because they are prone to develop PCOS and all the other things that we discussed, and weight control, and whole family, parents, caretakers. If we have to control the food of the child, the kitchen of the house has to be controlled. So everything, their parents will also be obese. They will also be having, mother may be having GDM. We need to ask what was the birth weight of the baby and take it on from there. Prevent the mother also, because she will be also young. Did she have GDM? Because many times GDM is not being tested. From the signs, symptoms, history, we can find out if she had GDM and screen them all the life for this.
And again, in case of thin PCOS, lean periods, so again, the same criteria applies. They have missed irregular periods,
yes,
like
yes,
all that, the same thing.
And ma'am, ultrasound is not taken into account because these girls are anyway not going to have ovulation. So they will be having multicystic ovaries. So ultrasound, and we cannot do a transvaginal scan. And most of them are obese. So transabdominal ultrasound does not have a very good sensitivity to pick up polycystic ovaries. So ultrasound has been removed from the criteria, but these two things should be present. Both hyperandrogenism is either clinical or biochemical, and also irregular cycles or amenorrhea.
And here again, in the lean PCOS also again, can we recommend metformin?
Yes, yes, ma'am. Because although the weight is low, but the waist-hip ratio, the visceral obesity is still there. So we don't tell them to cut down calories, but tell them to reduce the fat content and take a balanced, fiber-rich, protein-rich diet. And metformin is a wonderful drug. I have been using this throughout pregnancy in all my PCOS patients. Sometimes they go out to some other antenatal physician and metformin is stopped. In most of those patients, they do develop GDM. I have seen it very, very frequently. And although I also say that insulin is the first line, but for my PCOS patient, I do not stop metformin. It reduces all those complications, ma'am, abortions, preterm labor, premature rupture of membrane, GDM. And we have to increase the dose. As sir had said in his lecture, after 20 weeks, the glucogenic hormones will come up, insulin resistance will increase. So beautifully what sir said, we are doing practically also. We increase the dose of metformin and we test them for any glucose imbalance at that.
And we can take it for granted that majority of the PCOS do not develop GDM because of the use of metformin.
Yes, yes, yes.
Rajiv Chawla?
Yes, sir.
Only,
Sir.
I wish my my dream by next year you will again hold a conference. By the time many of us will come to a conclusion what I am dreaming, how to prevent diabetes. Please do some work.
Yes, sir.
Sure, sir.
If anybody wants, they can contact Rajiv, Shalini, or Piki, or Bhavadarni, or Dr. Balaji, Dr. What is their name?
Sunil.
All of them will have some idea on this. So Rajesh Jain, all of them are knowing what's happening. So we are still in the process of cooking. So next year, you should be able to get the Pakka answer. Hope everybody thinks about that. Think what to do. I will daily ask. Yesterday night also, I was discussing with Dr. Pinky what to do. I was surprised. And Bajaj also produced that slide. 2007, I published the data. GDM manifest in all trimester pregnancy, where those days was called first trimester was supposed to be 16th week. My published paper DRCP. Now when it became 12th week, I don't know. See, originally if you see the slides, 2017, 2002 and all, I'm an old time, those days we produced only 16th week. Now all of us telling first time 12th. Anyway, it's good, 12th week. But how the transition took place, I don't know idea at all. I don't know who can give the answer for this question, what I'm asking now. So it's better to do everything before told. After told, I told you, no use of giving any medicine, it will never prevent diabetes. That's all. Over is over. Nothing missed it. So no point in putting all the tablets to prevent diabetes waste. It is waste. So anyway, tell both of you, Shalini and Rajiv, please, you induce people to work on this concept. Send a newsletter to everybody. Anybody can do the work and see what happens.
Absolutely, sir.
True.
The long back in 2007-8, you have said that it prevents in all trimesters, and again in 2017 you have said it has increased, doubled. It has doubled. But now in 2020 and the Norbert Finkel lecture, they have said there is this is coming in first trimester also. Now only they have observed in 21.
Sir, in the textbooks and in our teaching, we were never taught that GDM testing has to be done in the first trimester.
Absolutely.
It was a totally out of the box thinking, and we always used to read and teach that it is to be done in 24 to 20.
Even in 2022, ADA is still sleeping on that, and Caucasian
No, sir. No, sir. ADA
not
has
even
changed their
mentioning
stand,
of
sir.
screening
Sorry,
in
sir.
first
ADA has
semester.
changed their stand,
Yes.
sir.
That's what I'm saying. 21 paradigm shift in the
Absolutely shifted. ADA has very clearly changed their stand, and very clearly they've started first point in pregnancy, you need to start testing.
But it has come in 21.
Yes. In the current recommendations, it is very much there. They have changed their stand finally.
The sir has told long back in 2007.
14 years later, when sir said in 2007, now in 14 years later, they are saying this.
And again, he has done another paper in 17 saying that it has doubled. First trimester, whatever was the 16 has become 32%. And again, the second 22 has become 41 and very little in the third. So it occurs much earlier.
Much earlier, actually. That is what they have been missing earlier, and they have been counting it as it is for the first time getting detected in second or third. Actually, sir has shown in his own data, a lot of evidence sir has produced, and his data is, I think, it is close to 30%, which comes in first trimester, if I remember your study, sir.
Yeah.
Almost 30%, 31% comes in first trimester itself.
That is
So
first study, 16%. Second study, when he repeated, it is 32%.
32%. Exactly. This is what I'm saying. 1/3 of pregnant women will develop GDM in first trimester in Indian ethnicity, at least. So I think we need to sensitize people, and whenever we are especially doing these now 23, as Dr. Hema Divakar, she's unfortunately not logged in. She's going for that international meeting. I think this message should go very, very loud that we need to screen much earlier. Maybe it may not be true for Caucasian, but at least for Asian ethnicity is very, very important. Those who are at a very great risk of developing type 2 diabetes, and we already have a pre-diabetes burden of an equivalent prevalence, almost 75 million diabetics and 75 million pre-diabetics. And these pre-diabetic females are the one who are likely to develop GDM in first trimester. So I think there is still a lot of need for a sensitization to Western community that at least for our ethnicity, it may not be true for Caucasian. For our ethnicity, we must screen as early as possible. And what he says and what he has been talking about his dream that we must start for primordial prevention as early as 9 weeks or 10 weeks. 8 weeks. Yeah.
8 weeks.
So I think we will coordinate from this side, from this part of the world. I'm happy Dr. Pikki is always in touch with us. Maybe we may do some pilot project, if not very long study.
We have started.
Yeah, I
collecting
discussed with you earlier also when we were in Nagpur. Yeah,
Yes.
something we may come out by next 1 year. Yeah.
Dr. Rajiv, and again, the age of marriage has gone up and the children are delaying the children.
Exactly.
And the age of occurrence of diabetes is coming down and down, all coinciding, and we have more of pre-diabetes, which is more dangerous.
This is again because of higher age of marriage, because they are getting married at 30. By then, they already have a strong family history. If they have a strong family history, they already have pre-diabetes. Moment they get pregnant, they are the one who are likely to develop GDM in first trimester actually. So these are not actually missed type 2. They are actually pre-diabetic who have never been screened. Moment you do their first sugar in 8, 9 or 10 weeks, they are the one who are likely to have full-blown GDM or GGI, what we say, maybe glucose intolerance in gestation.
I think this is where education, awareness, multidisciplinary approach between diabetes, endos and gynecologists has to be there, because I think by the time a patient is already diagnosed, I think the battle is lost. Then it is only damage control, and hardly any damage control we can do. So I think it's important to create awareness and sensitize the public on all these aspects, then only probably we can actually look at what we are aiming to achieve in the future, Sir's vision of primordial prevention.
Yes, as Sir says, it should be pre-conceptional awareness, and absolutely. They should be, he always says, fit to conceive.
Yes.
Optimization of PCOS patients, especially, sir. They are really increasing in numbers. PCOS girls, most of them are fat. In the OPD, you will hardly see any few patients who are normal BMI. Most of them are obese. Most of them are having PCOS. So we need to have concept of preconceptional counseling.
I think especially it is true about metros like Delhi and others. Dr. Anup Mishra already has a school study where they have shown that 2/3 of them, by the time they are adolescent in school, they are overweight or obese. So unfortunately, actually GDM is growing in the background of growing obesity and pre-diabetes, and higher age of marriage and late conceptions are accounting for higher prevalence in first trimester itself. I think we will have to close with a final word from Professor V. Sheshai, because 2:20 we need to start. Sir, a final carry-on message to every delegate, anything you want to say.
I enjoyed all the talks by the colleagues here. I told my desire that all of you must work, must think about prevention of diabetes. It is not difficult. It's a simple thing. Tell the once you conceive, come to the clinic. Everywhere they must put, every clinic must put. When you conceive, please come. Do the test, and then this is very simple treatment, not a big complicated. Put the now 2 paper, Pikki Saxena produced a paper, and then that Sunil Gupta showed a paper. Metformin, a very safe drug. You can easily give it to them, so that it's such a simple treatment. We can prevent. Well, at least India can become frequent. I don't know. You know about this. One day, month of April, I put a letter to the government of India. Same month. So this is excellent question. In America also, AD advertisement came. Pathway, something like pathway to
Pathways for prevention of diabetes.
Prevention of
Pathways
diabetes.
to prevent diabetes.
Huh?
Pathways to prevent diabetes.
Yeah. See, now they also got worried. So, at least now I have given the guidelines and answer. They have not still found answer. So by next year we should be able to find the answer and publish it. And from the now we have got that Indian Journal editor is there with us, Sunil Gupta. we should be able to publish our ideas. And at least I have given the guidelines to the press to publish it, just guidelines. Let us see what they do.
We will try to get it in IJJDC, and moment I take over, I think I'll invite a editorial commentary from you on
Sure. And
next
I will
year.
do that. I will do that. I will do that. Sure.
So we should make in India.
So, yes, absolutely. So thank you so much, everyone. I think we had a very, very stimulating diabetes in pregnancy symposium. And I'm so happy that the out of the box ideas, which I'm sure very soon will become evidence-based ideas and will get accepted very soon in the near future, will be implemented. But till then, I think the message is loud and clear. It's important that pregnancy is planned. Preconception is very, very important. You need good glycemic control, not only once she is pregnant, but before she is pregnant, if we really aim at primordial prevention of diabetes. With that, I thank Professor Seshia sir, Dr. Balaji, Dr. Sunil Gupta sir, Dr. Hema Divakar, Dr. Pikki, Dr. Bhavtarini, everyone else who's joined in today for this grand DIPSI CMRE joint symposium. Thank you so much for honoring us with your presence, and I'm sure the delegates go home richer with this.
I sincerely wish that Sir's dream of primordial prevention comes true in his lifetime.
Absolutely,
In his
and I'm
lifetime,
sure we will all work towards it.
That dream comes true.
Thank you so much, sir.
Thank you.
I now hand over.
Chawla and Shalini.
Thank you, ma'am. Thank you so much. Thank you so much. I now hand over to Dr. Rutul to kindly take over and invite the next chairpersons for the next session, please.
After this joint CMRE DIPSI symposium, we have again a session which is very much relevant to this thing, what we were talking earlier about PCOS and obesity. Now we have a session on obesity workshop. And for that, we have chairperson, Dr. Sunil Gupta, sir, and Dr. Ajay Gupta. Dr. Sunil Gupta will be joining us soon, but I'll introduce Dr. Ajay Gupta. He is MD, FIACM, and scholar, American Diabetes Association, and MACE. He is co-founder and medical director of Lotus Diabetes Private Limited and Madhumeh Clinic in Vaishali Hospital, and he is HOD, Department of Internal Medicine in Mexico. Over to you, Dr. Ajay Kumar Gupta.
Dr. Rutul. Thank you, Dr. Rutul. And like I was just attending the sessions from 12:30, and it was really a academic feast to listen to Dr. Seshaya sir and ma'am and this whole discussion about PCOS and gestational diabetes. And like you said, that another topic which we are going forward is the pertinent topic in nowadays, because whatever metabolic diseases we are treating or whatever metabolic diseases we are getting, the base of that is the obesity. And today we have none other than the great speaker, Dr. Rajiv Chawla, with us. So he'll be just illuminating on the science behind the obesity. And I don't think he needs any introduction. So first of all, my sincere regards and thanks to you for inviting me to such an good academic feast, sir. Sir is a very senior diabetologist and director of the North Delhi Diabetes Center. He's a visiting professor at JLN Medical College and KLE Academic of Higher Education. He has been trained in diabetes. He has got more than 100 papers related to his work. Has been awarded the ACE Travel Grant twice for this.
Ajay, good enough. Thanks a lot. Thank you. I think let's go to the topic and spend little more useful time there. Thanks a lot, Ajay. Manoj, your dream of having Chawlas and Chawlas, I'm not on Facebook, but I just read those comments, Chawlas and Chawlas being moderated by Guptas and Gupta, it will be Gupta and Rutul Thaker. So that hasn't come true. Thank you. But for me, it's dream coming true that I'm going to be a co-speaker with a star speaker like Manoj Chawla. Thank you. So let me share my screen here. Someone is still sharing the screen. Let me share. Yeah. Am I visible? My screen and slides?
Yes, sir. Very good, sir.
Okay, thank you. So, well, this is going to be a sponsored session by No Nordisk. Me and Manoj will take you through. What I have been asked to do is just discuss briefly what is science behind obesity. It seems to be like a layman teaching what we do to our third year students or to final year students, that whenever you talk about obesity, let me give you an overview. I'll be discussing physiology of weight regulation, then coming about etiopathogenesis of obesity, and toward the end, I'll discuss benefits of weight loss, which are so apparent. But problem is that how to avoid that regain of weight, which is a real concern. So let me start with physiology of weight gain. It was very, very simple, putting in layman terms that when we talk about weight regulation, it is something to do with energy balance equation where intake has to match expenditure. Moment intake is more and expenditure is less, obviously we will end up with obesity. So intake is about management of hunger, management of satiety, and the nutrient absorption which happens, which then obviously has to be burnt in form of calories, through metabolic rate, through thermogenesis, through a structured exercise program, and through a non-exercise activity-based thermogenesis. So body weight is obviously going to be determined by an energy balance, which is a U balance, whether food intake should not be much or we need to burn more calories. We need to have energy expenditure, a good basal as well as exercise-induced thermogenesis, so as to make sure that there is not going to be a weight gain. So when we talk about energy expenditure, I think it is important to understand that physical activity in any form is going to lead on to some amount of energy expenditure, whether it is a structured exercise, which refers to amount of energy utilized during structured exercise, like occupational physical activity, commuting activity, or even household works also involve a lot of exercise. Once it is NEAT, which is a non-exercise activity thermogenesis, which refers to amount of energy utilized spontaneously coming as a result of like muscle tone, posture, or balance. So even if you are standing, I think that also amounts to significant amount of expenditure of energy through NEAT, which is non-exercise activity thermogenesis. And when we are talking of a diet-induced thermogenesis, this is something new, which refers to heat production in response to food also, which we never knew earlier days. The amount of energy required for digestion, absorption, transportation, and subsequent storage of even ingested nutrients. So even that also needs to be metabolized, and there is going to be some amount of diet-induced thermogenesis. And of course, the basal metabolic rate is very, very important, which refers to energy required to sustain all essential physiological functions also. So let's see how hormones and peptides, they are involved in appetite regulation, and how unfortunately still obesity happens in spite of a good balance or imbalance which happens leading on to obesity. Once it comes to central location hypothalamus, it is the hypothalamus which is a principal organ which decides whether you're going to have a obesity or a balance. It depends on anorexigenic hormones like POMC, which is the most important. It is a precursor protein actually, propiomelanocortin POMC, which produces many biological active peptides like melanocyte stimulating hormones, alpha, beta, MSH, and even corticotrophin, ACTH, and beta endorphins also. Then you have nesprestin, which is not all that important, TRH, CRH, oxytocin is very, very important. Serotonin, we always knew, plays a huge role as an anorexigenic hormone, and histamine also. Once it comes to orexigenic hormones, which have an impact on hypothalamus, it is principally neuropeptide 5 or agouti-related protein, which are very, very important. And even endocannabinoids are very, very important. You remember a drug which was endocannabinoid inhibitor, rimonabant, which of course was withdrawn because of psychiatric insults or higher rates of suicide. But that was that way a good drug because it was possible to have some weight loss on that drug. Once it is peripheral peptides and hormones, it is CCK coming from the gastrointestinal tract, which is very, very cholecystokinin, which is very, very important. GLP-1, we all know that is how we are using drugs like GLP-1 receptor agonist, which is principally working as an anorexigenic hormone. Pancreatic polypeptide is also important. Oxytocin modulin is also very, very important. But once it comes to orexigenic hormone from the gut, it is ghrelin which plays an important role, and that actually contributes towards obesity because it significantly increases the appetite in a person. Of course, pancreatic peptides, amylin and insulin also are very, very important. So I think it is very important to see that an appetite regulation, these peripheral signals, they modulate appetite and energy expenditure via hypothalamic neurons. So arcuate nucleus are very, very important first order neurons, especially the medial arcuate nucleus, which gets addressed with POMC and CART hormone. And you have obviously then coming of satiety through stimulation of these POMC like hormones. But once it comes to satiety peptides, I told you PYY, GLP-1, PP or oxytocin are very, very important, and they played a very, very important role in getting that satiety effect. But once it is about hunger signals, I told you ghrelin is very, very important, and it is primarily working through lateral arcuate nucleus, and then it addresses the hunger center into the hypothalamus, increasing the appetite. So increasing predisposition to weight gain or obesity. So adiposity signals like leptin and insulin are also very, very important. And even vagus plays a very important role. All vagal efferent stimulations through nucleus tractus solitarius also are going to go to brainstem and ultimately lead on to increase in gastric emptying time. That is how there is a reduction in appetite, and of course feeding behavior changes because we have a sort of full stomach in spite of not having eaten for many hours. And of course the static peptide like amylin and GLP-1 also work through area postrema and then try to reduce gastric motility and delay gastric emptying time, which is a principal action of GLP-1 like hormone. That is how we use GLP-1 receptor agonist to reduce not only the appetite from the central mechanism, but also to delay gastric emptying. So role of brain is very, very important in controlling appetite. And actually it is homeostatic eating, which is actually an eating for hunger, which is mediated through GLP-1 receptor agonist, GLP-1 hormone, and PYY. I already told you, oxytocin modulin and amylins are very, very important because they increase satiety. But I told you it is ghrelin which increases hunger. So actually, if we are simply going with the eating for hunger, we may not get obese at all. It is hedonic eating, eating for pleasure, which in spite of the fact that there is hardly any hunger, and that we have a compulsive eating to get that pleasure out of that meal, which induces obesity. And we know here dopamine controls wanting, the motivation, the drive to eat. So this is very, very important. And opioid and cannabinoid receptors, I told you, they control liking. So if you have a drug which can address cannabinoid receptors, you may have still a check mechanism on dopamine like receptors induce wanting or over motivation or over drive to eat, because then obviously there will be lesser pleasure associated with food. But third important function of the brain in controlling appetite and to some extent in not getting obesity is executive function, which decides that how much is the homeostatic eating pattern, the real need for hunger to eat, and how much is the hedonic eating, which is an eating for pleasure. So this executive function of the brain actually then takes that decision. So this is deciding to eat, when not to eat. So it has to be a sum of feelings, thoughts, and behavior. That is why it is said that behavioral interventions are going to be extremely important in management of obesity, because they empower sustainable behaviors in controlling eating patterns. So it may not be simply that you're not eating, that true change in behavior will go a long way in sort of preventing obesity. Let me take you through now the etiopathogenesis of obesity. As I already said, it is an imbalance between an energy intake and energy expenditure. Unfortunately, obesity has long been misunderstood. It has been stigmatized as a lifestyle issue that can be simply effectively addressed by a mantra of eat less, move more. But I think it is much more than that. Now we understand that like any other chronic disease, any other metabolic disorder like hypertension or dyslipidemia or coronary artery disease or maybe something like diabetes. It has a heterogeneous condition. Has a heterogeneous behavior resulting from the complex interaction of a multitude of social, psycho, biological factors that promote excessive weight gain and ultimately impair health. So once obesity is established, I think this is very, very important to understand. We tend to blame patient that you are eating more, you're moving less, but it is possibly because of the fact moment you have obesity, that powerful neurohormonal factor effectively defend body against weight loss. This is what I heard Neeta talking about a couple of times, which was very, very impressive, that why don't we have a continuous weight loss on the same drug, on a same program, on a same structured exercise? Because in spite of all those programs going on, that neurohormonal factors or that behavior will make sure that you don't lose weight further. And this comes as a result of couple of inputs from gut, genetics, from medication and adipose tissue. So it is the hedonic input. I told you that pleasure eating, which is very, very important, because once it is increased, it gives you huge amount of pleasure in eating and you keep eating. But much more than that, even the environmental behavior is very, very important. That physical inactivity, that inactive lifestyle, moment you stop smoking, unfortunately, there is an increase in appetite, you tend to gain weight, and other psychosocial factors which are also equally important. So when we talk about factors predisposing to obesity, it is not simply genetics, which we know that there is a higher heritability of body weight. There are genes in hypothalamus, leptin, melanocortin pathway, which I have just alluded to, and single nucleotide polymorphism, which predisposes to obesity. So these SNPs, there are almost more than 300 SNPs which have been identified with over 250 loci for which are associated with obesity traits, which are very, very important because they tend to regulate not only total BMI, but there are loci or almost 49 or 50, which tend to determine the waist-hip ratio, which is then subsequently expressed in adipose tissue. So more than 100 genes and genetic loci are associated with obesity, and genes are associated with BMI are enriched for expression in the brain and central nervous system. So it is not much of peripheral response. It is actually into the brain and into the central nervous system that these SNPs or genes predispose to obesity. Of course, environmental factors are also very, very important once it comes to predisposing to obesity, like social, cultural factors, tradition, beliefs, and peer pressure to eat. Many mother-in-laws or mothers may insist you must eat. Socioeconomical factors, food environment. If you have a lot of availability of food, obviously you are going to eat. This is what happens when you are on pleasure trips or in conferences. And of course, these days, many fast foods are so inexpensive that and so palatable that it is difficult to control your weight or control yourself. And we know with the obesity, there is going to be multiple complication like metabolic, mechanical, and mental. Metabolic could be simply in the form of having you may say asthma, nephroid, gallstones, because these are mechanical impact of obesity. You may have osteoarthritis, you might have PCODs, which we were just discussing, and subsequent pregnancy complication and high risk of developing cancer as a metabolic effect. And then you have mechanical effects like OSA, osteoarthritis, and you are not able to walk. You have a chronic back pain, which makes you almost hidden or maybe on no activity at all. And of course, mental results of obesity are also catastrophic in the form of depression and anxiety, which comes as a result of obesity. So let's see, are there any benefits of weight loss? These are convincingly seen in all the evidences. Moment you have 5 to 10% weight loss, it will improve all obesity-related complication. May it be simply conversion from IGT to type 2 diabetes. There's significant reduction is going to be there in CV mortality, lipids are going to improve, blood pressure is going to improve, and there are going to be improvement in obstructive sleep apnea scores, and overall health will definitely improve. But if you have a greater weight loss, more than 10 to 15%, Taylor data in the direct study has shown that you can have 15% weight loss in 1 year time. This may reverse or put diabetes into total remission, because the moment you have more than 15% weight reduction, your dysglycemia disappears. Not only that, your triglycerides significantly improve, and even your blood pressure also may get controlled. Of course, with 5 to 10%, there are going to be benefits. I told you reduction in effort score, sleep apnea will improve. Obviously, osteoarthritis will also go down and many other things will also get corrected. The problem is maintenance of weight loss is challenging. All these studies, these meta-analyses have shown it is easy to have weight loss, which may happen within 6 months with any sort of therapy. It may be a structured exercise program and couple of drugs. But unfortunately, down the line, if you follow these patients over next 4 to 5 years, most of these patients, they regain the amount of weight loss what has happened. This is because of the fact that physiologically, there are changes which are diet induced as a result of weight loss. There is going to be reduction in energy expenditure moment you are on the lesser calorie diet, fat oxidation goes down, even thyroid hormones get reduced, actually cortisol goes up, and there is an increase in ghrelin, and overall appetite goes up moment you are, say, on very low calorie diet or VLCD type of thing. So not only your expenditure is going down, your appetite is coming up, and that induces again that weight gain, or at least whatsoever you lost, you try to gain. And there are going to be metabolic adaptation following weight loss. These adaptation resists that weight loss which you have done maybe over 6 months or 1 year period. I told you this is primarily because of the fact that there is a reduction in satiety hormones with increased hunger hormones coming up like ghrelin, which tend to increase the weight whatsoever you have lost. And overall metabolism expenditure, I told you, goes down. And this is one of the biggest loser study reality show data, which is a 6-year follow-up. Within 30 weeks, these patients lost weight and they were followed for a duration of 6 years. There was actually a reduction by 58 kg, minded 58 kg in 30 weeks time in these 16 patients. But unfortunately, within 6 years, they were almost back to the original weight and they gained almost 41 kg. Their resting metabolic rate, which was minus by 610 calories, actually towards end of 5 years went down by minus 700 calories. So obviously, once your resting metabolic rate is going down, or there are going to be metabolic adaptation, these are going to again lead on to weight gain. So by 6 years, most of the participants, they demonstrated a metabolic adaptation of almost 499 or 500 calories minus. So these data illustrate that metabolic adaptations, they counteract weight loss and it is going to persist over time. That is why subsequently you are going to gain the same weight what you initially lost. So to summarize, energy balance is regulated by brain through various sources of input. It has to be a meticulous balance between an energy intake and energy expenditure. Moment there is an imbalance in form of increased calories or lesser of physical activity, you are going to gain weight. The maintenance of weight loss is challenging due to metabolic adaptation, which I just alluded to, because of reduction in satiety hormone, but increase in hunger hormones and overall metabolism going down, leading on to energy expenditure. So brain controls appetite by regulating 3 types of eating. It is homeostatic eating, which is an appropriate eating for hunger. It is hedonic eating, which is inappropriate, which comes as a result of eating for pleasure. And it is the executive function of the brain, which decides what to eat and what not to eat. I'll stop short here and stop sharing here, and we'll go back to organizer, and we'll now listen from Dr. Manoj.
Thank you, sir. Thank you very much for this presentation for the science behind obesity. And now we have the second Chawla, sir, Dr. Manoj Chawla, for this session. And he'll take us for the assessment of obesity and how to grade and how to assess the obesity. Dr. Manoj Chawla, please.
Thank you. Thank you, Dr. Gupta. At the outset, let me thank Dr. Rajiv Chawla, Dr. Shalini Jaggi, and the team for inviting me. And it's a pleasure to speak in his presence. He an extremely nice and a modest person who encourages everyone. So yes, it's a pleasure to speak as Chawla and Chawla in the chairpersonships of Gupta and Gupta. So let me start by sharing the screen. Okay, so we had a wonderful talk and presentation from Dr. Rajiv Chawla about the weight aspects and what really leads to weight gain and how strategies to weight loss come across various roadblocks and challenges, and hence I need to understand what those challenges are when we start treating our patients with issues with being overweight or obese. I'm going to go a step earlier and then start with talking about the means of assessing and actually diagnosing obesity. What is the newer understanding of grading for obesity as compared to the earlier one, which was staging, which was based purely on BMI. And today we understand that we need to go way beyond just BMI means of assessing. I do have a contract with Novo Nordisk for today's presentation. The objective is to understand that BMI, what is the BMI approach to assess the classification? That's just based on your BMI, what we've been doing so far, and that's how we classified people as normal weight, overweight, and grades of obesity. But then let's look at the EOSS, which is the Edmonton Obesity Staging to assess obesity, and then some practical case studies to understand how this newer means of classifying an individual as obese, how it differs from what the earlier BMI means was. So initiating obesity management with your patients has 3 major steps. And the most important there is to diagnose your patient correctly. And then, of course, to discuss the aspects of different therapies that you're offering and then to treat the patient. So let's start with diagnosing. How do I diagnose it? So far, it's been the BMI. What is BMI? BMI in kg per meter square is an individual's weight in kilograms divided by height in meters square. It's an objective measure that can be used to diagnose obesity. And as I said, that's been the only means we've been doing. And yet we should continue looking at the BMI. In fact, it should be addressed at every clinic visit. A lot of today electronic health record softwares has, of course, have everything automated. The height doesn't change for an adult. You put in the weight, and every time when you're putting in the weight, the BMI numbers will keep coming onto your screen and the system. But recording that, hello, is there a problem? Okay. If you organize,
please continue. No, please continue.
Okay. So we also then know that the BMI parameters to define obesity have also been adjusted. May I request the IT person to mute some of the others who are not speaking? Thank you. And there is an India-centric BMI where the cutoffs have been adjusted, keeping in mind that Indians and Asians will have a lower BMI to be in that same stage of obesity. So to define obesity, you have a BMI of more than 25 kilogram per meter square. You're looking at the waist circumference more than 90 centimeters in men, 80 in women. At a waist hip ratio. Right. You look at the waist hip ratio in men.
Why don't you mute everyone, please?
In men, it would be 0.9, in women, 0.8. And then you start looking at body fat percentage. You have a lot of scales and machines, right, from simple ones to a little more sophisticated, which allow you to measure the body fat percentage. And more than 25 in men and more than 30% in women will consider as putting that individual in the obese class. You also look at the classification here based on BMI in adults. Less than 18.5 for Indians would be underweight, 18.5 to 23 would be normal weight, 23 to 25 is overweight, and above 25, you will see the grades of obesity, grade 1 from 25 to 30, grade 2 from 30 to 35, and grade 3 as more than 35. In children, of course, you go by percentiles, and remember that if the BMI is more than 95th percentile for age in children, that would be considered obese. And this is important because we unfortunately are dealing with a lot of childhood obesity, and hence the need for having these conversations even in schools today to prevent childhood obesity and early type 2 diabetes. With only BMI, we do ignore the normal weight obesities. And let's understand why the need to move beyond BMI. So if you're looking at that, you will realize that a lot of people who would be considered as normal weight would also be obese. So if you're going to be looking at just the BMI, you'll miss out on a fraction of people who have normal BMI but they are obese because they have high body fat percentage and so on. Which is where raises the question, is there something like healthy obesity? And it's time for us to understand that BMI, if you look at it, will have moved from the spectrum of normal weight to obese. But you also need to look then at the individual's metabolic status. Who will be considered as metabolically healthy? But somebody who has no other metabolic conditions and has normal weight. Also, there would be people who are obese but metabolically healthy. They would still be considered as metabolically healthy individuals. You may classify them as obese, but they are metabolically healthy. And then, of course, you'll have individuals who are obese and metabolically unhealthy. They could have more visceral than subcutaneous fat, hyperinsulinemia, presence of diabetes, dyslipidemia, inflammation, or sarcopenia, which is something that we are now beginning to identify more and more as a contributor even towards obesity and early type 2 diabetes and cardiovascular disease. Having said that, even in the normal weight individuals, those who could have metabolic conditions, again similar, diabetes, sarcopenia, inflammation, would be metabolically unhealthy and normal weight. So please understand both these situations, that you could have somebody who's obese by the BMI classification, but is metabolically healthy. You could have an individual who is normal weight, but is metabolically unhealthy because of the comorbid condition or other features. And that's what is today called as the obesity mortality paradox, where we speak about normal BMI, metabolically healthy. This is the desired profile for one to have reduced fat, increased muscle, increased fitness, normal insulin sensitivity, and so on. Then you have an obese individual based on BMI, but still at present metabolically healthy, has good muscle, good fitness, some amount of hyperinsulinemia coming in, but rest of the parameters normal. And then you have somebody with normal BMI who's metabolically unhealthy. You look at this individual, looks fine, but could have some chronic illness, could have muscle loss, excess visceral fat, reduced fitness, diabetes, inflammation, and so on. And then an individual who's obviously obese with the presence of various comorbid conditions and risk factors, making this person metabolically unhealthy. So we need to go beyond BMI and start looking at various conditions which may coexist. And which is why we do understand that BMI assessment will have its own limitation. It doesn't measure body fat. So people with the same BMI can actually have difference based on their body fat in terms of their risk involved. It does not assess the presence of concomitant comorbid conditions or disease risk. BMI alone does not provide measurement of functionality. How much can a person move? How functional is that individual? The quality of life or other factors. It does not take into mind even the mental health aspects, whether there is depression and other things which are important today. Changes in BMI or waist circumference do not necessarily reflect improvement in overall health or functioning, and that's a problem. Somebody's BMI may come down, but that person may still not be very functional. It doesn't change the individual's risk factors. So BMI does have a lot of limitations, and which is why the need to move beyond BMI for the right assessment of obesity, and which is where this beautiful paper much earlier in 2009 was published by the work of Dr. Arya Sharma and Kushner. They're complementing the BMI with a simple disease-related and functional staging system would be helpful. And that's where what came in was the EOSS, Edmonton Obesity Staging System. Of course, this is based on the work done by Dr. Arya and team from Edmonton, Canada. I believe now he's moved from there and lives in Germany, where he continues to do his work in the field of obesity. What did the EOSS tell us? That you're going to be looking at three aspects. You're going to be looking at the presence of medical conditions, comorbidities, etc. You're going to be looking at the mental state of the patient, including presence of depression and other mental conditions, and then functionality. Does the patient functionality get offered? Does the patient have OSA and then not function much in the day? Does the patient have obesity-related arthritis and they cannot move much? So all these three aspects are considered in the staging system. So you had grades as based on the BMI, but when you look at the EOSS, let's understand that this is staging. And this is extremely important. And as Dr. Rajiv Chawla sir said, that a lot of conversation that we're having is something that you do at the postgraduate or even undergraduate level, that we are going back to understand obesity and the changing concepts. And it's important that we understand the new staging system from stage 0, where you have all these absence, to stage 1, where you do not have problems with mental and functionality aspects, but there are some preclinical risk factors. Stage 2, you have comorbidities, diabetes, hypertension maybe. You have some moderate mental aspect like depression coming in, and moderate functionality getting affected. Moving on to stage 3 and stage 4, where you would have progress in terms of worsening comorbid conditions and mental and functional issues. Now you're looking at USS as the staging system when you use it to predict the mortality in cohort of people with overweight and obesity from the NANS3 data. Now from the NANS3 data, if you look at based on the BMI in different overweight to class 3 obese patients, you do not see a huge difference in terms of their survival. But you start looking at that data again based on the EOSS grade staging, and you'll realize that there's a huge difference. So individuals who would belong to stage 2 and stage 3 clearly have poorer survival. And that's why it's important to identify these individuals and try and offer help rather than looking just at BMI, which may not give us the clear idea. Now, this is something which gives us a clearer picture of understanding the difference between BMI and the EOSS staging. What this tells us that if you look at the NANS3 data, even if you look at the overweight population, which is 50 million in the NANS3 data, that if you're going to see just in the overweight population, you will have almost 47% of the patients which actually belong to EOSS stage 2 and 10% population here belonging to EOSS stage 3. If you had gone just by the BMI, you would have thought, okay, overweight, just overweight, no other obesity, not that much of an issue, and would have missed the aspect of the problems that this would plague such an individual with almost 48, 47 and 10% being in stage 2 and stage 3. And similarly, when you look at different classes of obesity based on BMI, you realize that they actually have higher percentage of people who may be in an advanced EOSS stage, and hence the need for us to look at the EOSS staging system. How do you offer them? What kind of help? And so EOSS stage 1, no risk factors, lifestyle modification. Stage 1, you're going to talk about behavioral therapy. Stage 2 is where the disease factor comes in. So you're going to talk about medical management. And stage 3 and 4 of the EOSS obesity staging, you talk about both medical and surgical and start talking about offering surgical solutions to this management of obesity. Let's understand this further. For example, in our case 1, you have 24-year-old physically active female, BMI is 32, no demonstrable risk factors, no functional limitations or mental health issues. If you go purely by BMI, she's class 2. But if you go by the EOSS, she's stage 0 obesity. By BMI, I would be much worried, and I'll be putting her into a stage 2 obesity and algorithms for the same. But if I go by EOSS, she'll stage 0. I just need to talk about some lifestyle factors here to this individual. Similarly, you see the case 2, 32-year-old female, BMI is 36 now. Hypertension, sleep apnea, depression. Class 3 by BMI, you go by EOSS, this is stage 2 obesity and would clearly merit the benefits of obesity treatment. Another example, case 3, BMI is 54. Patient has disabling arthritis, wheelchair, severe hypoventilation, fibromyalgia, generalized anxiety disorder. So every aspect of mental dysfunctioning and functional issues along with the disease would require aggressive obesity treatment, even maybe surgery if possible for such an individual. So let me summarize by saying that assessment of obesity with BMI just itself alone may not be sufficient to optimize treatment. The Edmonton obesity staging system is a simple disease-related and functional staging system as shown and would provide additional clinical information meriting what kind of treatment you need to offer to that individual, which may not be possible on the basis of just BMI. The treatment of obesity should be person-centric instead of just based on algorithms or which are BMI based. You need to take into consideration patient's mental status, patient's functionality, and then decide on the treatment to offer. So with that, let me stop sharing and hand it back to the chairpersons to take this obesity session ahead.
Thank you, Dr. Manoj, and it was a very enlightening talk on staging and grading. So now we have patients of obesity, and now we can assess the patient in a full manner, and thereby we can start the treatment. So now the house is open for discussion.
I think, Ajay, we can have discussion after the cases to save on time, and Dr. Sunil has also joined with you as a co-chair.
Finally, Gupta.
Manoj, I think you also agree we do case 1 and case 2.
Absolutely, sir. Yeah,
and then go on discussion. That will be better.
Yes.
So I'll invite Dr. Rajiv Chawla to present his first case. His case is I lose weight, but it just seems to come back. So
exactly. Can you see my slides?
Yes, sir.
Okay.
Yes, sir.
Okay. So we come back to, after having some basic discussion on obesity, the mechanisms, and of course, how to assess obesity in clinical practice. Let's do some clinical discussion. So what I'll be doing is presenting this case. This is about management of obesity and its complication. It is going to be an interactive case-based approach, and I'll try to keep it very, very brief. So this is one case who says that I lose weight, but it seems to come back again. What I said in my session also, this is a true problem, that losing weight may not be all that difficult, but retaining that lost weight and making sure or ensuring that you don't regain weight is going to be a true problem. So let me start case, which is a clinical setting or a prototype case. Is Sunil, 63-year male. His BMI is 42. He already has osteoarthritis, both knees and involvement of hip also. Lumbar spine is also having impending mobility and again going to disrupt his sleep. He already has plantar fasciitis, sleep apnea because of very high BMI 42, bilateral pedal edema, vitamin D deficiencies, and pre-glaucoma and pre-diabetes like situation, which is expected. His highest lost weight has been from 121, which was his highest weight, and he could get or ensure only a weight loss of almost 10 kg with all those interventions and drugs which he took. He walks only for 10 to 15 minutes. I told you, patient is very obese, has already osteoarthritis knees at the age of 63. So it is only 10 to 15 minutes per day for 3 to 5 days a week. He travels a lot and he admits that he's very, very foodie about. And he already has a strong family history of CAD, CVD, type 2 diabetes, osteoarthritis, thyroid diseases, and alcoholism, all lifestyle disorders or metabolic disorders. This patient was started on orlistat, which had little effect, and even another anti-obesity oral drugs were tried off-label, but these were not found to be very, very effective. So let's have a closer look at his presentation. How does this guide us for treatment in the future? Factors which are impacting his weight are: he travels a lot, he eats too much, he's very foodie, and he doesn't have that control. I told you, in an executive function of the brain, which can control your appetite and prevent that overeating, which comes as a result of pleasure. Already has osteoarthritis, doesn't do much. Most of the time, he's sort of inactive. So at best, in spite of all those efforts, he ensured a weight loss of 8% with lifestyle, some dietary intervention. I told you he has been on orlistat also, and couple of another off-label anti-obesity drugs which he tried, but it didn't make too much of difference. So once you go back to his history since his college days, even when he was in high school, he was eating a lot. So by the time he had his first job at the age of 2021, he was already very, very obese. At that time, it is for the first time that while working in his office through his colleagues, he came to know. Of course, he knew that he was very obese. He got sensitized to that, and he started following a very low calorie diet. And over next 2 to 3 years, he was able to lose about 8% of weight. And once he was being talked about behavioral therapy and all that, he was actually again prompted to stop smoking, which he quit. And that unfortunately again added to his appetite. I told you, moment you quit smoking, there is going to be an increase in appetite, ghrelin goes up, and then again that behavior overeating came, and he was started on once again on certain off-label drugs, but he hardly managed any further weight loss. He has been to diet consultants and obesity specialists. He's already married, and now he's 63. So he's almost back to what used to be his weight during his early younghood, maybe at 20 or 25. At this age of 63, with severe osteoarthritis, with a traveling lifestyle and overeating pattern, it is very, very difficult to lose further weight. So it is important to break the cycle of chronic pain and weight gain. It is again easily said, because any intervention you do to address that osteoarthritis or knee surgery or those pains which can make him more physically active are not going to be very easy, not easy to implement because of his too much obesity. At 42, even a knee replacement surgery may not work because patient may not be able to walk even after that. So another important aspect is we must intervene to address his weight through anti-obesity medication. So it has to be a bi-directional or a multi-pronged approach. First is to address his knee pain, which is adding to his negativity and giving him very low self-esteem, so that he picks up exercise, tries to lose weight and regains his self-esteem. And second is by improving his eating habits and putting him on some good anti-obesity medication, so that he becomes not only physically active, starts eating less and can have some meaningful weight loss. And we know that weight loss in people with obesity and osteoarthritis will definitely dramatically improve functional status. Moment you can ensure a 10 to 15% weight loss, I've shown you those evidences. If you can ensure almost 15% weight loss, your osteoarthritis symptoms will almost vanish and will disappear. So not only your physical function will improve, your pain will go down, your joint stiffness will also go, and physical quality of life index will be much better. And this is what has been seen in these data and in these studies, which have shown that if you can ensure a weight loss of 5 to 15, less than 5 may not do much meaningful benefits. If you can ensure more than 15, it may do wonders in terms of overall improvement in your scores or health related quality of life index score, which is SF36 at this time, is definitely going to improve. You can ensure a weight loss of almost 15%. Unfortunately, we don't have too much drugs. Only approved drugs in India are maybe an oral semaglutide, which has been just approved, and an orlistat-like drug. Unfortunately, we never had an approved or liraglutide 3 milligram, which was available internationally, and there was a significant weight loss on that because that reduces appetite significantly. Then drugs like naltrexone, bupropion, again, are not improved because it may improve, actually reduce appetite and actually lead on to some significant weight reduction by 10 to 15%. Only drug available is orlistat, which is not very, very effective. Over the years, we have seen it. Phentermine, topiramate, again, these could be very, very important drugs for 10 to 15% weight loss, but again, these are not approved by DCGI for Indian use. So we have only approval on a future launch of semaglutide 2.4, which is likely to get launched, and only drug which we have been using is orlistat. So this patient got enrolled in a clinical trial where he was started on semaglutide 2.4 milligram once a week, and this led to significant weight loss almost within 1 year. At 52 weeks, you could say that he lost almost 16% of baseline body weight. BMI came down from 40 to 35. Even HbA1c came down from 5.9 to 4.9. And here at 1 year, at end of 68 weeks, his treatment was stopped. Of course, then obviously he was looking for an immediate knee replacement, which was his primary goal. So that is why he was enrolled in that clinical trial program with oral semaglutide once a week. And treatment with that semaglutide had to be restarted because again there was a significant weight gain for next almost 45 or 50 weeks. So moment he was off drug, this was step 1 extension follow-up. You could see that at 68 weeks his semaglutide was stopped, and moment he was off semaglutide, within next 1 year, 52 weeks, he almost regained what he lost over 1 year. So I think that brings us to a discussion which we'll have later, that do you think that his drug like semaglutide should have been continued till he achieved a BMI of 25, and then maybe he could have gone for a knee surgery, or we should continue only weight management policies without any anti-obesity drugs? So that is, I think, meaningful discussion which we may have towards the end of this panel. I'll stop sharing here and we'll go back to Manoj, and after his case presentation, we will have some discussion. Over to Dr. Ajay and Dr. Sunil.
I feel this is one of the case which every one of us in the clinical practice, since we have started using GLP-1 analog more aggressively, especially addressing the obesity like in this patient, is not uncommon. And this is commonly seen in patient with, they started use it for say 3 months, 6 months, 8 months, a year or so, and then suddenly there becomes some or other reason, not the clinical reason, but usually the cost or the economical issues or something, and they stop it and they regain weight. I feel this is one of the things which we need to learn. We need to advocate for our clinicians that this drug cannot be just stopped, because once you stop it, it's likely that they will regain weight. And it should be a simultaneous process of the traditional medical nutrition therapy, lifestyle modification, along with the drug, which should be continued. Maybe Manoj can have his views, and Ajay can also add on to this.
Very true, sir. Means like Dr. Chawla has said that we have seen some patients who have stopped this drug because of financial reasons, and then the weight goes up. Means apart from the glycemic control, the weight also goes up. As sir said that we will have the discussion after the second case discussion. So I'll hand over the chair to Dr. Manoj Chawla for his second discussion about the cardiac.
I'll have a very brief case and some discussion around that. Okay, so we move ahead by seeing this interactive case-based approach. This individual who comes and complains of chest pain, essentially related to his comorbidities and risk factors, is something which will very often make us think, what more can we offer this individual with diabetes, obesity, and metabolic conditions? How do we manage his or her obesity and obesity-related complications? If you look at our case, patient has pre-diabetes, hypertension, ischemic heart disease, and osteoarthritis. 2 previous attempts at weight loss through diet and exercise, barely achieved 5% reduction, but could never be sustained. Has not previously been interested in discussing other forms of treatment for obesity, be it medication or surgery. Started recently suffering from angina. So 62-year-old male, BMI is 40, currently weighing at 130 kilograms. Ashok, now because of the anginal pain is a bit motivated to lose weight, with again starting some lifestyle intervention, managed 4% weight loss, but is open to discussing further options now. So the question in this interactive case discussion to all would have been, which obesity-related complications do you encounter most commonly in your patients with obesity? Now, the answers could be cardiac disease, the answers could be sleep apnea, answers could be arthritis, and so on. What is important to remember is that there is additive risk for type 2 diabetes in patients with obesity and pre-diabetes. Relative risk for developing type 2 diabetes versus healthy people is much higher. When they look at about 4,300 Finnish men and women in a follow-up study of 9.4 years, they found those with obesity will have about 5 times chance of developing diabetes. Those with pre-diabetes, almost 6.7% times risk to progress to diabetes. And those who have both pre-diabetes and obesity will have almost 17% times higher chance than normal other individuals to progress to diabetes. Also important to understand the prevalence of cardiovascular disease, both in diabetes and pre-diabetes, has been on the rise. So if you look at the NANS data, progressively from 88 onwards to 99s and 2005s and the 2011 one, you see this aspect that in terms of MI and CVA, both have been on the rise in diabetes and in the pre-diabetes population as compared to the earlier decades. What is important for us to know and advocate weight loss, as this can have a huge impact on complications. Let's also understand how much weight loss will have what kind of impact. So if you have 0 to 5% weight loss, it will help in certain extent in better control of blood pressure and even sugars. 5 to 10% may also be useful in preventing progression to type 2 diabetes and impact on NAFLD, polycystic ovaries, and dyslipidemia. 10 to 15%, you start seeing benefits again on NASH, arthritic knees, issues with gastroesophageal reflux disease, OSA, and so on. And more than 15% weight loss may actually help even provide remission in some patients with type 2 diabetes, definitely have a positive impact in reducing cardiovascular mortality, and also help patients with heart failures, especially the preserved ejection fraction ones. We look at the data from the STEP 5 study, which is for the semaglutide data, and as compared to placebo, at the end of 104 weeks, which is 2 years, what did injectable semaglutide show us in the STEP 5 study? You look at waist circumference down by 14.4 centimeters, which is huge. Systolic blood pressure down by 5.7 millimeters of mercury, which is better than some of the antihypertensives themselves. C-reactive protein as a marker of inflammation coming down by 56%, and triglycerides again coming down by 19%. So clearly weight loss, which was seen with semaglutide, has huge benefits in other aspects of the metabolic risk factors or the cardiac risk factors. You look at a specific post of analysis from the Look Ahead study. Now, if you remember, Look Ahead study was essentially trying to see the impact of intensive lifestyle intervention versus diabetes support and education on the cardiovascular risk. And in this study, which later on was stopped for, as they call it, as reasons of futility, they didn't see a huge difference between both these arms in the cardiac risk factors. But a post-hoc analysis tells us that in individuals who had more than 10% weight loss, you actually could see benefits in the MACE reduction, whether it was primary or the secondary outcome of extended 4-point MACE. It's only in that section who had more than 10% weight loss that you could see benefits. Again, the overall study was not looked upon as significant, but this post-hoc analysis gives us some interesting point that maybe a 4 or 5% weight loss may not give us great benefits. You need to look at more than 10% reduction ideally. Now you look at the cardiovascular outcomes for all the GLP-1 receptor agonists that that group of drugs. What do we see again for the MACE events? You see a reduction overall if you look at a meta-analysis of all these studies, but in most of them, you see the MACE going down because of GLP-1 receptor analog use, because of multifactorial pathways, but one of the most important ones there being weight reduction. Finally, let me appraise everyone listening in today that we have an interesting ongoing study called the SELECT study, which is a cardiovascular outcome trial in patients who are overweight or obese and having presence of cardiovascular disease. The primary objective is to demonstrate that injectable semaglutide 2.4 milligram, which is the one which is used for overweight and obesity, and I believe we should be having it in India in another 6 to 8 months as well, whether this drug lowers the incidence of MACE versus placebo and added to standard of care in patients with established cardiovascular disease and overweight or obese. As we can see here, diabetics are not included. It's up to 6.5%. Patients with pre-diabetes may be entered. 17,500 patients. The study started in 2018, is ongoing. We expect the study to get over by August, September next year. Again, event-driven studies may go longer, and my understanding is that all event-driven studies are going to go longer by 6 months at least because of the COVID pandemic, where a lot of events which may have been cardiovascular events were actually labeled as COVID-related deaths, and hence these events have not been accounted for in the studies will continue longer. That's an interesting study which will tell us more about injectable semaglutide and its benefits. So with that, let me end this case here reminding that today when your patients start complaining, whether it is for heart failure besides the other treatment that you're offering or angina, you have to start thinking about the weight benefit, including patients with severe osteoarthritis. It's going to be no good considering going in for a knee replacement if you're not going to be offering them weight loss aspects along with that. With that, I hand it back to the chairpersons, and again would like to thank both the chairpersons and the senior Chawla brother for inviting me here to speak.
We have just we can discuss 2 questions only as we are running late.
So, do we have any?
I thought we explained everything beautifully well.
Yes, sir. Yes, sir.
Is there need for questions?
That was enough, sir. And we had wonderful case discussion as well. So it was very well explained. Thank you.
Like we talked about semaglutide 2.4 once weekly, sir. It is about to come maybe in the next September or October, as far as my knowledge is concerned. So do you think that this will impart a breakthrough in the obesity treatment vis-a-vis people who are not diabetic? It's like we have many type 1 patients also who have been 34, 35 years of age and now means they are above 90 years of age. So will this impart a breakthrough for these type of patients where we are
So I think everyone, honestly, Dr. Gupta, everyone who is obese and looking at medical treatment there, these GLPs and we know later even the twin cretins, all of them offer great hope. The semaglutide injectable is doing extremely well if you look at in the Western population, and I would say far better than the oral semaglutide there. And Wegovy, which is a 2.4 milligram approved purely for management of obesity, is going to do great, just as the other group of drugs, including tirzepatide. So the entire incretin story is going to be seeming extremely exciting moving ahead. And interestingly, you brought about an obese individual with type 1. Why not? As long as you're not stopping their insulin for management of type 1 and offering other therapies for other benefits, I think that should also be an indication there.
Yeah, I feel we have to have, Manoj, some trials on these lines when we talk about using GLP-1 analog in double diabetes. That's been called a double diabetes. You have a features of type 2 diabetes in patient with type 1 diabetes. And I don't see any data on these lines. If Manoj has or Rajiv has this, then will be helpful to us. But at this moment of time, we have to have data on these lines.
I think there is some trials and data from, again, Dr. who's our gentleman from Buffalo, Dr. Paresh Dandona's work.
Devjit also. Devjit is talking in another session on dual incretins. I think he also has some work on that. Of course, mainly on triptizide, but Dr. Dandona has been working on that. Yes. His team, entire team.
But I agree with the caution that Dr. Gupta is bringing about that. I mean, this may be an indication ahead, but of course, we need to be cautious with every other therapy in type 1 so that it's never misunderstood. So.
True, with the data with Wegovy that we have, that 15% weight loss is being seen as compared to the placebo, which has got only 2.5%. So we look forward for this breakthrough in the obesity. And Dr. Sunil, if you have any closing comments, then we can just close the session, sir.
I feel we are still in our country underutilizing GLP-1 analog despite their availability across the continent. But I feel we have to be more awareness on these lines. We are actually depriving our needy patients from this wonderful drug. That's the final message. Every one of us have to open our eyes and see to it that obesity is certainly a concern, though it's not being yet labeled as disease by majority of the organization, but every one of us recommend that it should be labeled as a disease, and it should be such drugs should be utilized, maybe along with the SGLT2 inhibitors and other lifestyle modification, all that. Yeah, if they have diabetes, but even in non-diabetics, though we don't have the recommendation of oral semaglutide for obesity at this moment of time, but injectable, yes, it has been already approved in US and it should be coming next year. But I feel by that time we should have the experience of this, but oral SEMA, we should give it judiciously to maximum people who deserve to go for it.
I think we'll have to conclude here. We are up by 4 minutes, and Dr. Rastogi and Kobil, they are already waiting, and Saurabh is already joined for chairperson. Thanks a lot, Dr. Sunil, Dr. Ajay, for wonderful moderation. And as always, Manoj, you were wonderful. Thank you very much.
Thank you, sir. Thank you for having me.
Over to Rutul. Over to Rutul.
Bye.
Thank you.
Thank you, sir. It was really a wonderful workshop on obesity. And now we are moving forward to Analog Insulin Symposium. And for that, we have chairpersons Dr. Vijay Arora and Dr. Saurabh Srivastav from Noida. So, Dr. Vijay Arora is MD Medicine and FIACM Senior Director and Head Department of Internal Medicine, Max Healthcare. Dr. Saurabh Srivastav, very well-known figure in the field of diabetes and internal medicine. He is Head Department of Medicine and Chief Medical Superintendent, Government Institute of Medical Science,
Senior endocrinologist from Chandigarh, and he's going to tell us more about the newer analog basal insulins and what we are going to achieve by using the second generation basal insulins, and what we could not achieve with the first generation basal insulin as far as achieving of HbA1c or concern, or achieving the target in range. And we'll request Dr. Anshu Rastogi to his talk on achieving glycemic symmetry with the newer basal insulin analogs.
Can I share my slides?
Yes, sir.
I hope my slides are visible and I am audible.
Yes, sir.
That's great. That's great. Thank you. Thank you, chairpersons. And at the onset, I'll like to thank Dr. Chawla for inviting me to this interesting international symposium on diabetes. And today I will be talking about something to make more symmetrical. And especially about symmetry means the symmetry about the blood glucose control whenever we see our patient of diabetes. And we know that with all the guidelines, maybe the EDA guidelines or the ESG guidelines, everybody talks about the insulin, and especially the basal insulin, which is the add-on after metformin. So you can have so many things. Now there is so much buzz about SGLT2 inhibitors, GLP-1 RAs, which we have heard of, but still basal insulin still remain the bread and butter of the glycemic control. But there is a lot of heterogeneity in the basal insulin, and that I'll be covering in my presentation. So I'll be just telling you there were so many unmet needs with whatever insulin that we were using earlier, especially the basal insulin, because we have seen even in our clinical practice, there are a lot of patients who have hypoglycemias, and it's actually not truly once daily. So it has kind of a peaking effect, and then which is associated with nighttime hypoglycemia. And there is significant variability in this insulin because of, again, it's not actually peakless kind of insulin. So it has a peak layer which is responsible for its variability, and therefore most of the time these insulins are to be prescribed at a fixed time in a day. But with this lifestyle, what we are having presently, can we have more flexibility in this regimen of insulin to our patients? And whenever we talk about insulin, the very important factor which comes is the hypoglycemias. So high nocturnal hypoglycemias, which we have all seen with the basal insulin once we inject it at maybe the bedtime. This is a real concern in quite a significant number of patients. So these are a few unmet needs, and if we can probably tide over this all these challenges with something new basal insulin, then it will be a good thing. So now we have been using now degludec for quite a couple of years or even more than that. So we should be knowing actually what exactly is insulin degludec. So I'll be talking about this the unique action and mode of protraction of the insulin, which is responsible for its quite longer action as compared to the pre-existing basal insulin. And more important is the predictability. So once we inject the insulin, we know that how much hours it is going to work. How does it actually does it? So what happens is whenever we inject this degludec, it is in dihexamer formation in the pen that we use it, and it is with phenol. So once it is injected, what happens is this rapid phenol depletion after the injection is given, it leads to formation of long chains, and all these chains are form of a lot of hexamers. So this multiple hexamer chain formation is there, and the zinc diffuses slowly, which cause only the slowly this hexamers are released from this long chain, which deassemble, and then it leads to formation of first dimers and then monomers. And we know that it is the monomeric form of the insulin which is responsible for binding to the insulin receptors and having its action. So this is again same with regular insulin. It is again a monomeric insulin, but with this degludec, we have made it more protracted, more slow release. And this is because of the presence of phenol, presence of zinc, and some modification in the insulin molecule per se. Therefore, it is slowly released and has long duration of action. If I compare degludec with the pre-existing basal insulin, which is the standard, that is glargine U100 insulin, we see that the onset of action is almost around half hour to 1 hour earlier as compared to glargine U100. We see with glargine U100 is 2 to 4 hours, but with degludec, it is around 0.5 to 1.5 hours. Interestingly, it's said that both of them have almost peak kind of thing. But what is more important is that degludec, again, because of its dihexamer and multi-hexamer chain formation, it has a very long duration of action of more than 42 hours as compared to glargine U100, which has action of 20 to 24 hours. So degludec has a faster onset of action and prolonged duration of action as compared to glargine U100. There have been many studies where they have compared this insulin degludec with the glargine 100 also and glargine 300 also. Now, this is a comparison in the BRIGHT study where they have compared the insulin degludec with glargine 300. And they found out that there was a better fasting plasma glucose control with degludec as compared to U300 insulin. And there was a difference of around 7 milligram per deciliter, and which was found to have a significant difference. So we can have a better fasting glucose control with degludec. Moreover, degludec also provide a greater reduction in A1C as compared to even U300 insulin. And most of these patients were followed followed for a period of 6 months. So there was around 1.5% further reduction in the HbA1c with degludec as compared to glargine U300. And this expected treatment difference was 0.3, and it was quite significant. You can see from this P. So this confidence interval ranges from 0.51 to 0.03, and it was quite significant, suggesting that degludec was more effective as compared to glargine U300, both for fasting as well as HbA1c reduction. Now, saying that it is more effective in reducing fasting as well as HbA1c, and what I showed in the first slide is that these basal insulins are associated with more variability in day-to-day as well as within day. So this is the study where they compared degludec, which is published just around 3-4 years back in Journal of Diabetes, where they compared degludec with glargine U100. And now you can see this is a beautiful study where they just plotted the area under curve of the glucose infusion rate. And what they found out, when degludec was injected in a dose of 0.4 unit per kg, and glargine was also injected in the individuals with 0.4 unit per kg, the GIR was almost constant. You can see the injection was given here and the patient was followed from first 6 hours, the next 6 hours, then 12 to 18 and 18 to 24. So over a period of 24 hours, it is such a smooth glucose infusion rate that is required to maintain a persistent or a level of glucose that they have sought or plotted. As compared to, you can see, this glucose infusion rate is quite variable and it is decreasing in with this glargine U100. Suggesting probably this degludec is associated with better around the clock coverage as compared to glargine U100. And this is again another study. This is a little bit old study, but also you can see these blue bars are with insulin degludec and green bars with glargine U100. Again, this is the coefficient of variation or the day-to-day variability in the glucose levels, and this area under curve with glucose infusion rate. Again, you can beautifully see that this GIR was almost constant for a whole day, and they have just plotted every 2 hours as compared to insulin glargine U100. The glucose infusion rate initially peaked and then decreased. So a lot of variability is there in the action of the insulin, and that sometimes might be deleterious for the patient. And we know that this glucose variability is been plotted for and has been implicated for the macrovascular complications in patients with diabetes. Regarding the glucose variability, again related to the TBR, that is the time below range. So this is a study that mainly studied about the hypoglycemia level, whether it is nocturnal level 2, level 1, or level 1+2. And we can see that in these patients who were injected with insulin degludec, what they found out is overall there was around 20 minutes per day less time which was spent in the hypoglycemia as compared to insulin glargine U100. And that is a significant amount, because we know that even a single minute in hypoglycemia would have a significant implications and also contribute to marked increase in the glycemic variability. So this is a positive point with insulin degludec as compared to glargine U100. This slide shows target in range, which was better with degludec U100, you can see, and this was around quite significant, around 3% difference between the two groups. Same, the A1C was better controlled, and there was around 0.9% reduction with degludec as compared to glargine U300. Again, it was found to be significant, and time above range was less, and the difference was around 3%. So time above range is also less. So overall, if I calculate this percentage into the minutes spent in 24 hours, you would see that time in range was 44 minutes more with insulin degludec as compared to insulin U300, and the time above range was 44 minutes less with degludec compared to glargine 300 with a lower HbA1c. That is a significant advantage. This is again a CGMS chart that shows the significant lower glycemic variability with degludec. So intervention, this was the chart. You can see there was peaks in the insulin. There was again a peak that was present in these patients, peak glucose. And once the insulin degludec was injected, there was most of the time it was kind of a peakless kind of glucose, and it was almost in the range. So overall, the coefficient of variation was significantly reduced by injecting degludec, and the glycemic variability was also reduced. So most of the time when we treat our patients, we sometimes are so much engaged in only the fasting PP and the HbA1c, but we forget to take account into the glycemic variability, and that can be challenged by changing or switching our patients from the conventional basal insulin to degludec. Now moving on to the another part of my presentation that is pertinent, because hypoglycemia is a real risk, whether it may be any insulins, even the basal and the basal insulin analogs also, they are associated with hypoglycemia. But we need to compare as compared to the glargine U100. And we have evidences from large phase 3A studies, phase 3B studied, even the CVOT trial, which have also studied the hypoglycemia, because that was always one of the secondary endpoint of these trials. In the BEGIN trial, they found out that almost 49% reduction in the incidences of nocturnal hypoglycemia and 86% reduction in severe hypoglycemia was seen as compared to glargine U100. Same was seen in SWITCH 2, which was a phase 3B study, where they found around 46% reduction in the severe hypoglycemia episodes. And DEVOTE, we all know that it was a CVOT trial with this insulin degludec, where they compared with the glargine U100. And again, there was around 53% reduction in the nocturnal hypoglycemia in these trials. So there is significant evidence that if the patient is on this degludec insulins, the chances of hypoglycemia is less. If I just put this statistics into a different way, is the number need to treat, and that is important. So to avoid one hypoglycemia, you will need to treat just one patient for 1 year for overall hypoglycemia, and 21 patients for 1 year to avoid severe hypoglycemia. And that was if we see in type 1 diabetes patient, you need to treat one patient for 4 months to avoid oral hypoglycemia, and 3 patients for 1 year. And that is a significant number. That is a good number. And number need to treat is much less as compared to the other insulins. So I put it in another way now, that is the amount of hypoglycemia that a patient would experience per A1C reduction. So you can see on the x-axis is the HbA1c reduction in percentage points, And on the y-axis is the increase in symptomatic hypoglycemia. We know that whenever we treat our patient aggressively, whenever our aim is to achieve the A1C of around 7%, yes, the patient is bound and patient is going to have hypoglycemia. But with which insulin you can have lesser incidence of hypoglycemia, that is very pertinent. So once the patient has more HbA1c reduction, the hypoglycemia is increasing. But what is the difference is this blue line is with degludec and this greenish line is with glargine U100. So there was overall around 22% increase incidence of hypoglycemia with around 0.7% reduction in HbA1c with glargine U100 as compared to insulin degludec. So this is, again, we can very safely counsel our patients that when we are achieving our targets, probably insulin degludec might be a safer insulin as compared to insulin U100. This is in the maintenance period and the total treatment period in this study that is recently published in Diabetologia. So overall, either it may be the overall symptomatic hypoglycemias, which was less, you can see around 21% reduced risk of overall symptomatic hypoglycemia, 35% reduction in the nocturnal symptomatic hypoglycemia. And what is more important is the severe hypoglycemia, which we all endocrinologists and physicians fear, which required hospitalization also, was significantly reduced by around 81% by using degludec in this conclude study. So this is an important outcome measure in this. So change in the rate of hypoglycemia demonstrates overall a 30% lower rate of hypoglycemia with degludec versus U300. And there was significantly lower incidence of more than one episode of hypoglycemia with the odds of 0.64, which was found to be significant in favor of degludec. Once we are using this insulins, and we know that now degludec is associated with lower incidence of hypoglycemia, and the significant concern is the weight gain. And probably we believe that larger is the dose of the insulin, more is the weight gain. So to achieve a particular HbA1c, what is the difference in the dose with the degludec as compared to glargine 300? And this is detailed from this BRIGHT study, where they beautifully plotted the insulin dose, and then the patient was followed up to the week 24, 6 months, and they found out that there was 23% lower dose required to achieve a fixed HbA1c reduction as compared to glargine U300. And that will save to the cost. It will also reduce the episodes of hypoglycemia and also reduce the weight gain. So lower dose means lesser SMBG monitoring also is required. So in this study, they found out there was 10% lower dose with degludec versus in glargine U100, and overall 23% lower dose with degludec versus the glargine U300. So in this beautiful study, which was published in Diabetes Care, they found out that almost 2 strips less were required per week with degludec. And we know that strips really cost to a patient, especially to a patient of type 1 diabetes, where it adds to the treatment of diabetes. Moreover, once we are seeing less of hypoglycemias and lesser dose, which will also decrease the cost of the treatment, probably that might be some of the reasons that contributed to better adherence in patients with degludec. So the likelihood of discontinuation of insulin once we put our patients on degludec is less as compared to glargine 300, and that was 27% less. And I believe that this might also, in addition to this reduced dose and the cost, it might also be because of the reduced incidence of hypoglycemias in these patients, which contribute to better adherence. And another factor for better adherence might be the flexibility of dosing that I'll be detailing. So if you look about flexibility, for basal insulin, especially the conventional basal insulin, we ask our patient to inject at a particular fixed time of the day. If you look at our prescriptions, we write just insulin basal glargine at 10 p.m. or just before bedtime. So usually the time is fixed, but sometimes, or I would say most of the time, many of the patients have such a busy schedule, and it might be very difficult to take insulin at a particular time. So we need more flexibility, and more flexibility you could achieve with the insulin which have a longer duration of action, like degludec. So there is a lot of flexibility with insulin degludec. You can inject this insulin from a wide window period of 8 to 40 hours. So if a patient has forgotten at 24 hours, suppose he's injecting at 9 p.m. and he forgets to take because he is probably going to some marriage function or he's busy somewhere, so he might take even in the next morning also, that would roughly around 36 hours before the first dose or the prior dose, that will not lead to significant hypoglycemia or hyperglycemia, because it's a prolonged and protracted action as compared to glargine 300, which has to be administered within plus minus 3 hours. So we have a better flexibility with degludec also. And there's the last slide which talks about the the data, and that was related to major adverse CV events. And this is again because we talk so much about the CVOT trials with SGLT2 inhibitors, GLP-1Rs and GPP4s. So why not with insulin? Because they are also known and they are given in patients with diabetes. And this study showed that overall the incidence of the CV or the MACE events was neutral or found to be non-inferior. So if we talk about the very high, those patients who had a very high risk of the MACE events, the incidence was significantly less. You can see the confidence interval was 0.76 and CI of 0.58 to 0.9. So degludec overall had a significant lower risk of MACE versus insulin glargine U100 in patients who are at very high risk of severe hypoglycemia. So I would conclude by saying that insulin degludec is a newer insulin, though we have now experience of around 3 to 4 years with insulin degludec. It is kind of a faster onset of action within just half an hour to 1.5 hours as compared to 2 to 4 hours with the conventional basal insulin, and more protracted action that is responsible for more flexibility and also responsible for very less day-to-day variability, as also been demonstrated by many of these pharmacokinetic and pharmacodynamic studies regarding hypoglycemias, whether it may be the nocturnal hypoglycemias, the oral hypoglycemia, symptomatic, as well as severe hypoglycemia. It is significantly less with the insulin degludec compared to glargine. And flexibility, I always say to our patients that just don't put a burden on your mind that you have to inject insulin every time on the fixed time of the day. So probably this insulin is better regarding the flexibility. So thank you. Thanks for patient listening, and back to our chairpersons.
It was an excellent talk by Dr. Ashu. And what I think we can take questions in the end, Dr. Ratul.
Yes, Dr. Saurabh. Yes.
So we have another talk, which is a very good talk, a 2-in-1 solution for insulin initiation, a growing wall of real-world evidence from India. And it will be taken up by none other than Dr. Rajiv Koval. He needs no introduction. He is a famous diabetologist from Mumbai. Over to Dr. Rajiv Koval.
Thank you so much, Saurabh. Thank you, Dr. Rajiv Chawla and Dr. Shalini Jaggi for having me here. I'm just going to take it forward from where Ashu has left off, and we are going to look at the new, I wouldn't call it new because it's been there for the last 6 years, and whether this actually solves the problem that we have been facing in India. So the growing wall of real-world evidence, especially from India, for the co-formulation, which is IDECAS. I've been contracted by Novo Nordisk for this talk. This is my agenda. So we all know the importance of HbA1c. I don't need to stress it on this learned audience. But what is important to know that HbA1c reduction is infinite as far as insulin goes. And insulin used in the right dosages can get most of our patients under control. We are eating a very high carbohydrate meal, which is very evident from the starch study, which came in almost a decade back, and the pure study of Dr. Mohan, which came in recently. Sorry. So high PPG and fasting plasma glucose contributes to higher HbA1c. If you look at these Indian data, it clearly suggests that that high fasting and PP continues to be the driver for higher HbA1c. And we need to initiate insulin very, very early, and probably we accumulate an HbA1c about 8% for a long period of time before we can initiate insulin, as you can see in these real-world studies from India. Importantly, also data from Monnier as well as Wang has suggested that the relative contribution of fasting and PP to HbA1c, especially in Asian Indians, at all HbA1cs, whether it's closer to goal or higher
the PPG continues to be 50% or more as compared to Caucasian. And that is very evident in this particular study published around 4 years back. The glycemic responses in Asian and non-Asian people when they initiate a basal insulin is different. Almost 50% of non-Asians come under control with a fasting blood sugar reduction that basal insulin can cause, but only 39% come as far as Asian goes, thus suggesting that the postprandial does contribute a much higher contribution to HbA1c. Now, the key realities are that we need an insulin which is made for India, which has flexibility. We all want flexibility, has direct control on PPG, and is suitable for a high carbohydrate eating population. And basal insulins cannot address these challenges. So we need an insulin which is actually made for India. That is why the IDECAS co-formulation, I call it, and that it's an innovation that actually suits Indian reality.
This combination is derived with specially designed co-formulation. Insulin Degludec as not. Insulin Degludec is the first base of insulin that can be combined in a soluble solution with mealtime insulin, such that both insulin molecules remain structurally separate.
So the insulin Degludec as well as insulin aspart remains separate, whether it is in the subcutaneous tissue or in the solution or in the formulation in the pen. And as Dr. Ashu Rastogi spoke about, that this multi-hexamer formation seems to be the most important protraction mechanism. And once it's injected, the zinc and phenol diffuses out, and the biologically active monomers of insulin aspart and insulin Degludec slowly come into the circulation. And that is the whole protraction mechanism which prevents the glycemic variability with this particular insulin co-formulation. So as the video suggests, that it has a very distinct prandial as well as a basal element, which is very separate on chromatographic studies. And there's a sharp separation of these peaks, thus making sure that they do not overlap with each other. And the shoulder effect that we see with premixed insulin analog is not seen with this particular preparation as such. If you see data which we are going on to the studies, which are the phase 3 and 3B studies, which are the boost group of studies for the co-formulation IDECAS. Dr. Ashu showed us about the PKPD data from Tim Highs, where there was a lesser intraday and interday variability and a 4 times lesser interday variability with insulin Degludec as compared to U100 glargine. And what we see in the laboratories in the PKPD, if we see in phase 3 studies as well as in real world studies, then it actually improves the confidence of all prescribers. And this particular Asian study on naive patients from Asia, especially from Japan, were put on IDECAS and insulin glargine for reduction of HbA1c. One would say that this is comparing apples to oranges, but let's see. When you compare two active comparators and both cohorts or both arms are titrated to similar fasting plasma glucose, then surrogate endpoints become important because HbA1c continues to remain the same. So surrogate endpoints of dose of insulin, hypoglycemia, nocturnal as well as severe, all these become important. Important to see that in this particular study, there was a 1.4% reduction, but there was a 0.3% better reduction with IDECAS as compared to insulin glargine U100. Now, one would say that this you can have because you have a shorter acting element in IDECAS. But if you see, majority of IDECAS was at dinner time, and you had a better post-dinner control and a lesser nocturnal hypoglycemia and confirmed hypoglycemia with IDECAS as compared to basal insulin. So in spite of having a shorter acting insulin, which increases the chances of hypoglycemia, in this treat to target study treating IDECAS versus U100 insulin glargine in insulin naive patients in Asian, we saw that you had a better, superior HbA1c difference. You had a much lower risk of hypoglycemia, both nocturnal and severe. And you had more patients reaching, almost 72% reaching their target of HbA1c less than 7%. So what we saw in the PKPD and the laboratories, we are able to see also in the phase 3A, 3B studies. Again, if you look at time in range from this particular study, we see that there's a better time in range with IDEC as compared to glargine. That's the reason that many associations across the globe and the RSSDA also recommends IDEC co-formulation as a choice for insulin initiation. It also tells us that there has to be a narrative when we speak to patients, avoid insulin as a threat, alleviate patients' anxiety. Insulin therapy should be considered in all patients failing to achieve glycemic control on 3 orals. Again, let us look at a real-world evidence. We saw from Dr. Ashu, he spoke about the PKPD, then he spoke about the BRIGHT study, then he also spoke about the in-target study, and here we spoke about Onishi's data, and we look at a real-world evidence coming from India. This is a 1-year non-interventional study, multi-centric prospective non-interventional study of the insulin co-formulation in patients with type 2 diabetes, and was published almost a year back with Dr. Jyoti Dev as the principal author. As you can see, more than 1,000 patients, multicentric progressive single arm. That could be a sort of criticism that you did not have another arm to compare. Observational PMS, men and women with diabetes aged more than 18 years. You had to collect data and safety as well as efficacy data at 3, 6, 12 months, and also assess for HbA1c fasting PP at 3, 6, and 12 months. 40 sites, 52 weeks duration, a very good completion rate. 55 was the mean age. Duration of diabetes was 10 years. HbA1c in poor control. So as we have seen in majority of Indian studies, that our average HbA1c hovers around 9%. So this we can extrapolate to many of our patients, garden variety, who come to our clinic. Also, 25% of the patients were already on some other insulin. 75% were on OADs. A slightly gender dominance of males in this particular study. Reasons for starting the co-formulation, majority was to improve HbA1c, some were to improve fasting and PP, some to reduce the risk of hypoglycemia, and also for improving the flexibility of dosing. If you look at the change in prescription based on proportion of patients taking OADs, you can see there's a reduction in SU and metformin and alpha-glucosidase, reduction in TZDs, and an improvement in SGLT2 use and similar GLP-1 use. So secretagogues have slightly gone down, sensitizers have gone down, SGLT2s have gone up. If you look at the change in HbA1c from baseline, whether it's insulin treated or OAD treated, you have a fantastic 1.8% reduction of the 27% patients who were treated with insulin, and 1.7% of patients who were treated with an OAD at a baseline of 9.3, thus getting majority of our patients very closer to goal. If you look at fasting plasma glucose and PP, a very decent reduction in both fasting plasma and PP glucose with the IDEC co-formulation. This is interesting because we saw this in PKPD studies. We have seen this in other phase 3A, 3B data. But again, from Indian settings, the confirmation of a reduction in hypoglycemia with the co-formulation, which we would expect based on the PKPD study, is very reassuring. So if you look at the events of confirmed hypoglycemia 4 weeks before starting IDEC app, there is a significant reduction in confirmed hypoglycemia. If you look at severe hypoglycemia, both in patients with OAD and insulin, again, there is a significant and nil severe hypoglycemia once we have introduced IDEC on these patients, thus strengthening our confidence on using this co-formulation. So the SMART study summary was an effective HbA1c, fasting PP, and an improved safety in terms of low risk of hypoglycemia. What we saw in the Boost 3A, 3B studies, we again confirmed it with a real world evidence like the SMART study. IDECAS is a very simple and convenient. There's a lot of mealtime and meal related dosing because that they are done in the phase 3A study with the begin group of studies for degludec, where you can have an 8 to 40 hour dosing difference between the two insulin. Again, with the IDECAS, you could have a 4 hour, minimum 4 hours, because the aspart should not come together. Again, you have total control because the power of two insulins in one, which both work separately and do not mix with each other, makes it a very simple and convenient use. These titration algorithm can change based on patient to patient, so I'm not going into deep for this. Again, very insulin-friendly devices, which is important. So if you have a superior insulin, it cannot be in a mediocre device. Both the FlexTouch and the NovoPen 4 are very, very superior devices itself. So it can be used with patients with any kind of deformity, and thus making it accessible to majority of the population in India. In summary, it's an insulin which is made for India, suitable with for our high carb diet, gives us a total control of not just fasting BP but HbA1c. Again, it can be used in patients who are on other insulins and are not doing well. Offers a lot of simplicity and convenience, and most importantly, safety when you have a very, very good efficacy. Thank you all for a patient here.
Thank you, Dr. Kovil, for a wonderful lecture.
Thank
now
you.
We'll have a discussion for another 6 minutes. And the first question to both the speakers is, when should I follow Dr. Anshu and when should I follow Dr. Kovil? If a patient comes to me for a HbA1c of 8, what should I start? I should start with Ryzodec or should I start with the insulin degludec?
Dr. Rajiv, may I take it?
Yeah, please.
Yeah. So now, if you look at Monia data, as we were talking about earlier also, so roughly at around 8% A1C, as you are mentioning. So you have almost an equal contribution by fasting and PP with a tilt towards more of fasting. So I would believe that initially, and we know that treat fasting first, it has been long been taught in our the PG days also. So I believe that if you have a fasting which is controlled by maybe around 20, you can bring whole of the other blood glucose down, especially the postprandial component also down. But yes, saying that, I would be more interested in now with the current era of using all these CGMS things and these AGM also, I would be more interested in just knowing about what exactly is his routine, his eating patterns, and also is the fasting and postprandial component. So if I believe that if it's fasting is definitely way beyond the ADA and the PP is also beyond the ADA control, what is being mentioned, so I might add a Ryzodec, but I will be more biased towards first treating the fasting first.
So if the patient is belonging to Jain Dharma and he does not eat after 7 p.m., then what should be our the challenge? We should follow you or Dr. Kovil?
No, I couldn't hear the question, Dr. Could you be slightly louder?
So if a patient does not eat after 7 p.m., and what should be our
So Dr. I am a co-formulation person right from day one. And I speak based on my patient experience and published data. And we just published recently, 6 months back, data of primary failure of Ryzodec, which is IDECAS, versus insulin glargine, versus all basal insulins. And we showed that primary failure is almost 8 to 10 months delay is there when we use IDECAS. So for me, IDECAS is with the highest or the largest meal of the day. So it doesn't matter if the patient doesn't have dinner, it could be used as the largest meal of the day. And if you look at the Onishi data also, you can see that in spite of a better post-dinner control, the nocturnal hypoglycemia was lower with IDEC as compared to U100 glargine, thus telling us that degludec is a far superior insulin than glargine is in terms of its effectiveness and in terms of its predictiveness in action. And so I have no second thoughts on using IDEC whether the patient skips any meal also. He'll take one meal per day surely.
Any difference in weight gain by using degludec alone or by using rhizodec?
So again, Ashu, if I could answer that, in clinical practice, not seen, sir. Not seen. Whether with basal insulin, unless if the patient comes to you with an HbA1c of 12, 13, just the reduction in glycosuria would make the patient gain weight. Other than that, not much of weight. But again, basal bolus insulin, all those things can cause fluid retention. That is, it's seen with every particular insulin.
Wonderful. So can we wrap up the session now as we are running late? Yeah.
I think things have been taken care of well. So we can wrap up the session.
Great.
So,
thank you, Chawla, sir. Thank you.
Thank you. Thank you, Dr. Saurabh, Dr. Rutul. Thanks a lot, Rajiv and the previous speakers.
Yeah. So we are moving forward to the next symposium, that is back to basics. And for that, we have chairpersons, Dr. Ashu Rastogi and Dr. Krishna Sesadri. Dr. Ashu Rastogi has been already introduced in last talk, and Dr. Krishna Sesadri, he is American board certified endocrinologist and diabetologist and metabolism and internal medicine. He is consultant at Chennai Diabetes and Endocrine Clinic. And over to you, both the doctors.
Yeah, Krishna sir, please.
Dr. Ashu, you may start.
Okay.
Or Dr. Krishna.
Sir, unmute yourself. Krishna sir.
Yeah, Krishna sir.
Hi, Dr. Ashu Rastogi. Wonderful seeing you.
Hi, Krishna sir.
Very nice. It's great to be with all of you. And it's a very wonderful symposium that Dr. Chawla has put together. 3 talks, one on the pituitary and pancreas, second on class.
We cannot hear you, Krishna sir.
Rajiv, you can't hear me?
Yeah, we can hear you now.
Yeah, now audible. So
now.
Okay, so we have 3 world-class speakers and 3 wonderful topics. The first is exploring the link between the pituitary and pancreas. Can we have these?
Dr. Krishna, sorry, there is a little, I think you got the old program that has moved to the next session. Instead of that, we have the first session by Dr. Asta.
I'm going to ask Ashu to introduce that.
Yeah. So you may introduce her. She's
Sir, I think also I have the old one.
How come you people have old one?
But let's not delay the thing. So I think that we should invite Dr. Astha, and she is MD in dermatology and venerology in working in Bikaner. So Dr. Astha, the stage is yours, please.
You swapped Atul Kallan with Dr. Astha Chawla.
Yeah, just trying to share my screen here.
Share your screen, bete.
Somehow I'm unable to share the screen.
You have that green button, share screen.
Yeah, that's
at the
active.
bottom.
Yeah, I'm
Click
able to
that.
share. Yeah, it's working.
Yeah.
We also have
Hi,
Dr.
good
Hema
afternoon,
Devakar,
everyone.
who's just joined in.
Dr. Astha, we can see your slides.
Yeah.
Please, you can move.
Hi, good afternoon, everyone. I'm Dr. Astha Chawla Trehan, and I'll be discussing about the dermatological manifestations of diabetes mellitus. Now, can integument actually be a curtain raiser for diabetes? Is it actually a myth, or are we just megalomaniacs thinking that it can be a curtain raiser? Let's find out. So the manifestation of skin findings in diabetics in different studies has found out to be 30 to 70%. And the prevalence is similar in type 1 and type 2 diabetics. Although the cutaneous infections are more common in type 2, autoimmune related lesions have been seen more commonly in type 1 diabetics. And a good metabolic control not only prevents them, but also helps to cure some of these manifestations. Now, these skin findings can actually be classified into 4 major classifications. The first one being cutaneous manifestations of diabetes. Second one being cutaneous concurrences of diabetes. Third, diabetes associated with dermatological pathologies. And diabetic therapy causing cutaneous complications. Now, let's start the discussion about the cutaneous manifestations. The first one, which is acanthosis nigricans. Now, I'm sure everyone here would have come across acanthosis nigricans in their clinical practice. It basically presents as a velvety, hyperpigmented patch to plaque-like lesion, which is present on the nape of the neck and the folds like axilla. One point that I would like to make here is for the physicians, once they notice that a patient presents with acanthosis nigricans, to also please notice for similar changes on the face, because facial acanthosis nigricans has been an identity which has been well proven and does not respond to standard depigmenting treatment. A good metabolic control with lifestyle modification, a few keratolytics and depigmenting agents is the prime treatment for this condition. Acquired perforating collagenoses. Now, these are basically perifollicular. If you notice my cursor, these are perifollicular reddish papulonodular lesions which have a central keratin plug. These are commonly noted in elderly diabetics who also have an underlying diabetic nephropathy or are undergoing treatment for renal failure. Treatment here would be treatment of the underlying renal failure, and for the cutaneous manifestations, we can give topical retinoids and topical corticosteroids. Diabetic bullae. Now, these are basically sterile, non-inflammatory bullae which present on the normal surrounding skin, and the contents are absolutely sterile. Drainage under aseptic conditions with topical antibiotics would suffice for the treatment of these bullae. Diabetic dermopathy. A special point of note here that these are one of the most common manifestations that we come across in diabetic patients, and these are usually absolutely benign and harmless. These are also called as shin spots or the pigmented pretibial patches. Very rarely can they be infected secondarily by bacterial infection, which then requires treatment. Diabetic foot. Now, I'm sure everyone would have come across this as well in their practice. Now, this usually starts as a callus on the pressure points of the feet and progresses to form an ulcer, with the underlying pathophysiology being a diabetic neuropathy resulting from a microangiopathy. A wound debridement along with pressure relieving prosthesis would be an ideal treatment. However, prevention of diabetic foot would include a regular diabetic foot checkup with foot Doppler and treatment of any minor callus that the patient might present with. Eruptive xanthomas. These are reddish to yellowish, tender and pruritic. So they are not asymptomatic. These are tender and pruritic papulonodular lesion which usually presents over the extensor surfaces, and treatment of these not only require a good metabolic control in terms of a controlled sugar level, but also needs treatment for hypertriglyceridemia. Necrobiosis lipoidica diabeticorum, also called as NLD. Now, they typically present as bilateral, symmetrical, yellowish to brown plaques, although it appears red here because the patient is of a Caucasian skin type. So they usually present as bilateral pigmented plaques, and they tend to crust usually on the pretibial areas and can also ulcerate and be secondarily infected. Sclerodema diabeticorum, or also called as diabetic sclerodema. This usually presents as a symmetrical, diffuse, however, asymptomatic non-pitting edema, most commonly presenting over the neck, the shoulder, and the interscapular region. It can also present over the hands, where it can lead to restriction of mobility. Most of the cases have been reported post a streptolytic infection, and Usually it is self-resolving, and in addition, a good sugar control also helps in an earlier resolvement of this condition. Now, these were the cutaneous manifestations. Let's jump on to the cutaneous concurrences. The first one being acrocodons or skin tags. Now, these are basically benign cutaneous overgrowths. One important point to note is they usually present over a background of acanthosis nigricans. If they are presenting without, then you should also think about verruca vulgaris, or also called as the common warts, as one of the differentials. These by themselves are absolutely benign and do not warrant treatment until and unless patient feels cosmetically disfigured from them. Finger pebbles. This is basically diabetic thickening which occurs over the skin over the dorsum of the hand, predominantly affecting the periungual and the area over the knuckles, also called as the Huntley's papules. Pigmented purpuric dermatosis. Now, these very importantly need to be differentiated from vasculitic lesions. Most of the vasculitic lesions would be blanchable. However, these pigmented purpuric dermatosis, these are non-blanchable lesions which arise because of the capillary fragility leading to an RBC extravasation and formation of siderophages. Periungual telangiectasias. This presents as a reddish discoloration around the proximal nail folds. Usually it is absolutely asymptomatic and does not require treatment. However, if it is associated with any ragging of the cuticles or tender fingertips, it does warrant treatment. Rubeosis faciae, although extremely rare in the Indian skin type, it is very common in fair skin types like type 1 and type 2, where it can be present in as much as 60% of the population and could be a chronic feature, a chronic cutaneous feature of diabetes. One of the important messages that the patient needs to be conveyed here is to restrict the caffeine and alcohol intake to minimize this vasodilatation. Now, the last of cutaneous concurrences is infections, which can be broadly classified into viral, fungal, and bacterial. Viral infections, I'm sure everyone is well aware of, the most important being a herpes zoster disseminated infection or a fulminant herpes zoster. Now, one important point to note here is, as per our traditional learnings, herpes zoster is something which has always been unilateral and dermatomal. However, in patients with diabetes, it can also be bilateral and it can also be multidermatomal, involving as many as 20 dermatomes. So a patient who presents to you with a fulminant zoster not following the conventional rules of or zoster distribution, please rule out an underlying diabetes and also make sure that the metabolic control is well within limits. Another viral infection could be a recurrent herpes simplex infection, which might present as a herpes simplex labialis or a genital herpes simplex. Coming to fungal infections, Candida is the most common fungal infection which has been documented in patients with diabetes, which can present either in the form of a candidial belenoposthitis or a candidial vulvovaginitis. Besides this, other candidial infections like web intertrigo are also not uncommon. Another infection which is very common in diabetics is dermatophyte infections, also commonly called as tinea. I'm sure you would have seen such patients in your OPDs. Now, one point here to make note of is that please do not prescribe these patients with topical steroids, because not only that makes the fungal infection extremely resistant, but also changes the morphology, which makes it extremely resistant to the traditional as well as the higher treatments. Bacterial infections with Pseudomonas, with Corynebacterium, and with MRSA streptococcal are extremely common in diabetics, and a good sugar control is something which can help us eliminate these. Now, coming to diabetes mellitus associated with dermatological diseases. Now, all these diseases have been linked to diabetes by the virtue of sharing a common autoimmune pathway. The first one being granuloma annulare, which basically presents as skin-colored, absolutely asymptomatic lesion with a central clearing and a raised border, which is papillonodular. Although in a non-diabetic, these would be localized. However, a diabetic individual usually presents with a disseminated granuloma annulare. Psoriasis vulgaris, this is a papillosquamous lesion, which is usually covered by silvery micaceous scales and is commonly present over the extensors, typically showing a a predilection for worsening in the winter weather. Lichen planus. Now, these are usually pigmented, plain-topped pruritic lesions, which not only present in the skin, but also in the oral cavity, in the scalp, as well as the nails. In fact, there's an entirety wherein there's a triad of lichen planus with diabetes and hypertension, which is called as the Greenspan syndrome. The psoriasis vulgaris and lichen planus patients, both of them, they show something which is called as the Kibner's phenomena, which is basically the spread of the lesions on the lines of trauma. So in case you come across these patients, a general advice should be to not scratch or rub on any of these lesions. The last of this classification is vitiligo, which basically presents as completely depigmented irregular macules over the extensors, and not just depigmentation of the skin. They can also present with depigmentation of the hair, which is called as leukotrichia, and is associated with a worse prognosis. The last classification among the skin manifestations is the diabetic therapy causing cutaneous complications, which could arise because of the oral hypoglycemics or because of the insulin therapy. Now, oral hypoglycemics could by themselves cause generalized pruritus, urticaria, non-blanchable erythema, erythema minor, lichenoid drug rash, and chlorpropamide and tolbutamide have been specifically linked to phototoxic reactions. Insulin, on the other hand, could cause lipoatrophy, which could present like this, wherein there are localized areas of fat loss because of repetitive insulin injection over these sites. One of the ways we could mitigate this is by doing a rotational insulin therapy and switching to non-lipolytic preparations of insulin. The reverse of this is lipohypertrophy, which could also be because of insulin injections, wherein you can see soft dermal, characteristically described as under-finger slippable lipomoid lesions, which arise because of repetitive injections at same sites or because of a higher dose. Switching to more cutaneous friendly and a rotational insulin treatment is something that might help us prevent this. Insulin allergy has been reported to bovine as well as the porcine forms of insulin, and using human preparations is something which will help us prevent insulin allergies. Now, this is Mehta Chawla's criteria, which I had the privilege to formulate with my respective HOD during my residency years. So we have broadly classified them into predictive indicators and affirmative indicators. Predictive indicators include candidial belenoposthitis, diffuse alopecia, which is hair loss, extensive dermatophytosis or tinea infections, fulminant herpes zoster, and recurrent bacterial infections. Affirmative indicators include acanthosis nigricans, acquired perforating dermatosis, diabetic dermopathy, diabetic foot, and sclerodema. This was a review study we had done in 2016 on diabetes and belenoposthitis. This review basically sensitizes the diabetic care providers to take a history and perform a basic physical examination in any person presents with mild symptoms, and also encourages the dermatology care providers to screen for diabetes in such persons. Similarly, we also did a review on herpes zoster and diabetes, and it actually makes a really strong case for screening all herpes zoster patients for diabetes and making sure that they have an optimum glycemic control. So the key points for takeaway would be diabetic dermopathy, shin spots is an absolutely benign and one of the most common skin conditions that we see in patients who have a long-standing diabetes. The predictive indicators are as follows, and these are the affirmative indicators. Thank you.
Yeah, thank you, Dr. Astha, for very nicely covering almost all the dermatological manifestations that we often see whenever we see a patient of diabetes. Thank you for an eye-opener kind of presentation. We can move to the next talk. I believe that the questions will be taken at the end of the 3 talks. And Krishna sir, can you introduce the next speaker?
Thank you. It's indeed a pleasure to introduce Dr. Hanif. Dr. Wasim Hanif is a professor of diabetes and endocrinology and the head of service of diabetes at the University of Birmingham, and also a professor of medicine at the University of Warwick. He's no stranger to the Indian audience, and today I think we have a global audience. He, as the director of the Advanced Diabetes course, is an eminent authority on diabetes, obesity, and ethnic health. And today he has chosen a very interesting topic, and that is the emerging role of C-peptide in the diagnosis and maybe the classification of diabetes. Won't stand between you and Dr. Hanif. Dr. Hanif, welcome. Please start your lecture.
Thank you, Krishna, for your kind introduction.
Welcome,
Let me just share the screen first. 1 second. Can you see my screen?
Yes, it's visible, sir.
Yeah.
Yes.
Thank you very much. I would like to take this opportunity to thank Dr. Chawla and Shalini for their kind invite. It's always an absolute pleasure to speak at this meeting. Good evening. It's morning time in the UK. What I'm going to be doing today is to give a kind of what I call more than a direction, which I will try to do, is to some food for thought, or what I would call lateral thinking about how we diagnose diabetes, especially in what we call a South Asian or an Indian population with diabetes, and how best we could use the emerging technology to help us to do that. So we all know this is the 100th year of the insulin discovery, or from the time the first patient was given insulin, and we have made some really good advances when it comes to the evolution of diabetes therapies. And every 6 months to a year, the guidelines are being updated, and that's a good thing. So when it comes to management of diabetes, I think there has been a lot of progress. But when it comes to diagnosing diabetes, I think we are still in a bit of a primitive era where we classify diabetes into type 1 and type 2. And in most cases, so once the diagnosis is probably made in the primary care, and the marker we use is a surrogate marker. So once the glucose levels are more than 7 or an HbA1c of more than 6.5, the patient is classified as having diabetes. Now let us try and understand the hormone that is involved in diabetes. So we know that the beta cells secrete what is called as the pre-proinsulin, and that is actually stored in the beta cells as proinsulin. And just before the insulin is released, it is cleaved into the active form, the insulin, and from the beta chain, and you have got this small peptide released into the blood, which is called the C-peptide. And this is something which is very important for us to understand and elude the role of insulin. Now, whenever I talk about C-peptide, one of the students asked me, my medical students, why is insulin stored as proinsulin? And the reason is simple. If the body stores it as insulin and it is released, it will start causing hypoglycemia in normal people. So therefore, the proinsulin is an inactive form of insulin. And when it is released, the insulin C-peptide go in. And this is what the C-peptide looks like. So it's a cleavage product of proinsulin, and compared with insulin, it's got a longer half-life. Now, one of the pitfalls of measuring insulin in the blood is that, first of all, insulin is a very unstable hormone to measure in the blood. Most of the assays of the insulin are extremely noisy. And secondly, the insulin actually goes into the cells very quickly. So therefore, it becomes very difficult to measure insulin, or whenever you measure it, mostly for research purposes, you get all kinds of numbers. So compared with insulin, C-peptide has a longer half-life, more stable, and it doesn't go through the first pass metabolism as insulin does. and is an established marker now of beta cell function. Now, this is a quote that was first mentioned by one of my endocrine colleagues who does a lot of pituitary, and I thought this is something very important. The diabetologists are those endocrinologists that do not measure the hormone that they are treating. And for the most endocrinologists, this will be sacrilegious. Imagine treating hypothyroidism or hyperthyroidism without measuring the thyroid hormone, or Cushing's without the steroids. But as I said, most of the diabetologists, we are using a surrogate marker, be it HbA1c or glucose, not only to diagnose the patients and to also direct the treatments for them. Now, let us understand that why this becomes more important in an Indian population with diabetes. And this was an excellent review by my good friend K.M. Narayanan and in Diabetes Care. And this is a comparison between what he called the tale of two Indians. So one are the Pima Indians, and the Pima Indians are the classical model that has been used in the West to study diabetes. And the second model is the Asian Indians, and this is a kind of a cohort from Chennai. Both these populations have got a very high prevalence of diabetes, or greater than 50% by the age of 55 years. But their obesity profiles are very different. The Pima Indians are very obese, while Asian Indians are relatively thinner. The Pima Indians have got a higher 2-hour plasma glucose, while the Asian Indians have a mean fasting glucose, it is elevated. And the most crucial point is that the Pima Indians are insulin resistant, the classical model of type 2 diabetes, when compared to Asian Indians, while the Asian Indians have got less of the insulin secretion, about half to third in studies. So this brings us to what is we call the heterogeneity of type 2 diabetes. So you've got two populations. In one population, it is the metabolic load, the increased metabolic load, which results in decreased insulin action. This is the classical Western model. This is associated with adiposity, physical inactivity, dietary factors, 2-hour glucose, and you've got lifestyle and metformin. The model that we are seeing more and more in Indian population is of decreased insulin secretions. The factors are unknown. It could be epigenetics, perigenetics, poor-maternal child nutrition. I just saw the name of Ranjan Yachnik in your list of speakers, who's done some amazing amount of work on this area, which is reduced beta cell mass, and you're talking about fasting blood plasma glucose, and maybe the treatments are different. So now let us try to understand how we stratify diabetes currently. So when somebody presents with new presentation of hyperglycemia, which is high glucose, the possibilities are it could be MODY, it could be type 1 diabetes, it could be pancreatic type 3C diabetes, which is coming quite well, it could be others, or it could be in most people type 2 diabetes. As you would see, type 2 diabetes is mostly a diagnosis of exclusion, as we don't have any test that will allow us to conclusively say, yes, you have type 2 diabetes. So this is my bucket of who is in the type 2 diabetes bucket. One is the genetic for type 1 diabetes that's been misdiagnosed, and then we see a lot of patients with LADA. These are thin patients who have got LADA, but because they don't develop ketoacidosis, they have been put into the type 2 bucket. Then we have got a middle-aged or old at onset, overweight or obese, minority ethnic groups greater than compared to white populations. So these are bona fide type 2 diabetes patients. And finally, we have got the atypical type of 2 diabetes. So people who are different in some way, but don't have other types of diabetes. So when we talk about atypical type 2 diabetes, it is the type 2 diabetes that doesn't fit are expected mold. But what we need to understand is the mold has been defined on predominantly historical features in white European population. Early onset type 2 diabetes is actually normal for some ethnic groups like the South Asians. So what is the difference between textbook versus real life? So what the textbook tell us is you've got type 2 diabetes. This is associated with increasing age, increasing BMI. And then we have got type 1 diabetes, usually happening at a younger age and associated with lower BMIs. But what is actually true is something like this, that there is a lot of overlap between type 1 and type 2 diabetes. So you can have somebody with type 1 diabetes presenting in their 50s or 60s. I had a patient presenting in 90s with a proper type 1 diabetes. Similarly, more and more type 1 diabetes are becoming more obese. Similarly, we are seeing more type 2 diabetes occurring in a far younger populations at a far lower BMIs. So one of the biggest drivers of the type 2 diabetes occurring in lean people at young onset is ethnicity, and South Asian or Asian Indian ethnicity being one of them. So why is it difficult to classify? So you've got type 1, type 2, and others, and they merge like this. And you have got adult onset type 1, preserved insulin secretion type 2 in lean, ketosis prone type 2, young onset type 2, and ethnicity being an important factor. Now, there have been some very good things, not patient-based studies, but mainly cohort-driven clusters. This was one that started all published in Lancet Diabetes Endocrinology. And this looks at diabetes and risk-based clusters, nearly 15,000 patients, mostly Swedish cohort. And they classified diabetes based on a number of factors into 5 types, what they call severe autoimmune diabetes, severe insulin deficient diabetes, severe insulin resistant diabetes, mild obesity-related diabetes, and mild age-related diabetes. In an Indian population, there was this publication from Dr. Mohan's group and from the INSPIRED study, and they came up with the new unique clusters of type 2 diabetes patients, in which they have tried to attempt to classify type 2 diabetes in a different manner that helps to guide treatment. So what are the advantages of these new clusters? So it helps to accurately subclassify diabetes, helps us to plan therapies based on pathophysiologies, and helps to predict prognosis and prevent diabetic complication, and is perhaps a step towards precision diabetes. Now, coming back to C-peptide and how C-peptide can actually help us to solve this is, let us understand. So one is a C-peptide that helps us to determine the insulin secretion by the pancreas. And the second one are the pancreatic antibodies. Among the pancreatic antibodies, the 2 or 3 antibodies that are good in terms of measures are the glutamate decarboxylase, or what we call GAT65, and islet antigen, which is IA2, along with the zinc transporter. These are good and have been primarily studied in research studies to diagnose type 1 diabetes. The role in classification of diabetes is still unclear. So what are the caveats when you're trying to interpret the antibody results? So antibody negative does not exclude type 1 diabetes. Less than complete testing. People from some ethnic groups, including Asian Indians, have low rates of positivity, and titers diminish over a period of time. So when are we recommending C-peptide measurements? So this is been recommended by a number of societies in the UK. So C-peptides is beyond 3 years after diagnosis is a good time. It usually needs to be measured within 5 hours of eating is recommended. Why is that? It is because the C-peptide levels or the insulin levels are actually determined by the food that is eaten. So if you actually have eaten the food and measure the C-peptide postprandially, it may be high or low. Similarly, measuring the blood glucose levels concurrently is extremely important, because if the blood glucose level is low for whatever reason, maybe in the fasting state the patient is having a hypoglycemia, then the C-peptide levels will be low. Persistent C-peptide, and this is something very important, persistent C-peptide of greater than 600 suggests type 2 diabetes. And the measurement of C-peptide in various studies have led to reclassification in nearly 11%. So what's the best practice for testing antibodies? What's the clinical question? Antibodies should only be measured to support a diagnosis of type 2 diabetes, type 1 diabetes, and type 1 diabetes is not excluded if antibodies are negative. Clinical suspicion is high, then do not defer insulin treatment and start the treatment if you're suspecting type 1 diabetes. Clinical suspicion is low. Why measuring? Have a clear clinical question in mind. And clinical suspicion is intermediate and antibody positive. This is supportive of type 1 diabetes. What is a normal C-peptide? So there are no normal ranges defined for C-peptide, no robustly evaluated cutoff that delineates one type from another, and not interpretable at the diagnosis. And this is something very, very important. Let me give you a case that presented in my clinic. So this is a 19-year-old female in college in Birmingham of Bangladeshi ethnicity. BMI is about 23. She presented with 2 weeks of tiredness, polyuria, and feeling thirsty. Mother has type 2 diabetes on insulin, and mother checked her blood glucose capillary level of the daughter and was greater than 18 millimoles per liter. The question is, what treatment should be started on? So in the clinical decision about the treatment based on risk, what we want to know is we don't want to miss type 1 diabetes and delay insulin whilst awaiting specialist test. She's young, but she is not overweight. She is UK-born Asian person, so she appears to have same risk of type 1 diabetes. And sometimes diabetes classification may take time beyond the results of immediate specialist test. We started on BD-Levemir and Novorapid. That's the standard treatment that we give for patients diagnosed with type 1 diabetes. And 3 weeks later, her GAD-IA2 and ZNT8 antibodies came negative. The question is, would you re-evaluate the diagnosis now? We also know that we get antibody negative type 1 diabetes, and we need time to see how it evolves, and C-peptide will help further down the line. We also can consider monogenic diabetes or MODI. The family history is compelling, and we could proceed towards the genetic testing, or this could just be early onset type 2 diabetes. We checked her C-peptide levels. They came back elevated at 1,056 picomoles per liter. Concurrently, her glucose at that time was 8, and her HbA1c was 48. We also did MODI genetic testing, and no mutation in known MODI genes was identified. She currently remains on basal insulin, but the plan is to introduce her on orals. So this is classified as a typical early onset diabetes that we are seeing more and more in the South Asian or Asian Indian populations. So what's the summary of early onset type 2 diabetes? So it's a diagnosis of diabetes less than 40 years of age. Could be type 2 diabetes, but the chances of type 1 diabetes and MODI are much higher compared to the later onset of diabetes. We need to practice clinical due diligence and ask ourselves questions. Could it be type 1? Could it be MODI? Can be overweight and have type 1 diabetes, and specialist tests are available. Early onset type 2 diabetes is extremely high risk stage, so it is very important that we have a clarity about the diagnosis. In young adults, there is no 100% accurate diagnosis. Some blood tests may be supported. Age, body mass index are still the two most important factors that are most likely to influence diabetes. Age and BMI are now increasingly poor at discriminating the diabetes subtypes. These are some of the factors where you will differentiate between type 1 and type 2 diabetes. Ketoacidosis is very important, but we also need to be aware that we are seeing more and more of ketosis-prone type 2 diabetes. Now, this is a chart that has been actually developed by inputs from the ESD and have been adapted in the UK. So this is a flow chart of suspected type 1 diabetes in newly diagnosed adults based on data from white European population. This, I need to stress, is from white European populations. So if you have got an adult with suspected type 1 diabetes, then you test the islet cell antibodies. If the islet cell antibodies are positive, then it is very clear that this is type 1 diabetes. If they are negative, which we know happens in 5 to 10% of type 1 diabetes patients, then we look at the age. Is the age less than 35 years or greater than 35 years? If it's less than 35 years, the questions asked, are there features of monogenic diabetes like family history? If the answer is yes, you check or test C-peptide levels. If it's greater than 200, then genetic testing for monogenic diabetes is available. If it is less than 200, then you can safely say that this is type 1 diabetes. If the features of monogenic diabetes are not available, are not there, then we'll really ask the questions, are there features of type 2 diabetes? And the answer is no, then we can say it's type 1 diabetes. If the age is greater than 35 years and you unclear classifications and makes clinical decision as to how a person with diabetes should be treated, consider C-peptide test after 3 years. If it's less than 200, it is type 1 diabetes. If it's between 200 to 600, it's indeterminate. And if it's greater than 600 picomoles per liter, then you can safely say this is type 2 diabetes. Genetic testing is usually done for monogenic diabetes. There is a very excellent MODI probability calculator developed by the Exeter University by Andrew Hattersley and his group, which is easily available online, where you can put a number of factors, and that gives the risk of this being MODI and suggest whether the person needs genetic testing or not. So, Mr. Chairman, in summary, diabetes has a genetic basis, and in coming years, understanding has improved and continues to get better. Diagnosis diabetes correctly, especially in an ethnic or a South Asian population, is becoming important as it will help us to target treatments. Measuring genetic mutations in C-peptide will help us in the classification along with new tools that are being developed. Thank you very much.
Thank you, Dr. Ashu, do you think we can take a couple of questions or do it at the end?
I've been asked by the organizers to take questions at the end.
I think maybe toward the end, after Dr. Eddie's. Request Professor Hanif to stay back.
Oh, sure.
Another
20 minutes.
Yeah. So moving on to the last talk in this session, and that is very, very pertinent because we know that the cardiovascular events are definitely the killer in patient with diabetes. And once a patient lands with heart failure in the hospital, we believe that everything is related to ischemia or ischemic cardiomyopathy. But probably we might hear from none other than Dr. Adi Mehta, who is a faculty at the Cleveland Clinic, and he's associate professor in the Department of Endocrinology and the member of the American Association of Clinical Endocrinology. And he'll be talking about the diabetic cardiomyopathy, pathophysiology and treatment implications. So Dr. Adi, can we have your slides, please?
much for giving me this opportunity. I'd like to thank Dr. Chawla and the organizing committee for this very great honor. I really find this a wonderful symposium. So thank you very much. I'm going to be talking about diabetic cardiomyopathy, and I'm calling it the perfect storm. Basically, if you look at cardiovascular disease, it is the most common cause of mortality in type 2 diabetes. And I just want to point out that while we all talk glibly about it affecting 70% of people with diabetes will die from a cardiovascular cause, I think it's very important to break that down and realize that, number one, sudden death is very common in diabetes. In this particular study, SAVOR-TIMI 53, about 30%. More importantly, heart failure has twice the incidence that we of acute MIs. And we always think of diabetes having acute MI. And in fact, it's clear that heart failure has a bigger preponderance in this population. When you look at, obviously, this is very well known to you, incidence of any cardiovascular, death from cardiovascular causes, hospitalization for cardiovascular causes, or death from coronary artery disease is always more common in people with diabetes, and in fact, probably hits about twice more, or 2 to 3 times more frequently. What we don't always accept is that the incidence of CHF is also very common in diabetes. And what's most important is that it starts early, and that in fact, it continues, and it is relatable to age. And obviously, heart failure or CV death is more frequent, and I don't want to belabor that point.
Hello.
In the Wikipedia.
Sir, sorry to interrupt, but your slides are not visible.
Oh dear. Can someone help me?
Yeah.
Yes, sir.
Someone's going to... So sorry about that. I am electronically handicapped. So I apologize for my electronic handicap. Basically, I'm going to be talking about diabetic cardiomyopathy. And just to make sure you understand, I am very, very honored to have been asked to give this. So thank you, Dr. Chawla and the organizing committee. Basically, all of you are very well aware that diabetes has a very high mortality, and most of the mortality is driven by cardiovascular disease. And as I said in Saver-Timmy 53, if you look at the overall incidence of cardiovascular disease, there was a preponderance of sudden death. But more importantly, this topic, heart failure was twice as common as acute heart attack. So when you talk about cardiovascular disease, in fact, only a small portion, in quotes, is from acute MI. Most of the others is manifestations of heart disease, or alternatively, what they do in terms of life. And of course, there's clear evidence that diabetes carries a higher risk of any form of cardiovascular disease, and I'm not going to belabor this point at this point. I do want to point this out very importantly, that in fact, cardiac congestive heart failure, or heart failure, is extremely common in diabetes. It is relatable to age, and everyone looks at the right hand where you see older people getting a high amount of congestive heart failure. I want to point to the fact that it starts at a very early age. And it's very important to understand this, because as I go forward, you'll understand why some of Dr. Hanif's talk is partly where I'm going to be also touching on. And obviously, hospitalization to heart failure or CV death is more common in diabetes. In the UK PDS, it was found that at a hemoglobin A1C of less than 6%, approximately 2.3 heart failure events occurred in 100-person years. When you looked at a hemoglobin A1C of 10%, it was 11.9 heart failure events. Clearly, a 5 times higher incidence related to glucose control. And this is the incidence of sudden cardiac death. Again, you see a 2-fold increase just because you have diabetes. Now, if you look at congestive heart failure individuals, what you find is a fascinating statistic. In studies of individuals with congestive heart failure, somewhere between 33 and 50% of people have what would be called pre-diabetes. So in effect, there is something about congestive heart failure and diabetic cardiomyopathy that actually occurs way before we can diagnose diabetes. And I cannot underscore and stress what Dr. Hanif said, that in fact, when we use the surrogate marker of glucose, we are already with the horses well out of the stable, and we are trying to close the door on its rear end. And I think it's very important to understand that we have to start thinking about diabetes at an earlier time, mainly because the complications that cause the biggest degree of morbidity and mortality start before we even diagnose the disease. So the major components for the pathophysiology of diabetic cardiomyopathy, the major driver is abnormal fatty acid accumulation and metabolism. And there are 3 specific sites that get involved in this process: the epicardial adipose tissue, intracellular triglyceride, this is cardiac steatosis, very akin to hepatic steatosis, and coronary plaque accumulation. And we'll sort of go through this very quickly. So what is epicardial adipose tissue? It's an ectopic fat deposition located between the myocardium and the visceral pericardium. And there is no fascia separating this. It is almost becomes almost one tissue. So there's a huge amount of crosstalk between what happens in the adipose tissue to what happens in the surrounding tissues. It's mainly located in the atrioventricular, interventricular grooves surrounding the major branches of coronary arteries, atria, right ventricular free wall, and the apex of the left ventricle. So it actually forms a sort of an envelope for most of the heart. And in the grooves, it accumulates more easily. The adipokines and cytokines, whether they're beneficial or non-beneficial, secreted by this tissue, may exert very significant paracrine effects on the cardiomyocytes, the fibroblasts, the coronary endothelial cells, and smooth muscle cells. So this tissue, by being there, already plays a role across the whole pathology or the whole histology of that area. So what is the role of epicardial fat? Why should we have epicardial fat? First and foremost, it is an immediate energy tank for the heart. When in terms of stress, it can take a lot of energy from that area. It also is able to prevent cardiac lipotoxicity in the sense that it buffers some of the free fatty acids coming. It acts as a filter before the heart or the myocyte actually has to see the free fatty acids. Thermoregulation is very important in terms of protecting the heart, not only from the heat, but from the cold. After all, you have to keep the heart at a relatively stable temperature. Mechanical protection. The heart is constantly moving. The shear forces on the arteries, on the veins is huge. Something has to cushion the shear forces as the heart keeps moving. If you have a wonderful heart, you're going at 60 beats a minute, that's what you're going to have to protect against. And obviously coronary arteries require this protection from the pulse wave that they generate. And then there's an immunological support. This tissue has the ability to have modulate immune responses in the area. So what are we talking? What cells are we talking about? Well, adipocytes are not homogeneous. They're a heterogeneous group. In fact, epicardial tissue that is perfect is mainly made up of brown adipocytes, while imperfection is as it becomes white adipocytes. And this is an interchangeable cellular type. One can migrate to the other, and I'll show you that. But when you look at white adipocytes, which are the most common adipocytes that we see in adult life, they're located under the skin, around internal organs, in the central cavities of the bones. The main function is to store energy. Other functions is to insulate the body from extreme temperatures, cushion it, all the things I've already talked about. What about brown adipocytes? Well, brown adipocytes are mainly in the biggest abundance in fetal life and in infancy. And they're there specifically to protect the baby or the fetus from thermal stresses. So that is what they do. They generate heat, and they also tend to insulate from heat. So in effect, they are very active from that point of view. However, when you look at the transitions, you see them some difference in histology. Brown adipocytes have a lot of mitochondria, small droplets of fat. White adipocytes, mitochondria are gone. They've been pushed aside. They've become markedly less, and it's just a big white glob of fat. And as that expands, that's what we'll talk about. Beige adipocytes are a mixture between these two, and they're the transitional from white to brown. And then there's the pink adipocytes, which are mainly in mammary tissue and make milk. When you see the relationship, you find that cold exposure will increase your beige adipocytes. If you live in extreme temperatures like we do up here, most people will gain some weight in the fall and early winter. Why? Because they're protecting themselves against the potential cold temperatures. Now, we've obviously changed that around. You go from a heated house to a heated car. For God's sakes, even your steering wheel is heated, to a heated office. So we never actually expose ourselves to the temperature, but we are preparing for it. So now what happens is you get this beiging, and then now that we're collecting and we're not using this, it starts to go back to weight gain and become white adipocytes. Weight loss will induce a much more browning because you need to protect from the elements from heat and cold. And so there is a fluctuation in the histology because of the functional changes that are induced. Now, let's talk about where fat goes wrong, either because of an increased amount of what we eat, or because of something that Dr. Hanif sort of mentioned, the fact that in India, we have people who are lean, who are insulin resistant, but also have lowered insulin capacity. If your insulin capacity functionally is low, then you cannot hold adipocyte tissues, free fatty acids in adipocyte stores. They're going to increase the amount of free fatty acids coming out. So there is either free fatty acids from the diet or free fatty acids just because you're insulin resistant. The point is you've got a lot of free fatty acids in the circulation. They go to the liver, and in the liver, they're processed. In the process, extra free fatty acids get deposited in the liver, you got hepatic steatosis. Similarly, you get free fatty acids going into the heart. There, they're going to be collecting in epicardial tissue. When epicardial tissue cannot accommodate that, they now start going into myocytes, causing intracellular steatosis, and that's the cardiac steatosis that you see. And then the inflammatory responses you'll be talking about starts to affect the coronary arteries. So, how does fat deal with free fatty acids? Well, if you have a lot of pre-adipocytes, then all that happens is as you start putting more free fatty acids into the adipose tissue, your pre-adipocytes become adipocytes. That's a healthy hyperplasia, and you are going to find a relatively benign obesity. On the other hand, pre-adipocytes are limited. It turns out that we determine the amount of pre-adipocytes we'll have at a very early stage of fetal life and infancy, and then we don't have the ability to have a lot of pre-adipocytes. To have pre-adipocytes in adulthood, we have to take them from other sites, like mostly from pre-osteocytes. And so therefore, one of the reasons why with TZDs, you get osteoporosis, because TZDs tend to cause the pre-osteocytes to be able to become pre-adipocytes and store free fatty acids. So it's clear that we don't have a lot of pre-adipocytes. Now, the only option the adipocyte has is to become hypertrophic. Once it becomes hypertrophic, you've got three issues. The hypertrophy now makes the area insufficient in terms of vascular, because while pre-adipocytes are associated with new vessel formation, hypertrophy is not associated with increased vascular supply. So now you've got a store of fat that is already swollen and now is not getting enough of a blood. Once you start to get that, this is going to cause hypoxia within the adipocyte. This stimulates recruitment of immune cells, establishes an inflammatory response and fibrotic response. And this fibrotic further restricts the adipose tissue, so causing a further vicious cycle to entail. And so in effect, you've now got an expansion of a fat store because of the ectopic amount of fat that's being stored. Once any fat, anywhere, if you restrict it, it becomes inflamed, it becomes hypoxic. That's the reason why if you have to gain weight, it's better to gain weight in your hips. There is no restriction, your hips can go for miles, and therefore it is always going to be a relatively benign obesity. Once you put it into the tummy, there is restriction. Now you've got the inability of this fat to continue to function. It becomes hypoxic and becomes inflammatory. And so I think that's the difference between apple obesity and gynecoid obesity or pair obesity. So I've talked about the normal effects of epicardial fat. What are the pathological roles in the right side of the slide? Well, now you've got most of the cytokines that are beneficial start to become decreased in number, and the inflammacytes, the pro-inflammatory cytokines are going to start to increase, and that's what drives the tissue to become a hot bed for inflammation and the subsequent issues that we see. If you look at the location, and I told you there was no fascia, the perivascular fat that is inflamed is going to affect the vasa vasorum, which is going to affect the myocardium, and most importantly, the endocardium, the media of the vessel and the internal of the vessel. So now you've got an inflamed interior of the vessel, and now you've got a perfect setup to be able to have atherosclerosis develop in an accelerated fashion. So a perivascular fat that became inflamed suddenly made the vessel that it was trying to buttress and to protect into a hot mess. If you look at specifically fat in the atrial grooves, that fat in the atrial grooves, because of its ability to cause inflammation, is why there is such a high incidence of atrial fibrillation in these individuals. It's important to understand that the myocyte will pick up fat on a substrate basis. The more substrate, the more free fatty acids there are, the more free fatty acids it will pick up. When it picks up free fatty acids, it has two outlets. One, it oxidizes the free fatty acids to use for energy. The heart uses free fatty acids as a major fuel source, but it also tends to cause a certain amount of storage. So it's about a 25 to 75% split. But as the amount of free fatty acids going in increases, that 25%, even though it's only 25%, starts to cause a significant intracellular accumulation of triglyceride. Free fatty acids coalesce to form triglyceride. And so now you've got high levels of intracellular, intramyocellular triglyceride, cardiac steatosis. So epicardial fat spilling over into the myocyte has now caused the myocyte to become abnormal and become quite significantly dysfunctional. And we already told you that, in fact, you are going to get an extension into the vessel. In a study that was done where they did endocardial biopsies and related the endocardial biopsies to the glucose state, just as Dr. Hanif pointed out, the disease starts before the surrogate marker is clearly abnormal. So here you see that obesity and impaired glucose tolerance already caused a significant amount of myocyte triglyceride, and diabetes, which has further enhanced it. And what's most important on the right side is as those cells become filled with fat, you start to notice that there is a decrease in filling rate. You're starting to set up diastolic and systolic dysfunction. And in fact, if you were to look at the triglyceride content of the heart and look at its stages of dysfunction, you very quickly find that diastolic dysfunction with normal EF, when there's low amounts of fat, and by the time it becomes of very high levels of intramyocellular fat, you've got overt ischemia and infarct and heart failure. Now, what about the internal interior of the vessel? We know that insulin resistance, high free fatty acids will drive insulin resistance, and that changes how the lipid profile. So increased free fatty acids in the liver, you package the liver into a large number of VLDL. VLDL comes out of the liver. It is going to be processed by the action of lipoprotein lipase to IDL and LDL. Lipoprotein lipase is insulin permissive. In the face of insulin resistance, it doesn't work. So you get an accumulation of VLDL. That's why you see the high triglycerides. VLDL, under the action of CTEP, basically exchanges HDL cholesterol. So your HDL cholesterol starts to decrease in size, and most importantly, the nascent apolipoprotein of HDL, because it's no longer got fat in it, will be excreted, so you get the typical low HDL. So the typical atherogenic potential is high triglycerides, low HDL, and a small dense LDL. That has tremendous ability to go through the endothelium in the artery. It will accumulate in the endothelial lining, and then it will recruit monocytes, make them into macrophages, make them into scavengers, because that's how you scavenge it, and therefore you get foam cells, and now you've got the development of plaque. The more perivascular fat that you've got, the more diffuse the atherosclerotic drive is. And that's why we see such a diffuse atherosclerosis in people with diabetes. Notice again at the bottom of the slide.
Dr. Adi, sorry to interrupt. Please finish up quickly. As
sorry,
we are
I thought I was
running out of
going
time.
on time. Sorry, I will finish. So notice pre-diabetes, then diabetes. So clearly pre-diabetes is a very high risk situation. In treatment, you want to talk about exercise. Exercise works all the time. And in fact, a meta-analysis showed that overall, and then certainly endurance exercise clearly drops the epicardial fat. Statins clearly drop epicardial fat. A study done in patients comparing atoro versus pravastatin, you saw that the atorvastatin was able to drop epicardial fat. PCSK9s, even though they are not an anti-inflammatory, lowering LDL also has ability to lower epicardial fat thickness. Metformin has been shown consistently to be associated with lower incidence of congestive heart failure, and it protects against epicardial fat. Sensitizers, pioglitazone, I think all of you know about. DPP-4s have been shown in small studies. These are all small studies because it takes time and the ability to measure epicardial fat, but has been shown to decrease epicardial fat, and GLP-1 agonists have been clearly shown to do this. This is liraglutide after 12 weeks. Dulaglutide and semaglutide does the same thing. And so in effect, SGLT2 inhibitors have really focused in why a diabetologist has to know anything about the heart. And so that's where they played the biggest role. And today, SGLT2 inhibitors form a central role in the treatment of diabetic congestive heart failure or non-diabetic congestive heart failure because of this ability to look at sugar and free fatty acids in a different way. So I think I'm going to rush through this to indicate that SGLT2s also decrease the volume of things. And you all know the effects on heart failure and hospitalization, on CV death associated with heart failure. With SGLT2 inhibitors, I just want to point something out. We have to think about the mineralocorticoid. I told you there's fibrosis, there's aldosterone. Mineralocorticoid receptor antagonists, therefore, have to come in to stop the fibrosis. So, in conclusion, diabetic cardiomyopathy is an abnormal storage and excess free fatty acids. It causes and magnifies insulin resistance. It causes adipocyte hypertrophy, induces hypoxia, oxidative stress, which then affects the tissues around it. Similar to hepatic steatosis, it is initiated well before we make the diagnosis of diabetes. So what I'm asking you, and this is just out in the middle of nowhere, maybe we should be thinking of making the diagnosis of diabetes at a lower range, 100 milligrams per deciliter, or hemoglobin A1C of 6, or consider pre-diabetes as a clinical entity that requires therapy and not for us to say, you just try life and exercise and you're at risk for diabetes. I think it's very important to think early. Remember these two quotes from these Chinese people. The best time to plant an oak tree is 20 years ago. The second best time is now. And that's what we're doing. We're not planting the tree 20 years ago when the whole thing starts. We're trying to fix it now. And please remember, superior doctors prevent disease. Mediocre doctors treat the disease before it is evident, and inferior doctors treat the full-blown disease. We don't want to be inferior doctors. Thank you very much for your attention. I'm sorry I went over.
Thank you. Thank you
we
for
can have only 2 quick questions. Please, chairpersons, please make it fast.
Thank you for these 3 wonderful talks, especially, very classic talk in dermatology. There's so much of information that is just said by a picture that us endocrinologists and diabetologists can never match. Great, Dr. Asta. And then can I ask Dr. Hanif one quick question, and then I'll let Ashu take one. Dr. Hanif, Ashok Balasubramaniam has been in the past talking about classifying diabetes as AB, A plus, B plus, A minus, B minus, A minus, B plus, and so on. And while this is mostly in adult type 1 diabetes, but do you think that it's time to start using this classification throughout?
Yeah, no, thank you, Krishna. I think one of the big challenges with any of the classifications is that how far we deviate from what is known. As most people are more comfortable with numbers with type 1, type 2, it will be very difficult to try and go for a new classification because this involves global education and things like that. Now, in terms of type 1 and type 2, what we have got, and especially with type 3C, which I thought was a wrong thing both by WHO and ADA to reject type 3C, when it was something that was seen in an Indian population for a very long time. So this was the classical, what we used to call the malnutrition-related diabetes. It's a kind of pancreatic classification. Now, I think what I think is more important is, other than classifying the diabetes into the various subtypes, there needs to be more emphasis in terms of diagnosing, especially the atypical ones. Here, as you said, most diabetes is currently diagnosed by a single blood glucose test or an HbA1c. And if the patient is not in ketoacidosis, they're all labeled as type 2 for the treatment. And if the glycemic control is not good, it's the usual story, follow lifestyle. So therefore, I think we have to really revisit this. So what I think is what is important is that if you have atypical diabetes, then they should be seen by an endocrinologist to classify the diabetes properly. And I think that will be the first step before we really start understanding and reclassifying it.
Thank you. Can you, for our audience, also just clarify what the 3-year limit for C-peptide? Because I think that's not widely known.
Yeah. So the reason why we need the C-peptide 3 years limit is that there are lots of things happening. So we know the honeymoon phase of type 1 diabetes, where you still have the beta cells producing a little bit of insulin. So, those are the kind of things that confuse the picture. But after 3 years, then it is almost certain that if it is type 1 or atypical type 2, then the beta cells will be almost exhausted. So then you can actually classify between type 1 and type 2 in a much better way.
Ashu, thanks, Dr. Hanif.
Yeah, thank you, Dr. Krishna. So I'll just have a question for Dr. Adi. Dr. Adi, very interesting talk. He talked about the VAT and BAT and the cardiomyocytes and the epicardial fat and all. So do you think, as a clinician, is it really pertinent and relevant to differentiate kind of a cardiomyopathy, whether it is ischemic versus diabetic, especially because I'm asking this question, because do they behave differently? Do they behave differently to the treatment and especially the prognosis? And if you look at maybe the heart failure trials, actually they have really done that. And does it matter?
Oh, I think it absolutely matters. However, I think your question is very appropriate from another point of view. Ischemic and non-ischemic are relative terms in the duration of the disease. So that in effect, early on, when you're pre-diabetes or early in diabetes, you're more likely to have a much more congestive failure, and you're going to have non-ischemic. But as time goes on, the mere fact that this process produces atherosclerosis and is going to therefore cause a significant vascular disease, you're going to move on to an ischemic component. So it's more a duration with time rather than necessarily two differential buckets that you're dealing with. But yes, I think it's very clear that you can get a lot of disease in terms of heart failure without actually seeing the ischemic portion of it. But for me to be able to say that there is no ischemia involved in heart failure would be totally wrong. I think there is some, but I think it's not at a level of at a clinical presentation that has symptoms, or for that matter, that is going to be allowed to be treated. I think you understand that, why, for the sake of interest, and because I think this is such stupid science, the reason why insurance companies will pay for a stent to be placed or a CABG to be done only after a 70% stenosis. The basis of that was that someone, in his infinite wisdom, ligated a dog's coronary artery and found that when you ligate the artery is ligated to more than 70% stenosis, you get significant ischemic changes. So now they say that must be for humans too, and that's why we will not stent someone until they get to 70%. This is a stupid argument. In fact, when ischemia occurs, it always tends to occur in the 50% soft plaque rather than the 80% hard plaque that gives you heart attacks. So I think it's very important to understand that we have a very simplistic approach to this, but it's not correct. I think once you've got the startup of cardiomyopathy, you are going to end up to an ischemic component at some point. So Sorry, I might give you a long answer to a short question. But I think it's very difficult to differentiate.
Thank you very much.
I think we'll have to close here. I wish we could have continued with Professor Addy and Professor Hanif, two being top international endocrinologists with us. But I think in view of time that we have already exceeded by 20 minutes, we'll have to stop share here only.
Thank you very much. I'm
Professor
sorry to have
Hanif,
gone on so long.
Professor Addy Mehta, we are really obliged.
Thank you.
Dr.
Thank you.
Sheshadri, Dr. Ashu, entire lot of wisdom came from you people. Thank you. Over to you, Ratan. Thanks.
Thank you. Thank you very much, everyone. It was wonderful symposium on back to basics. And now we are moving forward to current concepts in nutrition. And for that, we have chairpersons, Dr. Kirti Sutta from New Delhi and Dr. Shefali Karkhanes from Thane. They are a very good friend of mine. And I welcome you both the chairpersons. They are very well-known figures. So I need not to introduce them. Please go ahead.
Thank you very much for the kind words. It was indeed, as Dr. Chawla sir has said, I would have loved to hear more on the previous topic as well. But yeah, we now move on to the next nutritional topic, which is extremely important because we are in an epidemic of obesity now. And here with us is Ms. Shilpa Joshi from Mumbai. She is a consultant dietitian and an educator. She has been the vice president and an honorary secretary of All India Association of Advancing Research on Obesity. She's a wonderful person, a master trainer. She's actually trained more than 3,000 plus diabetic educators. I'm sure the figures are much more now. She's had a number of awards to her credit, including the SWE Award by Foxy in 2019. And she's an excellent person and a very good friend of mine, and I welcome you, ma'am. She's going to talk about the most important aspect, that is intermittent fasting, the facts and the myths that we face today.
Thank you so much, Shefali. And at the outset, I would like to thank Dr. Rajiv Chawla and Dr. Shalini for giving me this opportunity. I'm going to be talking about a very interesting topic, that is intermittent fasting, myths and facts. So now intermittent fasting has become extremely popular. And, you have people talking about it, about going on a fast or, doing some 16 hours or 8 hours fast and without understanding the science. So to begin with, let's look at what happens. So we know, whenever we go for a movie, we know that there is an ad of tobacco, which is shown, which causes cancer, which causes oral cancer. But in that same movie theater, a lot of times we actually land up buying these samosas and these fries and these popcorn. And we, after knowing that unhealthy diets actually kills more people than tobacco or high blood pressure. Now, intermittent fasting, so therefore it's important to, have a good regime of diet, and intermittent fasting is one of the popular ones. Now, intermittent fasting actually is practiced as a part of religious component for many, many years, but it was actually made very, very popular by guys in the IT field. So the person who really made IF very popular was Jack Dorsey, who founded Twitter then. And then he would say that he would keep fast for 22 hours a day, so on and so forth. Even Steve Jobs did that. And Mark Zuckerberg also tried to do it. And hence intermittent fasting actually caught on all over the world. So what are the benefits of caloric restriction? Now, we all know that caloric restriction is known to promote weight loss, and it represents a dietary method that has numerous positive effects in obese individual. Caloric restriction also improves health status in normal weight people. So a lot of time, normal weight people also tend to do intermittent fasting, and it is seen that when they do it, their health improves. The reduction of caloric intake between 60 to 70% of daily requirement increases longevity by 30 to 50% in many, many animal species, and therefore it is thought that intermittent fasting is great. Now, what are the reasons for benefits of caloric restriction? One hypothesis actually claims that it modifies the energy metabolism. Other hypothesis says it reduces mitochondrial production of oxygen radical, decreases oxidative stress, and therefore the damage which is produced by accumulation of reactive oxidation species to proteins, lipids, and nucleic acid. And probably that is the reason that reduced caloric intake has a positive effect on longevity. So that therefore caloric restriction is very important, and intermittent fasting has been shown to be a solution to take advantage of caloric restriction benefit, but it does not have its side effect. Now we all know what is twin cycle hypothesis, and we have seen that reduction of calories drastically, in fact, could show remission of diabetes also, and we have seen that with this trial, direct trial. Now, what is the effect of meal frequency on weight and metabolic parameters? Now, this is an interesting study because we come from a point where a couple of years back, they were talking about eat food every couple of hours. Don't eat too much, but eat food every couple of hours to lose weight or to maintain blood sugar. And again, this was a study which was done in Prague, Czech Republic, where they actually did an open crossover single-centered study of 54 patients with type 2 diabetes who were treated with OHs, both men and women between 30 and 70 years of age, BMI between 27 and 50, and an A1C of between 6 and 11.8, that's approximately 12. And they were both asked to follow hypocaloric diet. One regime was 6-meal pattern, other regime was 2-meal pattern for 12 weeks each, and after that they were crossover. In both diet regime, very interestingly, they had the same macronutrient and energy content. Participants were asked to continue their pre-existing medication regime except when hypoglycemia occurred recurrently. The randomized crossover 24-week study demonstrated superior effect of 2 meals per day on body fat, body weight, hepatic fat content, and plasma fasting glucose, so on and so forth. Also insulin sensitivity. The effect of meal frequency on metabolic clearance rate of glucose and beta cell function was not significant. So it was seen that weight loss per se was better with a less snacking or a smaller meal regime. So these were the results. Now we know fasting is a spiritual discipline, and almost all religions across the world actually recommend fasting. And fasting what is fasting? It's voluntarily withholding food for spiritual, health, or other reason. Fasting may be done for a period of time, a few hours to a month in end. And in that sense, fasting is part of everyday life. And it is known that Hippocrates, father of modern medicine, considered that to eat when you are sick is to feed one's illness. So therefore, humans, like most of the animals, do not eat when they become sick. For this reason, fasting has been called as physician within. So fasting instinct makes animals and human anorexic when they are sick. So it is very important. Fasting is a very important part of our life. Now, there are many types of intermittent fasting programs. There is a 5:2 program where you can eat for 5 days and not eat for 2 days. Then there is lean gains, that is eat for 10 hours, eat, stop, eat. So fast 1 full day and otherwise eat normally, warrior diet where you eat 1 meal a day. And then, of course, there is a 16:8 method, which is very, very popular across India, where people do not consume food for 16 hours and then consume food in a 8-hour window, and that is more doable for people rather than consequently fasting for 2 days and eating for 5 days. That is a little more difficult to follow. Rather, time restricted feeding is easier. So these are characteristics of most common type of intermittent fasting. So intermittent energy restriction, where you eat for a day and don't eat for a day, versus time restricted feeding, where you do not eat for a period of time in a day, say 16 hours, and then eat for 8 hours. So the logic involved here is there is reduction in compensatory metabolic response. Here there is a circadian rhythm which is considered. Of course, this includes not eating late in the night. So if you're using the daytime to eat, then this will happen. Main principle of weight loss here is induction of energy intake in both fasting period, a set of days normally within a week, and the year in time restricted feeding, it is not for more than 24 hours. And we know that When there is fasting which takes place there is ketogenic state which is created, and then of course there is utilization of fatty acids for generation of energy, and when it is restored to normal state after consuming, then glucose is used as energy to generate ATP. Now, what are the benefits of intermittent fasting? There are many benefits. So the benefits which are said are they protect against neurodegenerative diseases, insulin levels drop, and human growth hormone increases. It reduces insulin resistance, lowers blood glucose level, reduces risk of heart disease, reduces blood pressure and cholesterol, boosts fat metabolism, extends lifespan, reduces oxidative damage, removes waste material, and reduces leptin levels and increases testosterone levels. So if you look at it, there are a lot of advantages of fasting, and we know that because there is a change in the metabolic switch because of restriction of energy, there is increase in the health span and there is increase in longevity among animals. So these are many reasons why because of which weight loss occurs, and also there is an impact on gut microbiota. Very interestingly, there is also an impact on appetite. So you find that typically people feel that if they skip one meal or they fast for a prolonged period of time, actually appetite reduction happens and they are unable to eat in the following meal. And of course, there are cardiovascular effects like reduction in oxidative stress. There is restoration of circadian rhythm, and of course, ketogenic state, which changes the energy metabolism. Now, there are two types of diets, right? There is intermittent energy restriction, that is intermittent fasting, or there is continuous energy restriction. And it is found that currently there is insufficient data to support that intermittent energy restriction in any form can affect CVD risk markers, blood pressure, lipid levels, or insulin or glucose to a greater extent than continuous energy restriction. So as of today, there are very few studies which prove that one is better than another. Sorry. Now there is a trial which took place, which is called as the Helena trial, which was a controlled 1-year trial in 150 overweight or obese participants who were randomly assigned to 3 arms. There was intermittent caloric restriction in one arm, on two self-selected or non-consecutive days a week, with 25% of estimated energy requirement, and 5 days a week without energy restriction. Then there was a continuous caloric restriction. There is daily restriction of less than 20% of the estimated energy requirement. And of course, there was a control group. Now, what results from Helena's trial show that there was no significant difference in adipose tissue transcriptome measured in 28 pre-selected genes between both the groups, whether it was intermittent caloric restriction or continuous caloric restriction. It also indicated that the timing of energy restriction does not induce differential transcriptional regulation of adipose tissue metabolism at net energy intake. So results of Helena trial showed that neither ICR nor CCR are superior to other with respect to weight loss and maintenance and improvement in the cardiovascular risk factor. Now, this was one of the older studies which was shown. Now, what are the problems with intermittent fasting, considering that we are looking at myths and facts both? Now, although intermittent fasting is very promising dietary procedure for improving health status in obese population with metabolic pathology, all-day extreme caloric restriction are associated with hunger and irritability, which makes them difficult to implement. So again, intermittent fasting or intermittent caloric restriction is not for everybody. There are people who cannot handle being hungry for a prolonged period of time. It makes them very hungry, very irritable. So it does not work for them. So therefore, far more compliant alternative would be time restricted feeding, where you are not eating for a couple of hours in every day. So these are various effect of various kinds of intermittent fasting and their impact on metabolic parameters. So alternate day fasting. So this is evidence in rodents and this is evidence in humans. And they have shown that there are really no dramatic changes in body weight. But there is increase in insulin sensitivity. There is no effect in glucose, lipid, or protein metabolism in healthy, lean men. Then there is about so there are many studies, and each study is showing different things. With time restricted feeding, the extended morning fast did not result in compensatory intake at lunch meal in obese individuals. I think that is very important, which a lot of people worry that if I don't eat a breakfast, then when I eat a lunch, I'm going to eat a lot of food and I'm going to undo what I did all through the time. So that is something which is not happening. Eventually, people start eating less. Then there is also religious and spiritual fasting. So there are a lot of, this is a very nice study which shows impact of intermittent fasting on metabolic parameters. And you will see that there is a decrease in HbA1c. It is, so some studies show that the effect on glucose level is neutral. So there are, these are outcome risk factors of cardiovascular disease and type 2 diabetes in 26 individuals of 22 intermittent fasting trial, where they have shown that the impact on blood pressure was neutral, body weight went down, BMI went down, glucose levels were again not impacted, HbA1c went down, and insulin levels went down. And again, this was again about in 5 intermittent fasting trials. Again, there was some data seen. So intermittent fasting in cardiovascular disease also show that people may lose more weight by intermittent fasting than by usual eating over a 3-month period, but not when compared against energy restricted diets for over 3 months or longer. So what happens is both ICR and CCR will cause weight loss. One has to cherry pick people who are good for ICR and who are good for CCR. Now, there are some unanswered questions. Does time restricted feeding during morning, afternoon, or evening have different metabolic effects? Because we know circadian rhythm is a very important thing, and whether skipping that breakfast actually will create less or more weight loss as compared to otherwise. And really, there are no answers. There are studies which show breakfast is important. There are studies which show it is not. So we really don't know. Are weight loss independent effect of intermittent fasting on cardiovascular risk marker and insulin resistance? Can fasting mimic diets, reduce aging or chronic disease? Is there an intermittent fasting protocol associated with higher long-term adherence? So these are some unanswered questions as far as intermittent fasting is concerned. These are positive claims that increase, the popular positive claim is there is an increased weight loss as compared to isocaloric diet. There is no evidence that IF leads to higher energy expenditure. So there is no evidence of that. There's reduced hunger as compared to traditional caloric restricted diet. Again, there are conflicting results. There is improvement in insulin resistance independent of weight loss. Again, in humans, there are conflicting results. Glucose control also, there some RCTs show there is reduction in weight and HbA1c. However, evidence that increased meal frequency is associated with poor glycemic control and anti-aging and anti-inflammatory effects. Now, what are the negative effects of intermittent fasting? So intermittent fasting would lead to overeating on feast day or could trigger eating disorders. Now, this is something which has been spoken about, that when you restrict for a longer period of time, then person tends to binge eat. And again, there is no data shown to show that this happens. Intermittent fasting could reduce lean body mass. Again, results are conflicting. We know when weight loss happens, all fractions of body are lost. So there is fat loss, there is also muscle loss, but whether there is increased lean body mass loss because of intermittent fasting is not known. Intermittent fasting is not sustainable and has high iteration rate. Again, we know people who have been doing intermittent fasting for years together and they're very comfortable with it. And intermittent fasting leads to nutrient deficiency and lethargy. Now, if intermittent fasting is accompanied by a well-planned diet, which is eaten in that 8-hour window, I do not think there is nutrient deficiency or there is lethargy. Of course, if there are OHAs given, then one has to change the doses of OHAs before the person starts doing intermittent fasting. And of course, if somebody has a peptic ulcer, or then one should avoid using IF, one has postural hypotension, then one is to be very important that even though they are doing IF, they need to hydrate themselves well, drink a lot of water. And if one has gout, then they have to avoid dehydration and they have to avoid alcohol while they are doing intermittent fasting. Now, this is a study which was conducted in my center, and I had presented this in the B.B. Tripathi Symposium in 2020, where we had shown that we had patients who were randomized into two groups, continuous caloric restriction and intermittent fasting. All the diets were planned with a 300 calorie reduction as compared to baseline, with 55% carbs, 15% protein, and 30% fat. Diets were primarily low glycemic index and fiber rich in both the arms. As patient had come for a diet consultation, even IF group was given a planned diet and no ad libitum eating. 16:8 regime was followed by individuals who did IF. Continuous caloric restriction group had 3 main meals and 1 snack, which were distributed evenly through the day, and no meal replacement or protein supplements were given. This was the study design, and these were the characteristics. CC group had more females as compared to men, whereas IF group had both in the equal amount. And it was seen that, this was the demographics that, this was the age in years and people who chose intermittent fasting over continuous caloric restriction. And what we saw is, as age increases, people preferred continuous caloric restriction. IF was something that younger people actually like to do. And again, the weight loss in both continuous caloric restriction and intermittent fasting was similar. There was no statistical difference between them. Even in triglyceride, there was difference. And in the change in blood glucose also, I have showed better results than a continuous caloric restriction. So in conclusion of the study, effect of CC and IF on weight loss and metabolic parameters was studied. From current data, it can be seen that there was no statistical difference between both the groups on weight loss, on fasting sugars and triglyceride. Shortcoming of the study was the sample size was small and the duration of the study was small. And therefore, more long-term studies are required to understand their impact. Thank you so much for a patient hearing. I'll be very happy to answer any questions, if at all.
Ma'am, we can take answers at the end of the session.
Yeah, just one sec. I'm not able to, just give me 1 sec. I'm not able to log out. Just give me 1 sec. Oop. Yeah. Okay. Thank you.
So moving to the next session, we have Dr. Kavita Gupta with us. She'll be talking about the nutritional strategies for obesity, pre-diabetes, and diabetes. Dr. Kavita is Director, Head Department of Dietetics and Therapeutic Diabetes Education, Sunil's Diabetes Care and Research Center, Nagpur, Honorary Secretary, Indian Dietetic Association, and she's award winner of Swarn Padak Award for Oral Paper Presentation, IDA Con 2020, Best Indian Diabetes Educator Award, and a lot more. Over to you, Dr. Kavita.
Yes, thank you, ma'am. Thank you so much. I'll just take a minute to share my screen. Yes, 1 minute. Yes, thank you so much, ma'am. And thank you at the outset. I would just like to extend my heartfelt gratitude to Dr. Rajiv Chawla, sir, and Dr. Shalini Jaggi for giving me this opportunity to share my views on a very important aspect, the nutritional strategies for obesity. I will be sharing few very practical tips. And as we all know that the epidemic of obesity is already increasing, and we can see that the obesity has been increasing from 1980. If you see, it's been from 4 to 5%, it's already reached to starting to 16%, whether it's male or female. So it's really increasing. When we also talk about about pre-diabetes, we also see that the incidence of pre-diabetes is also increasing, and where we as a paramedical, we do face, such cases with pre-diabetes and with obesity. So it becomes very, very important for us to for the primary prevention is very, very important, where we need to really focus. When we see we've also seen the prevalence of diabetes and pre-diabetes in this 15 states in the ICMR India Diab study, where the prevalence has actually, we can see all over in the different 15 states, it's almost from 4% to almost 13%. It is prevalent. So we can already see that the prevalence of pre-diabetes is increasing. So why do we need to really detect and treat these pre-diabetes, so that we can actually decrease the complications, maybe at the macrovascular level or even at the microvascular level. So hence we need to understand, and when we see obesity combining with type 2 diabetes, they are at about 6 times more risk of developing type 2 diabetes. So that is why we need to treat pre-diabetes, and there are n number of papers, and the most important paper which we have been really talking about is the DPP trial, which we have seen that the lifestyle intervention was the lifestyle changes could actually show that it could reduce with the intensive lifestyle modification, could actually reduce could prevent them with diabetes. Then we have also the 10-year follow-up, which also showed that the prevention or the delay of diabetes with lifestyle modification or metformin could actually persist for 10 years. Then we have the 15 years trial, which also supports the importance of diabetes prevention. And then we have the Indian Diabetes Prevention Program, which is the IDDP, which again showed that the progression of IDT to diabetes, which is high in Asian Indians, and both the LSM and metformin significantly reduced the incidence of diabetes in Asian Indians. And again, we have the number of trials which shows that the intensive lifestyle modification could relatively reduce the risk reduction to almost, the Darkwing study could reduce to around 42%, the Finnish study is around 58%, and the US Diabetes Prevention Program, which reduced the risk to less than 58%. So there are a number of trials which has shown that lifestyle modification is really, really important. And we have the famous DIRECT trial, which also showed that with the diet, the remission which we are all talking about, that around 46% in the intervention group could achieve remission at the end of 12 hours. And out of this intervention group, the subjects who achieved the weight loss of more than 15 kgs could actually achieve the weight loss, the remission at about 86%. So basically at 12 months, almost half of the participants achieved a remission to a non-diabetic state and of anti-diabetic status. Along with this, we also know that the Indian diet, India is a carboholic country, and our diet is loaded with carbohydrates. And the most famous, the START study, has also shown us that that our diet is loaded with carbohydrate. That's around 70%, whether it's north, south, east, west, and we are a carboholic country. And even this famous the CURE study, which also showed that the carbohydrate content is very high, and it's almost or more than 400 grams in males and 392 grams we are consuming, whereas the ADA recommends that the carbohydrate intake should be the minimum, should be around 165 grams. Now, with all this, we all know that the diet is changing because of the urbanization, and maybe these all are the factors we can say that which is leading to obesity. So can any one single diet can be recommended for the weight loss? So again, there are a number of diets which a patient can adhere to. But again, at the end of the day, we need few practical nutritional strategies which can help us to achieve weight loss. The American Dietetic Association says that a reduction of around 500 to 1,000 kilocalories per day is advised to achieve around 1 kg weight loss per week. So this again is very important if the patient is focusing for weight loss, and the total caloric intake should be distributed throughout the day with the consumption of 4 to 5 meals per snacks per day, with greater energy intake during the day, which should be preferred rather than the evening times. Now, when we're talking about also the weight loss, it can be classified into 3 categories. It can be it can be, the weight loss can be, the manipulation can be done through macronutrient content, which is the green, it can be the low fat, high protein, or low carb, and it can be also the time restricted fasting, which already Shilpa has told, and then it can be also restriction of specific food. Maybe it can be the plant-based or the Mediterranean diet or the gluten-free diet. So we need to focus on few things to achieve our goal. So we can substitute lower energy dense food for the higher energy dense foods, especially I think, and then my plate method is a wonderful way how we can actually tell our patient at our clinic that how they can reduce the energy dense food and they can replace it with more of fiber. They can decrease the energy dense even at the main course. So that's very, very important, because usually when we are hungry, we start eating a lot of carbs. So we need to focus on fiber more than on carbs. Add a low energy dense first course, and we all know about that we need to start with fiber first, and then we need to focus on the carbs. Choose water and other low calorie beverages to satisfy thirst. Include portion control tools, and there are a number of tools which can be used there. There are spoons, there are katoris, there are plate methods. There's so many tools which can be easily, there are hand methods which can be shown to the patient to choose foods. Then we can also choose low glycemic index foods. That's very, very important to reduce your weight and at the same time achieve euglycemia. We need to reduce the carb load. Again, that is very important. So we have to reduce the meal frequency. It's not necessarily that we need to eat. Traditionally, every one of us have been eating 4 to 5 meals per day. But again, it's not very important that we need to do so. We can also restrict our meals to around 3 to 4 meals only, because again, that would lead to high caloric and carbohydrate load. We need to keep a portion control, split our meals, add, especially in the mid meal, we can add a protein or a fruit or a healthy nuts can be added, maybe a roasted nuts or sprouts or almonds or walnuts can be added. When we are talking about beverages, we can also focus on low-cal beverages like your black tea, coffee, or buttermilk or vegetable smoothies to give a satiety, restrict on the quantity, and improve the quality of the carbohydrate intake. So yes, we need to focus more on the complex carbohydrates. We need to add a protein in every meal so that we are satiated and we do not feel hungry and eat frequently. Again, there are a number of studies which shows that the low carbohydrate diet also helps to improve the glycemic control, and it also helps to lower the anti-glycemic medications along with the weight loss. these are simple tips how you can ask your patients to reduce your postprandial blood glucose. So rather than focusing on high carbs like your aloo paratha and white toast or even toast or poha, which has been usually used as a breakfast, we can add a protein and a fiber combination so that we can actually reduce the postprandial spike. So we can add egg. Egg is a wonderful protein, or a paneer or a tofu, or even vegetables like your cauliflower or your green leafy vegetables can be added, and even sprouts can be added to reduce the glycemic profile, the glycemic index of that food. Again, the fruits and the vegetables intake are very low in, especially in the South Asia. So we need to focus on increasing on the fruits and the vegetables. We also need to increase on the fruits and the vegetables. We should also know that for India, the low intake of fruits and vegetables is causing higher deaths than intake of high sodium and trans fats. So hence we need to focus more on fruits and vegetables. And this is a snapshot of the picture which is just taken today by a wonderful lecture by Dr. Anjana, who has just beautifully shown this plate, which will prevent, where we can show that the people, this is the plate for the normal glucose tolerance, and this is the plate with a little modification where we can reduce a little amount of the carbohydrates, increase the proteins, and the fat can be almost the same, and the dietary fiber can increase a little. And this can also help in the prevention of diabetes. Again, meal replacers can be used. So substituting 1 or 2 meals, maybe with the snacks, can be it will be helpful in the weight loss. So it can be in the form of soups or smoothies, or even bars can be actually given to our patients. Then we have this very famous study which also says that the order of eating affects it affects the ghrelin suppression. So that is why we need to focus on fiber first rather than on carbohydrate first. And this is a famous study by Alpana Shukla. We also need to focus on reading food labels. So food labels will also help us to understand the amount of the food serving, amount of the energy in a particular food item, or the carbohydrate content, the sugar content, and the fiber and the sodium content. And there are various guidelines in the food labels which we need to follow. And we have we can follow this table which shows that if the sugar content is 5 grams or less can be taken, total fat should be 3 grams or less, and the saturated fat should be 1.5, or even the salt should be around less than 0.3 grams or less when we are focusing on patients who are hypertensive or with CKD patients. Again, along with the nutritional strategies, I also wanted to focus on this very important aspect is what sitting, which is again rated as a new smoking, and WHO recommends screen-free time of 2 hours. So that's why we need to reduce our screen timing. That's very, very important when we are focusing on weight loss. Then teleconsultation is again a way forward, and this is a very recent case report which is just published, and which has helped us to reduce the weight and the glycosylated hemoglobin, and also the blood pressure of the subject just with the teleconsultation. Again, when we are talking about nutritional aspect, exercise is again very, very important, and aerobic exercise at least 150 minutes per week is very important. Along with that, yoga and tai chi can also be included. And finally, we have this plate by RSSDI which also shows us that the carbohydrates should be limited to around 50%. I would say 50 to 60%, but 50% is better, and increase the amount of the protein, fat. The good quality fat should be focused, and we need to increase our diet and more in fruits and vegetables and pulses. So finally, we need to learn to make our lifestyle changes and not the diet. So when we are focusing for a long time period, we need to focus on LSM. And we all know that there is not an ideal percentage of calories from macronutrients, as there is no one size fits all. So we all know that diet has to be highly individualized, simple, structured, consistent, as per the current eating patterns and preferences and metabolic goals. So everything we need to understand finally that mindful eating is the key to success. Thank you. Thank you so much.
Excellent session, Dr. Kavita, I must say. It was, I feel, a very, very practical session in which you beautifully gave tips on how to manage your diet. Basically, I'll say how to make strategies. And I'm a firm believer of you should know your food, read your labels, and then choose what to eat. And this was what you focused on. And also to reduce the screen time and make yourself on the move. So any questions we have, Dr. Rutul?
Rutul, you're on mute. You're on mute, Rutul.
Yeah. In chat box, I can't find any question as audience is on other side, but you can have your own questions.
Yeah, I have a question. It is great that with all kind of lifestyle changes, of course, we can reverse pre-diabetes, etc. But a person who's following my plate, will they also benefit from doing extra intermittent fasting in whichever way, whichever ratio that we talk about? That's one question. And second question is, how long can we continue this intermittent fasting, if at all?
So intermittent fasting as in time restricted feeding, right? If you don't eat for like 13, 14, 15 hours and eat
or 3 to 5.
So there are people who have done intermittent fasting for many, many years. So, so there is no time limit. Although studies are not long-term, the time limit to intermittent fasting is not there. So, traditionally we know people who never ate breakfast or never ate dinner, and it just didn't bother them. That was
the Jain community. I mean, they eat at they have their last meal at sundown, and they eat the next day.
They eat next day, but there are people who eat at sundown and don't eat a breakfast.
Right.
So that's like a really long period of fasting. Actually, nothing happens. So that's the first thing. And the second thing is, I don't remember. What did you ask? Something else?
Ma'am, how if a person is following the My Plate regime as we tell, so will they benefit extra if they start intermittent fasting along with this?
See, Dr. Shefali, what happens is most of the time people who do IF think that because they are not eating for 16 hours a day, sab paap dhul gaye. And then after that, they are happy to eat everything. So that is not what causes weight loss. If you really want to do weight loss after intermittent fasting, in that 8 hour or whatever 9 hours eating window that you have, it is important that you go by My Plate method. Then you will have effects on CVD parameters, on diabetes parameters, or even if there is no weight loss, at least there will be bettering of metabolic profile and other advantages. Maybe longevity is a very big advantage, which people talk about intermittent fasting. And for all that, you need good doses of vegetable and fruit in your diet and not processed food, like Kavita put in her talk.
Perfect. So I think along with when you eat, sorry, ma'am, go ahead.
Yeah,
please.
no, there are also studies that in IF, like the earlier the better. Like, there are few people, they tend to do IF at later in the evening. So, but there are studies which has shown if you do IF in the early half of the day, you'll have better effects.
So that means it's better to maybe have a very early dinner rather than having a
absolutely
early having a late breakfast.
So circadian rhythm has to be kept in mind while you are doing IF. Yeah.
Sure. Yeah, so I think we can conclude the session because both of them have implied that it's just not important as to what you eat, but it is important how you eat it and what you put in your mouth as well, and when you eat it as well. So I think this is a wonderful session. Dr. Kirti, anything to add?
Okay, thank you so much.
Thank you so much.
Thank you so much. Thank you, Dr. Shalini. Thank you, Dr. Chawla, sir.
Thank you, everyone.
Thanks, everyone, for being here.
Dr. Shilpa, Dr. Kirti,
Great learning.
Dr. Kavita ji.
Thank you, sir.
So thank you very much, everyone.
Yeah.
Yes, thank you very much, everyone. It was excellent session on nutrition. Now we have another symposium on conceptual teaching, and for that we have Dr. Vinod Kumar sir and Dr. Anil Boraskar sir. They are very well-known figure in the field of diabetes, as Dr. Vinod Kumar sir is one of the founder member of RSSDI, and he is a consultant physician and former professor of medicine from AIMS, and professor and HOD of endocrinology, PGI Chandigarh. And Dr. Anil Boraskar sir is honorary secretary and scientific section of Diabetes Association of India and member and executive managing council of Diabetes Association of India. Over to you, both the chairpersons. Thank you very much.
Thank you very much. I am privileged to chair this session with one of the stalwarts of our country, Dr. Anil Boraskar. We have 4 speakers in this session, and their lectures are somewhat related, but somewhat not related to each other. And we have here Dr. Purvi Chawla. Who doesn't know Dr. Purvi Chawla? She is the face of social platforms for RSSDI. Without doing much of further introduction, which is not needed for Dr. Chawla, may I request Dr. Chawla to proceed with her lecture on obesity management as a primary treatment goal for type 2 diabetes mellitus. Purvi.
Good evening, everyone. Thank you so much. Vinod Kumar sir, I'm just humbled that I'm in this session with you stalwarts like yourself and Dr. Boraskar sir, who are chairing. And I'm very, very honored by this opportunity that have been given by Dr. Rajiv Chawla sir as well as Dr. Shalini. And he's been my mentor and teacher, so it's always, I'm always nervous speaking in front of him. But anyway, so I go straight to the topic, obesity management as a primary treatment goal for diabetes. A lot of things that I'm going to say are obvious, but I've just put them all together to drive home the point that we need to start thinking of tackling with obesity as a primary goal for diabetes rather than anything else, because it's almost like एक तीर से कई निशाने एक साथ मार सकते हैं हम. So, you know, it's that one driver which takes care of so many different aspects. Yes, the global challenge of obesity, we know more than 30-40% of the world's population is overweight or obese. And in India too, this is increasing multifold. It's obvious, and we as physicians are dealing with this every single day. In fact, even with the dual problem of malnutrition, whether it's undernutrition or overnutrition, the greatest rise and highest numbers of obesity are now seen in low and middle income countries, and India is in the top 5 out there. In fact, much higher for the prevalence in women, which is also very, very disturbing. Again, the prevalence of obesity in diabetes, and I'm driving home that point because more than 85% of our people living with diabetes are overweight and obese. And in fact, 8 to 10% are even morbidly obese. And I'm sure we are underestimating the numbers here. It's much higher than that. And the bad part is that the projections over the next few years is as bad. We are going to have more and more people with diabetes associated with obesity. And unfortunately, with every unit increase in BMI, the probability of developing diabetes increases 1.5% in those who are already overweight or obese. Again, the number of deaths related with diabetes, which are attributable to high BMI, are also very high in the Southeast Asian region, which includes India. Coming to this very nice term or phrase, diabesity, it is just used to describe the combined detrimental effect of this dual epidemic that we have, obesity and diabetes. Because again, just like I just told you, more than 85% of those with diabetes are overweight or obese. And this number of diabetes associated with obesity is only increasing and is going to be in further millions in the next few years. In every study that has been done to understand the risk factors associated with diabetes, increased adiposity is the strongest one. So this double burden of obesity or adiposopathy and diabetes is synergistic and syndemic in a negative way because they both promote the two core defects, which is insulin resistance and beta cell decompensation. For example, adiposopathy may lead to sleep disorders and inability to be, very active, and also the, social stigma, the impaired mental health, and all this we know feeds into diabetes. Diabetes, on the other hand, feeds further into obesity or adiposopathy. I'm using them interchangeably because that's how it is. This term is coming up very fast because obesity somehow was probably not associated or very well acknowledged as a pathophysiological condition, but adiposopathy clearly tells you that it's a pathological condition where it's all related to the adipose tissue. So in the background of adverse physical environment and also increasingly acknowledged social factors like disadvantage or violence or income inequality, we know that these two epidemics are literally thriving and feeding into each other. Obesity is also associated with increased morbidity and mortality, not just due to diabetes, but also hypertension, dyslipidemia, and cardiovascular disease. And this obesity, especially in the Indian population, is more linked with the abdominal obesity, which is the extra adipose tissue around the intra-abdominal organs, which is referred to as the visceral or central obesity. And this is what leads to the severe and the distinct pathological conditions. Again, the manifestations are myriad, as you can see. Almost everything is affected by adversely by obesity, as you can see, and even the development of cancer in so many different organs is associated or known to arise from the fact that somebody is obese. Well, the origin, the risk factors, and the pathophysiological mechanisms of both are common. It's common milieu. And increased adiposity is associated with increased adipokine synthesis, which leads to increased inflammation. There's increased lipid production. Again, that leads to lipotoxicity and dyslipidemia. And then increase in the activity of the sympathetic nervous system, as well as the renin-angiotensin-aldosterone system, and the mechanical stress of increased weight itself. All those together, they lead to the manifestation of so many different complications. And this is just to stress upon the fact that, right from stage 1, which is at risk, the population, which then goes on to develop pre-diabetes. ABCD is nothing but adipose-based cardiometabolic disease. And that goes on to, further, that feeds, the obesity increases, and then that is related to actually disease manifestation, and then cardiometabolic as well as the biomechanical complications, which is stage 4. All this feeds into the diabetes-based cardiometabolic disease, as we know. So it's very closely or intricately involved, and it's all based with insulin resistance, which leads to pre-diabetes and then diabetes, and then we have the macro and microvascular complications that manifest. So you see, it's all so intricately and closely feeding into each other, just different ways of showing the same thing. Again, as if you look at the top panel, very clearly it shows that increase in adiposopathy is associated with increasing insulin resistance and hyperglycemia in tandem, and reduction of beta cell function, as you can imagine. It's proven. The other thing to note here is that look at the continuum of obesity, and you can see that obesity is like sort of the origin of everything, because metabolic syndrome, pre-diabetes, diabetes, all manifest at some point in the continuum, but it's obesity that's actually there in the background throughout. So, well, at various stages of obesity, you want that you can intervene and prevent the comorbidities or prevent the next stage. Say, for example, if you just, when somebody is starting to gain weight and you can, prevent the comorbidities or prevent further weight gain, you can halt the entire process of developing metabolic syndrome or pre-diabetes or diabetes, and then the related micro and macrovascular complications. This is just to further impress upon that fact. Very specifically, the effect of rise in BMI on the likelihood of being diabetic has also been seen. And compared to non-overweight individuals, the likelihood of being diabetic is more than twice in overweight and obese individuals. With every unit increase in BMI, the probability of developing diabetes is more than 1.5% among overweight and obese individuals and 0.5% in non-overweight individuals. Again, the same thing, that developing more than 90% of our people with diabetes have overweight or obesity, and this is only increasing with increasing BMI. Weight loss now, that gives us a holistic approach to diabetes treatment. If you use the glucocentric approach, then you're tackling probably the microvascular as well as the macrovascular complications. But if you start upstream or you start at the weight itself, then you're tackling so many other aspects of being obese, and the comorbidities like hypertension, hyperlipidemia, as well as the cardiovascular manifestations also, and type 2 diabetes and hyperglycemia as well. The benefits of weight loss have been studied in several well-designed studies. And for example, the Darking study, Finnish DPS study, all have shown that intensive lifestyle change aimed at weight loss has always been associated with significant reduction in the progression of pre-diabetes to diabetes, almost to the tune of 51 to 48%. In the DPP also, it was shown that intensive lifestyle was far better than metformin, but metformin also helped in weight loss and helped to contain the progression to diabetes. In fact, the Look Ahead trial was one where the weight loss benefits were seen they were evaluated to have any effect on the CV outcomes. Even though they did not, it was very, very heartening to see the reduction in weight, the reduction in HbA1c, the reduction in triglycerides as well, the cholesterol as well as the blood pressure. And that was and a lot of increase in healthy lifestyle behavior as well in the participants. So again, a lot of benefits of weight loss. Direct trial again has been a landmark trial in diabetes remission. We all know that. And that was aimed at a 15-kilo weight loss in those participants using the whole meal replacement pattern. And we saw that diabetes remission was very well achieved in those participants as well. Lots of studies. Again, I just want to highlight that more the weight loss, higher the diabetes remission. We also know that weight loss with lifestyle intervention impacts the interplay of the hormones that impact the energy in and energy out. Metabolic surgery or bariatric surgery, which is indicated for those with diabetes with a BMI of more than 40 or more than 35 who do not achieve durable weight loss and improvement in comorbidities with non-surgical methods. Again, these are the ones who really benefit, as there is substantial remission of diabetes and other comorbidities associated with weight gain. Again, pediatric patients may require additional lifelong medical follow-up and management after surgery. But, well, if they were with diabetes, that is what would be required anyway. So again, we have lots of studies that have proven the effect of bariatric surgery in the remission of diabetes. If there is weight regain, yes, there may be some amount of diabetes that develops even post-bariatric surgery. But overall, the micro and macrovascular complications, there is a significant reduction in those with bariatric surgery, and the improvement in quality of life is unparalleled. Weight-independent anti-diabetes mechanisms of metabolic surgery are equally acknowledged now, with a myriad of benefits in the gut microbiota, or the nutrient sensing, or the hormones, or increase in the glucose metabolism, so on and so forth. But weight loss is very difficult to achieve in those with diabetes because of not only sedentary or lifestyle behavior pattern, but also the fear of hypoglycemia that drives some of them to overeat, the burden of diabetes itself, the medications, or even the reduction in glucosuria. Weight loss impacts glycemic control. The methods may be different, but sustained weight loss is the key for those with diabetes, and the amount of weight loss also determines the magnitude of glycemic control. Again, benefits of weight loss, as I already showed you, are much beyond glycemic control. Just to emphasize, look at this diagram, and you can see that those requiring a weight-centric approach to diabetes is far more than those requiring a cardiocentric approach or a glucocentric approach for managing diabetes. Balance is the key. There are some drawbacks, but we need to acknowledge them and then address them as we move on. And one important point that I would like to make here is that how much weight loss is really needed. Well, even 5% weight loss is beneficial, as we've been telling all our patients for years together. But that sweet spot, or something, or the magnitude of weight loss required to achieve all or most of these benefits associated with weight loss, is somewhere around 15%. As you can see on the scale, beautifully outlined by Lingwei et al. She even presented an oration at the ADA this year, and it was, I think, a very, very moving oration for those dedicated to the research of obesity. Well, so far, there were gaps in our obesity treatment, and we all have known that. Lifestyle modifications, as sustainable as they may be, they help us to achieve minimal weight loss. And then when you add drug therapy, well, yes, up to 10% is also possible. And then the surgical procedures were the only ones available so far that would help us to achieve that 20 to 30% weight loss. But we are in an extremely exciting era where we have new combination pharmacotherapy that's available now, and it's developing, it's in the pipeline, that's going to help us, and that's already been proven to help us achieve up to 20% weight loss, which was something in the past that was seen only with surgical procedures. So this is something that's very, very exciting. And I think this is also one of the reasons why we physicians are actually talking about weight loss as a primary goal to manage diabetes, as opposed to the conventional drugs that we had, which were actually making the patient increase weight. We have the newer medications that are either weight neutral or definitely associated with weight loss. Especially, I'd like to highlight the SGLT2 inhibitors, the GLP-1 receptor agonists, the amylin analogs, and also the GIP and the GLP-1 receptor agonists, unfortunately, which is not available in India, but will come soon. And even a good old metformin. Well, amongst the anti-obesity drugs ruling the world right now, tirzepatide is really exciting. It's approved for diabetes, but it's been one of the first molecules to actually show up to 20% weight loss in the trials and in the clinic. And that has been compared to sleeve gastrectomy results. So very, very exciting. Yes, adverse events are there, But I think somebody who's dealing with obesity and diabetes probably can learn to deal with the adverse events as well, with the help of a physician guiding all through. Again, the role of anti-obesity medications and its role in diabetes prevention is being studied. You can see that there are significant reduction in the incidence of developing diabetes itself, especially that has been seen with orlistat, liraglutide, phentermine, and topiramate combinations as well, and many other trials are underway. Their effects on HbA1c are in tandem with the weight loss that you see at year 1, and more than 50% are achieving more than 5% weight loss as well. On the horizon, this is very exciting. Multi-agonists are in development. The GLP dual agonist, the GLP glucagon dual agonist, the GLP GIP glucagon triple agonist, and many of you may be investigators from India on the semaglutide 2.4 milligrams and the craglintide 2.4 milligrams as well, because that's showing very promising results after tirzepatide. And yes, so these are the things that we welcome on the medical aspect of dealing with obesity. So again, if you have to look at the phenotype of the disease and sort of categorize that, then you can see that the adipose-related diabetes, as opposed to that with cardiovascular disease or just isolated hyperglycemia, this is a different approach to looking at diabetes. Is again, we can see that 40 to 70% of our patients would benefit from a weight-centric approach of managing diabetes. And in fact, those with cardiovascular disease, they are also going to benefit largely from the weight-centric approach as well. So again, the consensus for glucose-lowering medications in type 2 diabetes, we've always looked at the comorbidities and looked at prioritizing drug therapy that offers cardiorenal protection and cardiorenal benefits. But yes, these are the same drugs that are also to be preferentially used when it comes to causing weight loss or even preventing further weight gain. So you can see all the factors, patient as well as disease factors here, that determine optimal glycemic targets, and the characteristics, towards the left, these are all where we require more stringent control of A1C, and towards the right are those that probably can do with a less stringent A1C target. But weight loss is, once you achieve weight loss, then all these targets can be optimized and everything can just align with weight loss itself. You may not have to even consider these other factors. So in summary, weight loss is the primary target for the treatment of type 2 diabetes. Well, it treats the disease pathophysiology at its core. There is reversal, remission, and of course, glycemic improvement that has already been proven. It minimizes the progression and the manifestation of diabetes-related complications. The benefits are far beyond diabetes or glycemic control alone. And the weight loss goal definitely needs to be individualized. However, it's the 15% sweet spot of weight loss that leads to remission of adiposopathy-associated conditions in the majority of patients. And patient selection will be based on phenotype. So we'll start looking at patients in a slightly different manner, not the absolute BMI, of course. But most patients with diabetes will benefit from weight loss. Of course, it should be applied concurrently with all other applicable disease targets. You're not going to ignore other complications. And effective treatment options exist already and are on the horizon and will be coming soon to India. With that, I thank you very much once again, Dr. Chawla sir, Dr. Shalini, Dr. Hassaneen, who also has been my teacher, and the team for this opportunity, and you all for the patient hearing.
I think, Purvi, you have handled this topic so well. I really wonder what the other people have left to talk with, because you have practically covered every aspect.
So obesity is over.
I personally feel there is one issue. See, I am a garbage bag of diabetes. As you go senior, all complicated patients come to us. And primarily when the patient comes to me, he has already got 4 or 5 pathies. And the only thing I can offer him is sympathy. Now, point is, there is one concept which has really bothered me, is as you thrive at HbA1c coming closer to target of 6.5 or 7, there is a HbA1c kg paradox. Now, this is very interesting. Patient is referred to me across the country for control of sugar, which is not coming under control. All that the person wants is that his HbA1c comes to target with all my gimmicks and various permutation and combination, and particularly various insulin dosage. Now, many of my patients who already got an early nephropathy, neuropathy, at least 1 or 2 heart attacks, or underwent the CABG. Now, these people want their HbA1c to be brought to target. You try to do that, more than 4 to 5 kilos weight is gained at the end of the treatment. How do you handle this HbA1c kg paradox? This is a big dilemma I'm facing, and I'm sure with your vast experience in this field, I would like to know exactly how do you handle this situation, Purvi?
So that's a brilliant question. My experience compares nothing to anybody else here on the screen, but just my 2 pence I'd like to share. I would handle this, of course, we have to individualize therapy again, each case. And as much as we say that, yes, let's use the newer agents available, SGLT2 inhibitors, GLP-1 receptor agonists, we are often not able to do that in a lot of patients because of various reasons. Not just adverse events, but because of various reasons, we may not be able to use them. In those patients, there are a multitude of other ways also of losing weight. One has to just continuously, engage in the patient and, keep that dialogue on. And that minimal weight gain also we can keep tackling with one or the other method of weight loss, whether it's intermittent fasting. We had a beautiful session just before this, or whether it's meal replacements. Again, we learned about that as well. So a lot of other aspects can be spoken about with the patient, and the patient can be helped. It's not just drug therapy. It's not just medical therapy or surgical therapy that we need to talk to the patient about. And then look at any other cause also. Even the mental or the psychological causes also need to be looked into.
Thank you, Purvi. You've handled it very well. Over to my co-chairman, please introduce my great friend Samar Banerjee. It is a great pleasure. I have been with him many times in many sessions. He's a brilliant speaker, and he's a past president of RSSDI, IPSI, Indian Society of Hypertension, President, Association of Clinical Diabetology, Editor-in-Chief, Journal of Clinical Diabetology, authored 9 books on diabetes, and so many things. I think we will not narrate all his achievements. It will take one full session for that. Over to you, my dear friend Samar Banerjee, for your eloquent conversation and information. Samar.
Today I am very proud. I have got a session under Anil Dada and our great Vinod Bhai Sahab. Both are very old and I should call it as cheerleaders of our RSSDI. Thanks to Rajiv and Salini to some extent. Great to Rajiv and some to Salini. Today I am going to discuss the points just after obesity discussion. Responders and non-responders to SGLT inhibitor and GLP-1 receptor analog. Just to create the background of the SGLT inhibitor, glucose is filtered through the kidneys daily in subjects with normal glucose tolerance. So most of the glucose that is filtered in the primary urine in the glomeruli is reabsorbed back into the blood in the proximal tubule via SGLT.
So share your slides, sir. Share your slides. You haven't shared your slides.
I have shared.
Please unshare and share again, sir. They are not visible.
In between there, put your CV slides, so your slides.
Is it visible now?
Yes, sir.
Put it in slideshow mode.
Okay, it is now visible.
Yes,
Yes,
sir.
sir.
Okay, thank you. In healthy subjects, glucose is excreted in the urine when the plasma glucose concentration exceeds 180 milligram. In patients with high plasma glucose level due to poorly controlled type 2, the filtered glucose is more excess and leads to subsequent gross glycosuria. Hyperglycemia may be reduced by a decrease in glucose reabsorption via the SGLT2 receptors in the proximal convoluted renal tubules T1 and T2 segment. In this way, SGLT2 inhibitors act on this receptor and they prevent the reabsorption of glucose from the tubule, produces glycosuria, and finally lowers the blood sugar. In patients who receive SGLT2 inhibitor, the amount of glucose excreted depends on the level of hyperglycemia and the glomerular filtration rate and is approximately 80 grams per day. Numerous studies showed that they reduce the proportion of A1C up to 1.03 in monotherapy and by 0.7 to 0.93 in add-on therapy with other drugs. They also reduce body weight, and SGLT inhibitor, they improve insulin sensitivity, they reduce glucotoxicity and cell function, they decrease hepatic synthesis and increases the catabolism of triglyceride-rich lipoprotein. They also affect uric acid level. Due to the diuretic effect, they also lower blood pressure to 3 to 6 millimeter. But these favorable effects are not constant in all patients. I'll show the data, how much they are working. And there are limited reports in the literature regarding the glucose lowering effects of SGLT inhibitor in actual clinical things. In addition, they have beneficial effect on cardiovascular disease, blood pressure, hepatic steatosis, visceral fat mass. Now we are getting reports on the Alzheimer's disease and also the cerebral stroke. However, inter-individual difference in response to treatment with them may present in everyday clinical practice, and good predictors of glycemic response and the risk for adverse events in an individual patient are lacking. These are costly drugs except dapagliflozin at present, and the results are successful up to 70% cases. Lest we are losing, we usually give the drug, wait for several months, and then we change. And moreover, in the meantime, they can do something harm than doing the good. But a study which assesses the response to DAPA after 12 weeks, A1C and BMI index was significantly decreased from 8.1 plus minus 1.3% to 7.5 plus minus 1.2. And also BMI came down from 28.1 to 27.6. Both body weight and A1C was reduced to 67.7%. And A1C in 75%, that means about 7.3% patient had no response to weight, only to A1C. Who are the responders in this study? Younger age, male sex, shorter diabetes duration, higher baseline A1C and higher GFR, and having dapagliflozin as add-on therapy. They had stronger A1C reduction. Moreover, subgroup analysis of eGFR with renal hyperfiltration, eGFR more than 120 showed the largest reduction in glucose excretion. Multivariate logistic regression analysis showed the recent type 2 diabetes diagnosis. That means if you start earliest and higher A1C level, they have got with add-on DAPA therapy, they have got better result. Another retrospective study showed that the only higher baseline A1C and preserved effective GFR, that is, if it is up to 90, had positive correlation with glucose lowering. In a pooled analysis report, A1C lowering effect was decreased as eGFR declined. A Japanese pilot study showed that the renal threshold of the glucose slope was significantly steeper in young, that is below 40, compared with older adults, suggesting that the larger response of urinary glucosuria in the young accounts for the better response of the SGLT inhibitor. Higher A1C level decreased from 7.5% in this study and baseline to 6.9 after 3 months of SGLT therapy. Out of 20%, 16 with type 2 showed documented treatment response and 4% showed no change or increase in A1C level. That means 20% patient are non-responders. A significant negative correlation was found between the baseline A1C value and the reduction of A1C after 3 months of therapy. Non-responders had a significantly higher weight of 110. So initially, if the body weight is more than 110, this study shows they are not properly responding. Regarding glucose analog 2-deoxy-2-fluorodiglucose, we call it as FDG parameters, renal function measures such as mean transit time at baseline and 2 weeks after the initiation of therapy with the SGLT inhibitor was not significantly different between therapy responder and therapy non-responder patients with type 2. But general renal performance, we call it as GRP among responders, was significantly higher after therapy as compared with baseline. However, no linear correlation was found between A1C reduction and GRP increase in the responder group. Also, no relevant changes in GRP values were observed among non-responder patients before and 3 months. So the glucose excretion values does not predict whether the reabsorption will be prevented by SGLT inhibitor or not. This is another study which showed that in young patients, larger response of urinary glucose excretion. Another study by John Dennis et al. Demonstrated that routinely measured clinical feature of people with type 2 diabetes are associated with differential A1C response to SGLT inhibitor and DP4 therapy. They compared between these two drugs. By developing an algorithm, they created one formula combining A1C, current age, BMI, eGFR, and ALT. They identified a large group of people, 40.8% of UK patients, initiating this therapy with a predicted glycemic benefit more than 5 millimole per mole and greater weight loss on SGLT inhibitor compared with DP4. So they have created a formula. I think this should be well established in larger studies, and by putting this data, we can say that which one is responding or not. They also found a small group of patients with 16.5% of UK patients, so around 1 in 6, with a 50% lower risk of short-term discontinuation of the therapy. The remaining patients have a similar glycemic response and similar risk of treatment discontinuation. Using data from this study, 10,414 patients in 14 randomized trials and 26,877 patients in UK primary care, they showed that notably glycoted hemoglobin and kidney function are robustly associated with differential A1C. So higher A1C and better GFR. Combining clinical features into a multivariate treatment selection model, they showed a better and good results. Jimdal et al. From a cohort of 2,600 metabolically well phenotyped individuals at increased risk for type 2 studied the genetics. They investigated 5 single neuron protein, we call it as SLP, in the SLC5A2 gene. This is responsible for SGLT activity. This gene presence influence diabetes-related metabolic traits like body fat, insulin sensitivity, resistance, insulin release, A1C, plasma glucose, or systolic blood pressure. The investigated SNP did not interfere with the response to MPA treatment in type 2 diabetes patients and were not associated with A1C levels, fasting glucose, body mass, or systemic blood pressure in MPA treated patients. These 5 SNPs that present, results will be better. Now I am going to another molecule, GLP-1 receptor analog. Clinical research conducted over the past 30 years has established that there is a wide recommended class of glucose lowering agent. The best representative of this class are capable of lowering plasma glucose comparable to insulin regime. Now it is coming before insulin because it does not produce obesity or hypo. But with a lower risk of hypo and the added benefit of weight loss, the ability to prevent cardiovascular events in high-risk patients has re-emphasized the particular benefit. They are also helping in the non-alcoholic fatty liver disease. Kenjiro Imai et al. In patients with poorly controlled diabetes studied, and findings suggest that do not tend to respond well to GLP-1 receptor agonist therapy. Who are they? Will not respond. We have received previous treatment for diabetes, particularly beta stimulants, sulfonylurea or insulin, other than diet and exercise or metformin, who have a high BMI and who have a high mean preprandial blood glucose. The response was not significantly associated with the duration of diabetes or the glucagon stimulation test result. receiver operating curve analysis showed that the mean preprandial blood glucose level had the highest area under the curve for the prediction of non-responders. Another study, Elena, by you et al., treatment with GLP-1 is effective only in 50 to 70% of the cases. 30% this costly drug is not working. Taking into account the high cost of this medicine, discovery of the predictors of optical response to treatment is required to identify the predictors of the greater impact of GLP-1 on A1C, weight reduction, and improvement in lipid profile. The study group took into account 40 patients of type 2 with obesity. The follow-up period 24 hours, weeks. Patient evaluation was conducted at baseline and after 24 weeks. It included the assessment of the hormones in the glucose and lipid metabolism and appetite regulation. Patients with initially higher BMI, higher glycemia, and higher triglyceride had better response to GLP-1. They had BMI loss more than 5%, GLP-1 and fasting ghrelin level associated with obesity were higher, and ghrelin level in post-nutritional status was lower. A1C level decreased more in patients with higher GLP-1 level. Responders had lower baseline fasting plasma glucose with lower GIP level and postprandial ghrelin level. Evaluation of the glycemic control, lipid profile, GLP-1, GIP, ghrelin are usable for estimating the expected efficacy of a GLP-1 receptor response. MicroRNA, small non-coding RNAs, proposed as useful diagnostic or prognostic markers and for the responders. They investigated the expression profile of 8 type 2 diabetic patients with circulating RNA in 26 prospectively evaluated diabetic patients. They studied 8 RNA profile in 26 patients. Revealed that microRNA, high expressing and low expressing, two groups. Interestingly, a significantly higher percentage of patients in the high expression group reach the glycemic target. That means higher expression of microRNA means better result. To predict the likelihood of an early treatment response to GLP-1 receptor agonist, the microRNA will help. They will help to select patients immune to start his treatment and paving the way to personalized treatment. Reduced glycemic response to GLP-1 receptor analogs was associated with another study by Sanders G. Longer duration of diabetes, better result. Insulin co-treatment. Reduced response in cases of longer duration of diabetes, insulin co-treatment, lower fasting C-peptide, lower post-meal urinary C-peptide to creatinine ratio, and positive GAD or insulin autoantibody, islet cell antibody. These 4 are present, response will be less. Participant with positive antibody or severe insulin deficiency, lower response. These markers were predominantly present in insulin-treated participants and were not associated with weight change. C-peptide autoantibodies represent potential biomarkers for the stratification of glucose-lowering treatment in insulin-treated diabetes, and lower C-peptide and higher antibodies means less response. GU1 from China, the heterogeneity in response to GLP-1 receptor agonist may be potentially related to gut microbiota. Microbial composition of 52 patients with type 2 diabetes receiving GLP-1 were determined by 116S RNA, recombinant RNA amplicon sequencing. Bacterial biodiversity was compared between responders and non-responders. Beta diversity significantly differed between GLP-1 receptor analogs, and I will show that which microbiota will help. Bacteroides dori, Rosewaria in Inulinovora, the 2 microbes having immunomodulation effect, along with Laconoclostridium and the Butyriccoccus were positively correlated with glycemic reduction. That means more these 4 bacteria in the gut, better response. On the reverse, Prevotella capti, microbe related to insulin resistance, together with Ruminococci, Bacteroides, Eubacterium, etc., they are concerned with non-responders. Furthermore, Bacteroides dori, Laconoclostridium, etc., were significant after adjusting for baseline glycohemoglobin and C-peptide responses also. This is a study for liraglutide specifically. The objective of the study was to identify the baseline patient characteristics who will respond. Different effect of liraglutide seen on body weight and A1C. Someone responding to body weight, someone responding to A1C. Weight reduction was dose dependent. Liraglutide was not effective in patients where BMI is more than 45. This we see. So with the SGLT inhibitor also, very high, more than 110, less response. Baseline A1C is significantly correlated with the A1C. Higher A1C, better response. Lower leptin and higher GLP-1 concentration, better response. Liraglutide is probably more effective in patients with BMI 30 to 45. You go before above 45, response is less. Below is response is less also. And response is better with the dose schedule. Best result when it is more than 3. BMI is significantly predictor of response to GLP-1 receptor. This is another study by Musikian et al. Better result again 30, 45. A1C value of at least 8 will receive the greatest anti-hyperglycemic benefit. That means above 8. In non-type 2 diabetes mellitus group with obesity, the significant factor associated with the treatment response is the level of leptin in the blood. The main leptin level in the blood of responders was lower. So lower leptin, better response. And also higher GLP-1 level in the blood, better response. Again, come to genetics. Genetic evidence supporting a role for the human pro-glucagon gene encoding GLP-1 or the GLP-1 receptor in the susceptibility to diabetes or obesity is protected. Less information is available surrounding the genes determining the GLP-1 pharmacotherapy. Acute insulin response to GLP-1 infusion over 3 years was seen with the genetic sequences of RS 6923761 and 3765467. However, when genetic variation, GLP-1 receptor predicts the magnitude of the glucose lowering or weight lowering response in the subset of individual remains to be determined. That means we need further more data. Another data, similar response with the RS-H2028777, which I just mentioned. So presence of these genetics, better glycemic control, higher baseline A1C and lower baseline weight were associated with better glycemic response to liraglutide with this response. Another study, genetic variability. I am doing more boring with the genetics. A carrier of at least polymorphic RS6922761, RS103540, they are better response, they are showing. Gastrointestinal adverse events were transit and balanced between strong and poor responders. Single GLP-1 receptor analogs exert their biological effects by interacting with GLP-1 receptor. I'm not going to details of the genetics. Pharmacogenetics, you know, as we treat urinary infection, after doing the urinary culture sensitivity, time is coming when we select a drug after the pharmacogenomic study, which will predict which drug will respond and which will not. From the very beginning, we will not be the wrong way and select the correct drug. Available evidence suggests that involvement of genetic polymorphism in GLP-1 receptor gene and variation in glycemic response, metabolic parameters, gastrin and P in people treated with liraglutide. Polymorphism in CNR1, CTR, B12, TME, M114, etc. These are all goes in favor of better responses. Inter and inter-individual variability. Men had higher active GLP-1 concentration than women, so better result. Inter-individual variability of basal and stimulated active GLP-1 concentration. Inter-individual variability is low, consistent with slight physiological regulation. Finally, I want to show not only for the SGLT inhibitor GLP-1, potential factors which determine the weight changes with the drug. They are the pre-existing factors. Age, I have just mentioned, better in male, better in younger group, sex, better in female, socioeconomic, psychological test, comorbidities, baseline body weight, above 110 or BMI more than 45, result is poorer. Physical activity, better results. Then diet and genetics have discussed. What are the factors that depend upon the drug, whether body weight will lower or not? Mode of action, pharmacogenetics, pharmacogenomics, prescribing habits, adherence, compliance, and compensatory changes are physical activity, energy intake, substrate utilization, resting metabolic state. Invariant natural killer TINKT cells which resides in adipose tissue and acts as adipose tissue regulators are required for the full weight loss effect of GLP-1. In the absence of this killer cell, GLP-1 therapy is 30% less. And finally, I conclude that GLP-1 analogs, all drugs, I think you know about the oral semaglutide, very costly drug, and all the SGLT inhibitors except DAPA are very costly. If we can come to a point very successfully to determine at the beginning which drugs will respond, which patient will respond, which not, we will not unusually spend time and money waiting for 2 to 3 months for the result. I think the future will give us a formula or a marker, concrete marker where we can predict and start being sure that this medicine will result in a better response, patients will be benefited, and will be also greeted by the patient that, sir, you have given the best drug. Thank you for your patient hearing, but I express my heartfelt regards and thanks for all the people who have read my books. This is my last book, Neurodiabetes, 9 books. I'm trying for the 10th. My friends have requested for 10-digit books. I express my gratitude to all for giving me the chance. Thank you. Thank you for your patient hearing.
You know, Samar.
Yes, sir.
That was a real, that's why I call you a Pandit. You know, I have really heard each and every word that you spoke just now. I am very frank and a very, very honest man. About 20% of what you have said, I have understood. 80%, I would need to read again and again, such a scholarly presentation. Believe me, the exhaustive amount of work that you have put in getting these slides and presentations is just unbelievable. And no wonder the people from Bengal and Calcutta, they don't come to Bombay anymore. They're just very happy with the diabetologists sitting there, and particularly you as a professor. I tell you, this has been a fantastic presentation. I'm sure Dr. Vinod Kumar will have to add something to that. Over to you, sir.
Anil Dada, if you want, you can send your email. I will send you all the papers and if the slide. Rajiv is very, very naughty person. You will give me always the difficult topics which I will not accept. I was becoming a mad how to go for these topics, but I requested so many people, but with help of some persons and my own debut, I collected the papers. There are more information, but by the time I think I've been able to pass the message with the clinical parameters, the age, sex, body weight, etc. What you can do, not the genetics.
Dada, that is why this topic was given to you only. No one could have done justice to it.
Genetics is not very easy to done, but at least A1C level, etc. Fasting plasma glucose, you can assess that the drug is going to work for the patient. And best Professor Dr. Vinod Kumar is very senior. I am here. We are all here for the patient. They made me famous. They made us famous. They placed us in a better position. It is our social responsibility to help them with our knowledge, efficiency, etc. Thank you.
Thank you, sir. Thank you.
I would like to remind Dr. Anil Boraskar that Bengal is the seat of initiation of diabetes research in our country. 100 years before, it was Bombay people who were going to Calcutta. Calcutta people were not coming to Bombay. So Calcutta has a high heritage about the history of diabetes research. I have gone through this history in quite a great detail. And I totally echo the remarks of Dr. Boroskar that nobody could do better than Samar Banerjee to put such a extensive data and a very convincing data with evidence support that how to identify non-responders. And this is particularly important for expensive drugs like GLP-1 and SGLT2 so that we could target the correct type of patients for initiation of this therapy. It was an excellent presentation, Dr. Samar Banerjee. I would like to profusely congratulate you. Thank you very much.
I would like to
I just like to add one point. Why people from Calcutta is going to Bombay. In our part, till then, the highest number of people worship Ma Saraswati. Mumbai people, they worship in highest number Lord Ganesha. We say God for business. Now Bengali people have started worshipping both of them, so business will improve. Thank you, sir.
I have to add one more suggestion to Dr. Chawla and Shalini. I think you please consider one more session or probably a symposium only on Dr. Banerjee's talk.
We will have a separate webinar for that.
Pulse of wisdom that we got from Dr. Samar Banerjee. That can be one full session.
It will be anti-mortem or post-mortem.
Let's go to the next session, sir.
Thank you very much, Samar.
And we are fortunate to have him in next week. Physically, we are meeting him.
Yes.
Yes.
We are all coming to your state, sir.
So
over to Dr. Vinod Kumar to introduce this brilliant speaker. I think you will do a thorough justice to his biodata.
Oh, it's a long biodata and appears to be a very impressive biodata.
Very.
Professor Atul Kalan, who is a consultant diabetes and endocrinologist from Royal Glamorgan Hospital, Wales. The place, same place where Dr. Chawla and Shalini Jaggi from Cardiff, they have been associated. And he is a visiting professor, University of South Wales. And I think without reading his all biodata, we feel very fortunate to have Professor Atul Kalan to be amongst us and would be speaking on his topic. So kindly over to you, Dr. Kalan. Please give your lecture.
Welcome, Dr. Atul. For
Thank
people
you,
who
Shalini.
don't know, I think he's also been my teacher and guide during my course, and a great endocrinologist and a great human being, and especially somebody who's very fit, runs marathons.
Welcome, Dr. Kalan.
Thanks a lot, Dr. Rajiv, Dr. Shalini. It must be very late Sunday evening at the moment. I think India has already started well.
7 p.m.
I know we are in semi-final of World T20. Bit disappointing that we lost one of the matches. We are looking forward to winning the cup. And in 20 minutes in Bhubaneswar, there is a game of hockey which is going to be played between India and Spain. So I'm a sports fanatic altogether. So I can, rather than talking about pitch tree and pancreas, one of the days I can fill you up about hockey, cricket, tennis. Anyways, thanks a lot for giving me an opportunity to speak in here. I thought I'll just change the flavor here. I've heard talks from esteemed colleagues about diabetes management, SGLT2s, GLP-1s. I'm just trying to change the flavor to a bit of endocrinology here. So next slide. Anyone can control this slide? Next slide, please. Thank you. So I want more faces in here. Shalini, don't disappear. I saw Purvi also and a couple of other people around. It's much better to talk to an audience than me talking to the wall in my own study room. So I'll prefer people to be switched on. At least I'll see them and ask questions, and it will give me a bit of stimuli. So when you think about pituitary gland and the pancreas, what comes to your mind? I can ask Purvi, she's listening at the moment. Dr. Chawla, what do you think? What comes to your mind? And, I'm not asking to test your knowledge or anything. I'm just trying to build a forum and platform to talk about. Is there any context, or is it just my figment of imagination to join two topics, pituitary and pancreas, and create a talk out of it? You're at silent mode, Purvi? anyone who wants to take it up, or as I said, I'm keen for people to interact in here. Anyways, next slide, please. So around 83 years ago, in New England Journal of Medicine, there was a mention about pituitary gland linked with the pancreas. So that was the era. There were lots of animal-based studies. Now, it was interesting to note, I'm not going to read the whole paper, but if you take the pituitary gland, anterior pituitary gland, away from an animal, they were more prone to develop insulin-induced hypoglycemia. In addition, if you gave anterior pituitary extract in these animals, their glycemic control worsened. So even about 80 years ago, there was an interest in the anterior pituitary extracts and the hormones being produced from them having an impact on our glycemic control. And, next slide, please. So in diabetes clinic, when we are sitting in, 99.9% of the time, we'll be dealing with type 2 or type 1 diabetes. The joy of being a diabetologist or an endocrinologist is challenging the diagnosis to begin with. Are we clearly thinking it's type 2, type 1? Can it be monogenic diabetes, mitochondrial diabetes? Is it secondary diabetes due to something wrong with the pancreas? As an endocrinologist, it's exciting to know that there are other things which can lead to impaired glycemic control. So I've just created 2 clinical scenarios. I want to keep things very simple. Both the clinical scenarios are based on real life experience. So a 35-year-old comes to the clinic with aches and pains, arthralgias, on 2 medications, oral medications, metformin and glimepiride, and premix insulin. Body mass index 24.5 kilogram per meter square, and the glycemic control is poor. No family history of diabetes, nothing coming in. And this is an individual who was seen on multiple visits prior to it. So let's say it's about 2 years since the diagnosis. 9 out of 10 times in our practice, we probably will think about the compliance, we'll think about going through the injection technique, maybe switch him to SGLT2. His BMI is 24.5 kilogram per meter square. It's a Caucasian individual. So I'll say it's within the normal range. So anyone who wants to interact here? Okay, let's move on to the next slide, please. So when we investigated this individual, there was nothing clear, as you can see from the history, rather than the arthralgia, non-specific complaints per se. His prolactin levels were mildly elevated. His TFT were within normal range. His IGF-1 levels were elevated. 9 AM cortisol, not a very good test as such for excluding ACTH cortisol deficiency, because the results can be equivocal. But in this scenario, it was more than 310, and this is what we normally are using to establish the integrity of ACTH cortisol axis. So next slide, please. So, it's very difficult to do an online talk because there is no interaction here. But in this kind of patient who was being followed up in our diabetes clinic, when we put in our endocrine hat, we were able to establish the diagnosis. In a sense, we investigated him further. He turned out to be acromegalic, and as we know, the diagnosis of acromegaly at time from onset of symptoms to the point when it's established it takes 5 to 10 years. So in a sense, my question here is, how does the growth hormone excess influence the glucose metabolism? What are the things which we have to keep in mind to pick these individuals in our practice? What are the clinical characteristics which come to our mind? And then how is the treatment going to be different from people without growth hormone excess? So next paragraph, next slide, please. So in a sense, in clinical practice, we do know acromegaly is extremely rare, but it's immensely satisfying diagnosis. I think we probably diagnose maybe 3 to 5 cases per year locally. Probably there are cases which are missed, and part of the problem lies with the primary care not picking up the symptoms, because to begin with, the classical signs, the prognatism, the change in the jaw, change in the size of the ring finger, shoe size, they are very subtle signs. They are soft tissue signs. They may take long for us to pick it up. The active acromegaly normally presents with headache, sweating, and arthralgias. These are the signs of active growth hormone excess. Most of the time, the only characteristic which can give you help in clinical practice is these are the individuals who are relatively lean as compared to typical type 2 population we deal with. It's not excess visceral adiposity, it's the metabolism of glucose at liver level and insulin resistance, which is the key marker in these individuals. So normally, individuals with acromegaly present with a relatively lower BMI as compared to typical type 2 population. They are relatively younger also. Next slide, please. So I'll not go into pathophysiology at 7 p.m. in India, because this is not the time for you to waste your Sunday evening going through deep pathophysiology. But in a sense, we do know growth hormone stimulates the gluconeogenesis, induces lipolysis, and leads to insulin resistance. Next slide, please.
So may I just ask you a question?
I love questions, Dr. Chawla.
Great. So, sir, before you go into the details of acromegaly and glucose disorders, so would you just tell me why, yes, the patient was referred to you in the diabetes or endocrine clinic, but why exactly did you, what is the differential diagnosis? If you can just quickly run over that. Because I can completely vouch and tell you that nobody will think of acromegaly at the first stage the way you have picked it up. So, sir, if you can guide our physicians on, what would the differential diagnosis be?
Thanks, Dr. Chawla. And let me tell you, it took us 2 years of clinic visits before we picked it. Patient was being reviewed by our Thursday morning clinic, and this is a case from University Hospital a few years ago. We've got a Thursday morning diabetes clinic. Patient was coming in, being followed up every 6 months. There was an escalation of level of glycemic control from metformin, glimepiride. You can see this is around 2011, 2012, if I'm not wrong, or around that time. So we were not using as much. SGLT2s only came to UK in 2012. So I've not mentioned about use of that medication. After SUs had failed, we went on to premix insulin. The key thing was, as I've shown in this slide, that patient was relatively lean. And in my mind, I was thinking about that, is there something else going on? It's not looking like a monogenic diabetes. It's not latent autoimmune diabetes of adulthood. We did anti-GAD antibodies, which were negative. Men, mitochondrial diabetes, extremely less likely. Again, this is theoretically not possible. So we started to think that this patient is requiring higher and higher dose of insulin. And I don't remember the body weight of this patient exactly, but the insulin resistance meant that the patient was requiring more than 1.5 unit per kilogram body weight. So when you see somebody relatively lean and thin, you've excluded latent autoimmune diabetes of adulthood with anti-GAD antibodies, or whatever way you want to do it. 5 years from onset of symptoms, you can even do the urinary C-peptide level. But in this, we thought more about growth hormone excess or cortisol excess as a reason for such high insulin resistance. So the question which was coming to our mind was, why is this patient having such severe insulin resistance? What is driving it? So simply saying that, as I've mentioned in this slide, that these individuals are relatively thin, right? And they present at a relatively younger age group. As I said, the patient didn't have the classical phenotypic feature of acromegaly. IGF-1 was marginally elevated. And as I mentioned before, it takes about 5 to 10 years before we even pick up acromegaly from the time of onset of symptoms. So,
excellent.
It's not, it's just lucky. We, as physicians, as clinicians, we shouldn't take credit for anything, because if we, in a way, it protects us from not taking discredit for things when they go wrong. Next slide, please. So, yes, the treatment, obviously surgery and somatostatin analogs have a role for the disease which is residual or not cured by surgery. We do know somatostatin analogs bind to the somatostatin receptor 2 and 5. There is theoretical risk of hypoglycemia, and disease control and lower BMI are predictive for glycemic improvement. Next slide, please. So we've got option of pasireotide, but it again, in setting of type 2 diabetes, it leads to more hyperglycemia related adverse events. So ideally speaking, everyone with acromegaly, should be cured by surgery. But if there is no cure which is achieved, you go for medical management, with somatostatin analogs being first line. But pasireotide is something which is not preferred because it's associated with more hyperglycemia related adverse effects. So we've got pegvisomant in such scenarios. Next slide, please. I'm very conscious of time. I've got 5 minutes left. So just to sum up, I wanted to change the flavor altogether here. Acromegalics, 12 to 37% have type 2 diabetes. Impaired glycemic control is even more common. Growth hormone leads to insulin resistance. I mentioned about the surgical cure, which is preferred, and somatostatin analog for medical management, with pegvisomant being the second line agent. Let's move on to the next one. Next slide, please. So, second clinical scenario. As I said, I've got only 2, and I'm conscious of the 4 minutes I've got left to cover this topic. 42-year-old, type 2, low mood and fatigue, on metformin, isofane, and liraglutide. BMI 38, HbA1c of 10.2%. Very classic type 2 picture. There is nothing I've given which is special in here. Next slide, please. As I said, I didn't want to spend too much time, giving you time to reflect in here. That patient of ours had proximal myopathy, easy bruisability, thinning of skin. So we thought about hypercortisolism. And we do know, again, it's a rare diagnosis. It's not something common. Probably pseudo-Cushing's is some we encounter far more commonly in clinical practice as compared to genuine Cushing syndrome or Cushing's disease. There are multiple epidemiological studies related to hypercortisolism in type 2. And hypercortisolism, some studies have quoted, are seen in around 3.4% of patients with diabetes, and 1.4% of patients labeled as type 2 may have Cushing syndrome. I think it's a bit of exaggerated figure. In clinical practice, Cushing's disease is extremely uncommon. Again, if you start imaging in patients with hypercortisolism, in a genuine Cushing's syndrome, it's more pituitary adenomas. Next slide, please. So all I was trying to say was that in patients with type 2 who've got typical pseudo-Cushingnoid kind of appearance, we do have to think about possible Cushing's or hypercortisolism. It's rare, but it's an immensely satisfying diagnosis to make. This is what will distinguish us from the generalist per se. And this is my favorite slide in here, that ticking clock hypothesis, that the macrovascular complication, the dreaded macrovascular complications, start with onset of insulin resistance. And even before we diagnose someone with type 2, there is probability 1 of 10 may already have established cardiovascular disease. Next slide, please. As I said, I've got time which is limited. Let's skip this. So, as I said, my second clinical scenario, I've cut it through kind of because of the time limitation. We do know that in clinical practice, we've got more pseudo-Cushing's appearance, but there are some clinical activity scores which we have to keep in mind and pick up the patients with proximal myopathy. That's very easy to pick when you see somebody in clinic who's struggling to get up from the chair, suggests proximal myopathy. You look at the skin and the skin is bruising easily. There are hard signs, but it takes at least 3 years before somebody's diagnosed from the onset of symptoms, Cushing's disease. Pituitary-related ones are the more common one. Ectopic Cushing presents in a very aggressive way. More importantly, I think what COVID taught us, it's the iatrogenic Cushing we are worried about, and the amount of time individuals are on steroids, which are sold as herbal medications and over-the-counter medication. I think you guys will know more than me about how common it's to encounter iatrogenic Cushing. Next slide, please. And take-home message, just give me 30 seconds to go through it. I just wanted to give you 2 different clinical scenarios to talk you through what growth hormone and high cortisol can do. It's important to know, the eyes will see what the mind knows. So consider hypercortisolism if you've got some specific signs. I mentioned easy bruisability, proximal myopathy, and the stria. There are screening tests and confirmatory tests, which I'll not go into details at the moment, but it's just being aware in the practice and thinking that pituitary gland can impact the pancreatic function. Thank you. It's a very rushed kind of presentation. As I said, I wasn't I wasn't paying much attention to the time factor, and just wanted to share something different.
Thank you very much. Thank you very much, Professor Carlson. I think it has been a good change for our conference that you have shown interaction between diabetes and endocrinology. I would just like to make 1 or 2 small comments. The relation between pituitary and pancreas was exemplified many years before and it was clinically applied in the form of pituitary ablation in the treatment of diabetic retinopathy. And this particular fact was, in its basic science, was brought about by Professor B.A. Housey, who got the Nobel Prize for identifying the feedback mechanism between pituitary and target endocrine glands. That is number 1. Number 2, I would like to request you, do you think that the prevalence of diabetes in acromegaly is much more than what you find prevalence of diabetes in gigantism? If that is so, what is the reason? Gigantism occurs in younger age, while acromegaly occurs after the puberty. So do you think that prevalence is different between the two conditions? That is my small point of clarification. Thank you very much for enriching our knowledge.
Thanks a lot, Dr. Kumar. The paper I quoted was from Hussey et al. There was mention of Hussey et al. Doing the the removal of the pituitary gland and then seeing the impact of it. So thanks for adding on to that information. Second, I'm not sure what's the differences in the prevalence of acromegaly and the diabetes in acromegaly or in gigantism. We do know that acromegalics have more chances of impaired glycemic control with relatively less visceral fat. And the mechanism seems to be more hepatic rather than and insulin resistance driven. So I'm not sure if there is any kind of, to my knowledge, this kind of epidemiological data is, I'm not aware of.
Okay. The other point is about Cushing syndrome. Cushing syndrome, who have much lower potassium, when the Cushing syndrome is due to a carcinoma, which is uncommon. Most commonly, it is because of adenoma, and little less commonly because of hyperplasia, bilateral hyperplasia, where it is associated with a microadenoma in pituitary. That is, of course, a known clinical fact. But when the Cushing syndrome is because of a adrenal carcinoma, then the potassium levels go down very much, and they have a lot of muscular fatigue, and they have difficulty in walking. And it is these patients who also have greater chance of severe diabetes. Otherwise, in a Cushing syndrome, which is because of hyperplasia or because of adenoma, the diabetes may not be florid enough. Of course, there is a good chance of glucose intolerance in them. Thank you.
So I totally agree. The adrenocortical carcinomas are the ones which are very aggressive, and we believe that the disease manifests itself because the prognosis is so poor that it's not the diabetes complication which will lead to the mortality here. We've come across some ectopic ACTH excreting tumors. The last one which we found was originating from the pancreas itself. So, and that patient of mine was so aggressive that he presented with a hypertension, low potassium, and very aggressive diabetes also. But once the tumor was removed from the pancreas, so it was an ACTH excreting ectopic pancreatic neuroendocrine tumor. She's been cured of diabetes, hypertension, all the complications. So I totally agree. It's not the adenoma or the adenomas within the adrenals which are as aggressive. It's the adrenocortical carcinoma, which probably will kill the patient earlier. And in addition, the ectopic ACTH excreting can be aggressive.
Thank you.
I have one small question, Dr. Atul. From your extensive data that you showed us, that the growth hormone is seen in many patients much more than the clinical manifestation of acromegaly. Now, the point is that in any case of insulin resistance, would it be a good idea to do the growth hormone in all the patients of insulin resistance?
No.
See if there is an amenable treatment.
No. Growth
Because
hormone
clinically you may not get acromegaly.
Growth hormone should not be measured in clinical practice. Growth hormone varies 40-50 times in a day. Timing of the test is very important. So we'll not routinely measure the growth hormone. If you are suspecting acromegaly, IGF-1 is a good marker. So my suggestion will be that if you think clinically there is anything which is suggesting acromegaly, please measure the IGF-1, but please don't measure the growth hormone.
Right. Okay. Thank you.
Thank you. Sir, we may go to the last session.
Last lecture.
Thank you, Professor Atul Kallan. Wonderful. I think it was absolutely different flavor added to our Diabetes International Symposium.
I thought
I really appreciate.
you know,
Yeah,
this is better.
wonderful. We wish we had more time to discuss with you. A lot of learning came actually.
Thank you so much, sir.
Thank you.
Thank you. And now we have our friend here, Dr. Wangnu, who would be speaking on ectopic fat, not only in the heart, but in the brain as well. So we don't hear so much about brain fat, but of course, he would be adding to our knowledge. Dr. Wangnu is well known to everyone here. He works in Apollo Hospital. He is a DM in endocrinology from Chandigarh. I knew him ever since then. And I welcome Dr. Wangnu. Over to you. Please go ahead. Is he there?
My today's topic is ectopic fat in heart and brain. Not many studies are there for the relevance of ectopic fat in brain, but nonetheless, we have a lot of information about the consequences of the ectopic fat in the heart. Let's start. What is the ectopic fat? You know, deposition of fat in areas of the body where fat is not physiologically stored, like ectopic fat can happen in the brain, can happen in the heart, can happen in the pancreas, can happen in the liver, kidney, and the skeletal muscle. So today I'm going to focus only on two important organs of the body, that is the brain and the heart. Let's start with the ectopic fat in the heart. The different kinds of the ectopic fat in the heart includes the epicardial fat, and the epicardial fat is defined as the visceral fat that deposits within the heart. It develops from the brown adipose tissue and is located between the myocardium and the visceral layer of the pericardium, commonly exists in the atrioventricular and the interventricular grooves. It shares the same microcirculation as the myocardium, and they are having small adipocytes and the mixed cellularity. Metabolically, they are very active and source of several adipokines. This is the electron microscopic imaging of the human epicardial fat. On the left-hand side, you can see the microscopic appearance of the epicardial layer in the left ventricle, while on the right-hand side, you can see the microscopic appearance of the epicardial layer in the right ventricle. The arrow, what I have shown here, shows the islet of the mature adipocyte. No facial structure divides the epicardial adipose tissue from the underlying myocardium. Now, what is the physiological function of the epicardial fat? Then we'll talk about the pathological function of the epicardial fat. Normally, the physiological function of the epicardial fat can be broadly discussed in three main formats: mechanical, metabolic, thermogenic. The mechanical, it has the compressibility and elasticity that can mechanically protect the coronary artery against the excessive distortion caused by the artery pulse and the myocardial contraction. Metabolic is the highly active free fatty acid metabolism, supplies free fatty acid to the myocardium. Thermogenic, increased expression of the uncoupling protein 1 and the related genes, and the thermogenesis is similar to the brown adipose tissue. It protects the myocardium and coronaries from hypothermic damage. You know, the protective secreting factor produces cytokines involved in the regulation and endothelial function, coagulation, and the inflammation. Adiponectin and adrenomedulin are the cardioprotective. Now, coming to the epicardial fat versus the other visceral fat deposits, is a greater capacity for the release and uptake of the free fatty acids, lower rate of glucose utilization, the free fatty acid synthesis, and the rates of incorporation and the breakdown are significantly higher in epicardial fat than any other fat depot. Lipoprotein lipase and acetyl coenzyme carboxylase activity are consistently lower, and UCP1 expression is significantly higher. The ectopic fat in the heart also includes the epicardial fat, epicardial adipose tissue, pericoronary adipose tissue, which is an extension of the epicardial fat, and the intramyocardial fat, which is the infiltration of the adipocytes from the what we call the epicardial adipose tissue to the myocardium. Non-adipocytes and the cardiomyocytes have a very limited capacity to store excess fat. If they're exposed to high levels of plasma lipids, as typically occurs in the obesity, they can undergo steatosis and loss of function, ultimately resulting in cardiac lipotoxicity, what we call the cardiac steatosis. How do we measure the epicardial fat in the routine clinical practice? 2D echo is the simple, best, and the what we call the cheapest method to measure the thickness of the epicardial fat in at least 2 locations on the right ventricular free wall. MRI fat generates a strong MRI signal. Both thickness and the volume of the epicardial fat can be measured by the MRI. Non-contrast CT scan measures both thickness and the volume. It is a more sensitive and accurate modality, though it is a cumbersome, longer radiation exposure as compared to the MRI and 2D echo. If you correlate the epicardial fat with the obesity and the heart disease, the epicardial adipose tissue may turn into an adverse lipotoxic, prothrombotic, and pro-inflammatory organ, which causes a vicious cycle in between the obesity, heart disease, and the involvement of the epicardial fat. Now coming to what is the link of the epicardial fat and the cardiometabolic risk. We can say the epicardial fat is a marker for the visceral adiposity, significantly independently related to the metabolic syndrome, independently correlates with the various cardiac risk factors, associated with the presence and severity of CAD, and also changes in the left and right ventricle mass and diastolic function, and associated with the atrial fibrillation. Epicardial fat also correlates with the visceral adipose tissue. If you can see in the cartoon, is the correlation of the abdominal visceral adipose tissue fat in the area of A and the epicardial adipose tissue EAT volume in the cartoon B with the body mass index and that between VAT and EAT volume in the cartoon C. So it has got a very good correlation with the visceral adipose tissue, epicardial adipose tissue, and a good correlation with the body mass index. Apart from that, multiple commonly occurring cardiac risk factors also correlates with the epicardial fat content, like diastolic blood pressure, hyperinsulinemia, LDL particles, adiponectin, hyperglycemia, systolic blood pressure, HDL cholesterol, triglyceride, CRP, leptin, and fibrinogen, and also the left ventricular mass. So we can say the epicardial fat is the source of inflammatory mediators and has got an important role in the atherosclerosis and the coronary artery disease. And that is why we have to see how best we can prevent the accumulation of the epicardial fat. Epicardial adipose tissue is increased in the presence of the obstructive coronary artery disease and is an independent predictor of the presence of plaques with a non-calcified component. And this was the paper which basically showed the coronary artery calcium scoring and the epicardial adipose tissue volume measurement on 214 consecutive patients referred for the coronary angiography. The word I told you about the myocardial steatosis is an independent predictor of the diastolic dysfunction type 2 diabetes. And you can see in this cartoon, the myocardial and hepatic triglyceride concentration among the healthy subjects and the patients, and the correlation between the myocardial triglyceride content and the left ventricle diastolic function. You know, the increased myocardial triglyceride content is significantly associated with the decreased myocardial function. What you call, we can see the E early diastolic filling phase and the E by A ratio of the maximal left ventricle early peak filling rate and the maximal left ventricle atrial peak filling rate. I was talking about some of the physiological part of the epicardial fat, which is sometimes protective. And coming to the pathological, when there is abnormal accumulation of the epicardial fat, it is known to cause excess free fatty acid synthesis. It causes modulation of intramyocardial fat content. It causes intrinsic inflammatory state. It is a source of secretion of pro-atherogenic and pro-inflammatory adipokines, and has got a correlation with the coronary artery disease and also correlation with the atrial fibrillation. Can be attributed the functional relationship with the heart, causal and independent role in the CAD, causal and independent role in the AF, and abnormal regulation of the intrinsic cardiac nervous system. Now coming to the importance of the epicardial fat in the coronary artery disease, if you see, the adiponectin is downregulated, adrenomedullin is downregulated, which both are protective, but when they become downregulated, they cause an increase in the free fatty oxidation. Leptin is upregulated, resistin is upregulated, TNF alpha, IL-1, IL-6, MCP1, they are all upregulated. This is the pathophysiological role of epicardial fat in the coronary artery disease. We also talked about the atrial fibrillation or the arrhythmia. You know, the epicardial adipose tissue accumulation participate in creating an arrhythmogenic substrate. Because of the anatomical obstacle to the cardiac excitation, because of lipid overload, because of paracrine crosstalk with the myocardium. It is an increase in the activation delay, early and delayed, after depolarization, increase in the action potential duration, increase in the resting membrane potential, and increase in the fibrosis, which gives the ground for the arrhythmogenic substrate leading to the atrial fibrillation. Now, the whole cycle of the diabetes, obesity, and the epicardial fat expansion can also be linked with the HFpEF, the heart failure with the preserved ejection fraction. And you know, I have just given in red letters what are the drugs which can be used along to treat diabetes, along with the lifestyle modification, and also for the epicardial fat reduction. They are the metformin, GLP-1 receptor agonists, SGLT2 inhibitors, and sometimes the statins and the PCSK9 inhibitors. Let's see one by one. Coming to the lifestyle and the pharmacological intervention, simply the strategies to reduce epicardial fat start from the lifestyle changes apart from the drug, what I told you. And it has been seen beautifully that changes in the adiposity markers after weight loss. Overall, severely obese subject lost 20% of the original body weight, and the BMI reduced by 19% of the original BMI. The waist circumference decreased by 23% of the initial waist circumference, and the epicardial fat thickness decreased by 32% of baseline epicardial fat thickness, simply by changes in the epicardial fat by the weight loss. Apart from the lifestyle, exercise, statins have also been known to cause reduction in epicardial fat, and it is very much visible that change of the epicardial fat thickness according to the statin A, atorvastatin, simvastatin, ezetimibe, and it was seen the atorvastatin was associated with this most significant reduction of the epicardial fat thickness. The third drug, the metformin, has also been shown to significantly decreases epicardial adipose tissue in newly diagnosed type 2 diabetes. And in this paper, basically published few years back, the statistically significant decrease in the epicardial adipose thickness after 3 months of metformin therapy was seen that we can say that metformin alone monotherapy can also help to reduce the epicardial fat. Now, the third drug, the GLP-1 receptor agonist, which has been shown beautifully that weekly administration of semaglutide and the dulaglutide causes a rapid, substantial, and the dose-dependent reduction in the EAT, epicardial adipose tissue thickness. And there have been large randomized controlled trial where it has been shown the liraglutide causes large and rapid epicardial fat reduction. Now, coming to the SGLT2 inhibitors, we have seen in patients with type 2 diabetes and obesity, who were given dapagliflozin, the epicardial adipose tissue decreased by 20% from baseline to 24 weeks. And also it shows a favorable result in the heart failure with the preserved ejection fraction, including the EAT reduction. Now the second part of my talk is the ectopic fat in the brain. Not much has been basically discussed about the ectopic fat in the brain. Neither much research is basically being focused on the role of the ectopic fat in the brain. But whatever we know about the importance of the ectopic fat in the brain, the insulin receptors exist throughout the brain. We all know. And insulin has an important role in various brain functions, such as control of the body weight, food intake, and the memory formation. And we know the brain insulin resistance occurs in obesity, type 2 diabetes because of the elevated free fatty acids. And how the brain is involved, let's discuss how the brain is involved in causing brain insulin resistance. If you just see the brain insulin sensitivity, which is linked to the adiposity and the body fat distribution. Here, what they are trying to show the region-specific change in the cerebral blood flow in response to an intranasal insulin administration. It was extracted from the hypothalamus as a region of interest. You can see the picture A, participant with a strong insulin-induced suppression in the hypothalamic blood flow has significantly less visceral adipose tissue. In the cartoon B, subcutaneous fat content was not associated with the insulin sensitivity of the hypothalamus. In the cartoon C, the ratio of the visceral to the subcutaneous adipose tissue was favorably lower in those with the strong insulin-induced hypothalamic blood flow. And lastly, the cartoon D, pink filled circles, if we are seeing, are the female participants, open blue circles are the male, lines represent the fit lines. The females, they differ from the males in related to the hypothalamic insulin responsiveness according to the fat distribution. There have been many animal experiments that in response to the high fat feeding in the mice, there was increase in the lipid accumulation in the hypothalamus, and the hypothalamus, when it was excised from the mice and analyzed for the total lipid content, it was seen the hypothalamus was loaded with the lipid content. Similarly, individual species of the hypothalamic bioactive lipids in response to the high fat feeding, you can, do the DAG species, and you can see the various quartiles of the hypothalamic bioactive lipids in response to the high fat feeding in the experimental mice. Now, recently there has been a lot of interest generated in the role of astrocytes in the brain in the metabolism. Though these are animal studies, but it's again exciting to know that animal studies have shown astrocytes as a part of the metabolic circuits within the brain. Astrocytes are sensitive to the insulin, and insulin promotes glycogen storage and cell proliferation in astrocytes. Astrocytes are the main provider of the fatty acids in brain, have a role in lipid metabolism in brain. The ability of astrocytes to synthesize cholesterol is vital for the normal brain development, body composition, and metabolism. Free fatty acid uptake mediated by the LPL, astrocyte is essential for the control of cellular lipid storage. Astrocytes are capable of lipid synthesis, storage, and oxidation. And there have been many data in the literature to show that ectopic fat accumulation in the human astrocytes impairs insulin action. They cultured the human astrocyte in the presence of a high lipid content, lipid emulsion, consisting of the fatty acids and T gene to induce the ectopic lipid storage. And after several days, the cells were stimulated with the insulin and the gene expression profiling was performed. Ectopic lipid storage were detected in human astrocytes after lipid exposure, and lipid storage was persistent even when the fat emulsion was removed from the cell culture medium. The ectopic fat storage in astrocytes impairs insulin-dependent activation of AKT, glycogen synthesis, and cell proliferation. Overcoming astrocyte insulin resistance by reducing ectopic lipid load might represent one of the promising upcoming treatment targets for the insulin resistance of the brain in obesity, diabetes, and the neurodegeneration. So time is not very far, then we have many medicines for the neurodegenerative disorders. Now to close my talk, the summary, the epicardial fat has multiple functions to support a healthy heart. Obesity, metabolic syndrome, type 2 diabetes leads to the ectopic fat accumulation in the heart, which is in the epicardium, myocardium, the coronary artery. And because of the underlying lipotoxicity, inflammation, abnormal secretion of adipocytokine's, nitric oxide synthesis inhibition, it leads to the cardiac hypertrophy, cardiac dysfunction, coronary artery disease. Ectopic fat can be present in the brain and is associated with the brain insulin resistance. Drugs, which I have already discussed, targeting lipids and glucose homeostasis, can reduce the epicardial fat. Thank you very much for kind listening, and I'll be more happy to take question and answer when the chairperson allows. Thank you very much.
Thank you, Dr. Wangnu. Dr. Wangnu is there. Dr. Bharoskar sir or Professor Vinod Kumar, one or two questions you can have.
I'm very impressed with Dr. Wangnu's presentation, particularly the epicardial fat and the issues that are associated with it, particularly the atrial fibrillation, which is a very high-risk group. My only question is that the perinephric fat, which is sometimes is actually protective for kidneys, and people who lose a lot of weight, the perinephric fat is lost, and many times the kidneys actually come down and can produce kinking of the ureter. Such kind of problems are associated with a rapid weight loss and also a loss of protective fat. What is your experience about the epicardial fat? Does the loss of epicardial fat causes any abnormalities in the cardiac functions?
No, Dr. Bharoskar, in the kidney, the situation, the scenario is different, but it does not translate the same scenario in the heart, pancreas, liver, and the brain. In the kidney is entirely different scenario. That is why you are right that the rapid weight reduction in the perinephric fat is not beneficial, not good for the patient. But in the heart, it has been proved beyond doubt that the epicardial fat, plus epicardial fat accumulation, is injurious to the heart in many ways, which I already explained.
Thank you very much, Dr. Wangnu. So, beautiful presentation. We learned a lot, and we are grateful because we see so many issues in the echocardiographic. The report comes epicardial fat, and the patient asks us what to do with that.
We can straight go to the next session. That is by
Can I just make a very brief comment, Dr. Chawla?
Yeah.
Okay. Well,
Yeah.
Dr. Wangnu, wonderful presentation.
But still, I
was particularly interested about
very close
topics fat in the brain, and while you were talking about the relationship with memory, I just would like to say that Alzheimer's disease, one of the etiological factors of Alzheimer's disease is insulin resistance. And there are ill efforts
appointed to the post of consultant department of endocrinology and diabetes
at one time for the treatment of Alzheimer's disease. So when you say that reducing ectopic fat will reduce the insulin resistance, would you like to say that which of the drugs you would say, is there any information available, which of the particular drug that you have mentioned might be useful to reduce the ectopic fat in the brain?
The most commonly drug which has been researched and published is the role of GLP-1 receptor agonist, and the liraglutide is one of the molecules which has been shown to help in Alzheimer's, in the neurodegenerative disorders, in the Parkinson's, and these are the emerging role of the GLP-1 receptor agonist. I could not find any role of the SGLT2 inhibitors, but there's a definite role of the GLP-1 agonist for the protection of this neurodegenerative disorder, in particular Alzheimer's. I find the literature studied with the GLP-1 receptor analogs in Alzheimer's.
Thank you for sharing such a beautiful data, very hard, collated with great effort, I am sure. Thank you very much.
Thank you, Dr. Thank you very much.
Thank you. Thank you, everyone, for wonderful sessions. And thank you very much, Dr. Boraskar, sir, and Dr. Vinod Kumar, sir. That was really wonderful sharing. And thank you very much. And we'll move forward to the last session of the conference, and that is complexities in diabetes. And for that, we have two chairpersons, Dr. N.K. Singh, who is Director at Diabetes and Heart Research Center, Dhanbad, and Dr. Sunil Masand, who is Senior Consultant in General Medicine, MAH, Punjabi Bagh, Delhi. With this, I'd like to hand over the session to two chairpersons for the next session. Thank you very much.
Good evening to you all. I am really thankful to Dr. Chawla and Dr. Salini for giving me this opportunity. I think this is the last session, but I think this is one of the most important session. So we have got three brilliant speakers, as you know that Dr. Sanjay Bhadada, Dr. Anil is here, and Professor Vijay Trehan. So can I have a bit biodata of Dr. Sanjay? Yeah, so his topic is bone health and diabetes. So diabetic bone disease is a disease which hardly being discussed in most of any. I've not heard many lectures on this very important topic. So to introduce Dr. Sanjay, you can see he is the professor and head department of Indo at the Chandigarh PGMR, and he DM endocrinology, metabolic bone disorders and diabetes. It is his passion, and he's also chairman of RSDI chapter Chandigarh, and he is actively involved in so many projects. So without wasting further time, let us hear first from the Dr. Sanjay about this diabetic bone disease or bone health and diabetes. Dr. Sanjay, are you there?
I think when it comes to bone and diabetes, he's the man in this country, Dr.
Let
Sanjay.
me share my screen.
Yeah, please share. Dr. Sanjay is well known for this interest in this bone health and diabetes. So I think we listening to one of the best and brilliant speaker from the India. Yeah, please share.
Yeah.
Yeah, please.
Yeah, so my screen is visible.
Yeah.
And I'm audible.
Yeah, but you just start this slide show.
Yeah.
It is fine now.
Yeah. Okay. So thank you very much for the opportunity to talk on this international platform to Dr. Chawla and Dr. Shalini and his team. And thank you, N.K. Singh sir, for this introduction. And I agree with you that diabetes and bone is one of the neglected area actually, and so far not given due attention because probably we are busy with cardiovascular involvement, renal involvement, retinopathy and all these things. But today I'll say that bone involvement in diabetes can be actually a fourth component of diabetes microvascular complications. So you can call instead of triopathy, you can coin the term tetropathy actually, that include the diabetes as an end organ. And what I'm going to do is next 12 minutes or so, I'll try to convince you people that yes, diabetes and bone is an important area and that is having a significant effect. So let's see what is the status of fracture risk in a individual with diabetes as compared to a non-diabetic individual. So in the upper right corner, you can see the risk of hip fracture from this meta-analysis in patient of type 2 diabetes. It is clearly showing that the risk is around 1.5 times more in case compared to the non-diabetic individuals. The situation is actually much worse in patients of type 1 diabetes, and the risk goes up to 7 times as compared to normal or the control patients in compared to type 1 diabetes. In India, the situation is not like the type 1 diabetes. The reason is that in the best of the centers in our country, the mean age of type 1 diabetes is just 35 years or maximum 40 years. And that's why we are not seeing such patients in our setting. Now let's see how blood glucose or the hyperglycemia harms the bone. So on the right side, you see that there is healthy bone, while in case of other side, there's a patient with type 2 diabetes. We know that bone is made up of 3 important components. One is the cellular component, that is the one is osteoblast. And you can see in the healthy bone, the osteoblast number is good, while in case of type 2 diabetes, the osteoblast number is reduced. The second part of the cellular component is osteocyte. The osteocytes are nothing but the pituitary of the bone, and that actually control all the cellular function of the bone. You see in the healthy bone, the osteocytes number is more as compared to the type 2 diabetes, as well as their connectivity is very good among the osteocytes in a healthy bone as compared to the bone with type 2 diabetes. Then we were talking, Dr. Wangno was talking about the bone fat in the adipose tissue. So, sorry, fat in the heart or the fat in the brain. You see here in patient of type 2 diabetes, the adipose tissue collection is much more in the bone marrow as compared to a healthy individuals. The next component is the mineral component, and it is well documented that the cortical porosity, which is increased in a patient of type 2 diabetes as compared to the non-diabetic individuals. Then the small vessels, because in the bone or in the bone marrow, the vasculature size is the 20 micrometer. That is qualifies for the microcirculation, and that's why you can say the type 2 diabetes, and the bone can be a what you call the microvascular complication because of the capillary size is less than 20 micrometer. And you see in case of type 1 diabetes, in case of diabetes and the non-diabetic, there is number of vessels are more in the non-diabetic or healthy individuals as compared to the individuals with the diabetes. So the hyperglycemia harms in these many factors. And we know that when the blood glucose is uncontrolled, there is deposition of advanced glycation end products. These AGs deposits in the bone also, and that leads to causes a decrease, causes a collagen cross-linking that culminates into decrease in the osteoblast addition to the bone matrix. Then there is a decline in the alkaline phosphatase that leads to decreased osteoid mineralization because of decreased activity of alkaline phosphatase. Then binding of the receptor AGE to the pre-osteoclast that increase the osteoclast action, and there is increased osteoclastogenesis, and we all know that osteoclasts are the cells, those are responsible for the bone resorption, and there is decrease in the osteoblastogenesis, cells responsible for the bone formation. Because of all these 3 phenomena, there is increased risk of the bone fragility because of the advanced glycation end product deposition. The situation, let's see what is the situation among Indians. The situation among Indians may be very poor or worse because we have the onset of disease of diabetes almost 10 years earlier than the Western population. We have more central obesity, that's why higher insulin resistance. And because of this higher inflammatory markers. So all these 3 things ultimately leads to the more bone damage. On the top of that, there is a peak bone mass is not achieved because the onset of disease is at the younger age. And the females, there is menopause is also again early age as compared to the Western population. And on the top of that, high prevalence of vitamin D deficiency. So you can understand by this cartoon that the situation among Indians with type 2 diabetes is much worse as compared to the Western or the Caucasian population. We conducted a small study which was supported by the RSSDI a few years back. So what we did is that we selected the patients of the type 2 diabetes, duration of diabetes more than 5 years, their creatinine was normal, and what we found is that on the DEXA scan that the significant number of patients in the male and the female group, there is osteoporosis was seen in approximately 50% of the female patients. And the osteopenia was observed in around 30%. So you can imagine that the significant number of population of diabetes in our country is having the low bone mineral density. You can argue that the Western literature says that the BMD is increased in the Western population in type 2 diabetes, but in India, the situation is not the same. In the same paper, when we looked at the risk factors for the fracture, what we found is the important risk factor is the female gender. It has an implication that if a female patient you are treating for type 2 diabetes, if there is history of the osteoporosis is there, that needs more attention. Similarly, the vitamin D deficiency was the important risk factor, and the use of pioglitazone was associated with increased risk of the osteoporosis. So meaning by that, we should avoid in a female patient of pioglitazone if you are having a history of osteoporosis especially. Now coming to the what is the current situation, that how bone is good in the patient of type 2 diabetes. So we know that the bone strength is decided by bone quality and bone quantity. These two things. Bone quantity is assessed by the bone mineral density or the DEXA scan. The bone qualities can be assessed by the various parameters, but that is in general, neither physician nor endocrinologists nor doctors are bothered about the bone quality, and not much information is available on the bone quality. So what we did with the help of the IIT Ropar people, because they use this, assess the strength and the elasticity of the steel. So we took their help and we published an interesting paper and in the patients. So here is the two group of the patient we have collected. So non-diabetic group and the diabetic group. So these 70 patients with the hip fragility fracture. So this hip fragility fracture, generally our orthopedic surgeon, they remove the neck of femur and throw it. So what we ask them to please give us that bone of the hip area after the fragility fracture when they are going for the hip replacements. And you can see the baseline parameters. There is no difference in the any of the baseline parameter in the diabetic and non-diabetic group, except in the hemoglobin A1C, which is obvious that HbA1c will be high in the diabetic group. Remaining all the parameters were comparable in these two groups. Now what we did is that we take out from the neck of femur, that trabecular bone. We did the micro CT of this tissue. And you can see on the non-diabetic bone and the diabetic bone that visually you can have an impression that in a non-diabetic bone, this trabecular thickness is more. The number of trabecula is more as compared to the diabetic individuals. So we have clearly shown that the trabecular bone thickness and the trabecular number are less in the diabetic individuals or the diabetic bone as compared to the non-diabetic. Further, we assess the bone composition, and what we found is that in case of compared to the non-diabetic individuals, the diabetic individuals are less mineral to matrix ratio, meaning by that, again, it is showing the mineral content was less in the diabetic bone as compared to the non-diabetic bone, and it was statistically significant. Further, we went on to assess the bone quality by the technique called nano indentation. Nano indentation is a technique in which what we do is that the needle is actually pierced in the bone, and that assess that how early it come back and how much stress resistance it gives. So that is called the indentation. And in indentation, what we found is that there is reduced modulus in the diabetic individuals as compared to the non-diabetic bone. So it is clearly showing that the modulus is less in a patient in the bone of the diabetic bone as compared to the non-diabetic. And modulus is nothing but it gives information about the elasticity. So the elasticity is good, the chances of fracture are less as compared to the elasticity is poor. Further, we assess the hardness, and what we found is that in a diabetic bone, hardness is also less as compared to the non-diabetic bone. So it is again clear by the nano indentation that the bone quality in a patient with diabetes is poor as compared to the non-diabetic. Now it was about the trabecular bone. We again studied the remaining part of the bone. For the cortical bone was also studied in the, and what we found is that in case of the cortical bone, there is increased porosity in the diabetic bone as compared to the non-diabetic bone. So meaning by that in an individual with diabetes that the cortical porosity increase. So the cortical as well as the trabecular bone both are having the poor quantity as well as the quality. So we know that it is difficult to take every time bone biopsy. So we did the surrogate marker that how we can assess the collagen. So what we did is that we selected three group of patients. One is the healthy individuals, diabetic control, and uncontrolled diabetic individuals. We collected their nail clipping. We know that nail has a collagen, type 1 collagen, and the similar type of collagen is present in the bone. So we took nail clipping as a surrogate tissue instead of the bone. And what we observed is that in a patient with the healthy and the diabetic control, uncontrolled diabetic, you can see the structural properties are adversely affected in uncontrolled diabetes. Similar, the surface properties also evaluated, and we found, you can see in the healthy that nail is quite smooth as compared to the diabetic control. Controlled diabetes, it was poor. Even it is further poor the uncontrolled diabetes. So meaning by that it is a practical in also we know in diabetic individuals the nails are brittle, so that is further support the clinical information. And we also studied the nail about the mechanical property, and we found that the mechanical property again poor in the uncontrolled diabetes as compared to the diabetic individuals with control and the healthy nails. So that again it is showing that collagen is also abnormally affected in the individuals with the diabetes because of the hyperglycemia. And when we compared the ratio between bone and the nail, and it is going classically hand in hand, so we can say that collagen is poor in the nail as well as in the bone. So this is all about the various mechanisms how diabetes or hyperglycemia can affect the cortical and the trabecular bone as well as the collagen. Another interesting study was published from our department. We looked at the hip fragility fracture from the Tri-City, Chandigarh, Panchkula, and Mohali, various hospitals. And 264 patients with the fragility hip fracture, their data were collected and followed up. What we found is that approximately 25% of patients are having diabetes out of these 264 patients, meaning by that diabetes is significantly contributing for the fragility fracture cohort, and hypertension is even more. So you can say most of our diabetes patients are also having hypertension. So these both two are important risk factor for the fragility hip fracture. When we followed these patients for their outcome, and what we found is that at 3 months, approximately 12% of patients lost their life. At the end of the 12 months, approximately 20% of patients lost their life, meaning by that hip fragility fracture is associated with the significant mortality. And if it is associated with diabetes, the situation is even more worse. So what I say that diabetes and fracture outcome is having poor prognosis, they have delayed healing, frequent infections, they had a longer hospital stay, and the more prospective CV events were there in patients with diabetes and the hip fragility fracture. Now, how to treat if a patient is having the osteoporosis and individual diabetes? So currently there is no answer is available. So our department conducted an interesting study. In the patient with type 2 diabetes, we are using the 3 drugs which are available for the treatment. One is the teriparatide or the recombinant human PTH, Jolidronate, and the denosumab. And another group was given just a placebo in form of calcium and vitamin D. and other all 3 groups also received the calcium and vitamin D. The 30 patients were selected in each group, and at the end of 6 months, just we have collected the 1/3 of the data at the 6 months. And what we found is that if the patients are treated with the teriparatide, the response is very good. This is a new modality that is called high resolution peripheral QCT, which is available in our department, and we found that there is nice response with the teriparatide. So what is the effect of these various anti-diabetic drugs used for the treatment of treatment of diabetes? So generally the metformin is neutral, but thiazolidinediones are associated with decreased bone mineral density as well as increased risk of fracture. So these drugs should be avoided in a patient of already suffering from osteoporosis or history of fragility fracture is there. The SGLT2 inhibitors, their information is not yet available. And the GLP-1 analog is one of the preferred drug for the treatment of, for the better bone health actually. So I conclude my presentation by saying that diabetes is associated with increased fragility fracture risk more in type 1 diabetes as compared to type 2. Bone quality is compromised in diabetes individuals. Both the cortical as well as trabecular bones are affected. The fracture outcome is poor in diabetes individuals as compared to the non-diabetic individuals. The drug of choice for osteoporosis in diabetes is not yet clear, but very soon we'll get the results. So thank you very much. And I'll acknowledge my department colleagues and faculty for their support in collecting these data and publication. Thank you very much.
I think very illuminating and very original work you have shown. And I think you have become richer today by this your presentation. I think we can discuss this topic just now. So first thing, already you cleared that what is the difference between the type 1 diabetics and the type 2 diabetics? Suppose.
So basically in type 1 diabetes, the bone density is less because of peak bone mass is not achieved. And we know that in case of type 1 diabetes, hyperglycemia or the glycemic burden is high as compared to the type 2 diabetes. So that's why the risk is much more in type 1 diabetes. But the reason in our country, we are not seeing such patient. The reason is that the mean age of type 1 diabetes survival in our country is very less. So they are not reaching to that stage to develop the fracture. They are dying before we are losing these patients, before developing the bone-related complications.
What do you suggest for drugs which you are using, like SGLT2 inhibitors or pioglitazone? So what is your recommendations for that? Because it also can lead to sometimes a diabetic bone disease.
So I think we can avoid pioglitazone for sure. If any person is having the known history of fragility fracture or the family history of fragility fracture. Regarding SGLT2 inhibitors, not much data is available. So currently we can say we can use that. But of course, the metformin, insulin, sulfonylurea, these are fine. But the preferred ones are GLP-1 analogs.
Lastly, I would like to know your recommendation or your thinking. Just like you are monitoring for the retinopathy, for the albumin in the urine. So do you think that you should also go for knowing this bone health in the diabetics, and at what interval?
So actually there is recommendations are like this: age above 50 years and the duration of diabetes more than 5 years, we can ask for the bone mineral density assessment. And currently the criteria to treat diabetes with osteoporosis, the cutoff is -2 T-score. Instead of earlier, it was the -2.5 for the general population. The frequency is not yet very well documented. I think it is a very interesting question that how frequently we should monitor their bone mineral density. So answer to this question is not clearly available, but we say at least once in 2 years.
Thank you. I think
I need to ask, can I ask one question, which is of course very, very nice data, Sanjay. I'm really impressed with your work in your institution. And this is one area which is really important, you know. My point is the osteoporosis can be prevented in young people by giving them weight-bearing exercises. You see, the point is that all exercises which does not include the stress on the long bones. One of them is a jogging or walking rather than cycling or swimming. What is your opinion about that?
Yeah, I totally agree with you, sir, because to prevent the osteoporosis, to improve the bone health, actually, we need to stretch the periosteum. And for the periosteal stretching, the muscle action is required. The jogging and even simple walking is also considered a weight-bearing exercise. And that is useful to prevent or to maintain the bone mineral density.
Thank you.
Yeah.
Sir, I have one question, Dr. Sanjay. First of all,
yeah,
I must congratulate you for an excellent lecture that you gave.
Hello?
And the studies were very impressive. The studies that you have shown in your institute, they were very impressive. So your take-home message is that the diabetes, every diabetic should be evaluated for bone mineral health at the onset or 5 years of detection of diabetes.
Yeah, so I think this data is available after 5 years only. So I think current recommendation is like that. If they say the age is above 50 years and the duration of diabetes is 5 years, we can go for the DEXA scan. But if any other risk factor is there, like the family history of fracture is there, or the personal history of fracture is there, then these patients should be screened even earlier also.
Sunil, we can go to the next session.
Yeah.
Boroskar sir is already there.
Yeah. At the onset, I would like to thank Dr. Rajiv Chawla sir and Dr. Shalini for giving me this opportunity to chair the session. And I think we are at the end of the session. We had a wonderful session throughout the day today and yesterday. So I'll be just fast and introduce Dr. Anil Boroskar, though he doesn't need much of introduction, but still it is custom to do that. He's Honorary Secretary, Scientific Section, Diabetic Association of India, 1984 till date, Member Executive Managing Council, Diabetic Association of India, 1984 till date, Member of National Academy of Medical Sciences, Fellow of Royal College of Physicians, London, ex-chairman for Southeast Asian region of IDF. Dr. Anil has been running his clinic as Diabetes Care Mumbai and practicing since the past 35 years. And you can read the further ones. So there's a long list. And he'll be talking about diabetes and OSA. So without wasting much of time, I would request Dr. Anil to deliver his lecture.
Thank you very much. I am really grateful to Dr. Chawla and Shalini for including this topic and including me in this wonderful academic feast, I would say. So my topic is obstructive sleep apnea, and the link, or it's a bi-directional problem, and we have worked quite a lot on this subject, and particularly we see quite a few cases of OSA in our OPD as well as the people come to our institution, and that is a major problem, which is a treatable condition, and the treatable if you are suspecting it in quite a few people. Next slide, please. Will you please, What is obstructive sleep apnea? Repeated partial or complete obstruction of upper airway during sleep. OSA is a highly prevalent disorder which affects several body systems, and most dangerous complication of untreated OSA primarily include three systems: metabolic, cardiovascular, and cerebrovascular. Next slide. Next slide, please. Yeah, the risk of OSA is high. Next slide. Sleep apnea can lead to so many complications. What causes sleep apnea is a smoking, obesity, increased age, endocrine and metabolic, male genders, anatomic abnormalities of upper airways, family history of sleep problems, alcohol and sedative use. So there are many areas that need to be intervened before we start treating sleep apnea, because these are all risk factors. Next slide, please. Now, complications are metabolic, cardiovascular, behavioral, and other. The metabolic are insulin resistance, metabolic syndrome, weight gain, nocturia, sexual dysfunction, cardiovascular, hypertension, rhythm abnormalities, cerebrovascular events, MI, heart failure, and the behavioral, cognitive and memory problems, irritability, concentration difficulties, premature aging and depression, and excessive daytime sleepiness, fatigue-related accidents, and headaches. So you realize that obstructive sleep apnea has so many problems that can be addressed if you treat obstructive sleep apnea. Next slide, please. Now, what causes what? It's like a chicken and egg. Whether OSA comes first or type 2 diabetes comes first. It is a bidirectional relationship. Next slide, please. Now, OSA leads to diabetes. A number of studies, including longitudinal studies and analysis, have shown that OSA is a risk factor independent of obesity and other risk factors. Now, you realize if the patient is even not obese or even he doesn't have any abdominal obesity, he can still have OSA, which itself is an independent risk factor, insulin resistance, pancreatic beta cell functions affected, which causes glucose intolerance and type 2 diabetes. Now, this could be sympathetic activation, HPA axis alterations, oxidative stress, activation of inflammatory cytokines, particularly interleukin 6 and tumor necrosis factor alpha, changes in adiponectin profiles, and that can lead to so many problems. So this is a cause of multiple problems which can come from OSA. Next slide, please. Does diabetes lead to OSA? A meta-analysis has confirmed that moderate to severe OSA is associated with a greater risk of diabetes when compared with the absence of it. The shared risk factors are lipid profile, high waist circumference, smoking. Diabetes 2 leads to weight gain and autonomic neuropathy and causes insulin resistance, independent predictor of sleep apnea. Next slide, please. So you realize that there are multiple factors and therefore the relationship is bidirectional. It is interesting that both type 2 diabetes are associated with similar comorbidity, which include hypertension, cardiovascular disease, dyslipidemia, and chronic kidney disease. Many of the ongoing trials focusing on whether the having OSA and type 2 diabetes is associated with greater severity is going on in multiple centers. So their interest in this area has increased enormously because this is a treatable condition. Get it very clear. Please remember, one of the commonest cause of accelerated hypertension, which is non-responsive. You call the patient multiple times, his systolic pressure just doesn't come down with all the manipulating efforts to reduce the blood pressure. Resistant hypertension, you have to suspect OSA, and if OSA is treated, resistant hypertension comes under control and the associated risk factors. Next slide, please. Next slide. The effect of OSA on type 2 diabetes. What happens to type 2 diabetes who's got OSA? Next slide. Several cross-sectional studies demonstrate a link between OSA and glycemic measures like HbA1c, fasting glucose level, variation plasma glucose level, glycemic variability, which is more dangerous than elevated sugar. If the blood sugar in the morning is 70, evening is 300, it is worse than having a consistent blood sugar of 200. Particularly type 2 diabetes in Indian phenotype with abdominal obesity, which is also known as thin fat Indian. These are the people, the glycemic variability is more dangerous to produce complication. Now, OSA severity increases insulin resistance. And there is a simple method known as apnea-hypopnea index. If that index is high, then the patient is considered severely insulin resistant. And this is why you have to do this apnea-hypopnea index, which is a very simple test. Next slide, please. Southeast Asian studies, a linear correlation exists between OSA parameters and insulin resistance, defined causal risk link between OSA and insulin resistance. Higher the insulin resistance, that means the patient has got obstructive sleep apnea, you have missed. Treat obstructive sleep apnea, his insulin resistance will come down, particularly in Southeast Asian, our Indian people and South Asians. This is particularly a big risk factor. Next slide, please. Approach towards a patient with OSA and type 2 diabetes. How do you approach? Next slide, please. First, convince the patient. Comprehensive sleep evaluation, history taking, analysis of signs and symptoms of OSA, analysis of risk factor for OSA, examination of upper airway anatomy. Now, pre-test questionnaire, which is whether he snores loudly. Please remember one thing, all sleep apnea patients need not snore, and all people who snore may not have sleep apnea. So snoring can be a familial trait. It may not be associated, but snoring is important. And you feel tired after sleep. The patient says that I'm never fresh, sir. When I get up in the morning, I'm never fresh. Basically sleep is supposed to restore your cellular function, your metabolic function, your brain function. It should give you rest to all the cells. It does not happen. The patient never gets up fresh. He feels as if his sleep is incomplete and he does not feel energetic to work. Now, either there is an observed apnea. Now, this is brought to your notice by the spouse. You know, sir, when he sleeps in the night while snoring, suddenly he stops snoring. Suddenly he just stops, and I wake up because of he stopped snoring and I feel he is not alive. So this eyewitness examination by the spouse is very important. There is a high blood pressure, BMI more than 35, age more than 50, neck circumference more than 40, neck girth. Now neck girth in some good singers like Bhimsen Joshi was always high, but that was because of Riyaz. But people with a very thick neck, and that is one very big risk factor. Male gender, and there is a score of 3 to 5 moderate, 6 to 8 is considered high risk score, and these are the people to be subjected for sleep study. Next slide, please. So diagnosis OSA diabetic patient is type 1 study is usually costly, cumbersome, requires hospital stay for one night, requires resource of a rich setup to conduct the study. Now this is not really required of polysomnography or with a multiple 12-lead EEG, and that is done in the hospital. You have to stay for one night, expensive. Best is a sleep apnea study done at home. You call up the people, they come home and they to put one oxygen saturation meter, other is the leads on the chest, and this is a very simple test. Next slide, please. Can be done at home. It's a alternative type 3 device, home-based respiratory monitoring diagnostic device. The number of channel 4 to 7 are increased used to in a practice as well as research and supported by American Association of Sleep Medicine. Next slide, please. Can be done at home. Very simple gadget. Apnea air study in diabetic patients. Diabetes and OSA present similar symptoms. The IDF recommendation, screening people with type 2 diabetes. IDF recommends a practical approach which is so to investigate these people classical symptoms such as witnessed apnea, heavy snoring or sleepiness, daytime somnolence. Daytime somnolence is very important, and believe me, it is one of the most important risk factor. Daytime, a structure questionnaire stop bang is used to in the first stage. Those with a high risk undergo a second stage with overnight evaluation. Those people who are diagnosed can be subjected to overnight testing in the hospital. Next slide. You realize that the simple, easy to read report, sub-classification of apnea into obstructive, central, mixed, and unclassified. Obstructive and central, there is something wrong with the brain, Mixed is both and is a pulse variation, snapshot of the whole night, which is also very important report. And the report comes as a printer form. It gives you a hypopnea apnea index, which tells you exactly what we call is an index. If the index is higher than 15, it's a serious matter. Next slide, please. Now, how do you measure OSA? AHI, apnea hypopnea index. 0 to 5 normal, 5 to 15 mild apnea, 15 to 30 moderate apnea, more than 30 is a severe apnea. And this can be done at home. If you have a severe apnea, then you need polysomnography, EEG, 12-lead EEG, and which is an elaborate test and which will tell you exactly where is the problem. Next slide, please. Now, treatment options. CPAP is a gold standard treatment always. Along with CPAP, lifestyle modification, sleep hygiene, weight loss should be advised. Patient of type 2 diabetes with OSA. Other things I tell my patients that at night, do not look at TV. At night, do not read any messages on your iPhone. You must not have visual stimulation just before going to bed. Do not watch TV, particularly the news. It's useless. Some of the treatment options of USA include dental appliances, surgery in select group. Not all patients need surgery. Correction of the anatomical abnormalities. Conservative measures such as alcohol cessation, smoking cessation, as a mild nasal decongestion. Your nose passage should be kept. Saline nasal sprays are available. And that is because the mucus plugs in the night can obstruct the passage and you start snoring because the nose is blocked. But nose blocks don't need sympathetic nasal drops. You can use plain simple saline and that will help you. Next slide, please. Now, mechanism of action of CPAP is basically air which is forced in your nose. You can either wear a mask or there is something known as nasal pillows, which are very gentle. They fit into nostrils and deliver a flow of air at a particular pressure. And now the machines have an auto adjustment of the pressure. What is auto adjustment? Either the pressure can be delivered at a fixed 5 or can vary from 5 to 17. Now that can be adjusted depending on what is your need. If the patient in the middle of the night does not need that high pressure, the machine reduces the pressure. It's an auto adjustment that prevents the damage due to forceful, delivery of air current in your nostril and the respiratory passage, which can actually cause damage to your lungs. So this is a very, very sophisticated gadgets which are easily available, not too expensive, and they are auto adjustment pressures. Next slide, please. Now, these are the small gadgets which are air compliant, which is very important. That means you can carry these small gadgets which are size of a calculator and you can fit it in the air. The airline gives you a compliance certificate to carry this, and they are battery operated. Sometimes battery carrying is a big deal on board. So that is allowed. You don't have to deposit it with the security. You will say that this is your compliance certificate and the airlines honor those certificates. So there are different types of PAP therapies. The standard is the one which is automatic CPAP, which I have shown you in the middle. There is a bi-level, which you need multiple levels, and there is a moisturizer in that, attached to water chamber as well. And there is something known as CPAP small gadgets, which you can carry with you on board. Next slide, please. Next slide. The effect of CPAP on type 2 diabetes. Now, this is interesting. Next slide. When a person is put on CPAP, next slide, please. It reduces the risk of incidence of type 2 diabetes. In a pre-diabetic patient, we have seen that it reduces the Kaplan-Meier curves on the impact of CPAP on the risk of the incidence of diabetes patient with the AHI more than 20. Hypopnea index more than 20, if you reduce it, you can reduce the chances of pre-diabetic developing into diabetes. That is the beneficial effect of this therapy. Next slide, please. With CPAP improves HbA1c. Amazing. Mean hemoglobin levels before and after continuous positive and the patient with baseline HbA1c greater than 7%, groups were compared with treatment test, and it shows that the patients who were put on CPAP machines, the risk was reduced substantially. Next slide, please. Next slide. Yeah. Effect of CPAP on diabetes control, fasting insulin and insulin resistance. It clearly shows there is a significant reduction. Next slide. OSA and diabetes complications. What are the complications with the patient of diabetes having OSA? Next slide, please. And this is very important. Is an independent risk factor for hypertension and non-dipper phenotype. People in the sleep must dip their blood pressure. There are two groups of people. They are dippers, means the one who blood pressure falls down at night, pulse rate falls down. There is a reduction of autonomic drive. If that doesn't happen, the blood pressure does not dip. They are known as non-dippers. And they are vulnerable to develop many problems. Now, therefore, the mean arterial pressure must get reduced. The systolic and diastolic, both the blood pressure must come down during sleep. That is the effect of sleep. It doesn't happen in many diabetics. Next slide, please. So, presence of OSA is shown to increase the chances of stroke, coronary artery disease, and MI and heart failure. CPAP has been shown to delay or prevent the occurrence of coronary vascular disease. Amazing. There are a lot of studies which are done. They're seeing the CPAP machine has reduced the mortality, particularly from atrial fibrillation, which occurs in the sleep or at night, and early morning infarctions. MIs which take place at 4 a.m., particularly 4 a.m., 5 a.m., these are reduced when the patient uses overnight CPAP machine. Next slide. One of the most outstanding effect of microvascular complications, retinopathy, nephropathy, and neuropathy, these are all treated significantly. Microvascular disease also treated with a used properly, intelligently given CPAP machine. Next slide, please. So this is about the CPAP machine. Now, I must tell you something very frightening about CPAP, about the sleep apnea. The commonest cause of accidents in the United States is sleep apnea. The truck driver sleeping on the wheel, because daytime somnolence and nighttime insomnia. This is worse than alcohol-related vehicular accidents. More number of people have died because the truck drivers have slept on wheel and not slept at home properly. So Chernobyl, then a space shuttle mishap. These are all because of the sleep apnea. The pilots had sleep apnea, and that's how it's a major cause of economic loss, major cause of disasters, and this can be prevented by a simple test of apnea hypopnea index and put a patient on a CPAP in an appropriate way. Thank you very much for giving me an opportunity to express my honest and sincere wishes that people should suspect sleep apnea. All the patients above 40, you must subject this to this testing. If you don't suspect, you don't diagnose. You must suspect. 48% of the adult population, believe me, diabetic or non-diabetic, is suffering from sleep apnea. 48%. We miss it because we don't suspect. Thank you, Rajiv, for giving me a chance to express my views.
Wonderful session.
Sir, just one question, sir.
Can I make a comment?
Yes, please.
Yeah, so Bostrikers are very good, nice talk, but just I want to make a comment that obstructive sleep apnea is associated with poor bone health. Very recent paper came from our CMC Vellore group, and they have shown that we are talking all about the cardiometabolic, but it is having a very bad effect on the bone health also. So that's just they want to make this comment. Yeah.
That's
sir,
true. Thank you.
Sir, excellent talk, sir. For what you showed, this was a masterly thing which I heard today. So, sir, as I learned that what will be the duration of the CPAP? If someone is on CPAP, is it for lifelong or it can be halted sometime?
I tell you one thing, this question has been asked by many people who are using it for years together. They ask me, abhi band kabhi hoega? I said, the day your waist circumference comes down by 7 centimeters, I will stop your sleep apnea. Most of them people cannot bring it down by 7 centimeters. And you see, once you buy this gadget, there is no working expenditure. Get it very clear. There is no running cost. There is an initial investment. And by the way, this is paid by Mediclaim. Huh? This sleep apnea machine is covered in medical insurance. So you do it only one-time investment, but you try to understand. I just now showed, I mean, some of the banias who come to me, they calculate, डॉक्टर साहब आपने जो एंटी हाइपरटेंसिव ट्रीटमेंट दिया था ना, उसका मेरे को महीने का 20,000 रुपए खर्चा आता है, वो मेरा कम हो गया, अभी मेरे को 5,000 में सब काम होता है. Believe me, the beautiful drug ribellosis, people were taking 14 milligrams and 7 milligrams, they have come to 3 milligrams, and some of them are gone off the drug. Yeah. Some of them have gone off the insulin. So they calculate the amount of money that they saved by one simple gadget over a period of time is definitely beneficial.
I must congratulate, sir. I must really congratulate you for the wonderful lecture that you have given. And especially you have opened our eyes. You know, we will now be very careful when we see diabetes, hypertension, and suspect OSA. So all these three spectrum in our clinical perspective, you have really opened our eyes. And I think a wonderful session. Thank you. Thank you so much.
I think we will move to the next one and last one, that is by Professor Bajaj Trehan. So coronary artery disease in the diabetes, is it different? So as you see here, he is recently retired as the director, professor and HOD from the JV Pant Hospital. And he is a very well-known person in our country. So without wasting time, Sir Dr. Trehan, can you share the slides and start? Professor Bajaj.
Yeah, good evening to everybody. I think I'll first of all thank the organizers for giving me opportunity, and I think this is probably one of the odd conferences where I'm participating, and because most of the time I try to participate in conferences which are pertaining to intervention. It was the request and a persistent request by Rajiv Chawla, who is my younger brother, to come and express my views about does a diabetic patient behave the same way, especially with reference to coronary disease. So is my shared screen?
Yeah, put it in slide mode.
Okay. So my task is to talk about what if I have coronary disease patients who are diabetics versus who are not diabetic. Well, all of us know that diabetes is not only steadily, I'll say it is increasing its presence all over the globe, so much so that in the last couple of decades it's gone by 300%. That's in US, and I'm sure we'll have figures something like this, maybe worse than that in India, especially in metropolitan cities like Delhi. And I feel it has pandemic potentials to affect our life. So something which has pandemic potentials, and we know that of late NYHA, American Heart Society, they used to usually talk about NYHA class 1, 2, 3, 4, but nowadays for heart failure, they are talking about heart failure stage A, B, and C, and D. And stage A means if you have some risk. And if you are diabetic, you have a risk to get into problem as far as heart is concerned. So all diabetics That, and what I guess is about 50 crore people should be in the world having diabetes. So all diabetics are in a stage A heart failure. And we know if you are diabetic, you have some risk. If you get atherosclerosis, the risk is more. And if with diabetes and atherosclerosis, if you have had some ischemic event, then your chances to get into trouble are pretty high. So the magnitude of problem, as we all understand, is tremendous. And we also know that even though you cannot always have a full correlation of your metabolic derangements with your vasculopathy, but still, majority of the patients, as they have a deranged metabolic profile in the form of blood sugars, usually HbA1c, as they start climbing beyond 5.5, you start inviting problems. And typically, it's A1c around 8 to 9 when you start having problems, much in excess of the population at large. And the disease, as we used to think in the past, was metabolic, and we used to think about problems of diabetes used to be like hypoglycemia, hyperglycemic, osmolar problems, ketotic, non-ketotic problems. But I think those were the things of past, and they were addressing, and they were talking about only a small part of the syndrome of diabetes, where primary problem is vasculopathy, which involves almost all arteries of body, and specifically kidneys, and not only vessels. You also have affection of things which are in the vessel in the form of platelets, and not only the disease itself, sometimes the treatment, especially in the form of insulin, which also creates a problem in diabetics. And not necessarily every time it's a vasculopathy, you also have a problem in the muscle itself because of metabolic problems, so leading to myocardial dysfunction. And the magnitude of cardiovascular comorbidities in diabetics is almost 1/3 to 1/4 will have some kind of issues, either silent atherosclerosis, or they get into stable angina, which gets into ACSs, and with unstable angina and myocardial infarction, and subsequently get into heart failure. In fact, if I look at my cath lab practice, nearly 1/3, and sometime if you are handling more complex cases, nearly half of the patient will have diabetes in one form or the other. And many of the patients who enter our cath lab, it's possible that they have never been diagnosed as diabetic. The odd blood sugar reading might be like 180, 190, which many times the readings can be otherwise also in the absence of diabetes. So many of the people who enter our cath lab, they enter in cath lab without a fixed label of diabetes on them, but that odd reading in the form of 180, 190 of blood sugar, which can be otherwise also. Means a lot of people can have hyperglycemia related to stress. But what I mean is a significant proportion of patients who enter the cath lab without a label of diabetes, even an odd reading of blood sugar high, will often be reflecting that he has underlying diabetes. Now, as we start handling these cases, we start getting trouble right from the groin. If I want to have an excess, like I want to start my procedure from groin, want to have a femoral puncture, diabetic patients are more likely to have a peripheral vascular disease. And my problem will start from there only. Because if I want to have an access with a bigger bore catheters or a bigger bore devices, and nowadays we are using Impella, which is a device which is used for a lot of patients who have a poor ventricle, and if you want to do a procedure, I want that is cardiac function should be supported. It's like a left ventricular assist device which we put from the groin into the left ventricle, and even if the patient's ejection fraction has gone down, even during the procedure, if he gets into a cardiac arrest, still his circulation will be maintained. I'll be able to do difficult cases. So the moment I receive a patient who's a diabetic, I get alerted because not uncommonly they have associated peripheral vascular disease, and taking these devices which are with big catheters, it is at times difficult in diabetics. And also, if you keep these indwelling sheaths in them, then you invite problems. And one of the important problems is poor wound healing in these diabetics. So if I receive a diabetic in the cath lab, I think my problem will start from the groin excess itself. Also, a lot of patients of diabetes who enter our cath lab, many times we try to assess what is the ejection fraction. And we know the ejection fraction can go down in diabetic because of various reasons. But here I like to just emphasize that many of the patients who entered in our cath lab with an ejection fraction of 60%, which everybody considers good ventricle, many of these ventricles may be significantly hypertrophied. They might have significant fibrosis. They are very poor to relax. And in fact, we all know what is chronotropic, bathmotropic, ionotropy, and these are all things related to heart as to how well the heart works. But one more important tropy is lucitropy. That means how well the ventricle relax. And a lot of patients who are diabetics will have ejection fraction of 60%. So don't get carried away. They might have a significant diastolic dysfunction. And during the procedure itself, while we are trying to handle these patients with coronary disease, they have a pretty high chance to flood their lungs and get into pulmonary edema. So we don't get carried away by an ejection fraction of 60% in a diabetic. Also, we do most of the tasks on coronary artery disease with contrast. And contrast nephropathy is a special issue which is there with a lot of patients who have an underlying renal involvement. But if the renal involvement is because of diabetes, then my ears have to be alerted, because for the same degree of GFR, if the etiology is something different, then these people will tolerate contrast very easily. On the contrary, if the etiology for a low GFR is diabetes, then they are much more prone, much more vulnerable to get marked worsening of the renal dysfunction after exposure to contrast. In fact, Roxana Mehran has given a system by which we can predict as to possibly who's the one who's going to get into contrast-induced nephropathy. And if you look at it, diabetes is given 3 marks, and a large number of diabetic patients are elderly, are in heart failure, and they also have an underlying creatinine on the higher side. So the moment I know that this patient is diabetic, even if the creatinine is, let's say, 0.9 or 1, I will be alerted, because somebody who has a creatinine of 1, apparently a lot of physicians and a lot of my colleagues will think that his kidneys are working okay. But somebody donates 1 kidney, loses 50% of GFR. Next day, if you look at urea and creatinine, they will be okay. So even despite the fact your GFR has come down to 50%, still your creatinine will be okay, your urea will be okay. And many times the perception by physician is, well, kidneys are working fine. I'll say, even if it is creatinine is 1, and if a patient is diabetic, I'll try to handle this patient as if he's in CKD. Because, and I have to be very, very careful about contrast, try to limit the contrast as far as possible, and try to use all other methods on this earth which can be used to limit the quantum of contrast. And many of these methods nowadays are in the form of intravascular imaging, and trying to do hemodynamic assessments within the coronary arteries by floating in wires which can tell me pressures proximal and distal to the lesion. Nowadays we call them FFR and IFR. So I'll try to use all those methodologies so that I can limit the quantum of contrast as far as possible in a diabetic patient, even if the creatinine is normal. We also know that diabetic patients, as far as their coronary artery atherosclerotic lesions are concerned, these lesions are far more complex than in non-diabetic patients. They have huge amount of necrotic core. They have a lot of inflammatory infiltrates, and they also have a lot of calcium. And these 3 things make the life of an interventionist hell. Whereas calcium will not budge, will require a lot of hardwares to say grind the calcium or break the calcium. Whereas on the other hand, softer lesions will have a lot of necrotic core, and the moment you inflate a balloon, these people have a tendency to go into slow flow and get into marked ischemia, despite the fact we open the artery and put stents there. And these are much more common in diabetics. So we have to be alerted in diabetics, even if the lesions are soft. Of course, if the lesions are hard, because calcification is more often in them, we'll have to use different tools to handle calcium. Even after we have done PCIs, and if the angioplasty has been done very well, the result was excellent. If you follow up these patients, they have a much higher chance to die after the procedure. Either they get heart attacks, or they get heart attack related to the stented segment or segments other than the stented part, because they have a atherosclerosis which is more malignant than in non-diabetic patients. And that malignant atherosclerosis is in the form of diffuse atherosclerosis and lot of atheroma burden. And some of these patients might have even negative remodeling, like a 3 millimeter vessel which is looking 3 elsewhere. It is possible that in a diabetic, this 3 millimeter vessel is actually not 3, and it is like 2.25 or 2.5. And if you inflate a 3 millimeter balloon or put a 3 millimeter stent, these arteries can perforate. So we'll have to heavily rely on methodologies other than simple angiograms in the form of intravascular ultrasound while handling these diabetic patients. And many of them have a lot of prothrombotic states, which makes our life very difficult. And to handle that, we usually give antiplatelets of different varieties. We have nowadays new antiplatelets. About 40% of the diabetics, they have some kind of resistance to these antiplatelets. So our life is pretty difficult while we are handling diabetics. And especially if the diabetic is the one who's taking insulin, then we see that the things are much worse than those who are not requiring insulin. And we know that diabetes affects our cardiovascular system, especially coronary arteries, because of these various various mechanisms. But one of the most important mechanism by which you have adverse cardiovascular events is platelets, which are unduly active. They are very angry in diabetics. They have a tendency to collect together and form thrombus, excite fibrin, and let the red cells get entangled into those fibrin strands, and thereby forming clots and thrombotic events. Now the question is, which antiplatelet I should be using if I'm treating a diabetic with coronary disease? Well, often most of our patients are on clopidogrel. But clopidogrel, as I told you, about 40% patients might be having some kind of resistance to clopidogrel, especially if they are diabetic. Newer antiplatelets in the form of ticagrelor is found to be better, but much more effective antiplatelet in the setting of diabetes is prasugrel, which has been tested in Triton TIMI 38 trial. And in fact, in this trial, more than 3,000 patients with ACS, they were taken up. And we see that with clopidogrel, the incidence of CV deaths and strokes are pretty high. It has been decreased significantly by 50% by use of prasugrel. Surprisingly, these diabetic populations tolerate this prasugrel far, far better than the other population. And the incidence of bleeding is more or less the same as is there with clopidogrel. So one take for all of us is that if you're dealing with a diabetic population, then if you want to calm down the platelets, I think prasugrel is probably the drug of choice. Of course, we have some issues related to prasugrel. You can't give it to elderly people who are underweight. But other than elderly underweight, I think prasugrel is a drug of choice for me if I'm handling a diabetic patient. As far as ticagrelor is concerned, I think it is better, but probably it doesn't give as much advantage as is done by prasugrel. In fact, ticagrelor, if added to aspirin in patients who have had some problem in the past, even when we are not doing stenting, I think it is considered to be a good drug. And what has been seen is that in this THYMIS trial, which came up in the European Society of Cardiology, I think 3 years ago, and Deepak Lal Bhatt had presented it. It showed that ticagrelor, even without acute coronary syndrome, even without PCS, if it is added to the prescription of pure aspirin in patients who are diabetic with atherosclerosis, it makes our event rates much, much less. So I think ticagrelor can be added to patients who are diabetics, even without stenting or ACS. And of course, if we look at the disadvantages, there are disadvantages in the form of bleeds, but those bleeds are often not fatal bleed. In fact, commonly these patients will get a subdural hematoma, which can be often recognized and handled. So I think the takeaway from this trial, which is presented by Dr. Bhatt, is that even those patients who are not in ACS or not having stenting, I think you can add ticagrelor and maybe some smaller dose rather than 90 milligram. You can give 60 milligram dose. Now, a step further to handle the thrombotic issues. In addition to antiplatelets, can we even add anticoagulants? Well, it looks pretty odd because people get so much problem even with the antiplatelets. But of late, it has been seen in COMPASS trial that if you add low dose newer anticoagulants in the form of rivaroxaban, then the effect which you get from aspirin is bettered by rivaroxaban. And in fact, if you have a combination of low dose rivaroxaban and aspirin, you get the best results. And these results they have been seen that they are far more marked in diabetic than in non-diabetics. We also know that if you are a diabetic, your chances to get into heart failure after an ACS are pretty high. About 2/3 or 3/4 patients have a tendency to get into heart failure, even if it's a diastolic heart failure, if they are a diabetic. And I know for most of you, if you have to treat diabetes today, and if there is any question of heart failure, we tend to rely on SGLT2 inhibitors, which I think must have been talked about by various speakers. But I'll also again like to nod my head that this is a situation after ACS. I would like to add SGLT2 inhibitors, no matter whether they are diabetic or not. Of course, if they are diabetic, they are going to get a dual benefit. Often there is a question about whether should you subject these patients who are diabetic, especially if they have a multivessel disease, left main disease, to surgery or angioplasty. Well, this debate will keep going on, but there is a lot of observational data and a lot of randomized trials, and of late meta-analysis, especially with the newer second generation drug-eluting stents. I think now things are more or less settled. All these patients can have a tremendous benefit from stenting, and it is not a must to send these patients to surgery. However, you should just balance out that if there is a diabetic with multivessel disease, if you are subjecting these patients for bypass surgery, there is an earlier chance of having a higher mortality and stroke if you are doing CVG. But if you are sending these patients for angioplasty, then your chances of dying or getting stroke will be less, but you will have to buy higher chances or higher incidence of repeat revascularization. So that means stenting, if done, there is higher chance to get restenting, but the survival of these patients is going to be as good. In fact, initial survival may be bad with surgery, and many of these patients can have stroke if you are subjecting them to surgery. In other words, most of the patients, even surgeons, if you ask them that you are a diabetic and do you want surgery or not, very often they'll try to opt for stenting. This is because nowadays newer variety of stents, they have shown much better results than it was in the past. And most of the trials which have compared, they have compared with the older variety of stents. One new stent which has come up is abluminous stent, which has a drug which is on the stent. A stent is a jelly, so you can deliver drug only at some places. There will be areas in between where the drug is not delivered. So latest concept is that you put a drug on the balloon and also drug on the stent, so that the whole arterial wall can be delivered a drug. And this abluminal stent has a drug on it. It also has a balloon which also has a drug on it, so that the whole of the arterial tree can be uniformly treated with the drug. Here is one example who had a multivessel disease, and this is just one vessel which I'm trying to show. And this vessel was stented in different views, and finally this was the result. This is a stent which is lying here, and the classical picture of all these stents is that somewhere 5 years down the line, these stents will be working very well. So my take is that gone are the days when people used to push all these patients with diabetes towards surgery. Nowadays, many of them can be handled without surgery. Nowadays, we are trying to handle much more difficult cases, many of the cases which are even rejected by surgeons. So these are known as CHIP population. And how do I handle my CHIP population if the patient is diabetic? I am very concerned about the contrast nephropathy. I'll try to be very careful about the hydration, both pre, intra, and post procedure. And I'll be very much alerted to the A1C, and I'll try to control it to a much better level, especially if the angioplasty can be timed. Unless if angioplasty is an emergency angioplasty, of course, I don't have time to set it right, but otherwise I'll try to have my patient in the cath lab with his A1C more towards 6-7 rather than towards 12-13. I also want to know about not only systolic ejection fraction, systolic LV function in the form of ejection fraction. I'll try to do some kind of neuroimaging modalities to assess the diastolic dysfunction in these diabetic patients who are coming with complex anatomy. And I'll try to use FFR, IFR, and intravascular ultrasound in these cases, which will help me in using less and less amount of contrast. And I'll try to use stents with thin struts, limber stents, drug-coated balloon along with the drug-coated stents, and try to put them on potent antiplatelets for at least 1 year, maybe longer than that, and try to have very stringent control of lipids, because despite a stringent control of lipid, diabetic population continues to have newer lesions and worsening of lesions. So that is my take on this diabetic population, why I'm trying to address.
I think.
Thank you very much.
Yeah, excellent talk, sir. And I think we covered all the things which we are very, very much pertinent to the diabetic patients. So I think any question?
Can I ask one question, sir?
Sir, please.
Yeah, it's very interesting. I'm really impressed with your study. I have one question to ask. Is it mandatory before you do an angioplasty to do a FFR of a patient to understand whether the angioplasty is going to benefit him? And because there are so many audited reports which have come out from USA that quite a few angioplasties were performed in USA from certain years were not indicated. That was a discussion. So if FFR is now, is it mandatory before you undertake an angioplasty?
Actually, if the lesion is very tight, like it is 90% and above angiographically, then FFR is not required. But if the lesions are close to 70%, which I think majority of the angioplasties are done on lesions which are close to 70%, then the world has learned today that these calculation of percentages of stenosis on our angiographic screens, they are fraught with problems. In fact, same operator, if you give him the same angiogram today and maybe tomorrow or maybe morning, evening, he'll say the same lesion as 70%. And after some time, the same operator says, no, it is 80%, or he might say even 60%. And if the same angiogram is reviewed by somebody else, his assessment may be much, much beyond this task. It may be like 50% or 90%. So for lesions which are close to 70%, plus minus 10-15%, I think it is a good practice that you just have seen the stenosis. It is better to look at whether it is hemodynamically also important or not.
That's right. Okay.
FFR is a very important tool. We should use very, very frequently in these cases.
We do it very often. You know, I'm in a cardiac hospital. I'm in a hospital which is, we do about 5 or 6 bypass every week. So in the cardiac hospital, virtually it has become a golden rule that a person with a multi-vessel disease tortures arteries, whether the patient should be given an option for plasty versus of CABG. That's the time when they decide if the FFR is affected badly, then the patient is not amenable to single vessel angioplasty, then the suggestion is CABG. You know, that's the thing, you know.
In fact, I'll go a step further. Why only for stenting? A lot of surgeons, when they put grafts, many of them will close. And those grafts will close if the artery was not having a tight lesion.
That's right.
If you have a road which is fine enough and there is no red light, if you make a flyover over it, flyover पे क्यों जाओगे आप? Road है आपके पास जाते रहोगे. So those flyovers will block.
Yeah.
Similarly, if you have a lesion which is kind of a 50-60% and surgeon has put a graft, venous graft on it, all these grafts will close.
Right.
20% of the grafts put by the surgeons, they close in first month. And one of the important reasons for closing these grafts is you have put the grafts on vessels which were not significantly stenosed.
That's right.
In fact, there are a lot of people who nowadays have changed their practice. They will like to touch the artery, put a graft only if the lesion, especially if it was a mid-range, is FFR positive. So not only stenting, even putting a venous graft should be done after an FFR in lesions which are mid-range. If the lesions are tight enough, 90% and above, 100%, I don't think FFR is required. But if it is close to 70%, whether you want to put a stent there or you want to put a graft there, because a lot of people will say, no issues, you can still put a graft. There are issues because you give a cut on the artery, you put a vein on the artery, you are disturbing the integrity of the artery. And once you disturb the integrity of the artery, you get problems into the artery. So we should bypass only those arteries which require. So
I agree. What about PAMI? When we consider PAMI in a patient who is just brought to your casualty and you want to offer a PAMI, at that time, do you use a distal protective device anymore or you don't do it anymore?
Distal protection devices are a must if you are handling a vein graft.
Okay, okay.
Because there the chances of embolization are too much. But for routine native lesions, we try to give distal protection devices only if the artery is very large and thrombus chunk is too much. If the artery size is like 3 millimeter and the thrombus chunk is not too much, then we generally don't use a distal protection device.
Very nice. Thank you so much, Dr. Trian.
Thank you.
I think lastly, I would like to just know about, as it is known as the relationship between the diabetes and this coronary artery disease is very complex. And we usually have been taught that diabetes is a cardiac risk equivalent. But now lots of data is coming from some part of the world where they said that this concept is the wrong. So what is your opinion?
It is no more considered.
I really could not get your question. Your question is that if you are a diabetic,
do you think that the diabetes is a cardiac risk equivalent or not?
No, diabetes is a cardiac risk equivalent. As I told you nowadays American Heart has started to talk about heart failure stage A, B, C, D. Stage A is if you are likely to get, if you have any underlying disease which can possibly progress to heart failure, and diabetes is one of the important reasons. So by American Heart Association, 50 crore of the world's population is in stage A of heart failure, and a large number of them are because of diabetes. So diabetes continues to be a risk factor. However, there was a time when all diabetics used to go for surgery. Now I think that things have changed. Many of them can be very easily handled by a newer variety of stents. Of course, if you're putting stents in diabetics, you should be ready for restenting them much more often than you do it in the non-diabetic population. But the same thing is true even for the surgeries.
Yeah.
If a surgeon is operating on a non-diabetic, his chances of creating problem in sternum and so many other things are much less. But once he is handling a diabetic, then his chances to get into sternal wound non-healing or sternal wound infections, they are also much higher. Of course, his chances to undergo repeat surgery will be less. And somebody who's got a sternal wound non-healing, he will never like a surgery to be done again.
Yeah.
So it is not recurrence of the procedure. People don't, once undergone surgery, they will never like a redo surgery also.
Redo surgery is very common in diabetics, but redo surgeries are coming very often now to us. Particularly in our center is known, our cardiac surgeon is known world over. So we get a lot of redo cases, and their sternums are luckily, because what they do, they do, arterial grafts. So the sternal arteries are not touched. The sternal infections are now quite rare, I feel, nowadays.
Actually, this is just the reverse of what you're saying, because the moment you put arterial grafts, take two internal memories off the
sternum,
and you attach it to the heart, then these internal memories are connected to the sternal branches. So
that's right.
In fact, sternal healing is worse if you are using both the internal memories.
Correct.
Internal memories will continue to supply heart, so your heart will be happy, but your sternum will not be happy.
Sternum will not be. But you need radial grafts are okay, no? Radial grafts in this case.
Radial grafts are better than vein grafts, but they are nowhere close to internal memory.
Internal memory, correct.
Nowhere close.
Yeah,
internal memory is by the God is resistant to get erythrocytosis.
That's right. That's right.
It is also somewhat resistant to get spasm. Radial arteries is very much vulnerable to get into spasm. So IMA is a conduit of choice.
Very nice. You've given us a lot of insight in handling people.
Thank you.
Yeah, Dr. Sunil, can you conclude?
An awesome lecture by you, a very awesome lecture where you took all the aspects of the coronary vascular disease and diabetes, the MI, the heart failure, everything was well taken care of. In Hindi, what we call it was Gagar Mein Sagar, the entire sea in a small, to summarize it in a subshare. Was very excellent, sir. A very simple question. As of now, where do we stand? Do we promote the use of antiplatelets in primary prevention of CVD in diabetes? So what's the opinion right now?
At the moment, if your Has blood score is low, that means you try to weigh the risk of bleeding. If your Has blood scoring is low, then in a diabetic, I think it is sensible to add not only antiplatelets, even low dose anticoagulants. But you have to balance out the bleeding risk. If you're trying to give to everybody, then probably the disadvantage of bleeding will outweigh the advantages which are going to get in the form of prevention of cardiovascular atherosclerotic thrombotic events. So I think while we are trying to give, it is the onus is on us that we try and calculate Has blood score. And if the Has blood score is pretty low, then I think these patients are, and especially if the ischemia risk is higher, if the risk of ischemia is higher and Has blood score is lower, then I think the evidence goes in favor of making the blood thinner.
And which antiplatelet would be preferred in that scenario, sir?
Certainly, we will, at least I will try to not use clopidogrel in these cases, which is often used by most of us. I will try to rely on either ticagrelor, or if a person is younger and he has had many ACSs or he has a thrombus in the coronary artery, then I try to rely on prasugrel, provided the patient is not very old and is not underweight.
Okay, thank you, sir. Thank you.
So thank you so much, everyone. That was an excellent closure to a marathon 2 days conference. We've had great sessions. Yes.
Yeah, actually, I just wanted to add a little more on that question by sir who had asked regarding using of antiplatelets in diabetics. So actually, there was this ASCENT trial which was done, which had around 30,000-40,000 patients. So in which, just like Dr. Trehan mentioned, that in that what happened was that there was definitely cardiovascular benefit, but it was largely balanced because of the bleeding. So as Dr. Trehan has mentioned, that if there is any sort of a bleeding risk, then we should be absolutely careful. And in that setting, actually aspirin is the one which has been studied as of now. So that's all I wanted to add.
So I think it's time to say goodbye. We've had a marathon 2 days, excellent sessions, more than 5,000 plus registrations to start with, and we've had almost 2,200 plus logins. That speaks volumes about the quality of science and the deliberations that we've had. Excellent speakers from all across the world. We've had people from UK, US, the Gulf, the Middle East, Cairo, Egypt, and our own very own national faculties, top national faculties. We've had great chairs, great moderation, great scientific deliberations. So many thanks to one and all our faculties, speakers, our chairs, and last but not the least, our delegates who've made this event a huge success. And we promise you a physical conference, our landmark 10th conference next year, where we will all interact face to face. And many thanks to all our pharma sponsors, our partners who've enabled us to reach out to everybody, as well as to Team RX Events led by Hardik and his entire team, Neelam, Neerav, Darshan, Ria, and everybody else who, just in case if I've forgotten somebody, it's unintentional. But let me just deliver this vote of thanks on behalf of Dr. Chawla and me, because he's closing in the other hall. It's been great meeting everyone, listening to everyone, a great virtual scientific feast, and I'm sure all of you have enjoyed it. It will be available on YouTube. If you've missed any lectures or anything that you want to watch, please feel free to watch it on YouTube. All the recordings will be available. And the delegate certificates will be mailed to all the delegates who've logged in and who've been part of the sessions. Many thanks. Goodbye. Take care. Good night.
Thank you.
Thank you, Dr. Sunil. Thank you, Dr. M.K. Singh, sir. Thank you.
Thank you. Bye.